I'm Dr. Samin Sharma, one of the course director for Complex Coronary Cases Symposium 2022 in-person event. Friends and colleagues, we would like to welcome you to the 25th Annual Complex Coronary Symposium. We are thrilled to be hosting the 25th year of CCC Symposium in person in New York. After a very successful symposium last year, we are excited to return as in-person event in 2022. This has been a wonderful 25 years of education, teaching and connecting with expert colleagues from all over the world to present the latest techniques and technology in the field of interventional cardiology to a global audience. The main focus of CCC Symposium is the live cases. We will perform 10 live cases from Mount Sinai Cath Lab of complex CAD covering everything from left main, bifurcation lesion, LV support, calcification, CTO, and more important, using device synergy to get the best results in the safest way. We will showcase from the beginning to end, so all technical aspects will be highlighted and you can take that into your practice. We'll have our world-renowned faculty as panelists providing feedback and outstanding discussion on various techniques. We also encourage the audience to interact and ask us your questions throughout the day. We are committed to offer this 2022 symposium as a platform for continued innovation in interventional cardiology and the main goal of achieving safe procedural outcome and a strong emphasis on the appropriateness of the revascularization choice. We hope at the conclusion of this symposium, you will take home the key points to make you a better operator and give your patients the very best care possible. We welcome you to the 25th Annual CCC Symposium. Please enjoy and good luck.
We were knowing that last year was a little hybrid, and I'm so happy to welcome all of you, along with my national and international faculty, myself, Dr. Kini, Dr. Mehran, three course directors for this exciting 25th year. 25 years is a long, quarter century to make it from educational symposium and stay there. So many, we know the meetings comes and go, but we started in 1998. With everyone, we have our audience, many of them are frequent. Of course, many new faces I'm seeing today, and hopefully during the course of day, we'll have more interaction. The most important point, as I mentioned very simply, is that live cases, and go through the technique, not to just show that we can do the complex case, but a step-by-step that what can be done. And that is what Dr. Kini will be performing in majority of the cases, along with me and my other staff. Many of them you have seen there. And to put all this together, the credit goes to one person, and that is Dr. Roxana Mehran. She actually brought all this stellar faculty. I'm so thankful to her for putting this together, and just have a good day. So after a little introduction, we'll start our usual topics. Anu?
Good morning and welcome to everybody. It's great, I think, early morning. We see a lot of faces. Thank you for all the faculty for personally taking time off and flying and coming here. We know how hard it is nowadays to actually make a trip from one place to another place. Thank you for being here and contribute to our this educational symposium.
So good morning, everyone, and welcome to this 25th year anniversary and the live cases and the complex coronary cases that these two legends perform and will be showing you. The incredibly wonderful fantastic faculty that we've been able to bring together, along with these live cases, make this case tremendously unique. And I really want to echo what Dr. Kinney just said about how difficult it is. Literally, there's a meeting every day. There are like 5 other meetings going on, so you're in the best one, and we're just so happy that you're here. And we want to make this the most valuable time that you take away from your daily activities to learn, to interact, to network. Please meet our faculty. They're amazing. Most of them are sitting here. They want to talk to you, and take the time to introduce yourselves and ask them anything. These are some of the best people in the world, and we're really, really proud to be here. And thank you so much for attending. And I don't know, we're going to have most of this content online, on the online platform that Dr. Kinney and Dr. Sharma have developed through the website. So if you miss something, don't worry, it's going to be there for you. And let's make this interactive, fun, and an amazing learning experience for this day that you spend with us. Thank you so much for being here.
Fantastic. Thank you. And as you know, usual, Anu will be rushing back. Get ready for the first cases for this morning. And again, simple that try to, as Dr. Mehran mentioned, interactive. So ask the questions. I'm sure they will show how you can send the question to the podium, and Dr. Mehran will be the one moderating our 2 sessions of the 4. Then will be Josh Dangas and then Pedro Moreno. So questions, send it, and will be tackled and answered. So with that note, I will usually start with my top 10 advances of interventional cardiology. So you know that until last year, I used to keep it only for a year before. So if I make 2021, and what happened in the last 5 months, I was a little far behind. So I changed now. So we're making it interventional cardiology 21-22. Means last June 1st to May 30th. Anything which has come in our field, because ACC particularly of the same year, which is one of the important meetings, many things come from there. So I changed this a little bit to our top advances. And I've said this tribute, where we are and able to do it, is by teaching. And of course, Andreas Grundzig is the father of angioplasty. Dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patient, which I added with utmost safety. Let's see what happened here. Okay, maybe I have to go this way. Okay, sorry. With utmost safety and appropriateness and ambulatory, of course, we know 60+% cases are done as an outpatient. So basically, idea is to select, which has changed our practice in last 1 year. So I want to start with the first one, is the CABG turned down cases, which is the optimum registry. So patients who have complex disease, but turned by surgeons, by the heart team discussion, and this was the case, 750 cases in 22 centers, all very complex, very high syntax score. Reason for ineligibility is shown here. Many of them because of the poor target, bad LVs, lung disease, frailty, and look at the complexity of the angiographic characteristics on the left side, which we say these are the truly complex, and those are type of cases which we'll do few of them. And the left main being in 38% of cases, atherectomy in 1/3, and rotam and hemodynamic support in about 27%. But what did it show? Basically, that in these complex cases, very interesting, that many of these cases, we are able to decrease their syntax score. Means majority of the lesions were taken care. The syntax score of 0, only in 11%, but 1/3 of them became less than 8. Remember, the residual syntax score have correlated less than 8 is okay. So also, the key is that you can do them safely. And safely basically means that, yeah, you can do it. But what will be your predicted mortality in these patients? And you can see based on the various prediction of models that mortality was 5.6, in hospital was 3, and 6-month mortality is 12.3. You say, well, it seems to be high. But these are the cases which I can predict. Without intervention, their probably mortality would have been 25-30%. Also showed that your completeness of revascularization, that yes, you have better revascularization, your event rate goes down as well as health status improves. So anytime you even want to do complex cases, you need to target more complete revascularization. Second, relationship of hemoglobin A1C with cardiovascular outcomes post-PCI. So this is actually data from our large single center registry from Mount Sinai with Usman Babar, the lead author. Idea I suggested that let's see, we always talk about A1C, diabetic patient who have PCI, what does really matters in a large scale? So yes, some randomized trial where you are carefully followed is a different story, but what about in the general? So we have 14,000 patients, and we have A1C available for them before procedure. So this is the A1C, and you see the individual distribution of A1C 5.5, 5.5 to 6, 6 to 7, 7 to 8, more than 8. It's about half of the cases, the A1C was between 6 and 8. So these are the individual characteristics in each group. Clearly, once you go to a higher A1C, more than 8, more complex disease, multi-vessel disease, and the patients have other comorbid conditions. And intervention, of course, required because of complexity. More complex interventions were done for those patients. But more important, goal was different, not acute results. What happened to them for follow-up at 12 to 14 months? And you see here, we have death, MI, and target vessel revascularization. Look at the death. If your A1C is less than 5.5, it is 5.6% higher. Very low A1C associated with higher mortality. And if MI, higher with the high A1C. And of course, the TVR didn't matter. Slight trend, you can say, with the higher A1C, but really did not matter. Very interesting observation. I know some of the studies have shown that also. And we saw this kind of relationship with the A1C. So basically, it turns out to be that you have a trade-off. Too strict, patients die. We know that various of the diabetic trials have shown too much hypoglycemic episodes and so. So basically, we concluded that patients undergoing PCI, pre-procedural A1C level display a U-shaped association with one-year MACE, pattern that reflects greater risk of death in presence of low A1C, 5.5, and high risk for MI values for more than 8. So there was a nice editorial with that. And more important is, I say, if somebody asks, what is the sweet spot with this? I think 6.5 to 7.5. Don't be too strict, and of course, not to be too high. That's what we learned from this data. Then the drug-coated balloon. I think for US interventionists, it still remain a sore thumb in the sense that we don't have drug-coated balloon for coronary arteries. Lots and lots of data are coming. And basically, it works either in instant restenosis on the top or de novo. Basically, idea is the local drug delivery. No additional stent or metal is left in the vessel. And of course, it's a little different technique to use the drug-coated balloon compared to regular balloon or stent. You had to leave it for 60 to 90 seconds. But it has shown very effectiveness. And this I presented last year. The drug-coated balloon is especially useful in the ISR. And the question is why? Because low depth dependence. So this multiple trials have shown actually mortality of various of the drug-coated balloon trials. Now, what we learned is that is actually going on at present. We have a lot of our European colleagues and from Asia that using drug-coated balloon in small arteries. Question comes, in a small artery, you put a stent, already taken part of the lumen, metal. What if your drug-coated balloon will work? Now we have the 3-year data of the small basket, small 2, of the about 750 patients, and basically showed identical outcome. So drug-coated balloon is small artery in all the aspect, fares well with a drug-eluting stent. Even look at the stent thrombosis, although p-value was 0.18, but definitely lower with a drug-coated balloon compared to DES. Only thing is, if you put a stent in the drug-coated balloon situation, when you had for some dissection, the curve on the right side, that has a little higher event rate. So drug-coated balloon alone works very well. The individual, the data in terms of in diabetic and non-diabetic, it turns out to be the benefit is more in the diabetic, on the lower, as you can see, with a drug-coated balloon compared to non-diabetic. So yes, non-diabetic doesn't make much difference, but diabetic, higher restenosis anyway, but significantly reduced TVR, no difference in MACE, but significant reduced TVR in a diabetic patient as shown here. So what about acute coronary syndrome? Benefit was both stable syndrome as well as acute coronary syndrome. So I would say a small 2 trials showed the drug-coated balloon is a good option in a small vessels. You do a good angiographic result. If you have no dissection, you leave it. And of course, you can always do a drug-eluting stent. But data are coming that probably is better just do a drug-coated balloon. Then we have multiple imaging trials. Some of them may be confusing to you, which I'm going to present. But just to say, enhance or improve our interventional results. So that's basically is. The decision is made by many times some of the devices, particularly FFR and IFR. And more importantly, additional multimodality imaging. And that is will be shown in the cases today, whether it's the IVUS, OCT, or NIRS, and of course, even ambiguous lesion, you make a decision based on this imaging, or with the FFR or IFR, which have been shown by the trial, has become kind of class 1 indication for us that in a borderline lesion of 40 to 70%, you do a imaging or physiological imaging usually before proceed for intervention. And ultimate trial is the IVUS guided 3-year data, which we have now, that IVUS guided in the red compared to the blue angio guided, that overall significant improvement in outcome at 3 years. And there is another trial which showed the combination of both IVUS XPL and ultimate trial showing that benefit in mortality, not even just the TVR and TVL, but definitely benefit in mortality. And there's some data showed lower stent thrombosis by using imaging, particularly in complex cases. Now then, there was a trial called EyeSight, a randomized trial comparing 3 aspects. Angiography guided, a small number, 50 in each group. IVUS guided or OCT guided. So is there a difference? It was a small trial, very intense, where criteria that what your protocol should be to get good results of the IVUS and OCT, and basically showed that overall much not different, but yes, by doing imaging, you do have a little higher fluoroscopy time and sometimes the contrast volume. But what did show that you have a better stent expansion compared to angiography alone. So although outcome at 2.5 here, a small number, there was no difference. So then the question came that do you do an intervention based on the FFR or based on the IVUS? And this is the flavor trial. A large number of patients, 1,700. So particularly intermediate lesion, 40 to 70%. You decide based on the IVUS. They have the criteria of the IVUS, which is that vessel size, and so lumen less than 3 millimeter or between 3 to 4 with a plaque burden more than 70%, or FFR less than 0.8, and then try to get optimal results. So basically, patient came for cath possible intervention. You either an FFR group or IVUS group, and then proceed with intervention. What did happen? At 2 years, exactly identical outcomes. And the individual outcomes are shown here. Red is the FFR guided, and blue is the IVUS guided. There was no difference in angina class, as well as overall outcomes were different, whether you do FFR guided or IVUS guided intervention. There was another trial called Erosion 3, because many times we have patients who have MI, they basically got thrombolytic or just came late, and now we have only 60, 70%, but little ulcerated lesion. Should you stent them? Many people say, well, maybe the vessel is already open, infarction has occurred, maybe stenting not be beneficial, maybe we can follow them. There is a question about erosion, plaque rupture, and various things. So key is decide based on the angio versus OCT guidance, and what it showed that if you decide these patients, 226 patients, OCT guided on the left side, requiring stent versus no stenting, you see that OCT guided stent was 44% versus 59% with the angiography guidance. And various OCT characteristics shown on the right side, and overall outcome were identical. So just to say that many of these cases you can defer stenting. And we know that in these cases, many times you develop slow flow, and so using less stent probably is a better in this case without causing any bad outcome, which are shown here in this trial. Again, a small trial, but gives you idea that once you have lesion less than 70%, if you can do OCT and identify that there is not the erosion or so, they can be left alone. Then many times happens, patient is negative FFR, but they still develop event. So this is the combined FFR OCT trial. That can OCT predict on top of FFR in this FFR negative lesions? And what it basically showed that thin cap fibroatheroma. So if you have a thin cap fibroatheroma in the FFR negative, look at the event rate at 18 months, is 13% versus goes down to 3%. So your FFR negative sometimes have an event later on. Why? Because there was a thin cap, and that ruptured and caused the event in future. There are 2 randomized trials which we need to wait to really put our imaging into actual class 1 indication is one is the defined GPS trial, which is IFR guided therapy, optimize your results. And secondly is the iLumen OCT versus angio. Will take a couple of years, but we'll have a final answer, kind of a level 1 indication, class 1 indication for these imaging in our interventional cardiology. Then the new CIN risk score after PCI and long-term MACE. So clearly, Dr. Mehran Authority, and she is the director of our interventional research at Mount Sinai and oversees our interventional database. And she actually came up to reanalyze the old risk, her Mehran's risk score, and come up with the latest what we have, because we know things, patient characteristic changes. This is the old Mehran's score, which taken together in terms of hypotension, balloon pump, CHF, age, anemia, diabetes, contrast volume, baseline creatinine, and used to come with a score. So that was one of the very highly cited score in our interventional cardiology, in a CIN, AKI score. So took this initiative to have a new modified, knowing that the definition of AKI are different with the ADQI or AKI, acute kidney injury network, or kidney disease improving global outcomes, and basically showed that let's look into that, are the predictors different at present in this contrast-associated kidney injury 48 hours, and then follow them for 1 year in terms of their outcome. And this is basically, again, large series from interventional database, again, 15,000 patients who have creatinine available in-house before procedure and discharge many times creatinine from outside, but we looked into cases which we have creatinine values, and overall, these are the study population that develop the set and then prospectively validate within the same group. Now look at the incidence of AKI. Very interesting. Over the years, our AKI incidence has gone down. Good news. Why? Because we are more conscious about it. Use a small dye, maybe some imaging. So clearly, AKI incidence has gone down over the years, and more importantly, that the model which was created based on the pre-procedural variable and including post-procedure variable, and has a very good correlation in terms of the low risk, moderate, high risk, or very high risk of developing contrast-induced AKI. And this is actually very nice illustration of coming up with a factor. So question comes, what does that all mean? So these are all various models and statistics showing. And more importantly, that patients who developed AKI, you can see their death rate is much higher versus those who did not develop kidney injury. So clearly, we need to do everything to prevent AKI. It's not only 30 days, even after 30 days as shown here. So there's a very nice editorial with the paper that we still have various parameters relevant in modern era, try to limit our dye and contrast induced. There's another data came that patients who develop from the ADAPT DES 2-year follow-up, those who develop contrast-induced AKI, kind of supplementary to the latest Mehran's article, that those who develop contrast-induced nephropathy, they are normal creatinine even. So many of them, but you develop contrast-induced nephropathy, had a bad outcome at 2-year follow-up, individual one shown here. And this basically goes down to that if originally you have CKD, no CKD, then CKD with AKI, and the CKD without AKI, you see the gradient. So basically is that if you have even normal creatinine, you develop AKI, associated with the bad outcome at follow-up. But you have baseline high creatinine, develop AKI, trouble. 5% became 14% 3 times. And then more important, very nice editorial, that bump in creatinine post-PCI might bump off your patient. Nice editorial, just like we used to say for the peri-procedural MIs. And then go to the next one, and this is a lot of trials in this way, depth de-escalation. So we learned over, like I would say, until 5-6 years ago, all that focus was use a stronger antiplatelet therapy. Now in 5-6 years, we have many trials, and every year this is part of my top 10, that can we downgrade our de-escalation, use it maybe acutely when it's necessary. There was one trial in Talos AMI trial, ticagrelor versus clopidogrel in a stabilized patient with acute MI. That after, we know that after 30 days, we need a potent, but after 30 days, you don't need a potent inhibitor, because the patient do very good after good intervention. And so this was the trial that after 1 month, Talos AMI, everybody got aspirin ticagrelor, but after 1 month, they were randomized to aspirin plus clopidogrel versus aspirin plus ticagrelor. No loading was done for the clopidogrel, and this is up to, and followed up patients up to 12 months. So basically, 1 month, a strong, potent antiplatelet therapy, and see what? De-escalation. Event rate is almost half, and which were basically mediated by no difference in the MACE, although 1% lower, but biggest difference in the bleeding. So what we used to worry about in the past of the stent thrombosis and ischemic event does not happen nowadays. This has been stopped by trials after trials have shown that now. So go maybe in the acute phase, do the strong antiplatelet therapy. After that, your focus should be to decrease the bleeding. And that was, many papers have been published from our interventional database by Dr. Mehran also, that it's the bleeding after the acute episode which is a bad outcome in the PCI, kidney injury, another aspect, and so. So this actually goes to various trials which have put into this de-escalation, Talos-AMI in the TICO, Twilight, Tropical, Popular Genetics, Host-Reduced Polytech, ACS, all basically having a common message that de-escalation is safe, no difference in ischemic output, endpoints, and it decreased the bleeding significantly. Then the whole question came, you are given your aspirin, clopidogrel, or whatever antiplatelet therapy for 6 to 12, 18 months. Now what? Usually what we do, we take away the clopidogrel, we continue aspirin. Is it better? Versus you change it to the clopidogrel. So this was like Capri trial. Capri, remember aspirin, clopidogrel on the various disease setup. So this is index PCI, then randomized after 6 to 18 months. You wanted to give DAPT, good. But now question is, you give aspirin alone or you give clopidogrel? Our usual practice is what? We give only aspirin. We take away the clopidogrel. So this is the primary outcome. Look at this one. On the right side, these patients, large number of patients, 4,500. And so 7.8% event in the aspirin and 5.6 in the clopidogrel. And see, basically mediated by two important things. ACS readmission and major bleeding. Clearly, and then of course, clopidogrel was beneficial in decreasing stroke. So very interesting observation. So now, based on this trial, you can make it a point. If patient wants to continue clopidogrel rather than aspirin, we have the data to support for a long term. Then abbreviated DAPT trials in the same kind, which have been many other studies have shown. I'm going to talk about two of them, most important being the master DAPT presented last year, published in NEJM. This is again, high bleeding risk patient, 30-day after PCI, and patient no event. You abbreviated DAPT, stop after 1 month, or you continue your 5 to 12 months as based on your recommendation. And these patients were high bleeding risk. They got one stent only, Ultimaster, and there was no restrictive based on the clinical presentation of PCI complexity. And basically, majority of those patients after acute time received clopidogrel after 1 month in the single DAPT group. And overall event rate, as you can see here, NACE, major adverse, as well as non-major bleeding. Actually, NACE and MACE, okay, but more important, that you decrease the bleeding. So again, the same message comes down that you decrease the major bleeding after, by abbreviating the DAPT. So they did a subgroup analysis, patient who have MI 1 year ago, still there was no difference. And lastly, in the complex cases also, they did not have any difference. They did not have acute MI and subsequent indications, so, but looks like that a patient with high bleeding risk is stopping antiplatelet therapy at 1 month is okay. Stop DAPT2 was a trial done to abbreviate your antiplatelet therapy after 1 month, but then ACS, especially in the acute coronary syndrome, wanted to see, can we stop it in 1 month? Remember, recommendation for DAPT at present is 1 year in acute coronary syndrome. Stable is 6 months. But question is, can we do it in acute coronary syndrome at 1 month? And these are the combination of both stop DAPT2 as well as some data from step DAPT2 and ACS. And overall, the overall endpoints are 3.2 versus 2.8, no difference. But more importantly here, you see the 1 month DAPT in blue in these patients, ACS patient, and 12 month in red. And overall event rates here. But one of the biggest issue is 1 month DAPT has a higher MI rate. Yes, bleeding is lower, that is true. But this is the first time de-escalation at 1 month compromised the patient's safety in terms of ischemic endpoint. There is another trial done 1 month of the DAPT, which taken all the patients together, no difference. But more important, even this trial, look at the ACS. 7.2 1-month DAPT versus 5.1 6 to 12-month DAPT. So message resonates that acute coronary syndrome should not stop in 1 month, preferably 6 months or so. And that actually goes to the guidelines, and part of the guideline have been incorporated 12-eye data that you can stop your aspirin after 1 to 3 months. Of course, bleeding risk patient, you can stop at less than 1 month and so. Then, of course, many patients, you may continue even beyond 12 months if appropriate. So next is the left main revascularization, the meta-analysis and EBC1, because remember, this is the 5-year data of the Excel, lot of controversy, overall endpoints were not different, but mortality was higher, 13% in the PCI group, 9.9 in the cabbage group, although it was not a pre-specified, but clearly we knew that a lot of controversy about the mortality of the 5-year Excel trial. So then we have this meta-analysis of the 4 randomized trial of the Syntax, pre-combat novel Excel by Dr. Sabatine and Dr. Eugene Brownwald group of 4,400 patients and 5 to 10-year follow-up, and overall basically showed that these patients, the event rate of 5-year mortality or 10-year mortality is identical. There is 1% difference in 5 years. 0.2% mortality per year in the PCI group compared to cabbage group. You take all the 4 trials. And that message is the same thing in 10 years. 1 year, 5 year become 1%, 10 year become 2%. And rest of the events as shown there, the stroke actually in early stages was lower with the PCI, but if you take all of them, no. Only difference is revascularization. You'll have a higher revascularization as shown here, and these are the individual endpoint. Spontaneous MI a little higher with the PCI versus cabbage, and other endpoints were not different. So key is the patient with a more complex disease, high syntax score, definitely did better with the cabbage. So that's what our goal is. That more complex disease with the left main, go for cabbage. Less complex disease, go for PCI. So jury is still out there. I think still this will continue to hear more about. Then there was a trial that which technique you should use. DK Crush showed that 2 stents are better, but the European group took into that again to the challenge that what if we just do a stepwise provisional, means 1 stent, maybe 2nd stent if needed, compared to dual stent strategy. And they used actually the technique which was not propagated by the DK Crush. So DK Crush was done in very small % of cases. It was all done with a Coulot. Coulot already had been shown by the DK Crush group that the DK Crush technique is better than Coulot, but that was the trial as such was. And 22% in the provisional stenting group got the stent, and overall outcome basically showed maybe slightly better outcome, but no difference in stepwise provisional versus systemic dual technique. So more of the technique. So just to come back, that rather than putting a 2 stents in the left main, this EBC1 has raised the bar again, that maybe we should just do a 1 stent and optimize the results. It still remain. But I think this is a part of our heart team discussion, and when we'll get a class 1 indication, it still need to be seen. Then FFR trials. FFR has embedded in our interventional cardiology, in all our mind. We have to do everything with that based on the FFR. And we all know how good anything is, it comes back with full circle. There are a few trials in the past with plus minus, but majority have been plus. I say classical example is Digitalis, digoxin. Great drug at its time. Now it's like everybody thinks it's a poison, although I still use many times to control the rate, but nobody wants to use digoxin. So same way, so 2 major trials of the FFR. And the FAME3, that was FFR-guided PCI compared to cabbage. These are the about 1,600 patients, FFR-guided, that you do PCI on lesion which are less than 0.8, leave others alone, or you do cabbage based on the angiogram. This was a 3-vessel disease. Left main was excluded from this, and overall event rate and procedural characteristics are shown there. Done perfect job of what's supposed to be done, but look at the data. Non-inferiority versus superiority. To me, it's a superiority. I know the conclusion was that FFR-guided PCR, the FAME3 trial, FFR-guided revascularization was not non-inferior. It was basically inferior. 10.6 versus 6.9. Why? Look at the biggest issue remained, revascularization. 5.9. Many of those lesions which we deferred. Classical, we learned from the OCT FFR. May have thin cap fibroatheroma, for a few other lesions, they will give trouble. This is actually 1 year. Guess what the trials of the PCI versus cabbage we are lost in 1 year? We have lost maybe in syntax, and that is only because they did a revascularization. But if you take away even revascularization, most of the trial of the current PCI and cabbage were identical at 1 year and so. But clearly in 1 year to lose because of this strategy was not appropriate, in my opinion. So basically, just by FFR alone is not enough. Maybe we had to go a little further. We interventionists do a little better job. Only one thing happened, the low syntax score we did good. But intermediate or high, of course, the cabbage was better than PCI. So there was some, I would say, reassurance from the FAME-3 trial that low syntax score, it said that yes, PCI is good, numerically better, but more important, event rates of the revascularization have gone down, and also, particularly, the quality of life parameter. The PCI did a better job in the short term. Of course, at 1 year, they were identical, and more return to work, younger patient. More patients return to work when they got the PCI compared to cabbage, but that we would know from many other trials and so. The second trial of the FFR was in MI patients. You did a PCI of the STEMI culprit vessel, but what about the non-culprit vessel? Do you do based on the angiogram, or you do FFR, guided PCI, for complete revascularization? And this is the trial that FFR-guided PCI, 66% got the stent. Angio-guided, almost everybody got the stent. And overall outcome, angio-guided PCI was about no difference, but definitely not worse than FFR-guided. Individual endpoints are here. Overall, it did not make any difference, but still, there's about 1+%, 1.3% event rate higher in the FFR-guided, and that is basically revascularization. Look at that, 2% higher revascularization in FFR-guided versus angio-guided. So the whole idea of our FFR field had come to question by these two major negative trials. So people may want to make it in some positive way or so, but I think we need to understand a little more. Just FFR alone is not enough, and maybe an acute coronary syndrome is not enough. Maybe you need to think about something else in these cases, additional. And I would say the top 10 advance of interventional cardiology is the 2021 guideline for coronary artery revascularization, which Dr. Lawton and Jacqueline, who is one of the faculty here. Guess what? You know when was the last ACCHA guideline was? 2011. After 10 years, came with, very interesting, they actually have a lot of focus, not only just the patient or the lesion, but as the team, equity of care of the revascularization, ethnicity, race, then shared decision making, and patient is at the center. Ultimately, decision is what patient decides. And you provide the whole aspect of the peri-procedural and post-care, not that just put a stent and you are done. No, you need to go beyond that. And they actually have all assessment of the heart team with the STS risk score, syntax score, and then the recommendation of the physiology, class 1 indication for the FFR, and imaging is 2A indication, pre, and they actually go through various aspects that which patient is good for revascularization compared to medical therapy, and I put it here clearly, that patient with ischemic heart disease, if your indication to improve symptoms, patient with angina, revascularization is okay. Now, where you make FFR guided or so, that need to be seen. Second is, those who have anatomic indication, that we need to improve survival. From the survival point of view, if there is a left main disease, complex left main, suitable cabbage, class 1 indication. But if it's not suitable for cabbage, you don't let the patient die. You have a heart team discussion. Many of those patients will get like optimum trial, PCI, which will be okay. So whether it become class 1 and so. Then those who are no complexity, the PCI become 2A. Very important. Now, multi-vessel disease with PCI. This has been a little controversial. What they have put into here is LV dysfunction as the primary. So that is basically that if patient anatomy not suitable, probably medical therapy is okay. But more importantly, if those who have cardiomyopathy, less than 50% ejection fraction, and suitable for candidate, class 1 indication. But if in some cases, you can have patients are not suitable, ejection fraction is more than 50%, then your PCI is 2B indication. So clearly here, the controversy was that in these patients with multi-vessel disease, cabbage became 2B, no longer class 1 with this guideline, and that is one of the issue has been. A lot of people discuss that maybe correct or so, but these are based on the data that trials have been done. PCI has done great job on many of these patients. Complex disease, they have with the diabetes, radial femoral, perform radial. The imaging is still 2A, and then calcific lesion, ISR, all the individual points, and then DAPT duration, same. They continued that you have 1 month for BMS, 6 months in stable patients for DES, and 1 year in the acute coronary syndrome, and so on. And dual antiplatelet therapy, cardiac rehabilitation, smoking cessation, and more importantly, also psychosocial risk factors, which you don't think much about. But key is that you need to have compliance of these patients at follow-up. So those are the top 10 advances of interventional cardiology for 2021 to 22. And I put this thing together, maybe because FFR-guided PCI versus CABG, FFR-guided PCI in MI, short DAPT in acute coronary syndrome is thumbs down. The PCI versus CABG and unprotected left main, PCI in CABG turned down, drug-coated balloon in small vessel, hemoglobin A1C and outcome, good data. Imaging-guided PCI, DAPT de-escalation, clopidogrel better than aspirin on long-term, and new CIN score, 2 thumbs up, and 3 thumbs up is short DAPT in high bleeding risk patient, and maybe sometime all cases. And more importantly, the 221 revascularization guideline really giving us some guidance, which we have been waiting for a long time to make us better interventionist and so. So volume is going up. Intervention volume, people were concerned. What is happening? This is our data at Sinai. That of course 2022 was 2020 because of COVID was, but we definitely have a growth in both intervention, and more important actually is in the structural heart intervention. This is the latest data, the highest number in our New York with Mount Sinai with their respected 30% risk-adjusted mortality and significantly lower risk admission. So just to complete, the CCC live webcast has been a big hit. Over 2 million people with a CCC live webcast. Every month about 18,000, and both between live, our webcast and YouTube. And we'll be talking a little later, Dr. Keeney and team has developed this multiple cardiology apps, which are more than 60,000 download for everyone. And just want to thank all my cath lab attendings to be a part of this great organization which we have built at Mount Sinai. And thank you to be part of this one-day symposium today. Thank you very much. So with the usual, the tradition we keep, followed by today's presentation, we can take off this now, slides. The Dr. Fuster, everyone knows Dr. Fuster has been the great mentor, personal advisor, all since I joined Mount Sinai in 1988. And achievements everyone knows about. Dr. Fuster is director of Mount Sinai Heart, physician-in-chief, and is the only one who has received the ultimate award from both ACCH and European Society of Cardiology. Every few weeks, we hear about another great, the medal and the award Dr. Fuster receives, but those are shown to a bio. But more importantly is that Dr. Fuster keeps changing the message based on the time. As you remember that many, many years ago, it used to be platelet, but then revascularization, then diabetes, and now the imaging of the heart and the brain. So we really need to learn from Dr. Fuster how to keep changing with a changing time to give the great message to all of us. Dr. Fuster, thank you very much.
Well, thank you very much. First of all, congratulations for this 25th anniversary. But after your presentation, nothing is left on this meeting. So I'm going to move into a different direction, which I think is justified, and that is imagenomics, heart to the brain. What went on in the last 3 years on a program that we have, which is very much dedicated to understand health before disease takes place. Is an age-dependent program, and certainly we are involved with actually very new technology. So let me just move into, let me see how it works. Which one?
Let's see.
No, it's not.
The slides are not moving.
I hope it does.
I hope it moves. Hold on. No, they're not really moving. Okay.
Well, let's try and see.
Try again.
This is not good.
Okay, it's working.
Let's try. Thanks very much. So we have, this is the program that we have, is Development and Innovation, Cardiovascular Health, Age-Dependent New Technology. And if you go to the bottom, this is what we have done over the years to understand the disease before or after the acute coronary events. But we are moving up now to understand how the disease begins. That's number one. Number two, different ages are different aspects that are related to the development or the prevention of disease. Is completely different at age 60 to 100, 20 to 60, or from birth to age 20. And on the right is, we are talking about new technology. We are not talking about charitable work, which is socially oriented. We are talking about imagenomics, artificial intelligence, innovation therapeutics, as we will talk today, and then the issue of single cell, like a macrophage, which can provide a lot of information about us. So having said this, let me begin, Let me begin now with people at between age 20 and age 65. What is the challenge? The challenge is, I am developing the disease or I am not? These are the conventional risk factors that are affecting the endothelium of the vessel wall with the entry of cholesterol. And here it is, how to understand a healthy vessel. Certainly you cannot go into intravascular imaging because these are already patients with significant disease that has evolved. So what we have done over the last 10 years is to develop specifically 3D ultrasound to address two carotid arteries, the main aorta and the two iliofemoral regions. And then we have used actually CT for calcification of the coronary arteries as an indirect technology to address altogether 6 different regions. And as I presented here last year, the first thing we learned is that the disease begins in the femoral region. No clinical events, no claudication, the arteries are very large. This is why the manifestation clinically may be in the small arteries, like the coronary arteries, but not where the disease actually begins, in actually most of the people. And this is based on 4,000 people that we have done such imaging technology between age 40 and age 55. Now, the question is, we learned something very fascinating. All of this was at autopsy, but I'm presenting now imaging in vivo. So here on the left are males, on the right are females. And here you have, under age of 50, 2/3 of males have already subclinical disease, which is where we are focusing our research. One region being involved, 2 or 3, 4, 5, or 6 in women, half of them have already subclinical disease by the technologies I mentioned under age of 50. But there is more. We are following these people for 20 years now, and we follow them every 4 years. And just on the first look after the baseline, 4 years later, 41%, there was some progression of the disease in one artery or another, in one plaque or another. I think this is very important. What we have done is MRI and PET of the large arteries in 900 people. And here on the right, you have you have PET, which really is the combination of cholesterol deposition and macrophage infiltration. And here on the right is magnetic resonance imaging of arteries that are actually already fibrotic. It's like a healing, and actually there is also calcification. And the key point I want to make is somebody mentioned platelets. I began working with platelets, and cardiologists didn't know what I was talking about. I'm talking 45 years ago. And actually, I had to deal with all the meetings with the hematologists. I was not in cardiology meetings. I will tell you today that the key issue in the defense mechanisms in health is the bone marrow. We are going back to the hematologists in a way. Let me explain to you what is happening. Now, when there is infiltration of cholesterol, the fatty streaks found at autopsy, the bone marrow reacts, and actually the macrophages try to take the cholesterol out. And in general, is a winner. Here you have, defense mechanisms in yellow. There are some good, some bad. This one is yellow. But the first one is very good, and that is these lesions convert into fibrotic lesions seen at MRI. This is very nice, but let me tell you the patients you are dealing with. Basically, when the substrate is significant, a lot of cholesterol in the artery, the macrophages commit suicide. They think they cannot do the job, they become apoptotic, and they release cytokines, tissue factor, and metalloproteinases that may lead to plaque rupture. So what I'm saying to you, the patients that you see with interventional people, you're dealing a lot with a loss of a war in which the macrophage gave up, and it's a tremendous release of substances that can be very tricky. It's the same that COVID-19. In that case, it's not cholesterol, foreign body, it's the virus. And it depends the load of the virus whether the macrophages are going to win or to lose. If they lose, they release all the substances that make patients to go into the intensive care units. The same happens in the coronary arteries. So we have a defense mechanism when the substrate is not too large, but when in fact the risk factors continue, the ones I mentioned at the beginning, and the cholesterol keeps entering, we are in defense mechanism number 2, which is basically a loser. I look at my presentation last year here. And actually, I don't know if the title was the same, but I will tell you 2/3 of the slides presented today are different. And this was published 3 weeks ago. And basically, when we do PET, we can see the bone marrow, how it is activated. You see this here. And actually, you see in the next slide, this is actually what we see with positron emission tomography. So we have a complete parallelism between activation of the bone marrow and deposition of cholesterol in the vessel wall, and this interaction between cholesterol and actually the macrophages. So one of the first concepts that I think is important is that the cardiovascular disease, atherosclerotic disease, obviously is a silent disease. The iliofemoral region is the first one that is sensitized to the development. And then we have the protagonists, which are the risk factors, and then a war between the substrate, which is the deposition of cholesterol with the risk factors, and the issue of inflammation. And we already talked about winners and losers. Here comes an important second concept, very important actually. Here are the 4,000 people that we studied at middle age, high Framingham score, middle and low. You know the colors means disease subclinical. Why we have so many people who actually within just one risk factors or none, they already have significant subclinical disease? This is a critical question. Lp(a), fibrinogen, my friends, there is something else in all of this. And this is what I want to show to you. Number one, fascinating. The guidelines, which are completely primitive, I have to say, on the guidelines on prevention, the guidelines are all based on clinical events after age of 40. If you go below age of 40, you don't find anything that is meaningful. It's forgotten. And it's only with events. So what happens is if you go to subclinical disease, you realize that a normal LDL cholesterol means a lot of subclinical disease. You have it here. A cholesterol LDL of 100 to 120, that's what's considered normal. But look at this. You need to have an LDL of less than 70 to talk about normality without subclinical disease when all the other confounders and risk factors are taken into account. Number two, hemoglobin A1C. You just had a presentation. Hemoglobin A1C, when it is pre-diabetes, may lead to events. Sure, we have the data. It's exactly the same data. We just published this. A hemoglobin A1C from 5.7 to 6, which is pre-diabetes, has a lot of subclinical disease already. So to say that hemoglobin A1C is an alarm that you are going to develop diabetes, I say it's more than an alarm. You're already developing the disease. So what we consider normal today is completely abnormal because we all have been focused in heart events in over age of 40. The same happens with triglycerides. So this is the number one concept that is important. What we consider normal is not. And the second is equally important or perhaps more. We got into the cardiac study, people between age 20 and age 40 that were followed for 40 years. And what we look is the impact of the risk factors in the first 40 years of life. Cholesterol goes up and down, blood pressure goes up and down, and you have an area in the abscissa, is the time of follow-up. In the ordinate, what is the level of LDL? And that area is telling you the impact. Well, we found something fascinating. It's just summarized here. And again, part is published. LDL cholesterol, the fluctuations within the first 40 years of life have a huge impact. The area that we are measuring, and this is the blue, into the events that happen later in life. And that is, higher are this area before age 40 has much more impact than the Framingham risk factors that we look at age 40. This is a complete change in our understanding of this disease. We are missing everything. We only act when the disease is advanced, and we miss decades of the problem, as I am presenting here. So the second concept that is critical is cardiovascular disease, atherosclerotic disease, is very frequent without obvious risk factors. First, we consider normal, which is quite abnormal, so clinical disease is there. And second, there is an age cumulative effect that has been completely ignored. And these issues are critical because what we are doing is absolutely measuring subclinical disease, and we are measuring events. So I think this second concept is also important. This led us to the third one. We are developing a trial, the first one in young people. People between age 20 to 40, with an LDL cholesterol more than 70, which we consider is abnormal, are going to be randomized into bringing LDL to 40 to 50 versus what the guidelines say. They say, at this age, please take care of the risk factors. That's what all the guidelines are saying. Nothing absolutely specific. And the primary endpoint is the progression of disease. These are young people. The secondary endpoint are events, are young people, so you don't have many events, except I have to make a comment. We already have data in people between age 60 and 100, 12 years of follow-up. Can you see what is here? This is at time 0. Actually, we look at the burden of disease, subclinical, and these are all the people, so we can look at events. And higher is the burden of disease, subclinically speaking, higher is actually the mortality. We just look at the carotid arteries. We now have the data in coronary calcification. So in our study, the secondary endpoint that will be events are very young people, but we will transfer the data of how much disease or burden in disease into what the burden of disease would give if this patient was older. And this can be done statistically. So that's number 3. Number 3 is early in life. There is a unique approach, which is be strict into what is considered normal and abnormal, and this is the trial I just mentioned. Well, this is the story. The patient comes tomorrow, and you see somebody who you want to intervene, but by chance you have the brother or sister over there, and the question is what we should do. Well, let me tell you how we have done 7 projects now. Half of them are already published, which is 2 approaches to change lifestyle on people that we identify subclinical disease, something very pragmatic. One approach is individual. This is Kenya, where people have high blood pressure. These are the investigators. And I think I want to make one point. Individual approach, in this case, high blood pressure, because this is a poor part of Kenya, that they keep the food with salt. There's no freezers. They have hypertension, and we get with there individually pamphlets, phone calls, nurses, medications, and so forth. I can tell you one thing, very expensive. The individual approach to risk factor modification today, everybody talks about it. And your patient who comes to your office who knows you will follow you. But if you go globally, forget it. It's extremely, extremely expensive. This is a second approach. And this is the one, group therapy. We did this in the island of Grenada, in a town in Spain, and then in all these villages in Spain. And actually, I give you the total result of all these studies. The group therapy all was randomized. One group, they met every month, 10 people. I am obese. You smoke, I will help you, and then they meet every month 10 people with all the risk factors that you can send. Well, then this is randomized with a group that is individual approach. And just say, do whatever you want, okay? And this is the control group. And I'm just summarizing all the studies that we have done on individual and on group therapy approach because the results are very similar. One is more expensive than the other. Here is the intervention, everything goes great. Cholesterol drops, everything goes fantastic. Afterwards, something happened. It is a drop. Sustainability, forget it. We are not sustainable, all of us. We are not. We can change anything you want. After 2 years, you go back to where you were before. That's number one. So you have to reintervene. In our hypothesis, the reintervention will be, in a way, exponentially of benefit if you have intervened before. Okay, that's very important, and I have data on that. And the second issue is, what about the control group? Look at this. These are people that were controls. Why they did so well? Because of the culture of the place where they were controls, but other friends were intervened. So they learn about it, and they take care. So a control group that is close to the intervened group is fantastic. You have good results, much more than what you could expect. The issue of culture in an environment is the second aspect that we learn. So sustainability has to be repeated, and then the issue of the culture. So this fourth point is cardiovascular disease and risk factors. You can tell anything you want individually, you can do as a group therapy, but it's transient. So we have to keep in mind very clearly that reintervention is critical when we talk about risk factor profile. If you want to not become a neurotic and say, I am going to succeed. And what we have some information suggesting now, this is in children too, we have information suggesting that when you reintervene, the results are magnified exponentially. So that's the point. And the final thing is, what about genetics? Fascinating. What is more important in this disease, the genetics or the acquired risk factors, as I mentioned? Well, here you have the study that we did together with 55,000 people, the ARIC study, the Malmö study in Sweden. This is our study, bioimaging, people between age 60 and 100. And this is the women's study in Boston, health study. And we took 50 genes. And the question is, how many mutations are? These are genes that in the literature appear to be important in coronary disease. This is a large number of mutations, middle and low, and this was related to progression of disease and events. The same happened with the 7 risk factors that are conventional. More risk factors, 4, 5, or 6, more events. What was very fascinating, there was no relationship between the genetics and the acquired risk factors, except in diabetes type 1 and in familial hypercholesterolemia. Now there is something else, though. Most of the people who have a high genetic risk have also a risk factor that may be modified. And we have a subsequent paper a year later in which actually is when we drop in people with hypercholesterolemia and a high risk factor genetic profile, when we drop the cholesterol down, was a significant reduction in progression and in cardiovascular events. So there is no excuse to say, genetically speaking, I am in trouble. I will add something else, though. When we talk about genetics, we are very superficial. Because what we found that 50% of the people who have parents or brothers or sisters with the same disease, in fact, they say the same acquired risk factors that the individual we are seeing. My father had a heart attack at age 40. Was your father a heavy smoker like you? Oh, sure. Is this genetics? So we have to be very careful when we take a history in categorizing people about genetic disease. Be sure you control or you go over the risk factors. But there's something else that came from the study, and this is the so-called chip. We go back to the hematologist. The bone marrow is a defense mechanism, but the genes appear to affect these macrophages that leave the bone marrow. For example, of the 50 genes, TT2, if it is mutated, is big trouble. And this is called CHIP. That is, the macrophages are genetically altered. And here it is. Let me tell you about the Cantos study. Very simple. As the macrophage goes along an area that is somewhat suspicious, previous heart attack in a coronary artery, there is a call there. The person making the call is the macrophage that circulates and releases interleukin-1. You know what happened? It's devastating. This is a defense mechanism that tends to really clean the whole artery. And in general, the cleaning is too much, and you can provoke rupture, and you can get too much. You try to get these debris out with the interleukin-1, making these macrophages from the bone marrow to be aggressive, and it's too much. That's the success of CANTOS. You block interleukin-1. But there's something else. You know TT2? TT2, the gene I mentioned, is preventing this cleaning to be too far. So if TT2 is mutated, you are in trouble too. So today, two approaches is, can we interfere with the color, interleukin-1, this is CANTOS, or can we edit in the future TT2 that is mutated? I'm just giving you the sense of what is the research going on at the present time. Well, here you have, in the bottom, something very important, and that is, in the defense mechanism, you have a very good news with early fibrosis if the lipid cholesterol deposition is not significant and the risk factors are taken care of. This is one in green. Two bad news. The disease progresses, and then the macrophage gives up, and everything released, tissue factors, metalloproteins, cytokines, plaque rupture, and thrombosis. The defense mechanism failed because the macrophages actually commit suicide. And number three is the last one I mentioned. The macrophage may be good, but genetically it's not. So the motor engine is playing. And this appears to be a key risk factor in the elderly population. And that is the defense mechanism comes out, but is not appropriate, doesn't have the quality on that. So here is an issue that this paper that, again, we published 2 or 3 weeks ago has actually an editorial comment which is quite interesting. Basically says the marrow is evil. It can be defending you or can be betraying you. And that, to me, is a lot to learn about the future of pharmacology in this regard. And so this is basically what I'm saying. Cardiovascular events, the macrophages may become apoptotic if this is a problem, or the genes are actually altering the motor engine I am mentioning. And now I'm going to finish by saying to you that actually we talk about the risk factor profile between age 20 to 60. But what is the challenge between age 60 and 100? Your brain, the cognitive function. And actually Alzheimer's said long time ago, more than a century ago, my disease is a disease of the blood vessels of the brain. It was a pathologist. And the question is why the research has failed, because it has been focused completely on the neuron, not on the vascularity. Well, I want to show you some data, and this is a study that we have done in 300 individuals in which we look at brain function, new imaging of the brain, imaging of the large arteries, and let me tell you what we learned. First of all, you see the risk factors, as you know, can cause large vessel disease. I have discussed this. But then hypertension, hyperlipidemia, and high cholesterol leads to a cerebral hypoperfusion, which we measure with MRI technology. This is all new. We can measure flow in the brain. Not only that, the entry of glucose by PET is decreased. This is number 3. And number 4 leads to cognitive dysfunction. And in Alzheimer's, we believe this also can operate. Alzheimer's may be a disease of the neurons, but the vasculature may be an accelerator. And in Alzheimer's, in an animal model, we have found also amyloid beta is prothrombotic, and we see the clots in the arteries, which we can actually prevent, in this case, with the use of Pradaxa. I don't want to go into more details. Well, this study was not the right study because not everybody went through the 5 stages. Now the study that we have, everybody goes to one stage after the other over a 20-year period. But there's something else in the bottom. You see this here? These are new markers like troponin. For the first time, and this is this year, we have markers of brain injury, NFL, GFR, that can tell if something goes on with the brain, like troponins tell us if something goes on with the heart. This is fascinating. So we are now measuring not only the amyloid situation in the circulation, the measurement of tau or the measure of beta amyloid, but also the measurement of these markers to see when things are beginning that may be actually problematic. And this leads to the final comment. Everything I mentioned to you about imagenomics, new therapies that may come in the future by enhancing the risk factors, and goes into education. And this is what we do in children. We are dealing with 50,000 children around the world with randomized studies. That is, how can we prevent these children when they are adults not to follow the rules as we have not. And these kids with very small number of centers in the brain, they capture what you tell them between age 3, 4, and age 8. And this comes out when you are an adult. That's the projects that we are now developing, which I'm not presenting today. Summary. Later we are, my friends, this is where you are. Higher is the cost and less is the benefit. Earlier you go, higher is the benefit, lower is the cost. So I thought this presentation today, I presented to you 10 new concepts. 5 related to imagenomics in middle age, and 5 what's happening to the brain. Well, it's the fact of the matter is this is so exciting, and this I'm sure is important to you for one reason. When you see a patient that you're intervening, get obsessed about the risk factors of such patient. Because if you don't treat that, you are actually, I don't think the job is actually well done. Thank you very much for your attention.
Wow, that is always the highlight of our launch of our meeting with Dr. Fuster presiding. Thank you, Dr. Fuster. Physician-in-chief, mentor-in-chief, everything. Thank you. Thank you. May I ask for our live case panelists, please, to come up. We are going straight away live to Lab 2, I think, with Dr. Kinney. May I ask Dr. Rasha Alame, who is the interventional consultant, cardiology consultant at Imperial College, NHS Trust. We're so excited. Senior lecturer at the National Heart and Lung Institute within the Imperial College. Of course, the PI, clinical trialist, PI of the Orbita trial, rocking our world in PCI. Professor Frems, professor of cardiothoracic surgery from University of Toronto. Please join us up on the panel here. Dr. John LaSala, who we can't do a case without you, Dr. LaSala. So nice to have you, of course, and Dr. Bill O'Neill, Dr. Reitman, Dr. Gennaro Sardella, and Dr. Holger Thiel. Fantastic, incredible, and I think those were the 2 new faculty that I presented, and everybody else knows everyone here because we often have Holger and John and Bill. And Rino Sardella is a professor in University of Rome, and it's wonderful to have him, interventional cardiologist. Dr. Kinney, we see you live with Dr. Sweeney. So good morning. Tell us what you got.
Good morning.
Yeah, myself, Dr. Sweeney, I have Isha and 2 as our fellow, and the cath lab team. We have Will, Alina, who is a nurse, Pablo, who is a chief tech, and we have Keiski, who is going to be our imaging faculty. We just, got him on board, and then of course NP Derek Pineda. So if they can put the slides of case number 1 side by side. So this is a 65-year-old male who initially actually presented to an outside hospital out of state, angina for the last few months, with past medical history of hypertension, hyperlipidemia, questionable that he was not tolerating statin very well. And there the cardiologist did a stress test, very interesting, only inferior ischemia with normal EF. We had a cath there outside, which had shown moderate left main, but 3 vessel disease with a syntax of 35 or so. And he was advised to go and have surgery because of 1 vessel that was CTO, and we will show you the rest of the angiogram. Of course, patient declines bypass. He met the surgeon, then came to Mount Sinai to see if it's possible that he can have multi-vessel PCI. So when he first saw me, medication was very little. He was just on aspirin and statin. Subsequently, we started him on some cardiac medication. So here is the angiogram we are going to show you. The right coronary artery was a totally occluded vessel. He came here and we did two stents of the distal RCA and the mid RCA. And here we are for his right coronary artery. So if you see here, moderate left main disease, some dampening as we engage it. So we had to play, create some side holes in the left-sided guide. Circumflex, you can see that it's a mild disease and probably about 30–50% lesion in the LPL and OM2 area. But this is where we are, cranial picture of the LAD. So prox LAD, angiographically mild calcium, but significant calcium in the large size, moderate size diag. That's where we are, and a small ramus. And if you see the left main, not, we haven't engaged it, but we wanted to keep it like that to show that there was a moderate disease. So the residual syntax score after having done the right coronary artery is about 25 with a STS score that was very low. Today our goal is to do the PCI of the left side.
Can we work
if
to make
can,
sure that your
panel.
mic?
Yes.
No, thank you, Dr. Kinney, excellent. While we're having a discussion, maybe you can work on your mic because your audio comes in and out. So maybe they can do that. In the meantime, fantastic that we have a surgeon here. You saw this. This is a pretty complex anatomy, Dr. Frems. You're on the guidelines. This would be a class 1 indication for CABG. The patient declines. What are we supposed to do? What do you think?
Well, that's a great question.
Can you press down so you can speak?
Yeah. Hello?
Yeah, go ahead. Just press down and you should be able to.
Well, you're quite right. This would be a class 1 indication for CABG. In this case, the patient declined. Before he declined, I would make sure that he understood the pros and cons of both. But he selected PCI, and I think the cardiologist, the interventional cardiologist, tackled the CTO first. And if that was unsuccessful, then he may have been represented for CABG. However, the CTO procedure looks successful, and I'm not going to comment on how the PCI should be done in this case, but I think the order or the sequence looks appropriate.
Yeah, thank you, Steve. That's a really good point. John, you see this a lot. You're looking at this now, and is this mean it's an IVUS? I mean, to me, first and foremost, what's the role of imaging here? And we see, I think, Dr. Kinney's already going in with a rotational atherectomy into the diagonal, but is that for the left main? Is it really a must these days for imaging? And does it need to be? And I mean, it looks like she's going to take care of this. She's approaching the LAD diagonal. We're seeing it already. But what's your take on it?
Yeah, I think all of our PCI trials involving left main had such a low incidence of IVUS that it's really doing a disservice as to how we can maximize our outcomes. I think it's unconscionable that you would do a left main without having some sort of imaging, either OCT or IVUS.
Yeah, so I'm sure Dr. Kinney is going to plan to do that. Any comments, Dr. Thiel over there, Holger? How would you approach this? You see, and then we'll go. I mean, you see, we're already immediately moving towards atherectomy into that diagonal. I see it already. What do you think?
Yeah, it's a reasonable approach to go for atherectomy in this case. Honestly, I'm not sure if we really would have at first stage used atherectomy in this patient, but nevertheless, it's a reasonable approach to do it.
Rasha?
Yeah,
Sorry, I'm calling everyone by their first name.
Yeah, and that's perfect.
Rasha.
So,
can you press down so
yeah,
we can hear you?
So, I mean, I think it's a fantastic case. I think it's real evidence of the kind of stuff that we see in the labs all the time. My question, I guess, would be, is there any role for physiology here? We can see tandem lesions in the LAD. We know that the patient has angina and obviously 3-vessel disease, and this is a patient that would be outside of many of the trials, but I just wonder whether using physiology might help us just to work out which lesions in that LAD and the left main indeed are important to treat, and also how diffuse that disease might be and whether it would guide, our length of stents and what we need to do in terms of strategy.
Fantastic. Dr. O'Neill, I can't leave without having your comments, and then we'll go to Dr. Kinney.
Just to add something, the other possibility is to do a robotic lima and then treat the other arteries with PCI. I think that kind of is, we always talk about PCI versus cabbage, and I think with centers with expertise, that's a really wonderful strategy which minimizes the invasiveness, which is probably why this patient turned down bypass, but does give him the longevity of a lima.
And by the way, John Puskas does perform those, but it seems like this patient has denied any kind of an open or even a robotic procedure because I'm sure it was contemplated. Dr. Kinney, tell us your plan.
So our plan would be, based on the angiogram, we knew that severe calcium is mostly in the diagonal, so we decided we'll do rotational atherectomy to the diagonal and then decide what to do with LAD, but we did imaging. So if you can show the, this is a diagonal. If you see that it is about 2.25 to 2.5 vessel, come proximal. So as you come proximal, you start seeing severe calcium, almost 3-quadrant calcium, which goes with the angiographic finding. Initially, we decided on 1.5 bar, but then after having seen this again, we went down, we took a 1.25 bar. And then the LAD we did imaging was mild calcium. So I think we have decided we'll just do, score flex or any kind of a just mild calcium.
And that osteal left main looks
and significant. Go back to osteal left main.
That's really
this is where we are. Yeah. 3.9. Yeah. So the way we plan is that we'll do rotational atherectomy of the diagonal. Then we will wire the diag. LAD, we'll do the cutting balloon of the LAD and left main as we are coming out, balloon the diag. And we'll do dedicated 2-stent technique of the LAD diag. And then we will, stent the left main and of course optimize it and then do imaging at the end. So I have a 1.25 bar there. Just we are going to go back in again, going into the left main.
So do you want to comment a little bit about the sizing of your burr? Because I think that's an important teaching point for our audience. So imaging actually changed your mind. So it was good to image, to go to a smaller burr size. Do you want to talk about that a little bit?
So, yeah. So what our current strategy in the severe calcium, the rotational atherectomy rota bar is just about 0.5 or so. And if you see here, I think 1.5 probably would have been better. The 1.25 just what I say
I would have chosen a 1.5
across. Yeah. Dr. Sharma wanted 1.5. I said 1.25. Probably we should have done 1.25. Okay, so it just moved along. But we have 1.5 bar also if you want to just think that we want to go us with 1.5.
Well, let's get to that point. We now have a lot of devices for calcium modification. Dr. Sardella, Reno, tell us, what's your take on that?
Thank you, Roxana. I think that it's mandatory to perform imaging. Now, at the moment, we have 3 devices, shockwave, rotablator, and orbital atherectomy. I think that to assess the calcium burden and how is distributed the calcium on the vessel, I think that it's mandatory to choose the better device. I think that in this case, it's the good choice, the rotablator, because it's a very concentric calcium, and to start with 1.25, I think that it's a good choice too, because I'm used to make a step up of the bar, starting with the smallest, except for the vessel more than 3.
Do we do 1.5?
Any other comments? Anyone would use shockwave or
I think you got it.
the CSI device? John?
Yeah, I think we're going to discuss this a little bit in some of the noon breakout sessions on atherectomy. Try to give us some algorithms on how to work through this. Obviously, there's more than one way to do it. CSI would work fine. I favor more rotablator, but certainly CSI I think would work well. We do a lot if, I know it's a little more expensive, but if you see that you've created sort of a pilot hole when you have really dense calcification with an atherectomy device, following up with something like Shockwave, if your NC balloon does not further fracture it, is a pretty reasonable alternative. And this is the reason for having these kind of algorithms and the necessity of using imaging both pre, during, and afterwards, because it allows you to go down that pathway to take advantage of the synergism between the devices.
Dr. Reitman? Governor-elect of Georgia from the American College of Cardiology. Welcome.
Thank you.
Is ScoreFlex ready?
Not working. Sorry. Better. I think what's most relevant is what Dr. Kinney alluded to, the fact that the LAD proper didn't have that sort of 270-degree arc of calcium, which a lot of the shockwave literature seems to support. So I think that that's beneficial and leads us, sort of down the road of using primary atherectomy in the diagonal, and then going about it with our usual bifurcation techniques.
Wonderful. So, Dr. Kinney, you seems like you're done with your with your ablative, and you're bringing in a buddy wire into the diagonal. What's next?
Yeah, so no, I think I agree with all the panel discussion. The question was, should we have done rotational atherectomy versus orbital atherectomy in the diagonal once we know the calcium is severe, which is more than, this was almost 3 quadrant there. Yes, either of the 2 devices would have been okay, but we chose rotational atherectomy. But definitely for LAD, even angiographically as well as on the imaging, since there was not a lot of calcium, there's no indication for any kind of atherectomy. I think I agree with Dr. Lasala, who mentioned that, of course, people now will say after we have done rotational atherectomy, there are 2 ways of handling. Image it, okay, and see what rotational atherectomy has done, and then decide if you need additional you can consider either IVL, go, IVL,
going up,
or you can do other way of doing it is that you can just do with high pressure balloon first, and if high pressure balloon you see the lesion are not dilated, then you can again consider maybe down.
It looks like now you have the cutting balloon. What size did you choose? 3.0?
So this is a 3.0 10 millimeter ScoreFlex.
Okay.
So we can go high pressure.
And we see it dilating nicely.
20,
it looks like it's really expanding.
22 atmosphere, yeah.
That's at 20 atmospheres.
So he said he went up to 20 atmospheres. Now give me the diagonal. So I can use this same balloon to the ostium of the left main. We know we are going to stent it, so I will get the guide out. Yeah, down.
So what's your plan for this bifurcation lesion? So we have a calcific bifurcation and an osteal left main. So it would be interesting to note. And before you tell us your plan, maybe I can hear from the panel. Rasha, 1, 2 stents.
You get the ostium.
So, I mean, I think now that we have modified the diagonal, we're committed to a 2-stent strategy. I think in terms of size discrepancy, it kind of takes you away. The diagonal looks smaller than the LAD. So I think I'd be thinking probably, mini crush might work well. Perhaps, I think we'd have to go away from techniques like the colloque, because there's definitely a difference between the 2 sizes of the vessels.
Excellent. Holger, 1, 2 stents.
No, surely this is a 2-stent strategy in this situation, because it's calcific, and she already has done some rotablation in the first diagonal branch and as well a PCI in the LAD. So this must be a 2-stent strategy.
Reno, you're on the bifurcation club.
The bifurcation, first of all, I think that rotablator you can avoid the plaque on the side branch. I think that for this reason it's a good choice too. I would start with a provisional stenting and after rotablator to see if something is changed in the angle of the side branch, because sometimes happens that the rotablator can change the angle or can change the distribution of the plaque. And then I will see, but I would start with a provisional stenting.
Interesting. 18. Anyone else endorse that? Because I would say 2-stent, but John?
20.
Done.
Yeah, I think you're a little bit too far down the line to go with a provisional stent. I would agree with the approach that Dr. Keeney's taken right now. I'll cite Dr. Sharma's data from the mid-90s that the likelihood of losing a side branch is directly related to how much plaque there is at the ostium and inversely related to the size of the vessel.
I think go to 225.
That the percentages go up dramatically when it's a small vessel with
But
a lot of
22538
disease.
does not come, right?
Many times that will mitigate as to how I approach a bifurcation, knowing that there's a high likelihood of compromise. I'd more commit to a two-stent strategy.
Yeah, and that's good. And I'm hearing you thinking about sizing. So, Dr. Kinney, it seems to us that you're going with a two-stent. Is that right or no?
Yeah, that's right. I think that was an excellent discussion amongst the faculty there, saying why provisional stenting. I think you can see how the bifurcation club, we have a bifurcation club here in the United States, recently started by the SKY by George Dangus, a big group of people. Of course, the European Bifurcation Club people are also part of it, but always the teaching has been that provisional stent, provisional stent, provisional stent. But there are certain cases when you want to say that you want to do dedicated
Why are we seeing an empty room?
Technique.
Go on, yes.
Yeah.
We're seeing an empty room. We want to see you.
Promise.
Okay, you can see.
22538.
Okay, 2538. So, dedicated two stent will be, side branch is large, side branch a significant disease, or side of, they always mention about the angle, which is less than 45, more than 70 degrees, or the length of the lesion. The length of the lesion here, if you see here, almost 30 millimeters, significant side branch. And this is a, moderate to large size diagonal. So based on all that criteria, it's better we go with the upfront two-stent technique, which I think majority of the people agree.
So before you show us your two-stent technique, our video is showing an empty cath room. So please tell your videographers to show us there we go, thank you. But I'm seeing it, oh, there it comes. Okay, excellent, because excellent. So tell us exactly what, did you choose a 225 for that side branch? I'm hoping not. You will post dilate.
No, we are taking a 25. We are taking a 2538 to the side branch.
Good.
Of course, we don't have a 48 25. Doesn't come with a 48. Then we are going to take a 30, 20 to the LAD. So we will do a mini crush technique of the LAD diagonal. Once that is done, we will recross KISS, and as we are coming out, then we will stand the left main. Yeah.
Do you think you're undersizing for that LAD? What was the size of the vessel? I never want to think that a 65-year-old man has a 3.0 proximate LAD. No, I'm always thinking it's a 3.5. But, you had the imaging.
2.7, yeah, no, that's not the thing. After the septal, come proximal.
The distal reference is actually smaller than we thought.
So distal reference is 2.5, but I think at the level of the septal, look at that, what we are getting, 2.7 max we got. That's stretching.
Okay.
Yeah.
That's kind of surprising.
He's no history of diabetes. Hemoglobin A1C is well normal in this guy, but behaves like a diabetic vessel.
Yeah, it's interesting. Okay.
So they can play the video of the mini crush technique, non-left main disease.
So you're really covering the entire disease segment, very long stent in that side branch. So I hope you get a really good result there.
Yes,
and
I can tell you he's on clopidogrel. On clopidogrel, his PRU today is 60. Because one thing for sure, somebody with multiple stents, I think already discussed by Dr. Sharma in this kind of, no high bleeding risk, but he's a guy who could probably do with some, intense
more potent agents,
but I think if the PRU is already that low, we don't want to go to a potent agent. Then definitely there's a risk of bleeding.
John has a comment. John?
Yeah, I think it underscores a key thing that for those of us who thought that we're so good that our eyes were instantly calibrated to what the appropriate diameter is and the length, they were constantly readjusting as a result of IVUS and OCT. Whether it's usually it's a larger vessel than we think, and it's always longer than what we think. So we've been missing a lot of these over the years, and for those who don't do it routinely, you're still missing it.
Okay. Okay, good.
Can I just
okay,
ask,
ready? Take a picture.
On
So
what basis
you can, is a video playing by the side?
Go.
Just the length of the LAD stent, because the LAD
Yeah.
looks quite diffusely diseased, and I just wonder
Yeah.
whether...
So do you think your length of your stent in the LAD is appropriate, Dr. Kinney? I'm thinking you need a little bit longer than that.
Okay. We could go longer. I actually wanted 16, but your IVUS measurement said 19. I would have gone.
I'm thinking 23.
24. Give me a
24,
275, okay? Because distal is not big. 24. So we will go larger in the,
And
longer
then
in the LAD.
you'll just plump it up with a bigger balloon, I think like a 3.0 at least, or maybe even
When
a
we
3.25 balloon.
when we are going to do the final KBI, definitely it will the proximal will
Bill,
be okay.
you have a comment?
Yeah, I think that we've done a wonderful job of measuring lesion width with IVUS, and our eyeball is terrible for that. Similarly, lesion length is terrible, and here in this case, you kind of wasted one stent. So I think a tool that would measure lesion length, I'm working on one, so that's a conflict, but I think we need something simple to measure lesion length for these cases.
Yeah.
Rox, why you didn't perform a DK crush?
Yeah, so good question. I think a lot of people are mesmerized by DK Crush and its whatever those superior results from the work that Shalin Chen has done. But in our lab, we feel like we're getting excellent results with imaging, even doing this mini crush and not really going through the difficult, long journey of the DK Crush in most of our cases. So, Dr. Kinney, maybe you can tell me, you have an app that helps us with bifurcation in your bifurcation app. Would your bifurcation app tell us we should be doing a DK Crush or a mini crush here?
So our bifurcation app actually, if you take about that, we will talk about a DK Crush mostly in left main, non-left main also. We always say left to the discretion of the operator. Now going back to the DK Crush 5, how the study was done. So they had to have, people have already done over 100 left main PCI. They had to do DK Crush steps and over 30 cases or so. Only when approved by the committee, they were allowed to do the technique. So it's not an easy technique to be done. And we are showing you how the same thing could be done, okay?
So can you go over these steps with us just now, what you just did? So you place the stent into the, go through step by step, because that's what we promised our audience.
Yeah.
Good. So we place the side branch stent. Yeah, we side branch stent first. Once you place the side branch stent, you go to the main vessel, place the main vessel stent. You make sure 1 millimeter. So actually when you're doing mini crush, we are actually talking with micro crush, which means just a millimeter of the side branch stent is sticking into the main vessel. Once you are happy, then we deployed the side branch. Once you do that, the SDS comes out. You just give some dye, make sure there's no dissection. Once that is done, you remove the wire. Never leave the wire in the side branch. Once that is done, you remove the wire and then you inflate the main vessel. That's what we did. We did the main vessel coming out. We'll take a picture now.
And now you come with your side branch.
Yeah. So everything looks good. So far, everybody's, you see that the lesion is covered. So now my side branch wire is still in the guide and I'm going to try to recross.
And you've already dilated that left main ostium with your cutting balloon, so things are looking pretty good and hemodynamically very stable. We see the hemodynamics in the side there. Everything is looking good.
Dr. Keeney, would you do
any questions, any comments?
Dr. Keeney, would you do a proximal optimization first before you cross?
For non-left main, I'm not a fan of doing a pot. I think we can show some papers side by side, especially the ProPOT trial that was just came out. They did OCTs. And in fact, when they did POT, they saw more strut of the OCT covering the side branch, saying that compared to just doing a kissing balloon. This is something I was a proponent of having said that for years together. No, this is one thing, yeah. And now I'll try to recross the side branch. And also we have our own paper that they can also show side by side where we do so many bifurcation. So we compared OCT with the endothelial flow, which we did. So cutting below, KBI versus a pot, no difference. Because what is the biggest thing people say? Now we recrossed with the same filter wire that was in the guide.
That was a beautiful
biggest
rewiring
thing what people,
through, you know, only in your hands, Dr. Kinney. Beautiful. Make it
Thank
look
you.
a little bit harder.
Any special wire you favor? Any special wire do you favor, for Dr. Kinney, on that side branch reentry?
Yes, he make it a final.
Yeah, the side branch, again, there's you know, question what they would like, but we always like polymer jacketed wire, whether it is fielder or whisper. I'm a fan of fielder. Dr. Sharma is a fan of whisper. So it depends. And what we say, there's always, many people are worried when it's a polymer jacketed wire that they will be worried because there are reports to show that a polymer jacket can be stripped off. But that's only if you leave. Give me the LED. If you leave the wire in the side branch, which we did not leave the wire in the side branch. But if you are doing provisional stenting and we want to leave the wire in the side branch, we still use the polymer jacketed wire, which we just said. And usually they keep a memory, you see that? So we leave it in the guide itself. You don't have to remove it out. So you're shortening the steps.
So are you going to do a little post-dilatation more distally before you do the, with that balloon in that side
No,
branch?
I think with the vasodilators should take care of that. And what we will do is now we have a 3O
in the
NC
distal end
and
of
a
the stent,
2,5
I feel like it's not
yeah.
fully dilated yet.
So this is a hissing.
So
Good.
tell us the sizes of the balloon you have, the 3O and a 2.5, right?
So, yeah, 3O and a 2.5. So remember for the LED, we took a 275 stent. Distal vessel we thought was 275 even based on, so I'm going to pull back. So when you're doing this, go up for the diagonal, high pressure, 16, 18, to make sure the ostium. Good, okay. And now LED, individually we go up and then we do the kiss. And when we're doing kiss, we'll go moderate pressure, maybe 8, 10 atmosphere, that's it.
18.
Good. And John, I know you asked a question, and while we are imaging, you can see it, that we have done so many cases with the mini crush technique without pot, and while you image, you will see the proximal edge is go up with the both 8 atmospheres.
Yeah, I was actually kind of setting you up for that.
Hold on.
And you answered it well.
Down.
If you're,
So we can see it. Yeah, go.
if you're IVUSing and you don't have this huge malapposition of the stent strut,
Yes.
you're right. You don't really have to do the pot.
Good.
Okay, down. But you are true. I would not say that do not do pot for non-left main in every case. Like Rasha initially mentioned, that if there's a big mismatch, that you have a 4O LED and the distal vessel is 3O, 3.5, you're placing 3O stent, 3.5 stent, and the proximal has to be optimized in that situation. But here, everything looked okay. So we'll take a picture now. If you want, we can image and then we'll image the main vessel so you can see that IVUS. Or I think we can put the left main stent. Are they ready in the other room?
Maybe some vasodilators for that distal LAD as well. It looks like it's a little bit, you know, and maybe you'll do some nice imaging. Arthur, did you want to have a comment?
I think that one of the most important things we've moved beyond, which is, yes, that optimization of the carina, the stent size, all those things, but vessel preparation, which Dr. Sharma and Dr. Kinney spent so much time emphasizing when we were in training. I think the principles are the same, and it allows you to accomplish a result like this. Vessel preparation, first, second, and third, allows you long-term durable results which are superior to sort of not taking care of it from the get-go.
One other point too, that most of these people that you're doing multi-vessel stenting on have diffuse disease. There's no normal reference area, so you can become over-exuberant as well in trying to stent the entire LAD, which I never recommend. Mm-hmm. So what you want to do is find a reasonable zone that has maybe only modest disease and not significantly narrowed. And that disease downstream at the present time, there's really no benefit to going after that.
Too long.
So sometimes you have to restrain your enthusiasm too based on what you see.
Now, what is an ideal?
Yeah, I was going to ask.
You see that ostium is fully covered. Yeah, some die.
Yeah.
You don't see the ostium. Okay, this I think the ostium looks good. Yep. Same. I'm just going to pull back the guide.
In terms of length of that left main stent, it's difficult, isn't it? Because either you just cover the ostium and keep it short, or you join them up.
Remember the body. Yeah, good. Okay. Yeah. So the body of the left main was okay. We didn't want to cover the bifurcation. This guy does have a disease elsewhere. Down. Okay. So we will. Left main definitely needs a post dilation.
Do you have any comments about how you find the ostium of the left main? That always seems to be a problem in terms of getting it in and not missing the actual ostium.
No, really important.
Excellent question.
Did you hear that, Dr. Kinney, about the ostium and how we've got to be very careful about not missing that ostium? So what are some of your tips and tricks?
We will image it and show how we got it right. I will tell you. In the cranial view is the best view actually. So whether you want to go a little bit RAO, straight AP cranial or LAO. Here we went little LAO to see it. So take a picture. And then to make sure it is fully covered. So in this view you see that? Does not look like that way. I will go another view. LAO cranial. Okay, no. Good.
It always looks worse when you fix the proximal part. Again, that's
yeah.
You have to decide where you want to cut.
So the way the left main is taking off, you see there you will have few struts sticking out in the inferior part of the left main, but definitely in the superior part it is up to the ostium, and you can see one strut sticking out.
So you're going to.
So we'll do the imaging right now. Yeah.
One trick I like to use, since you've got the IVUS down there anyways, is to use the transducer site on the IVUS to mark where the ostial of the left main is, or any other spot for that matter, but for the ostium of the left main.
Right, while you're imaging before you're...
So in there, just take a picture when you're right there, and don't move anything after that, and use that as your reference spot.
It's a great tip. And any other ones?
I think Dr. Kenny's also demonstrated, although she does things so quickly, but she's demonstrated how she's been manipulating the catheter back in over the balloon, because we see so many times those ostial left main stents get damaged by us going in and out with the catheter.
That's right. Really, really important point.
Yeah. So, Rasha pointed out an important thing. Yeah.
Is there going to be a second case, because we're getting close to the time of...
Yeah.
Because
no, there's a second case. They're ready in the other room. You see the IVUS and you go. If needs proximal optimization of the left main, I will do that. But to me, it looks like it's fully opposed, even the left main stent. So just to finish, our total contrast volume was 130 cc with the air karma of 0.8.
I feel like you could squeeze that a little bit more, the LAD stent, that proximal.
Come to the bifurcation. Now it's a native. This left main bifurcation. This left main is not covered.
Really
the body is normal. Yeah, this is the edge of the left main stent. Looks perfect. It's coming. Expand it. Come to the ostium. Yeah, stick to the aorta to cover the lesion.
No, there's a couple of millimeters into the aorta. But it looks like you have a little bit more optimization to do in the LAD diagonal from my look. But let's go to the other lab. Is that okay? You've done an amazing job. Thank you, Dr. Kinney. Beautiful.
Thank you.
Yeah. All right. Dr. Sharma, you have 10 minutes to do a complex case. Let's go.
Wow. But we have one more case?
Yes.
No, we have two. Yeah, good. Okay, now 10 minutes, okay. Why that much time? But I'm so happy that we got a good start. A lot of imaging, lot of discussion, and hopefully we did part of it already, and we'll have a discussion here. So can you hear us very well?
We hear you very well.
Dr. Amit Huda on the right side. My fellows, both of them are here, Mayank and Shiv, and our cath lab staff. Those very common familiar faces, they all are here to facilitate this tough case. So this is a patient. If we make a slide number 2, live case number 2, very quickly. This is a patient, actually 54-year-old, multiple risk factors. On the left side, as you can see, the end-stage hemodialysis, diabetes, heart failure. Ejection fraction is between 25 to 28%. For many years were presented with exertional dyspnea and angina and as a positive stress test. So basically, patient had multi-vessel disease few months ago, and then at that time had a discussion, you know what we do on these cases. Classical optimum type of patient, multiple high risk. You take the patient out, let surgeon see the patient, and after the discussion, half of them will decline surgery, whether surgeon or the patient or the family or the cardiologist. So basically that time, 3-vessel patient had a stent in the OMR, ramus and RCA, and now here for the left main, distal left main bifurcation, which is the calcific nodule on angiogram, and we'll show you the OCT on this case. So with that note, let me take you through the angiogram now, although just appropriateness. Go to the next slide so we can complete from appropriateness point of view. Where's the clicker? Oh, sorry. I have the clicker with me. Good. So this is basically clearly patient has STS. Always we calculate STS as well as syntax score in this particular case. STS is 2.8 and syntax of 30 and appropriate after the heart team discussion. So yes, high syntax score, but because of the heart team discussion is appropriate as we made a point on our recent guidelines. With that note, if we can go back to our angiogram. Now let's see, this is the crux of the matter. This is the case. You see the left side, see the chunk in the distal left main. Shadow. So well, is it a thrombus or what? You see the eccentric view, look at that. Big chunk of the distal calcium and the ramus stent is good. This is the ejection fraction. EDP was 28 and EF is still about 25. They did an echo this morning also. Patient has been in flutter, was on warfarin, which have been stopped 2 days, but they wanted to confirm there is no LV apical thrombus. Echo, the point of care echo showed no LV thrombus, but bad LV, and right coronary stent remained good. So that's where we are. Because of the low EF, high EDP, we are going to a complex intervention. We decided to go with the Impella CP, and in the same one, if we can show with the camera, make a puncture. So single access. If we can show this camera for the groin, that single access, which we say, the vascular complication in our recent data of the PROTECT 3 and have gone down, and largely because of the single access. Can we focus the camera on the groin, please?
We still don't, yeah, there we go. Now we see it.
Yeah. So single access. Now single access key is that you cannot go through the same diaphragm, same puncture site of the Impella catheter. Had to make a separate puncture in the diaphragm, and that actually has been very important. When 5 years ago, we did a live case here, when we went through the same patient bled. So you cannot go to the same hole of the Impella. You have to make a separate with the puncture, and then you can accommodate 7 French. So this is a 7 French Impella patient, hemodynamically completely fine. So what we did is, just to understand this mechanism and knowing that we want to make imaging, what I would have done differently is a different story, but as a part of the educational, and there are a lot of the fellows are there, and the budding fellows, and they really want to see what exactly it is. So we did the OCT from the left main to LAD and from left main to circumflex. Yeah. So with this, and we'll show, this is there, and then we did in the circumflex. It easily went, right, Amit? Yeah. So let's go to the OCT findings. Let's show the OCT screen, and whatever the OCT gurus are, comment on it, what it is. First, we are going to show you the LAD to left main.
Sure. So this is a fast forward LAD to the left main. So now we can see the calcium protruding inside. This is at the bifurcation of the left main. So this is a proximal LAD. We can see the 2 quadrant chunk of calcium. If you go to proximal, it's 3 to 4 o'clock. There's a protruding calcium.
There is a protruding calcific nodule.
Yeah.
Huge calcium.
Okay. Show the circumflex. I think circ nodule. Yeah. Huge calcium, but circ to me, if I had to make a diagnosis, I would say bigger nodule should be in the ostial circumflex. Sure. Let's see.
Yeah, little wire movement because of angulated circ. Yeah. So from the distal come to the proximal. Yeah, I see. Yeah, here's also some because of the guide wire artifact, we cannot see behind, but I saw the nodule here also, well delineated and signal poor and protruding inside. This is also the protruding cousin from the sac to the left main.
Okay, so there is a calcific nodule. So with that note, we did a 2 bar. Let's go back to our angiogram.
Before you show that, Dr. Sharma.
So we did a 2 bar into the LED. Yeah.
Dr. Sharma, I know I said 10 minutes, but really we want to learn something here. So let's make sure we discuss a little bit about the choices here. This was a dialysis patient, 54 years old.
No, I know, but let me just.
Let's do that. Let's just talk about that, please, for 1 minute, because we have this amazing panel, and there's going to be a lot of great debates about a case like this. Does it need LV support for this high-risk angioplasty? We're going to have the two debaters are actually sitting on this panel, and we don't want to give that away because we can't wait to watch this debate. But certainly, we really, really want to talk about this. It's a 54-year-old man. CABG was denied by the operator, by the heart team, Dr. Frems. So you're good with that, right, Steve? Would you take that in University of Toronto?
I think in this patient we would have been pushed pretty hard to operate on the patient. He's in his 50s and it's a trifurcation lesion in a bad LV, so I don't think it's an ideal PCI case. And it's right, the surgical risk is higher, but it's not too high. I think it's high for medical reasons, not for graftability.
No, absolutely. I think the distal targets are great. That's why. That's why the heart team. That's why Dr. Sharma put the patient into but our surgeon said no. So, okay. So
they quoted. Now let's find out what is the risk their project based on this, because our surgical risk, although STS was barely 3, surgeons told him 10% mortality, 30 days. So that is why patient said no. That's the question. I want to just put that word into it. Again, this was not decided on the table. Patient came out, had a discussion. We want to send this patient to surgery. And this is the same way that like an optimum trial, every patient had that discussion with the at an outside matter, not on the cath table.
No, it's really important
in a controlled environment. Yeah.
Because I think it's really important that at Mount Sinai, we really, really employed the heart team approach. And I think many people are, oh, you have such a high volume, you must not be talking at all. And we really do. And we work very closely with our surgical colleagues and love working with them. And we do have this great heart team. So here we go. Now it's a PCI. We've got this huge calcific nodule. But before that, we have a low EF, huge calcific nodule sitting right there in a 54-year-old man in that bifurcation lesion. Holger, you don't think we should be using LV support, and would you use that in this patient? Because I know in Germany you guys use a lot of this Impella guided stuff. So tell me what you would do here.
So maybe because we have the debate later on, I have to defend my position. But nevertheless, this probably would be a case where I would select left ventricular support, because this patient has really a reduced. Reduced left ventricular ejection fraction. But I will show you the data later on. So what you are doing currently in the United States, probably this is some kind of overuse, but this probably is carefully selected case where you should do it.
Does anyone disagree? I mean, Bill, I'm not going to you because I know what you would do, but does anyone here disagree? And Bill, do comment, because your comments
Roxanne,
are so important.
I love this course because it's the beauty of actually showing patients and not just p-values. I mean, p-values are wonderful, all right? I like them. I've lived with them.
Yeah, don't.
This is a real 54-year-old patient who has no p-value. And using rotational, whatever you do, you want to take your time with these really high-risk patients. And you can't rush. To do it right. So that's so I completely agree, because the rotational atherectomy is going to impact the left main and cause basically global ischemia, which is going to cause this patient to have severe hemodynamic compromise.
But, you know, I'm just going to say that, you know, we'd call it rushing, but when you're with Dr. Sharma in the lab, it feels like it's always rushing, but it is like it's his slow time with the LV support. John, Rasha, anyone, any comments before we go to we use a lot of rotational atherectomy. I don't think we need to talk about the LV support. I think everyone here endorses that, unless someone doesn't. Anyone here? No, everybody thinks yes. Even you, Reno? LV support?
So I love rotablator.
So let's come back to
rotablator. But maybe Impella mandatory.
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 Okay.
Maybe shockwave in this case.
Maybe shockwave.
Maybe
Anyone,
shockwave.
and you see the rotablator is already sitting in the guide, and we're going to let go to it. But anyone else doing anything different? Rasha, IVL?
I don't know. I mean, you might have a good result, but we've seen some data that calcified nodules in AVL, you know, we get some good results, but it's a bit unpredictable, I think. So for me, I think it'd be rota up front.
Rota up front. Anyone? Any other? Arthur?
The only thing I would say is from the Excel trial, the greatest likelihood, the greatest problems tended to be in circumflexes like this. So this may be an excellent rota shock case because of the eccentric nature of that.
We'll talk about that. In our institution, we're doing a rota cut trial, so that's another exciting thing. Dr. Sharma, did you want to say something, Rasha?
I was just going to say, I mean, the one value really for shockwave is that you could at least have your second wire in and have the protection there of both vessels protected. So that's the only thing that would steer me in that direction.
Okay, great point. Dr. Sharma, you're back on. Sorry, I wanted to make sure we had that discussion.
Beautiful. All right. No, good. No, actually, listen, I enjoyed it. Not only that, even before coming on now, what we are going to show, I knew all our panelists going to say. And guess what? First we did, this is the 2O bar or the LED. You can see here, 2O bar. Vessel size, as you saw it, 4 millimeter LED, circ is 3.5. So then we did good. So brought the same wire and same 2O bar into the ostial circ. So every time, actually LED took only 15 seconds. Circumflex needed 2 turns, about 40 seconds. And then we did a cutting the score flex 4.0 for the LED because still wanted to get a bigger lumen. And now we said before we go on to the circumflex, combine with the IVL. That's what I'm listening to our panelists. So we are ready with the IVL. I said, let's see what IVL is going to make a difference beyond the rota which has done.
So you randomize the vessel. One got a rota cut, the other one's getting a rota shock. Is that right? Yeah. You randomize the vessels.
Shock will get later. Yeah, that's it. So this one we are going to show after IVL. If somebody can show the OCT after rota before IVL. Show it now.
Yeah. So now it's at the level of
in the circumflex now.
Yeah, left main bifurcation. I can see the ablated nodule calcification at the 12 o'clock. This is the ablated calcium by the big rotor, but still huge calcium burdens here.
But so, did it make any difference in that nodule size? Did it shave it a little bit?
Yeah, nodule shave here.
Shave.
Yeah.
Okay. Let's see. Now we are ready with the 3.5 IVL. And Roxana, for that time, what I'm going to do is, we are going to do IVL of course, will become rota shock of the circ. We'll do the OCT. Then you can go on your lecture, put us on the side, because after that, we'll do a mini crush again, same. At Sinai, we do 95% mini crush, 5% DK crush for left main, and very, very happy with the results.
Fantastic. So let's see what you're doing now.
Yeah. Okay, so this is the 3.5.
What's great about all of this is that we're
atmosphere.
doing all of this, OCT, rota, rota shock, rota cut, all these things in the left main of a 54-year-old man, and no one is hearing a beep about the patient, hemodynamic compromise, etc. I mean, I think that's the reason maybe why we are really, in the right patient, the LV support is really, really crucial in doing precision and well done PCI. This patient deserves the best PCI that he's going to get, and we're seeing that here.
Beautiful. No, I really love the comments and appropriateness. I mean, again, sometimes we may do over, but this case needs it. As Dr. Bill O'Neill said, this is the case if anybody needs it. And Thiel also said that anybody needs, this is the case you need, because you get no room. In this case, you want to be ready with your all full armamentarium. So we went to 4, do a pulse, go down to 6. I moved a little bit, and you can go up to 6, and then before deflating, go to 8 because it's a big vessel. So anyway, just do 3 pulses. I think will be good enough here. And we are going to do OCT as we mentioned, and after OCT, we'll see how much additional shaving or cutting or cracking of that calcific plaque will be done with this combining rota with the IVL. Okay.
So everyone in the audience who may not have heard of IVL, this is intravascular lithotripsy, and ultrasound waves that are being, basically applied to the lumen and to the plaque.
Through the balloon.
And breaking up through the balloon, breaking up that plaque and allowing for a better dilation and a better stent dilation in these calcific lesions. So that's what IVL is. It's a newer technique, but it's been around for a while, and it's picked up a lot because it's just like a balloon. You don't have to be worried about that rotoblader and the rotowire and the machine and all this other stuff. So it makes it a little bit easier.
And you can check multiple.
But the unpredictability is one thing, and I think we need more and more data. I don't think we have to continue to watch that. Arthur, did you want to say something? I saw your finger up.
No.
No?
I was going to say that obviously you can protect multiple.
So now you're going to show us OCT in the circ. This is amazing.
Yep, and Arthur.
Russia, who says we don't image enough here?
Shock. I can tell you, I didn't prompt Arthur Reitman to say, but he's the one, he said it. But I would say, OCT, what is happening with the OCT catheter? Huh?
Well, it underscores something else too, that lesion prep goes beyond just the first step.
We are there.
That's right.
You're doing atherectomy and you're doing another preparation before
you
you get down to the point of actually stent deployment. So whether that's done with IVL, which works very well, or in this case is a cutting balloon, you're not done.
The catheters, you see that now? Very interesting. We are going into the circumflex wire. See this? And then I have the guide, and looks like to me that catheter.
It's not really going.
No, it is going into the LED. See the proximal end? Why? Anybody can tell?
Why is that happening?
It's hard to close.
I'm sorry, what?
It's hard to close after it's bent. It's a very fragile catheter. So we can open other one.
Okay, listen, catheter block, please. That's enough. For Sharma, one OCT is okay. 2 OCT will get toxicity. Let's take a picture. And I think we just put a
we really appreciate you giving us that show. We know you're not going to do this all the time. At least at the end of the procedure.
Yeah. So we make a new catheter by the time, and you start your lecture after this angiogram.
Yeah.
We see that.
Show us this angiogram because we have our wonderful.
Okay. Good.
Wow.
So far, all vessel looks angiographically good, and we are all set. And you go for your lecture, and you'll see us on the side.
But you see the difference here, though, between the two.
Mini crush, and then we'll do the OCT in the end. Yes.
So I want to know, what are you doing? A V stent here? What are you going to do? What's your stent?
No, mini crush. Mini crush. Because remember, there is a little plaque in the distal left main. So we put our plan is, Amit, tell us what the plan is.
Don't lose that intermediate lesion while we're out, okay? Behave there, okay? All right, good. That middle lesion, the ramus is big.
4 of 15. 4 of 15 in the LED and 3.512 in the circumflex. We'll do a Zyme. And we do mini crush and post dilate with a pot with a 4.5 or 5 proximally. With that note, I'm okay. And you continue your lecture.
When we come back, we want to see the final result, Dr. Sharma. When we come back and watch that ramus.
Yep.
Okay, great. Thank you. Thank you.
Okay.
All right. Thank you so much. Beautiful work. Thank you to our panelists. Thank you so much. It is really indeed a huge pleasure for me to introduce our first speaker in this next session. Our next session is very much devoted to imaging. You saw today how imaging is so very, very important. And there is one woman who has done more work on imaging than any of us combined in this room, and that's Leslie Shaw, endowed professor here at Mount Sinai with an incredible track record, over 800 publications. She's the director of the Blatnick Family Research Institute. She's in Department of Medicine, Population Health Science, and Obstetrics and Gynecology. I mean, she is incredible. I call her my colleague, my friend. And today, we are going to the world's expert is going to be talking to you about CCTA, with or without FFR, the ultimate diagnosis tool, or is it overused as an imaging tool? Thank you, Dr. Shaw, for gracing us with your presence here today. We're so lucky at Mount Sinai with such amazing, amazing leaders. Dr. Leslie Shaw.
Wow. Thank you so much, Dr. Marin. You're going to listen to me after that. I mean, that's really a tough act to follow. I'll do the best I can. And I deal with very low-risk people largely. So here we are in a complex case, and I'm going to talk to you about a population that largely has normal coronaries. So it is what it is. You see them as well. So let's go. Some disclosures. I highlighted the ones that I've gotten paid for. Most of the talks, as you all know, we don't get paid for. So here we go. Roxana asked me to not only talk about CT, but also to cover the guidelines, the chest pain guidelines, which were very controversial. I was a member of the guideline committee. I chaired the section on imaging. So I'm going to give you the perspective on CT, how it advanced through the indications, as well as throw in some data on FFRCT. And so here we go. Overall, the guidelines emphasize this algorithmic pathways in working up patients. Sometimes they were perceived to be perhaps a little cumbersome, but there was a lot of data to cover. So in the acute chest pain, there are 11 randomized trials with CTA versus a standard care, which is largely stress testing. And the intermediate risk patient with no history of coronary disease, I'm going to cover the stable chest pain guidelines, which are even more controversial, where there are 9 randomized trials. But let's look at the CT use in the ED. There are, as I said, 11 randomized trials, most of them very small. The evidence that was accumulated in the clinical practice guidelines focused in on 2 key results. You can use CTA more promptly, get a quicker diagnosis, and you can promptly discharge patients that have no coronary disease. The no stenosis, no plaque, or minimal coronary disease can be, and that's the lion's share of the patients, can be promptly discharged. You don't want to discharge a lot of people and have them come back. And the randomized trial evidence says no safety issues with CT, either death, MI, repeat ED visit, or ACS over a near term. 2 new trials, the Verdict and Rapid CTA, they expound on those previous data, and except they're in higher risk patients. Verdict trial was non-ST segment elevation, ACS, AMI, dynamic ECG changes, or a gray score greater than 140. Results very similar. Only earlier use of CTA for accurate and prompt discharge. Same message. High negative predictive value. Same message as the data that's used in the clinical trial in the clinical practice guideline. Rapid CTA was even looking at higher risk patients with a suspected or provisional ACS diagnosis, either had to have known coronary disease, an elevated troponin, or abnormal ECG. No difference in outcome. Consistent pattern in the literature. So that's what you see. You see right here, 13 randomized trials, all with the same result. No difference in outcome. Early discharge, accurate discharge when compared to a standard care approach. So here you see CTA, that message in this algorithm, very clearly class 1A indication, highlighted in red, prompt discharge without safety issues. Important message. Is it the definitive message? No, but it's still an important addition to the literature. Now, you can also use CTA in the patient who has had prior testing if they've had a prior inconclusive or mildly abnormal stress test within the year. Current state of stress testing. I think we've seen some illustrative cases where stress testing wasn't very helpful on those patients. Low rate of ischemia in general in the people that undergo stress testing. We've seen in my career, on average, ischemia has gone from about 40% to about 5%. Can you imagine all the stress tests are done in the United States? And we're seeing about a 5% rate of ischemia. The rate of obstructive disease in the symptomatic evaluation is quite low. You deal with very sick patients. Overall, in a stress testing or CTA lab, only about 1 in 10 has obstructive disease. And what happens with that population is when they get referred to the cath lab, you see a very, very high rate of no obstructive. This is a very inefficient and ineffective pathway that we have going on right now. So what happens if we switch to this using CTA? So here is the data for CTA based upon the guidelines. There are 9 randomized trials, a very recent one, the discharge trial, which was published about 2 months ago. There are 2 types of trials. One in the elective patient using CTA as a replacement instead of invasive coronary angiography. The results all consistently show no difference in major adverse cardiac events at around a year. The discharge trial, which was recently published, emphasizes another key factor, and that is there's no difference in MACE, but there's around a 70% reduction in procedural complications. All of you know the procedural complications are quite low, but they're even lower with CTA. That just is a no-brainer, right? But probably the more controversial types of trials have been CTA versus stress testing. There's no difference in near-term effectiveness. So CTA has similar results. It's a similar strategy which can be employed as compared to stress testing. The planned secondary analysis, these are planned analysis, show an improved long-term outcome. And here you see the Scott-Hart result at 5 years on the bottom right. And we saw a 40% reduction in 5-year rates of coronary heart disease death or myocardial infarction. This is incredible. You all demonstrate in trials all the time improvement in outcome. But you have to know these are the first trials that we have seen in lower risk populations that we can actually make a difference based upon an imaging guided strategy, which is amazing. We certainly need more information. The Scott-Hart, that impact of reduction in CHD death or MI was tied to a greater use of statins and aspirin in those patients with non-obstructive plaque and obstructive coronary disease. So in PROMISE, a planned secondary analysis showed the same pattern as in Scott-Hart, but in a diabetic population. Fascinating results and really, really very controversial in terms of the guidelines. So here's the guidelines. So now you have two options. You have a CTA strategy versus a stress testing strategy. Most of you are well entrenched in terms of stress testing strategies. A lot of my career in the COURAGE trial, BARI-2D trial, and ischemia trial also emulated those research patterns in terms of guiding the use of stress testing to guide interventional practices or medical therapy. But now we can throw in there an alternative, an anatomic strategy, one that is very different than what you have seen historically over the past 30 or 40 years. But let's talk for a moment about the use of FFRCT, and I'd like to take the perspective really on how the guideline committee assessed it. Now, it is FDA cleared, the use of FFRCT, so it has 3 controlled clinical trials that led to its approval. It has 2 very large multinational registries. I'm just showing you the 1-year results from the ADVANCE registry published by Manesh Patel and the ADVANCE trial group, showing an increased risk of cardiovascular death or myocardial infarction at 1 year in patients that had a reduced FFR. The hazard ratio is about 4-fold elevated. There are some other CTA measures which I think probably hold more promise, including the delta of the FFR across the lesion. Some people also like to use the delta across the vessel to get more an idea of diffuse changes. But importantly, what has happened and what has transpired in the literature is there's been a lot of fluctuations on where you measure the FFRCT, which has led to a lot of variability in accuracy. We've come to the conclusion that you should measure it close to the stenosis. I know that sounds like brain surgery that the imagers came up with, right? We figured it out, you should measure it close. But people were so eager to get a reduced FFR that they would often go much more distally, and then they showed a discordance with invasive FFR. So what are the strengths? There's a high negative predictive value to exclude ischemia. That's important in the patient you don't want to send to invasive coronary angiography. It is a one-stop, so it's all post-processing. There's no additional, any kind of additional radiation or imaging that you have to do for the patients. The CT data is sent out with a somewhat prompt measurement, a couple hours. Now, you say, well, that's still a couple hours. I want the decision to be real-time. But if you compare it to sending the patient to another stress test, then it is more efficient, and from a patient's perspective, it does actually result in just 1 test instead of 2 tests. So there's no additional testing with FFRCT. Limitations, the correlation, the concordance, because of the issues on differences in measurement, have been moderate between invasive FFR and FFRCT. All of you in the room, I bet, would have heard cases or know you have used this yourself, and that's an important limitation when you use this for revascularization decision-making. The other major challenge is that you won't use it very much. So if you decide to use it, remember our cohorts in the outpatient sector, they're lower risk. The prevalence of coronary disease is low, 10, 15%. So you might use it in about 10% of patients. So you're not going to use it that much. You're going to have a tough time because Medicare reimbursement for a CT angiogram is around $400. and you want to add on an 800 plus costly FFR CT. So that's a negative in my world, where $800 is a lot. And we certainly need randomized trials to show improvements in outcome. So where are we? CT has got a Class 1A indication as a CT, as a first strategy for the evaluation of stable chest pain, no known coronary disease. You can take that very traditional approach. You could even think about using CTA after ischemia testing, like we did in the ischemia trial, but you could also think about a pathway of CT that leads subsequently to invasive coronary angiography. So, whirlwind tour of CT, lots of evidence, strong evidence, really more stronger evidence than contemporary evidence than for any other imaging modality. It is the test for suspected coronary disease, and I think the reason for a CT first strategy is that you'll get more patients into the cath lab who have obstructive disease. You can more selectively use stress testing, even FFR, to be more lesion specific, and it results in a more cost efficient strategy. So thank you for letting me discuss this today. Thanks.
Thank you, Dr. Shaw. That was fantastic, and it is really my honor and a pleasure to bring you my colleague, my dear friend, but an incredible research, clinical trialist, and interventional cardiologist consultant, Dr. Rasha Al-Lameh. Traveled all the way here from the UK to be here with us. We're just so thrilled this morning to have you. And today we're going to talk about FFR, a bridge too far or a bridge to improved outcomes. Dr. Al-Lameh.
Thank you so much, Roxana. Thank you so much for the introduction, and thank you so much for inviting me here today. It's been 3 years since I've been back in New York. The last time I was meant to come, we suddenly had the pandemic, and so it's fantastic to be back. When I looked at the title of this talk, I realized that this was going to be more than just a kind of academic journey through FFR, but a kind of personal journey, because I trained in one of the centers in the UK, Imperial College London, where we developed IFR technology, where physiology has been the absolute backbone to what we do in our cath labs. And I've realized that over time, things have slightly changed for me. So here are my disclosures. Sorry. Okay, cool. Here are my disclosures. So I looked back and started thinking about the data and realized that when I trained back in Imperial College, I feel very old now, that there really was a good old days. There was a moment when everything seemed crystal clear in terms of invasive physiology. We knew exactly what we were doing, and we thought we were doing exactly the right thing for patients all the time. We had lots and lots of data out there that we believed, and we were happy to use in the treatment of our patients. The vast majority of the data started with us thinking that ischemia was incredibly important for patients, and that in those patients with high burdens of ischemia, or based on observational data, there were higher death rates and MI rates, and that ischemia and a reduction in the blood supply to the heart was really important to our patients. We knew that there was lots of data out there from FFR that told us that actually it was possible to defer patients who had low ischemic burdens, that they did very well in the short term, and even in the long-term data out to 15 years, those patients did better. So we didn't need to stent everything we saw. We could use FFR as an evaluation of what was best to stent, and then we could happily be safe with the fact that if we deferred patients, they would be fine. We also knew that if we used FFR versus angiography based on the FAME data, that we had better major adverse event rates and that patients did much better. So all of this seemed very clear, and this was why we were using physiology all the time in our cath labs. We had data from FAME2 that showed that while using FFR in stable patients didn't necessarily reduce death or MI rates, it certainly reduced the risk of urgent revascularization, and this seemed important to us. And all of this we put together in terms of working out what to do. We also had lots of data that showed us that the use of physiology frequently changed our treatment strategy. We could take 3-vessel disease down to 2-vessel disease, 1-vessel disease, back up to 3-vessel disease. But placing a invasive physiological wire down a vessel meant that we could understand much more about the physiological pattern of disease and decide on that basis exactly what to do. So it all seemed totally clear. We knew what we needed to do, and importantly, when we stented patients, the FFR and the IFR would go up in patients. We could see that the burden of ischemia was reduced, and of course, we had that belief that ischemia was incredibly important to patients. If we improve the blood supply to the heart, they should do better in terms of their outcomes. And importantly, because I believe this isn't really just an FFR talk, it's an invasive physiology talk in general, we also had the data that, of course, my group at Imperial and my PhD supervisor, Justin Davies, pioneered, which showed us that IFR was non-inferior to FFR in terms of guiding treatment strategies for PCI. So we could use all of those invasive techniques interchangeably. In the SE guidelines, we were given a 1A recommendation for both FFR and IFR, and of course, in our labs, we rolled it out. And actually, in our lab in Imperial, we use invasive physiology in around 80 to 90% of cases. We used it in a very black and white way. We were happy to say that there was a red light if the FR or IFR were negative and we shouldn't do anything further. And we used the green light of FFRs of less than or equal to 0.80 or IFRs of less than or equal to 0.89 to tell us to treat. And we were happy to use these very binary cut points. But now I'm coming to where we are now. It all got very, very, very tangled. So that very clear, good old days where we were happy to use these binary cut points kind of got messed up over time with lots and lots of data sets, including data that I helped to produce. And now it's become a bit more confusing. I started to look back at the data and think about the data in a less black and white way. So let's look back at some of that physiological data, and you can go on that personal journey with me. So first, we were very happy to believe that if we performed physiologically guided PCI, we could improve angina. But of course, all of those trials that we had before were unblinded, and patients were told exactly what they'd had done, and perhaps that had had an impact on what happened. We saw from the FAME dataset that, in fact, if we used FFR versus angiography in terms of guiding treatment, there was actually no difference in terms of functional status. So while we might have believed that improving the blood supply to the heart definitely would improve angina outcomes, the data wasn't so clear. We also looked back at the FAME2 dataset and thought about that urgent revascularization trigger and thought about it much more clearly. Now, you can imagine what happens in an unblinded trial when you tell a patient that you've passed the pressure wire down their lesion and you fixed it with the stent. The blood supply to the heart is much better. They immediately feel better. What about if you tell them that you've used this new pressure wire to assess the lesion, we've worked out that the lesion really is significant and the blood supply to the heart has been reduced, but we're not going to do anything further because you're in a randomized controlled trial. What happens next? Well, patients come back with chest pain. They come back with chest pain immediately after they've been told that they were not stented. So when you look back at that FAME2 data set, not with my initial very naive eyes, you start to think about it more clearly and realize that actually trial designs can have a real impact on what happens next. So many of those patients that came back in the FAME2 trial had symptom-only chest pain, no troponin elevation or ECG changes, and they were predominantly in the medical therapy group. So perhaps that unblinded trial design had really had an impact on the results. And importantly, it doesn't seem to have had as much of an impact on patients who came back with true acute coronary syndrome events. So maybe some of that data that we took to really guide where we were with physiology needed to be looked at more closely. How about if we looked at the benefit of PCI in terms of a continuum of ischemia? Well, we have the sense that the lower your FFR or IFR, the higher your ischemic burden, the worse you will do, and there are lots of meta-analyses out there that show that. But in fact, many of these meta-analyses are driven by those urgent revascularization rates in trials like FAME2. So we need to remember that while it feels that the biological plausibility is there, that actually perhaps the data doesn't support this. And it started to get even messier as we got the results of ischemia that showed us that that original association that we had between ischemia and outcomes in observational data sets was not so clear in the randomized control trial. And in fact, as we've heard from Professor Shaw today, that the anatomical trigger of events seems to be more obvious. And then we come to some of my own data. We started to look at what happens if we try and predict the placebo-controlled impact of angioplasty on angina. So we remove that element of unblinding that might change the event profile in a trial and take a blinded trial to try and work out what we should do. Well, what we saw was that if patients had lower FFRs and IFRs, higher ischemic burdens, we were much more likely to see an improvement in ischemia on a stress echo with angioplasty versus a placebo procedure. And importantly, that we did see that 20% more patients in the angioplasty arm were free from angina. However, we didn't find a signal that lower FFR or IFR rates predicted the improvement in angina. Now, this may have been because the trial was underpowered to do this. It may have been because there's much more to study. And now we come to the two trials that really over the last year have started to confuse us even further. We were hoping from Flower MI that we could really use FFR to guide what we did in non-culprit intervention in patients who'd come in with ST elevation MI. But in fact, we found that FFR-guided angioplasty in the non-culprit lesion versus angiography-guided PCI, there was no difference in outcomes, and it was non-inferior. So again, that absolute panacea of FFR seemed to be suddenly challenged. And in data from the UK, we started to understand that actually systematic physiological assessment of all lesions at a diagnostic angiogram doesn't necessarily have an impact on what we do. It doesn't reduce costs, and it doesn't necessarily improve quality of life in patients. So while we were using physiology to 80 to 90% of our diagnostic caths at Imperial, we started to wonder whether we should really be doing that based on the data from Ripcord 2. And finally, we've got FAME3. FAME3 that confused us even further because we were hoping as interventionists that we could use FFR to really improve outcomes in PCI patients versus CABG. But actually, it turns out that when you take very, very complex patients, their outcomes don't necessarily improve just because we've used physiology. The complexity of their disease means that PCI is non-inferior to CABG. So where are we now? Where do we even go with this massive myriad of things that have made us really start to question what we should do? So I think we need to be really, really realistic. We need to understand that there's a reality of ischemia, that there is no ability to use a binary cut point to decide exactly what we do, and we need to use much more than just the physiological assessment to guide our treatment strategy. It is likely, and we hope, that with the higher burdens of ischemia, we are more likely to have an impact if we intervene, but we've got to get more data. What we also need to understand is that physiology gives us much more than just a binary cut point or a red light, green light, go, no go situation. It actually allows us to think about the pattern of disease. It tells us about whether we have diffuse or focal disease or a mixed pattern. And in fact, over time, I think we're going to realize that it's this that makes an impact to treatment. We know that even after very good angiographically successful PCI, there is residual ischemia in up to 25% of patients. And it's possible that this is the problem. We also know from some of our data set in Orbiter that actually the placebo-controlled impact of PCI is much greater on focal disease than on diffuse disease, which we might expect. But that it's the physiological pattern of disease that starts to predict outcomes. And that maybe the targets for PCI that are important are going to be to target focal lesions, lesions we really know we can cover with a stent, and then we will have better long-term outcomes versus trying to intervene on diffuse disease. And what's important to remember is that often the diffuseness of the disease is not something you can see on the angiogram. It's the physiology that allows you to evaluate that. So what's in the future? Well, I think there's lots of trials to look out for, and there's going to be much more to come. I think it's going to be really important to integrate both anatomy and physiology to try and work out what we should do, and we can't use physiology as this very blunt tool. I think there is going to be increasingly a place for non-invasive physiological assessment, whether it's CT-FFR or angio-FFR, but trying to guide outcomes without not necessarily passing the pressure wire down the lesion. And I think it's going to be really important to think about what the angina threshold is for FFR or IFR, because believe it or not, that has never been studied. And this is a new trial that we're going to start imminently called Orbiter Fire, where we try and work that out. And I think it's going to be really important to work out whether when combining angiography and physiology, we can improve outcomes. And we saw earlier from Professor Sharma that we're going to hear the results from the DEFINE GPS trial in the next couple of years that will tell us whether this makes a difference. I hope that over time we're going to use physiology much more to evaluate our post-PCI result. So again, using it in a much more intelligent way to work out if we can improve outcomes, because it's not enough just to say, oh, well, the physiology was positive, so I've stented this lesion. We need to work out whether we've truly rendered that patient physiologically normal, or at least much better than they were, and whether that has an impact on outcomes. So where are we now? Well, I think that maybe the solution is just not as simple as I thought in the good old days. I think that binary cut points might be what we need in guidelines and in clinical trials, but are unlikely to be the answer. And I think invasive physiology is increasingly going to be used in making a diagnosis, because our patients, of course, need that, but also in defining disease patterns and working out who we should leave alone. And then finally, I think the future is going to involve an integration of both anatomy and physiology, not one or the other, but both together to try and work out if we can improve outcomes. And I'll stop there.
Wow, that was truly fantastic. Rasha, I think your Oxford education is making me feel really, really good about my daughter who's attending there, your ability to articulate and give us data so beautifully. Thank you for that fantastic, fantastic lecture. Well, our only man who's speaking in this session is my dear friend, Dr. Farooq Jaffer. He's the Director of Coronary Interventions and CTO, PCI, over at the Massachusetts General Hospital. I had the wonderful pleasure of being with all of you last month. It was fantastic, but he's also Associate Professor of Medicine at Harvard. We're really, really so happy to have you. You were the Tom Linnemeyer Award winner some years back, and here you are shining, and it's incredible. IVUS OCT optimizing complex PCI. No one better to give this talk than Farooq. Thank you so much for being here.
Good morning. Thank you so much. Really a pleasure to be part of this conference. Just a delight to be part of this tremendous speaking panel, and I'm delighted to be invited. So this is a really great topic. I think, fortunately, the answer's already been kind of given to you this morning. I think you've seen just imaging after imaging after imaging be so important in the management of how we take care of complex coronary disease patients, with both IVUS and OCT being shown today. So we'll get into it. These are my disclosures. And so what is the role of intravascular imaging in PCI? I think we can kind of bring this into multiple different bins. There's a lot of discussion about IVUS or OCT. The short answer is either. In terms of what we can do, we are clearly focused in on optimizing stent placement with PCI, and that's really the main focus, is intraprocedural use. There are other important applications, including understanding mechanisms of ACS, and then really other parts of aiding in complex PCI, and we'll show some of these cases. For stent placement, as you've seen, we really need to understand size. Our eyes just are insufficient for angiography, both for diameter and length. Calcium, clearly underestimated by fluoroscopy. Plaque burden, we know that ending stents in large areas of plaque lead to inferior outcomes. We cannot see this when we only look at the lumen. We need to look at the wall. And then during PCI, we need to understand if there's significant edge dissections or significant malapposition. For acute coronary syndromes, what we're interested in understanding, sometimes it's not always clear to find out what the culprit lesion was when we have multivessel disease in non-STEMI patients. Sometimes it will be important to understand, especially as you saw earlier, the potential for erosion to be managed differently than plaque rupture. We need to understand some of these mechanisms. OCT is really the best for looking at the surface of the lesion due to its high resolution. And then mechanisms, sometimes we're going to find that what we thought was a stenosis might actually be due to hematoma and underlies SCAD etiology. In terms of aiding in complex PCI, some of the really important things are important in more complex situations to understand if one is in the true or false lumen, whether or not there is hematoma induced by the work that we are doing. We can resolve ambiguity, particularly proximal cap ambiguity in the setting of total occlusion intervention. And then for more advanced techniques, we can do real-time wiring using IVUS. So what is the baseline real motivation for this is that we are still limited by restenosis. Can't be said enough. We know we do a fantastic job. This morning, you saw incredible cases. But despite the phenomenal acute results, we still have significant MACE rates in year 1 and then 2% per year every year thereafter, even in the modern DES era. So restenosis is not a benign illness. It leads to hospitalization, acute coronary syndromes, re-intervention, brachytherapy, and bypass. We can reduce restenosis. This is our best technique for reducing restenosis. Is doing a great job at the time of PCI. Optimizing stent expansion, covering significant dissections, and again, avoiding plaque burden areas that are high when we place our stents. This is where imaging can really provide an advantage. So here's the clinical data, just to be brief. We have multiple randomized trials, left main, CTO, long lesions, all comers, all showing that we have about a 50% reduction in TLR. We don't need a next generation stent before we actually start to apply imaging. We can get a TLR reduction of 50%. And so this is incredibly helpful at the point of care to consider this. And I think you saw it today being used really efficiently. You don't always have to have a separate advisor to help you analyze the images. There's now a lot of automation, particularly in the OCT era. This will happen further with IVUS as well. We need to know where to place that stent, what the stent length is. Do we need to prepare the vessel further? These are fast, easy things to actually address as soon as you get used to imaging in your workflow. And so again, going back to the question of is it IVUS or OCT, I think for mechanisms of ACS, OCT is superior to look at the lumen and certain aspects of mechanisms of restenosis and stent thrombosis. But for general, for stent expansion, PCI, clinical outcomes, there really is no difference. This is a recent meta-analysis published in CCI based on about 7 randomized trials that have looked at IVUS and OCT comparisons. And there really is no difference, maybe even slight trends towards OCT. We're going to learn about this in the future with Illumium 4. OCTA-IVUS in October will be our next set of randomized trials that really inform this. And again, we'll hopefully provide class 1 indications for imaging in the guidelines. So the consensus imaging guidelines, just important to show before we show a few case examples in complex PCI, is that the minimum stent area can be quantified very quickly and by IVUS and OCT, 5.5 for IVUS, greater than 4.5 for OCT, and in a slightly more complicated formula to look at the overall stent expansion by dividing the surface area by the reference luminal area, and that is a target of greater than 80%. Other important aspects is to avoid plaque burden landing in areas that are less than 50%. Avoid significant dissections or cover them when they are there. Tissue prolapse, which is probably, again, better seen by OCT due to its surface resolution, can try to be avoided. Sometimes it will require covering with a second stent when extensive. And then avoiding severe malapposition greater than 400 microns and over a 1 millimeter period. All right, so talking about some more specific applications, imaging is, again, now increasingly recognized in the United States. It is fundamental in the SCI guidelines for managing complex calcium. Really, before embarking on treatment of a calcified lesion, understanding the circumference, the length, and with OCT, the thickness, really changes our strategy. And here is a case where we had just recently where we had worked on a right coronary total occlusion, true lumen crossing, tried to dilate. You can see here that we are underdilated here. Maybe the mouse will work or maybe not. On the bottom left here, and you see the IVUS rotating through and pulling back across the lesion. Well, it becomes very clear while it's non-dilatable. 360 degrees of calcium, very, very unlikely to break. And with continued non-compliant balloons, we are going to end up with a significant dissection in an underexpanded area. So you can see that right there on the bottom right. So this leads to the decision to do rotational atherectomy. which then ultimately leads to the ability to expand this lesion with high-pressure non-compliant balloons, leading to an acceptable angiographic result. So critical in calcium modification, we've heard about it. We've seen a beautiful example of dealing with a very difficult problem, a protruding calcified nodule that was clearly visible by OCT, requiring a large burr or other techniques such as orbital or lithotripsy are needed. You can't get at that without actually understanding the inside of the vessel. What about detection of hematoma? So here was a case where this is another more complicated case of a total occlusion, successful antegrade dissection reentry. In the middle panel, there's our final outflow. What's going on with that? Is that an edge dissection? Is there no reflow? What should we do with it? Should we just cover it with another stent? Well, imaging really clarified this. So on the right, this is a manual pullback, and what you'll see here is that at the very edge of the stent, distal to it, right here, you're going to see at 3 to 9 o'clock, this large crescent. That turned out to be a significant intramural hematoma. And so rather than trying to deal with it with another stent, which could actually propagate hematoma further, because of the IVUS, we were able to recognize this was an intramural hematoma, probably from the dissection reentry approach. This allowed us to use a cutting balloon. Sometimes we use the same techniques for SCAD. This allowed us to lyse the hematoma, angioplasty only, no stent with improved outflow, and this was really clarified by imaging. Here's another example of resolving proximal cap ambiguity. We had a flush occluded mid-LAD total occlusion. See a large diagonal coming here, but where is the actual LAD origin? And so this is something that one can sometimes get at now that we're using CT more and more. We can absolutely clarify this by non-invasively by CT. But in situations where in the cath lab, we can use IVUS. And the way that we do this is we place an IVUS in the side branch, pull back to understand where the main vessel is. And so here's an example of this with an IVUS coming on the right side. And you'll see in the upper right corner, this is the true vessel of the LAD coming in. Not only can you understand that it's there, you can mark it with the IVUS. As Dr. LaSala mentioned, you put the IVUS right at the origin, take an angiogram, you know where that IVUS is. Now that allows us to actually direct a wire under real-time guidance into the actual vessel. And so that's another application of IVUS, is for real-time guidance. And so that's what we did here. This was a stiff wire being directed. And one of the nice parts is again, when we want to understand, did we actually cross in the true lumen or the sidewall? You can see here we're intraplaque with the IVUS. This was true lumen crossing, aided by real-time IVUS works. This was then used for the more classic aspect of recognizing that we were underexpanded in this very large positively remodeled plaque in the mid-LAD. Even though we'd sized well to the distal lumen, we saw there was a tremendous residual plaque burden. This informed us on how we were going to do post-dilatation, where we took this initial 2.5 stent up to 3.5 and 4.0, and then did a final kiss to resolve the diagonal. So to conclude, IVUS and OCT, both are incredibly useful. IVUS improves outcomes in multiple randomized trials. OCT performs similar to IVUS for PCI guidance. And using intravascular imaging can provide valuable insights into multiple aspects of complex PCI. Thanks so much.
Thank you. That was fantastic, wonderful. And it's really an honor and a pleasure to welcome our next new faculty to CCC, Dr. Shrila Banerjee. She's a consultant interventional cardiologist at Surrey and Sussex Healthcare NHS Trust. She is amazing, has had huge interest in coronary artery disease in women, and of course also lifting women in cardiology. She has received a grant from Women as One, where mentorship escalator award winner for having a mentor who's now receiving a Master of Science over at Oxford. It's just incredible, the work that you're doing in lifting other women. But who better to talk to us about MINOCA, ANOCA, and SCAD, a disease of non-obstructive coronary disease that happens in women. We need so much more data to figure out, and microvascular resistance could be a way forward. Dr. Shrila Banerjee, welcome to CCC.
Good morning, everybody. Is that okay there? Can everyone hear? Right, well, thank you for that introduction, Dr. Moran, and thank you to Drs. Kinney, Dr. Sharma, and Dr. Moran again for the invitation to speak today. I'm just trying to work out how to sort all this out. Oh, wrong way. That's the end of my talk. Right, here we go. Right, I'm going to talk about MINOCA, INOCA, SCAD, and the index of microvascular resistance. 4 topics that I could actually talk about for over an hour, but I won't, don't worry. We'll keep to time. These are my disclosures. And let's start with MINOCA. MINOCA has been talked about for the last 80 years or so. And in fact, I was only actually given the tag of MINOCA in 2013. MINOCA is diagnosed as myocardial infarction with non-obstructive coronary arteries, and the definition actually involves using the classification of the fourth universal definition of MI criteria, so a rise or fall of cardiac troponin associated with cardiac sounding chest pain, ECG changes, and some imaging modality showing ischemia. In addition to no evidence of any significant coronary artery stenosis more than 50% in any major epicardial vessel, and also the exclusion of other alternate diagnoses that can cause a similar presentation, such as sepsis, pulmonary embolism, and myocarditis. So what do we need to think about when we consider giving the diagnosis of MINOCA? Well, they're the non-coronary and extracardiac presentations which can mimic MINOCA, and in particular we need to think about myocarditis and Takotsubo cardiomyopathy, which have recently been removed from the MINOCA group of diagnoses. Other cardiomyopathies, cardiac trauma, sepsis, pulmonary embolism can all cause chest pain and troponin rises, but are not true MINOCA presentations. So the coronary presentations and the coronary vascular presentations are the ones we need to think about, and those are really what I'm going to concentrate on today. So in particular, plaque disruption, SCAD, coronary spasm, coronary thromboembolism, and coronary microvascular dysfunction. So how do we make the diagnosis? We use this quite eloquent diagnostic pathway, looking firstly at the clinical history, the ECG, echocardiography and cardiac biomarkers, and follow this with coronary angiography, which demonstrates no obstructive lesions. And obviously an LV angiogram at that point can also help with the diagnosis of excluding the diagnosis of Takotsubo. Today we're really going to talk about the coronary causes, but the non-coronary causes are often very precisely defined by CMR performed in a timely fashion, so it's cardiac MRI, and also provocative tests not performed so soon after the initial presentation. So the coronary causes we're going to talk about are investigated by using physiology testing, in particular FFR, CFR, and IMR, and also the intravascular imaging we've heard about today, intravascular ultrasound and OCT. But really, the diagnostic pathways are essential to provide a definitive diagnosis, which is crucial to provide the optimal treatment for our patients. So what is the utility of intravascular imaging in MINOCA presentations? This very eloquent meta-analysis performed by Palicia looked at over 8,500 patients and actually broke the investigations down into different groups. So looking at coronary imaging, we find that about 29% of patients presenting with MINOCA present with plaque erosion or disruption, and about 16% of patients present with spontaneous coronary artery dissection. And then if we look at the yield of IVUS in MINOCA as an investigation, in this study performed actually in New York by Harmony Reynolds in 2011, before the actual MINOCA tag was devised, about 50 patients were reviewed, and IVUS helped with making the diagnosis in about 70% of that group by defining plaque disruption, plaque rupture, and plaque ulceration. When we look at OCT in more recent studies, it's even more helpful. In this group, looking at 40 patients with MINOCA presentations, OCT was helpful in defining plaque rupture, plaque erosion, SCAD, calcific nodules, and most importantly, thrombus, which seems to be the real defining difference between OCT and IVUS in MINOCA presentations, in that OCT is a much better modality for determining the presence of thrombus. So when we put intravascular ultrasound and OCT against each other on a head-to-head, what are the advantages and disadvantages? IVUS is an ultrasound-based modality which has a lot of years behind it, so we've been using it for 30 years. It allows deeper penetration, allowing a better assessment of the plaque, the lipid content in particular, and looks very nicely at vessel remodeling. But the disadvantages are that thrombus detection is challenging, the plaque morphology is less well visualized on the superficial level, and the findings can be difficult to interpret when not by an expert. But when we look at OCT, which is an infrared light modality, the advantages are that the resolution is so much better, it's user-friendly, and plaque rupture is very well recognized and characterized. And the disadvantages really are to that group of patients that have impaired kidney function, in that we have to use contrast flushes, and that is necessary to clear the vessel lumen. So IVUS, it seems to be the modality of choice in SCAD presentations, and I'll talk about that in a second, but OCT seems to come out the clear favorite when it comes to MINOCA presentations, as it seems to be the superior tool for imaging coronary plaque pathology. So let's have a look at some OCT images. MINOCA is often caused by thrombus either with plaque erosion or plaque rupture, and in image C you can see at sort of between 6 and 9 o'clock the fibrous cap is thinned, and there's an area of thrombus adherent to the fibrous cap there. And in image D you can see plaque rupture, which is obviously a perfect portal to capture further clot and cause a STEMI-type presentation. And plaque disruption is responsible for 35 to 40% of MINOCA presentations. When we look at thrombus on the OCT, you can see that it is much better visualized, and thrombus acutely looks quite irregular, and over the course of a week, if you image it repeatedly, you'll see that it smooths out. But thrombus can obscure the underlying vessel wall because of high signal attenuation. And as we said, IVUS detection of thrombus is more challenging, but maybe high-definition IVUS will lead the way forward for us in the future. So now talking about spontaneous coronary artery dissection, and again, another condition that affects women much more than men, especially middle-aged women, with fewer traditional cardiovascular risk factors, and it accounts for up to 35% of all ACS cases seen in women under 50. So the thing to remember about SCAD is that SCAD can be a cause of MINOCA presentations, but it doesn't automatically become a MINOCA presentation, because sometimes it causes more than 50% stenosis in a coronary angiogram. And of course, we know that there are sex-related risk factors in this group of patients. So what do we do with SCAD? So we know that SCAD has been classified according to 3 different types, and type 2 is broken down to A and B, depending on how the distal vessel reorganizes. And so type 1 and type 2 are usually quite visible on angiography. And I think really what we have to remember is that sometimes you can take a safe situation to a very unsafe situation by just manipulating an investigative catheter or an intravascular catheter, and is it really necessary? So if you've made the diagnosis of SCAD with angiography alone in type 1 and type 2, then you probably don't need to do much more. But in type 3, where there's more ambiguity and there's a bit of overlap between this, could this be atheroma, could this be a type 3 SCAD, then imaging is definitely worth considering. And in this group in particular, IVUS is safer and has greater penetration. And you can see on the bottom there the 2 images. I think OCT may not always be better in, say, the CTO field, but it actually does produce much prettier images, doesn't it? Right, so now I'm going to finish off with the utility of coronary functional testing in MINOCA presentations. And again, from that very elegant meta-analysis by Palicia and colleagues, when they looked at coronary functional testing, they found that about 28% of MINOCA presentations were related to spasm, either spontaneous or provoked, and up to 32% of MINOCA presentations could be related to microvascular dysfunction. So looking at ANOCA, ANOCA is another umbrella term, similar to MINOCA, but obviously missing the M, because there's no myocardial infarction involved, it's just ischemia, and it encompasses a number of different presentations, so non-cardiac chest pain, vasospastic angina, and microvascular angina, and also a mixed picture of both. So what do FFR, CFR, and IMR measure? Well, you already know everything there is to know about FFR from my colleague, Dr. Alami, but fractional flow reserve shows flow limitation and lesion level ischemia, and looks at the epicardial stenoses. Coronary flow reserve is an assessment of vasodilator capacity of the coronary vascular bed during hyperemia. And the index of microvascular resistance, which is what we're interested in, is a guide wire-based measure of coronary microvascular function. So how does IMR work? Well, basically, it doesn't take seconds, really. It takes probably as long as this presentation. So passing the pressure wire to the distal vessel, we flush the catheter and then perform 3 saline boluses at ambient room temperature at rest, and then again 3 saline boluses of 3 mils each with maximal hyperemia. And we measured the transit time. The transit time is the time taken for the temperature drop across the proximal to distal sensor on the pressure wire. So really, it's a very simple procedure that can be performed at the end of your diagnostic coronary angiogram. And what are the normal ranges? So the IMR is normal if it's less than 25, and if it's above 30, it confirms coronary microvascular dysfunction, along with the CFR less than 2. So when should we use IMR assessments? Well, we need to be thinking a bit more about how we assess our Minoka patients. A diagnostic angiogram is not the beginning, not the end of the diagnostic process, it's the beginning. And we need to use microvascular dysfunction assessments for both stable angina in OCA patients and in patients with recent or acute MI presentations, for instance, Minoka patients. It doesn't significantly add to procedure complexity or time. And we've got to remember that the CORE-MICA trial showed us that there's a huge benefit of diagnosis. Knowing what is wrong with you makes the patient's stress levels reduce and makes their quality of life improve quite significantly. So I think it should be part of a routine diagnostic pathway for Minoka. And really, this is now the time for considerate and thoughtful cardiology. So what future work do we need? We need to have multi-center clinical trials investigating both the prognostic impact of diagnostic and therapeutic strategies in Minoka patients. And the Minoka BAT is one of those trials looking at beta blockers and ACE inhibitors and angiotensin receptor blockers in 3,500 patients with Minoka, and it's due to complete in 2025. But we need also to think about a standardized global protocol for coronary physiology assessments. There seems to be a lot of variability. Should we stop caffeine? Should we stop beta blockers? Should we change any other therapies prior to the assessments? And obviously, if these patients are acutely admitted in hospital, it can be quite difficult if they're being treated for a STEMI presentation and they're on a number of these drugs already. So our take-home messages today are that Minoka is not a benign diagnosis. It's a diagnosis that's associated with a significant mortality and morbidity. And as I said earlier, a normal angiogram after a Minoka presentation is not the end of the road, it's the beginning of that diagnostic pathway. OCT predominantly and IVUS have a great utility in Minoka, and in particular IVUS for type 3 SCAD. And we also need to think about the index of microvascular resistance along with the CFR as being a useful tool in CMD assessments. And it should become part of our routine workup for Minoka. But really to remember that better diagnostics allow more targeted and appropriate therapies for our patients. Thank you for your attention.
Please, let's get our panel, the added wonderful person, professor from Harvard, Dr. Michael Gibson. He really doesn't need any introduction. He's a frequent flyer here at this meeting and part of our faculty always. So we're going to make it really just 4 minutes. Amazing talk. Thank you so much, Shrilla. Mike, you watch these angiograms. You've done so many of this at Perfuse. I don't know, thousands, hundreds of thousands of angiograms. What does it mean? Is the angiogram IVUS, OCT, how do you put it together?
Well, you guys are putting me out of business, and that's good. It's been quite a journey watching all this. You know, back in the old days, I'd look at the angiogram and I'd say, gosh, if we just knew the physiology too, and that's why I developed the frame count, and now I'm so excited by the QFR stuff. QFR angios are taking the frame count to get the velocity, integrating it with the anatomy to give us the FFR non-invasively, so maybe we won't need to put the wire down. And very excitingly, now some of the newer generations are looking at IMR. So we might get to a point where we have a more non-invasive way of looking at both the lesion and the microvasculature. But again, I'm sad we only got to spend a few minutes on the microvasculature. I think the microvasculature needs a lot more attention. As I said in our last meeting, I don't think women should be leaving the cath lab where, you know, someone says, another false positive troponin.
Yeah.
People, you know, it took 67 years for that person to get there. We can spend 6.7 minutes doing some of these other measurements to figure out why they're there. You know, it just doesn't do anyone any good to send people out of the lab after putting them at risk to say, oh, nothing to see there. Probably something going on. So this is one of the best series of presentations I've seen on all this, so congratulations.
I know, isn't it amazing?
Really
incredible, incredible. Send me questions, guys. We got 4 minutes because we've got to go to the next set. Leslie, it's okay, I'm calling you with everybody first name. So Leslie, amazing presentation. So you just heard all the invasive stuff and you gave us a talk. I mean, if we have CT-FFR, why do we need all this other stuff?
Well, I think there's a lot more that FFRCT has to develop. I mean, I think the evidence is much more robust, as we've seen in these rapid-fire presentations. But I think it's an adjunct in the non-invasive world. It's an important adjunct. There are limitations to stress testing, and I think it adds. I think what you're going to see is another evolution of CT evidence, that is plaque quantification. There are 5 or 6 companies which are ongoing, and you'll see a whole lot of different, and integrating, you know, not even having stenosis, integrating plaque into that equation, plus FFR really adds for a robust diagnostic test, particularly in the lower risk patients. I mean, you all are talking about intervention, but we're largely talking about in a diagnostic population is who needs preventive care. Right? It's a different kind of focus. There are some patients in there. So I think the FFR combined with plaque assessment is really going to be the way.
That's going to be really cool, understanding that before they get into the cath lab. So Farouk, you're in the cath lab and we're here, we heard all these. So which one is your favorite? Which one, which device in whom? You tried to give us a thing, but what are you really doing in your own practice? I'm feeling like you're doing a lot of OCT, and I'm more of an IVUS girl. So tell me what I'm doing wrong and what are we doing and how do we choose? Quick snapshot.
Sure. Again, the important thing is choose one, get comfortable, at least one. I think you can't function in the lab without having an IVUS system. There are going to be times where you're contrast limited, times where you have to be able to inject or to image smaller vessels or larger left mains. So you need to be fast with IVUS, but I think both are great. I use IVUS a lot in the total occlusion space because they're dissections, and so sometimes it's hard to inject contrast in that situation where you're doing dissection reentry work. But if I'm interested in mechanisms of stent failure, restenosis, or mechanisms of ACS, I'm very interested in prioritizing OCT for that.
Yeah, great. Rasha, does ischemia matter? I mean, I'm like totally confused.
Yeah, me too. I think it does matter. Clearly it matters in terms of giving a diagnosis, but I think what we've learned probably from all the talks is there isn't one perfect answer, and that actually you kind of have to put more together. And I think, just as Leslie's just said, what's going to be increasingly important is the patients we see coming into our cath labs having STEMIs very rarely tell us that they've been on a diagnostic list waiting for an ischemia test or that they've had chest pain for the last 6 months. They come with these de novo presentations. And I think what's going to be much more important is working out why some people rupture their plaque and others don't. And perhaps it's not ischemia that tells us about that. I don't know.
Yeah, and Shrilla, so important. You've done a lot, but this IMR's business, I feel like we really, really need to get to the bottom of this. There's got to be a combination of IMR, FFR, CFR, and maybe even the angiographic stuff that we're seeing. We have the person who is named his frame count, the Timmy frame count, but it was Mike Gibson who did that. It was also Mike Gibson who gave us the blush score. People don't know this, but everyone should. And I know you don't
talk about it too much, but let me be your sounding voice to say that. But how are you incorporating IMR? Are you doing it really in every patient? If it takes 10 minutes to do, that's not going to happen in an angiographic suite like ours.
It's really tricky because you know, that we are all time pressured in the cath lab, but I think actually we've just got to take a step back and, as I said, be more considerate and actually think about the patient first, that patient who's on the table. We have to actually do the right sequence of investigation. So angiogram, then perhaps some intravascular imaging, and then if that doesn't show anything significant, then the coronary microvascular dysfunction testing. And I think we just need to be systematic, and that's what I was saying, that we need to have like a really good protocol, and actually you have to just enforce that. You know, we can't just keep taking shortcuts.
Fantastic, really important. Flash questions here, flash answers, okay? So this one's for you. So you make the diagnosis. How do you treat them with ANOCA, or even microcirculatory issues?
Very good point. It'll be the same tablets you were going to put them on before you even made the diagnosis with these physiological tests. But we know that there are trials coming, and in fact, I'm hoping that you and Rasha will do more trials in the same field to define exactly what the evidence-based treatments for this group of patients are. We know there's beta blocker benefit in certain groups, not the vasospastic groups. And we know there's calcium antagonists and statins as well. And
I mean, my answer also is we just don't have good treatment modalities because we never diagnosed it, so we never knew. And now we're going to design trials, and you guys are going to help us figure this out in randomized clinical trials. Rasha, 60% lesion, IFR is normal sometimes, then FFR is abnormal. What's a girl to do?
Yeah, so I think this is one of these things where I often say if you then toss a coin, you'll get different answers. And so I think that the question of discordance is one that's maybe not as big as it ever should have been. If patients have these intermediate lesions and one test is positive and one test is negative, they are unlikely to be the high-risk lesions, is actually the truth. And therefore, I think you can kind of do whatever you would like, but actually what's most important is probably to do as Shrilla said, and Mike said, to assess their microcirculation and see what else is going on, because it's unlikely to be the epicardial lesion that's causing the problem, and the discordance may be because they have microvascular dysfunction. So I think that's your next step.
Fantastic. Well, wow. Thank you so much. Thank you for this flash roundtable. Sorry for the limited time. We now move to, thank you so much. We have a round of applause. Okay, well, the next set of talks are just as exciting. Going digital in healthcare, what to expect. And boy, do we have an amazing group of physicians who are going to talk to us. The first up is Dr. Ami Bhatt. We're just so glad to have our Chief Innovation Officer here from the American College of Cardiology, who's Associate Professor, I believe, am I getting that right? Associate Professor at Harvard Medical School. She's at MGH. It goes on and on, all that she has done in the digital world. It's no wonder that she is the Chief Innovation Officer now at the American College of Cardiology. And we're so lucky to have Dr. Bhatt here with us to talk to us about digital wearables in clinical use. She was one of the first who, before we even talked about telemedicine, she had it going on at MGH, and she's done this now, and now after COVID, we're seeing how incredibly useful it is. And now we're on to digital wearables, and there's no one better than Ami Bhatt to take us through this. Dr. Bhatt.
All right, thank you for having me. This is really exciting. I was born and raised in Queens, so I feel like I'm coming home, which is good. Now it's been 20 years in Boston. I don't know how that happens. Digital wearables in clinical use. This is kind of where we'll start, but I'm going to do some level setting first. So disclosures, I don't have any financial relationships. I am the CIO of the ACC. We have some relationships there that you can find online. I'm also an adult congenital heart disease doctor. I feel like I need to disclose that because generally, people won't love that I say this, but when we walk into a room, we have the most complex patients. And then I walked into this room this morning and I was like, oh, hold on. These guys might have more complex patients. It's been a great morning. I will give a quick shout out to Dr. Farouk Jaffer, because as our adults with congenital heart disease get older, and we're doing a good job, They also develop coronary disease, and he has always risen to the challenge of taking the complex patient with the complex coronary disease and taking care of them for us. So thank you, Farouk. So level setting, the new cardiovascular landscape, what does it look like now? So we do a few things, right? One is asynchronous communication. They use MyChart or Patient Gateway. We do electronic consultation, but we also communicate with our patients in an asynchronous mechanism. The next is blended care. So we have in-person and virtual visits. There are different percentages of it based on what practice there is. That's okay, but patients are used to now and teams are used to doing a combination of blended care. Clinical remote monitoring and medical grade devices, we used to have them before, right? We've had the pacemaker since forever. However, the infrastructure for bringing in that information has gotten so much better because of COVID in the past 2 years that we're actually doing a lot more of it, both globally and here in the country as well. Where we don't have any infrastructure is digital tracking and wearables. And so that's really the area where we'll focus on where we need to go next. And then I highlighted this because I think it's important. The sheer level of information we gained this morning from being here together, the guidelines that are out there, the most recent studies, plus all of the data from all of these areas above, there's actually not a way that we as an individual human brain can optimize the level of cardiovascular intelligence that exists at our fingertips. And I think that is really why we have to get comfortable with the idea that analytics need to be a part of our future. That way we can raise the foundation of information that's given to us and then do that excellent, super specialized job on top of it. And so I just want to start getting people used to that, and we'll talk about that a little bit as we go along. So why am I here? Digital healthcare, right? What are we doing? We are ideally optimizing the patients who are coming to you for complex care. If we think about what cardiovascular disease looks like now, the majority is chronic management of not just one, but usually multiple diseases. And when you are, I was outpatient director at MGH for 5 years, when you are looking at the cardiology patients who are coming in, it is a significant volume of patients coming in. And there is no way to triage them until they get in your door into your clinic. That results in some patients who have significant disease and are waiting longer, not getting to you on time, not being at the optimal state when you need to intervene on them. And so our goal is to push a lot of that management to the patient and the community, where we can do chronic management in a continuous fashion, not episodic. If you have a disease 24/7, 365, you shouldn't see me twice a year. We should be monitoring you continuously. And then only when we notice that you have rise in risk, that is when we either intervene with you in your home, in the community where you live, or bring you in if necessary. And then those who require intervention can rise to the top and actually get to the kind of care that you provide in a more timely manner. And so our goal with digital health is to be able to help patients get care in the communities where they live, but also be able to help specialists do the work they need to do in the most optimal time and optimal fashion. So the next 3 slides are going to be show and tell. It may not be as good as the cases were this morning. That was incredibly fun and educational, but we'll do it. Arrhythmia detection from single lead EKG. Everybody's pretty familiar with this. I've only given some examples. There are many companies who do this. The idea being that there is a ton of data behind this. Please don't feel that there isn't. I just gave you one example in the bottom corner. 91,000 ECG records. This was a Stanford study, and they were able to look at the algorithm behind looking at those EKGs and identify the 10 different arrhythmia classes that were there and find the 12 outputs of different arrhythmias that could be identified. That's just one study of many, knowing that the algorithms from single lead EKG are solid now, so please don't doubt that. There are different ways to monitor patients, and there are different reports that you'll see that'll come in. Many of them are cloud-based, such that anybody on a team can actually download them and look at them, and team-based care is really important in digital health as well. Then there is the consumerism of healthcare, right? So PPG, photoplethysmography, this is the way that the majority of individuals out there started to understand and love the idea of tracking themselves, okay? So you can say the PPG led to the consumerization of healthcare. You will also notice that this is used for the oxygen saturations, for heart rate, but it is now being studied for blood pressure. These are the kind of things that go direct to consumer, do not need a prescription from us. They are not necessarily medical grade prescription devices. And so these are the ones in the community where we really need to figure out how are we going to incorporate this data. I'll just show this example, which is, my teenage daughter loves the one on the bottom with the pink band. For this week, for Pride celebration, Apple has come out just today with Pride watches. Again, consumerization of healthcare. This is not aimed at us as physicians. This is aimed directly at the patient. And then there's the ones that are going to be useful in that triage process we're talking about. So digital stethoscopes, I have 2 examples here, but there are many, can now give us a single lead EKG, so we know rhythm, can tell us about a phonogram and analyze it for your valve disease and whether it's progressed or not, and can then do an algorithm off of the single lead to tell you whether or not you have heart failure reduced ejection fraction. Can't give you a direct percentage just yet, most of the algorithms, but they can tell you less than or greater than 45%. So if you want to know if anybody in the community out there has valve disease with AFib and a low EF, we can actually do that now, okay? If you look in the top corner, that little gray device, that gray device is in Sweden. It is coming to the United States. Dr. Shaw was talking earlier about the low pretest likelihood patient who likely doesn't have anything, but now they're going to get a CT, right? What are we doing with those patients? This device is not an ultrasound, it's actually an acoustic device. You put it on the chest, you can use it in a primary care office, and it can actually tell you whether or not you have a coronary that is obstructed. Greater than 70%. Phenomenal new technology coming to the States now. Would I use it in one of your patients? No, I'm not talking about 5 coronaries with calcium, and that's not a good idea. But in the low pretest probability patients, is it perhaps an alternative to a CT? Is it an alternative to staying in an ER for 8 hours? Absolutely, and does it make the primary care field feel better that they've done something for the patient and can let them go? Yes. The socks are for peripheral arterial disease fans in the audience. So these actually have temperature sensors and can tell you whether or not your patient has changes in their feet for their perfusion based on temperature and then alert you to it. And then the most recent, there are a couple companies out there now that do infrasonic hemodynography. Try and say that quickly. That comes in your earbuds. It doesn't matter what earbuds you're wearing, but when you leave here and you go home and you put your earbuds on the flight home or the train home, it can actually be in there and then be able to tell you about your heart sounds ranging from valve disease, EF, rhythm, just simply based on the fact that you're wearing earbuds. And so that's a new continuous mechanism that's coming. So the only thing we really need, however, is a place to put all this data because you cannot have it come directly to you. So there are many remote cardiovascular monitoring systems that are out there for actionable real-time data. This is an example that actually shows you how it communicates with the patient as well. These are examples of what it might look like on a screen or dashboard and what all the different parts of a unit at home might actually look like. There is reimbursement. The codes aren't great. We're getting better. I'm just going to leave it at that with this slide. So last 2 slides. Our focus moving forward at the ACC is on analytics. We need to make sure that we address bias when we're looking at large data, and so especially in this digital wearable area, we have to make sure that we're getting the right kind of technologies to the right populations. We also need to focus on what we call collaborative intelligence, not calling it artificial intelligence, because artifice implies that we don't trust something. So for collaborative intelligence, there are 3 things that can happen when you do analytics. It's either right, it's wrong, but you don't put it away. You say, hey, this doesn't seem right, and therefore I'm going to go back and teach the analytics what to do. Or you'll learn something you didn't know before, and that's discovery. And that's the most exciting part of analytics. The last thing is we can't do this alone. So we create workbooks at the ACC to help people with the kind of technologies they're using in their office. We have many more coming out for point-of-care ultrasound, care at home, remote monitoring. But we also work with the Consumer Technology Association, which has standards for these products that you see that are being delivered in the stores. And we actually now added cardiovascular standards. You must meet the following standards if you need to be there. And that was really a great move, I think, for the CTA to think about it and invite us to do that. And lastly, we're doing it globally. So we have a digital health roadmap coming out at the European Society of Cardiology in August so that we're not doing digital health alone in different countries in different ways, but we're really doing it together. Thank you so much for having me. I do not do this in a vacuum. We have a great innovation team, and I'm grateful to all of them for their help in getting this work done.
Thank you, Ami. Wonderful.
Now we go virtual to the cath lab, live to the cath lab, but in a virtual way for Dr. Kinney. Dr. Kinney is going to make up time. You're not going to go through all those slides, right, Dr. Kinney? We're going to have to make up time. Dr. Kinney, she's the founder of the app technologies that she's used in the cath lab for enhancing clinical practice. She's the director of Interventional Cardiology Fellowship Program, director of our cath lab, the endowed professor of Zena and Michael A. Wiener Professor of Medicine. Dr. Kinney, amazing cases today. You were amazing. Thank you.
Yeah, good morning, and thank you, Roxana, for the introduction. So I'm going to talk on a few things on how clinical practice can be enhanced using apps. I have now a financial relationship with anything that I'm going to talk. So just to tell you what are the key areas that we can improve using digital innovation is patient experience, understanding for the patients, care team communication. That's what I'm going to talk on next. Optimization tools, help in better diagnostic tools, and of course educational apps and big data, where I think a few people will be talking using massive algorithm to make things easier. So important initiatives we have had are the 4 in the cath lab. The STEMI, coming to the STEMI, I think we all interventional cardiologists are still very interested to make sure what we can do better in STEMI care, and I think we have hit a plateau with regards to what we can do. For a referring institution, what is important, because we are a large healthcare with multiple sister hospitals involved who want to send it to the hospital which has a cath lab. So door in, door out have to be less than 45 minutes. And for us, we have to pay attention that if it is non-transfer from our cath lab, the door to balloon time has to be 90 minutes, and transfer time if it's coming from outside, less than 120 minutes. We all know that, but there's nothing improvement that has happened over the last, I would say, 7-8 years, even as like the AHA registry, everything has told. So there are multiple challenges why we cannot achieve is all this is that we talk here between the emergency room, the cath lab team, and of course, if you're transferring between sister hospitals, we have a transfer center that has to bring the patient. Right now, it happens with the phone call pagers and of course, people's own messages, chat messages, which is not HIPAA controlled. And then if you see here, Mission Lifeline Registry has over 170 things that we need to enter for the patients to make sure they are entered in a registry, which you need a 1 full-time FTE. This is just to show you the app that we created as a communication platform. One of the case from the sister hospital to us who presented at 3 a.m. in Mount Sinai, Queens. So how does this happen? That young patient that comes with anterior ST elevation, with hypertension, smoking. So how does the app work? That you press the button and then you take the EKG picture and then you send it to the on-call attending. So you have a direct connection with the interventional cardiologist, no in-between person, direct connection with the interventional cardiologist. Now there are a few things that they need to add. And of course, in the next generation, when we are going to incorporate EMR, a lot of this will be gone. And once that happens, I will look at the EKG. If I need to talk to the ED physician, I will have, I can call the number, contact number is right here. I can call them, or if I need to do a video call with that referring ED doctor, I'll do a referring. So I'll have a 2-3 minutes discussion, and then I will say, yes, I've accepted this patient. When that happens, the entire team gets notified. The entire team of the cath lab, which includes the nurses, the technician, the radiology technician, the CCU, who will now know there's a STEMI that is coming and that they better be prepared, and cath lab will be prepared. Now, what else we need for preparation of the cath lab? Most important thing the nurses want to know is some basic history of allergies, and so the nurse of the ED and the nurse of the cath lab will have their own chat. Everything is HIPAA compliant here, and if the patient has any signs of shock, the shock vitals could be entered, but of course when we become, we can incorporate with the EMR, that can be added. In a city like New York, when it's so busy, okay, this was at 3 a.m., you can see that there'll be no traffic, but in the middle of the day there is traffic, so we can GPS track the ambulance that is in Queens coming to us directly, and everything else is time-stamped. So if there is any QA issue, everything is time-stamped right from the time the activation happened. This was the case, that mid-LAD thrombotic lesion you can see there, single stent was inserted, middle of the night, this is the EKG immediately post. And door to the balloon time, transfer time, close to 90 minutes here. So this is what we have achieved. So when we first presented, made this STEMI app, actually the rationale and design was already published in European Heart Journal Digital Health. And our initial experience of the pilot implementation actually will be presented as a moderated poster in ESC 2022. This was just a case I showed you. The cases that we have done will be showing that. The other thing that we have challenged is tower scheduling. And why this is so challenging? Because we have a team of people involved. There's a referring doctor, which include, and then there's a patient family and the caretakers, accepting, which is many people, which is interventionalists, a CT surgeon, vascular surgeon, anesthesia, ICU team. So many workups have to be done. Everything needs to be coordinated. Not that easy to coordinate all these things. So we created what is, we called it TowerBot, but essentially it is for all structural cases. As soon as a referring doctor calls, we will register the patient into this system, and then a link is sent to the patient, so that that link becomes to that particular patient. And after that, they part of the bot where they will understand how to go in, review what the procedure is, they can watch videos, a lot of educational materials are provided to them. And then when the multiple appointments are done, they will get all the notifications, where to go, how to go. Also for us, interventional cardiologists, referring cardiologists, they can log into this portal and then see where and which part of the scheduling the patient is, and will know what has been decided. And at the end, everybody, means the patient especially, can go and do an survey, which we normally collect from this patient. The third point that I need to highlight is, can we use the app and do trials? And this is where I want to tell you that the trial that we are doing to show that regular lifestyle modification versus yoga, is there a way that we can show that in patients with CAD or metabolic syndrome, that chair yoga is probably better. And if you see here, what did we do in this? That we created this app. The patient, once they are enrolled, they will download the app, and you can see that various videos created by this, actually she's my personal yoga teacher, and people can watch this at home. And other thing is, we can track everybody that has been enrolled in this trial. And if they have not done the yoga for a number of times a week, they get this notification. And also this is the habit of every patient can snapshot, because we get the consent. Very important that we have their consent saying that yes, we are going to monitor you. And then this is how we can say that this person was non-compliant, then our coordinator can give them a call. Final thing is the educational apps that we have created. The timeline, the first one we started 2017, and we have been developing so many educational apps. So a couple of the apps that I wanted to show and go over. The GuideWire app that we published last year, actually on November 2021. For interventionalists, very important, if you want to see, it's a lesion based, whether it is CTO wire, non-CTO wire, and then we go over each wire description. The most important thing is that there's a wire library. Over 130 coronary guide wires. The description of each wire, why which wire to be used during which difficult cases, everything has been discussed in that app. And this is, if you want to do CTO, which we'll be doing a couple of CTO cases later on, understand each wire for the antegrade or for retrograde. And if you're taking just fielder, I'm just giving you an example. If you want to understand fielder, there are several fielder wires, so property of all these wires can be understood. The device aid is, we are releasing it today. The mobile app will be ready soon, but what is device aid? It's the same. There are so many devices in the cath lab. So do all of us know every device? Probably not. So there is a beautiful library that we have created. So we start from the access, Then you go to the sheath, the diagnostic wire, the catheters, guide wire, and everything that has been discussed. So this web app, which is all ready, and you can go in right now and start accessing and explore the device aid to understand what are the various devices Cath Lab has. This is just to give you a snapshot of the devices that we in the Cath Lab use it. And every device has a small description to understand exactly what the device and what it's used for. And Angio 3D will be coming maybe later part of this year to understand the engagement of the coronaries and also to which views to be used at which time. This is more of a gaming app. Exactly how to do it. You see that you can inject dye, you can advance the catheter and use a toggle button so that you can pan. So that this will be probably helpful for more of the cardiology fellows also to go there. Thank you for your attention. And this is all the apps that were created and the device aid that just released today.
Unbelievable work, a decade of work in less than 10 minutes. Thank you, Dr. Kinney. You are really, really making a huge difference on this educational app tools. Our next speaker is no other than Mike Gibson. Dr. Gibson is professor of medicine at Harvard Medical School. He's also the CEO of the Baim Institute, one of the best academic research organizations for clinical trials. He's also the CEO of Perfuse and the Boston Clinical Research Institute. So he's really tremendous. And he's going to talk to us today on role of artificial intelligence in our future clinical trials. So let me see what my future is going to look like. Thank you, Mike, for being here.
I changed the title a bit. The title was, will artificial intelligence replace clinical trials? The answer is no. These are complementary, not competing intelligence. And Roxana, your future looks quite bright, by the way. I've received grant support from different companies engaged in this area, particularly Apple for the Heartline trial, which I'll talk a little bit about. Artificial intelligence. Basically, I think it is not going to do a lot for us, I hate to say it, above and beyond traditional statistics and decision making. I do think it is going to have a big role in imaging. In terms of decision making, I've published a few articles on this. We all want to take data from trials. Those are averages of patients, but we treat individual patients. How do you make an individual patient decision? And we like to know, is a patient going to have a reduced risk of bleeding and a reduced risk of ischemic events? That's in that upper right-hand quadrant. And we can identify those patients using artificial intelligence. So yes, it may have a role in identifying the appropriate patients for a trial or therapy. The failure to date is to say, at baseline, I can predict what's going to happen years from now. What we do as clinicians, someone comes back, and we iteratively make decisions. And I think the real role of these technologies is going to be in assisting us in those iterative decisions. Imaging. This is a company I do work with, Us2AI. Carolyn Lamb, a world-class heart failure doc, is one of the founders. And what they do is they acquire images, and it is agnostic to the technology or the company, acquire ultrasound images, and within 30 seconds after the images are acquired, tells you every quantitative measurement about the heart. Amazing technology, and I do think this is going to advance care. If you look at what Mayo is doing, the Mayo has techniques of looking at the EKG, and using AI, they can tell you if it's a man or a woman. Thank you, I don't really need that. They can tell you if the person had AFib recently or not. That's great. But they can tell you if the person had LV dysfunction. And the idea is that that could then be the trigger for technology like this, where in primary care, someone could take this probe hooked up to their iPhone and make some definitive diagnoses. So we're seeing a lot of technologies like LiveCore, Us2AI, many throughout medicine that are going to supplement our decision making. In terms of the digital landscape, I do think we're going to see virtual trials replace traditional randomized trials. I'm going to talk about one I'm running, which is the Heartline trial with Apple. It's a randomized trial of up to 180,000 patients to see if the Apple Watch with some algorithms can detect new AFib and improve outcomes. This trial will cost 1% of a traditional randomized trial. Why? It's not hospital-based, it's virtual. You can be anywhere and get enrolled in the trial. We're not using ECRFs, we're using claims databases to see if someone had an event. Again, it's not paper, no IRB, not institution specific, it's global with a centralized IRB and all electronic. We used to enroll 10 to 20,000 patients trials. I think that's a mega trial. In these trials, we'll be enrolling tens of thousands of patients, and they'll be much more real world than the highly narrowly focused trials of the past. We'll have very good odds of showing a treatment effect given the size of the studies. In the past, we were lucky to enroll hundreds of people a month. Now we'll be enrolling tens of thousands per month. The key is to get patients. We're reaching out into social media, traditional media to find patients for these studies. And as I said before, instead of spending $1 billion to do a randomized trial, we'll be doing those trials for 1% of the budget. If you're only spending 1% per trial, you can do a lot more trials and have a lot more shots on goal. Again, instead of the traditional CEC, we'll be deciding if someone had an event based upon claims databases. Does this work? We published this recently. Here on the left-hand side, you see event curves using traditional CEC, people, humans adjudicating events. And over on the right-hand side, you see the same Kaplan-Meier curve if you use a claims database. And what you can see is you get the same answer. So we could eliminate the need for CECs. If you use claims databases, you have no patients go missing. In the US, if you're an older person over 65, you're going to be in the claims database. And we're going to have terabytes of data per patient to actually personalize the decisions. So I think wearables, as we heard from Dr. Bott, will collect tremendous amounts of data that we can use for that kind of individualized decision making. We're also coming up on ways to share data. Many of us published this perspective in the New England Journal about how we could be doing a better job of sharing. There are tools out there that are going to go into the electronic health record, pull the information out that we can all share. But we have to be careful. We have to be careful with observational data. We all learned during the pandemic that there were so many treatments out there that we heard were successful in treating COVID, and they weren't when we did a randomized trial. And you have to be careful of all these correlations you see. Correlation obviously does not imply causation. We've been led down this path many times with observational studies. When you do the randomized trial, you really don't see the benefit. And finally, when it comes to AI, it is a bit of a black box. It comes up with a diagnosis or a decision, but you don't know why. One of my favorite examples is looking at the prognosis of melanoma patients, and they thought this tool was great. It could tell you the prognosis of the patient. It turns out all it was really doing was identifying that there was a ruler in the background. So if there was a ruler, the doctor was suspicious that it was big and going to be associated with a bad outcome. We have to make sure we're not just identifying rulers, that we're really identifying things that will make a difference. So technology should work for healthcare. We should not be working for technology. And having health information does not mean we have health care. We have a lot of work to do there. But I don't think digital health will be competing with human intelligence. I think it will complement all of us. And I hope that it will allow us to more efficiently put the patient back at the center of healthcare. Thank you.
Well, fantastic session. Let's take a 15-minute break. to thank our sponsors for putting a wonderful show out there for you in the exhibit hall. Please visit them. Please spend time, get your coffee, come back in this room in 15 minutes. 20 of 12, everyone back in the room. Thank you.
to the cath lab. Live case number 3, number 4, coming up on calcific bifurcation lesions. So please, may I have Dr. Davouri, Dr. Freeman, Dr. Jaffer, Dr. Lasala, Dr. O'Neill, Dr. Reitman, Dr. Sardella, and Dr. Tamis Holland, and Dr. Teal up to the podium, please. Thank you. And we go live. Oh, Jazz is replacing Dr. Reitman. Hey, Jazz. Dr. Singh is here, too. Excellent. Please come on up. Can we go live to the cath lab with Dr. Kinney, live again with Dr. Sweeney and Dr. Kinney? We still have all of your apps online here. Can we please show the cath lab instead of the Octave? Thank you. Hi, Dr. Kinney. Hi, Anu. Room 2, we're going to do case 4, LAD bifurcation. Let's go. Dr. Kinney, you're live. Can you hear me?
Good. So, this is case number 3. If you can complete it.
Okay, your audio is not good at all. Can you? There's an echo, and we cannot use your audio like that at all.
Okay, can you hear now?
No. Can we get everybody back in the room, please?
It's easy to answer the question. What would you like to do?
Okay, can you try it again, Dr. Kinney? Anu, can you speak again?
Yeah. No, I'm talking here. Can you hear me?
No, not good at all. Not good at all.
So there's an echo.
Yeah, there's a huge echo. How about now? Try again.
Yeah, can you hear now?
Yes, it's still echoey. It's a little bit better. Why don't we start with the case presentation? Let's see what happens.
Yeah. Okay. So you have case number 3. 33-year-old male who has
No good. We can't. No, Dr. Kinney, it's not good at all. You need to change your microphone. No, the other room is not ready yet. Anu, they're not ready yet in the other room. Let's try again. Yeah, we hear you. Try that now. Let's see how it goes. Go ahead.
No, but can you, yeah.
Much
can you
better.
Hear now?
Yes, we hear you now. 73-year-old male.
Yeah, 73-year-old male, classical angina, multiple risk factors, hypertension, diabetes, prior bypass surgery. So after bypass surgery also, he continued to, have re-blockages. So bypass was in 2012. And he has had multiple PCIs of the vein graft, all these things. So this was the vein graft intervention we did last time. So left side, show the left side. So circ is okay, stent looks good. There's a patent lima. So this is the case of today, where you have this ISR, and we actually have seen the stent, original stent was done outside. So when they did the original stenting, they did orbital atherectomy, and they did, put 2 large stents from the distal RCA all the way to the proximal RCA, and at that time, if you see it, the stent was well expanded. So here we have this ISR. So I can tell you for the last 15 minutes after my talk,
can you show us the angiogram, please? Okay.
Why I don't see what is playing there?
Yeah. Now we see it.
Okay.
We see the right coronary. So, wow.
Okay, so they're showing you the right coronary. Can we also put in multiple screens, the 5? Yeah. So that you can see it. So the center part is ISR. So angiographically, if you see that, I think though, like I said, when they did the initial PCI, it looked well expanded. It looks like there is under expansion, or maybe the calcium. It was heavily calcified vessel. They did do orbital atherectomy, but here looks like that area exactly is under the under expanded stent, or the calcium outside the stent. So what would we do for guide selection here? Should be either a SCR guide, because it's a shepherd's crook takeoff, or probably Lima. But then we tried all of those catheters. We are able to wire, but then we can show the thing. You see that? No. What we yeah. See that?
Yeah, we see.
This is the fine cross.
Fielder
went down. Fine cross would not make a turn. I tried to do free wire of the rota, would not go. Then we thought maybe a Lima guide would do a better job. Even with Lima, was not helping us, and then we moved on to changing from, instead of that, we took a Corsair, and even with Corsair could not get it. And right now this is where we are, in the sense, you see that it has crossed the lesion. The dark part is distal to the lesion. Our initial plan was that the way we saw it, that we could do a imaging first, 175 bar, then image, and then do it. We were not sure imaging anything would have happened in the first imaging. So since we are having so much difficulty in wiring, we are not going to do anything right now image wise. We will try to do rotational atherectomy. Initially we had selected 175 bar, but the way we are struggling, we have downgraded it to 125 bar. And I think let's see how we will proceed as we go. So I'm advancing forward. Good. 125.
So on fluoroscopy, it looks like it's a little bit underexpanded. That's the area of the overlapping of the two stents.
Yeah, but I'm also
the wire
thinking.
didn't go distal because of the compliance of the vessel is so high.
Yeah.
No, it's a tight.
How's she going to rotate it?
And the lesion itself, if you see, angulated lesion. It's a. Okay, good. Okay, guide.
Are you ever concerned? I mean, it's an interesting question. This is a tough question, and maybe we'll just go down. We have a lot of great operators here, and maybe we start with you, Jazz, Dr. Singh. What would you do here? Would you be so concerned about the wiring that you'd use a guide extension already to just get a really good distal wire position, or you see what they're doing. They're already going in with the rotoblader, and they might dynaglide in and try to get a better position. What would be your approach here?
Good.
Yeah, I would, first of all, the guide is not sitting well, and I think there are 6 French. I would have probably used a bigger guide, an M-Plus guide, probably, and then leave that wire in there, and I would wire a second wire down, and I would take a second wire alongside it. And then once that goes, there's a good likelihood that it might go. So now, they're dynagliding the rotoblade. I would, in this scenario, I would probably think about doing, because of this complexity, do a laser atherectomy followed by shockwave. That's what I would probably do, because this is a very resistant lesion.
Ron Waxman, welcome. It's so nice to see you. What are your comments here?
Thank you. One approach is to use a guideliner to help you to situate it. And if you can get the guideliner a little bit further in, you'll be able to get enough support to do the case.
Yeah, Any other comments?
You might do even something simpler. Dr. O'Neill and I were discussing this, that they went from an AL to a Lima guide. You could actually go the other way, go to an AL2, give you more backup and support, bank off the aorta, give them a little bit more support to try to get this down.
Okay, stop.
I'm always a little hesitant to try to rotoblate in an area where I'm very close to the radiopaque portion. As people recognize, it's an 014 wire at that point, but the rotoblader travels over a 9,000th of an inch wire, and if you hit that part too hard, you can separate it.
Okay, stop.
Roxy, is this an extra support wire, or it's a...
No, that's the rotoblader.
No, this is a
roto wire.
But
rota floppy wire,
yes,
extra support wire would not even make a turn.
Which rota wire is it? Extra support or the other one?
It's rota floppy.
It's a floppy wire.
The floppy wire. Floppy.
That's a misconception too.
Bill, did you have?
No, we have done these cases in the sense, once we have done the
really
rotational
careful about
atherectomy
rotablating
at
at the
that level,
radial
usually
page
the
portion
wire will
because
move.
I've separated 2 wires that way. It's kind of risky to go right there.
Yeah, the thing is, if you think, why does rotablator work here? You know, the way it is, it's, you know, it wasn't underexpanded, and now you have restenotic tissue. Maybe it was underexpanded. The only way it really works is it doesn't cut really metal. It causes heat generation. So, you know, in this scenario, you could actually create big pulse with a laser atherectomy and shockwave to get a similar picture. But this is a risky approach because sometimes the rotor can get stuck in these areas too, and especially where your wire not being far down.
I'm a little concerned about that very small burr.
And you can't control when a rotablator jumps out of the lesion because it can come out like a pistol shot, and that's how you lose it. Bill's recollections and his own experience of separating 2 just like that. So this is a risky proposition here.
Dr. Kinney, what are you thinking? What's going on there? Tell us a little bit about
No,
what your
I know
thoughts are.
wire is coming back. It's about, my thought was that even if I do half, maybe I did maybe 1/3 of that lesion with rotational atherectomy, we'll try to go with regular wire. You know, like Dr. Singh mentioned, should try a laser. I don't know whether laser will make a turn because majority of the things, nothing is making a turn. You know, the shepherd's crook is not making a turn. But we will we will need 5 minutes to get the laser ready anyway. Dr. Sharma said, yeah?
Just leave that wire there and wire alongside it. I think with a buddy wire, I think there is a chance.
It may not go. It is such a tight lesion. Side by side may not go. We'll try that. But we'll come out with this. I guess with this one, we'll come out, right?
Yeah, this is clearly such a difficult lesion. This whole vessel is encased in calcium that it's going to be a multimodality kind of case. It may be a laser followed by a rotablator, followed by a shockwave with some ballooning in between.
Okay.
You will tell them.
Yeah.
So what we are going to do is I will rewire it with the fielder and try laser. And then like Dr. Lazala mentioned, nothing wrong. We have done that, especially in CTO cases, heavily calcified CTO. Sometimes you do laser, get some lumen, and then try to do rotational atherectomy. So I think we will use that route. But they're saying they're ready in another room.
Oh, good. So can we go to the other room?
Go there? I don't know.
Yeah, it's a great idea. We really want to stay with you, Anu, because this is really a very, very interesting case.
This is the tough case to understand how you would handle something like this.
Yeah, but we'll come back. But let's go and get the other case under our belt as you're working. We'll give you some peace to work. Let's go to Dr. Sharma's room, please, room 3.
Let's come back here.
Here we are. Dr. Sharma, you're on.
Good. So we got our team ready here. The Amit Huda is my associate today. And we have our 2 interventional fellows ready to work, Anup and Hitu. And rest of the cath lab staff, I'm sure everybody knows those from our CCC live cases. And every year, almost everybody is Ultim, maybe one new person, right? But everybody else is the same for many years. Okay. With that
Wait a minute before you start. Okay, here we go.
Yeah.
Go ahead. This is the 75-year-old woman, right?
Yeah, 75.
Okay. Let's go.
This is the patient who had risk factors as shown there, class 3 angina, and patient had 2-vessel disease of the circumflex and LED diagonal. The circ has been taken care, and today is for LED diagonal bifurcation, and patient is appropriate because of the 2 antiplatelet therapy, and secondly, because a patient has positive stress test. So both symptoms, dual antiplatelet therapy and positive stress test. Maybe we can show on the screen now, all the staff here. So I know they are getting ready. It takes a little time for the laser to get warm up, but hopefully with the heat of this room, things will warm up there sooner.
Okay.
So with that note,
show us the anatomy.
So let's go to the anatomy here. This is the case, as I mentioned, that they had done the PCI of the circumflex. RCA is good ejection fraction, but circ stent looks very good. You see that large one?
Yeah.
And then this is the LED. LED diagonal bifurcation. Actually, the diagonal is much more tighter. It was about 70% just about a month ago, and now it's like 99%. And very calcific. The LED, you can see, question is whether you call it a moderate or severe with a tram track. and knowing that this is kind of an imaging atherectomy conference, we put we said this case we'll try to do orbital atherectomy. And this is I was in, OCT in preparation for atherectomy. And you see that we did this is done on the Viper wire. So if we can show, and we need to hear from our experts that what are we seeing on the OCT.
Okay, actually we started from the mid part of the vessel.
We can't hear you, but maybe we have, I think Farouk Jaffer is here, right? Is Farouk up there? No, I don't see.
No, he's back there now.
Okay, we can't hear at all the OCT.
No, you will hear it.
Need to turn his mic.
Actually, the vessel side is...
Yeah, you can hear now?
Now we can hear it, yeah.
Okay,
Yeah.
and I'll come back. So this is just the level of the diag. We can see the diag at the 7 o'clock, and a little bit more proximal, we can see that like 360 calcium, very thick calcium. So I can measure the thickness of the calcium. It's like 1.05, and almost 360 calcium. And I go to proximal, the lumen is getting bigger, and looks like here is a little bit better lumen. And go to more proximal, still a little bit chunk of calcium, but here the lumen is open. So the tightest is just before the diagonal, 360, very thick calcium.
So it is a 360-degree arc of calcium with a lumen of 1 millimeter and thick calcium, but no calcific nodule.
Yeah.
Compared to the earlier case which we showed, no calcific nodules is a long segment. I just wanted to remind everybody, this is the angiogram, and we are ready with the orbital atherectomy. Okay, so this is orbital, as you know, is a 1.25 bar, and I know that everybody has spoken that what should be the question is you do rota versus orbital. These are the kind of cases, the majority of the cases you can use either, and this is the type of case, not angulated, and the orbital is good enough. So we are going to show orbital with a 1 point, which is only single bar and only 80,000 RPM. And I know this has been spoken quite a bit. To me, I think in the orbital, and of course, Roxana, you'll have a discussion with the faculty. I think they should not even have 120 for the coronary. 80, rather 40 should be even better, because any trouble we had in the beginning with the orbital, all were cases with 120,000 RPM, and you can ask the faculty.
No, we have a great panel. We're going to discuss that. But my big question is, why the LAD first? I'm a little bit nervous that with going into the LAD, you might compromise after you do plaque modification. You might move some plaque into that very tight diagonal. I wondered why you're not doing the diagonal first and then moving to the LAD like we saw in the previous case that Dr. Kinney did.
Right. No, I can tell you the reason is, look at that. I think the diagonal we can do with a balloon. And even OCT was very tough to push. I was ready to take it out, but then we pushed again and it went through. So the lesion before the diagonal, you see that? That's the tightest 1 millimeter. The lesion is so tough. So if we start going into the diagonal, we'll start the cascade of the balloon angioplasty and so goal here is hopefully by debulking, whether it's orbital or rotational we have shown that less plaque shift and less occlusion of the side branch.
All right, well, let's see if that's the case. And as you're doing that with orbital atherectomy, we've got a great panel here. Bill, how often do you use orbital atherectomy over a rotablator?
I really don't use it because I use, when I have a really heavily calcified vessel, I use rotablator, and then for less calcified, we're using shock waves. So, I mean, you have to kind of pick, but that's our algorithm.
Holger, what's your thought about the use of orbital atherectomy here?
Yeah, so we probably would have used just normal rotablation in this case, because at my institution currently we do not have orbital atherectomy, so it just has been approved in Germany very recently, and that's the reason why we don't have it.
Jackie?
I just want to make a comment in response to Dr. Sharma's comment about the rotational speed. It's true. I mean, personally, I have never used anything the larger speed, the higher, faster speed, because the only cases I've seen the higher speed happen, both of them had resulted in a rupture. So,
any other comments on the speed on this panel, John?
For rotablator? For this.
The speed of the orbital atherectomy, are you going to the lower speeds now?
Yes, pretty much, almost universally.
Universally, Jazz?
I agree. I agree with Dr. Sharma. You should not do 120. They should take it away from the coronary.
I think there's a much more latitude with a rotablator where you may start at 160, but I quickly go up to 180, and if it's not going through right away, you go up to 200. I realize that violates some of the basic principles about heat generation and platelet aggregation and all that, but there comes a point when you've got established flow, which will mitigate against most of those problems. So rotablator at least gives you the latitude to go to a higher RPM and get through the lesion.
Yeah, go ahead,
The
Jess.
other thing, in this orbital makes a little bit more sense is, I'll tell you, because of the diagonal you were talking about, when orbital goes through this calcium, and if you're patient at 1 millimeter per second, you actually not only are treating that thick calcium that you saw in OCT, but you actually are doing deep calcium also, which will affect that bifurcation that you do. And you can see actually the compliance changes after orbital because the way it rotates and does it. So I think theoretically it makes sense to do orbital in here.
Srini?
So therefore what we did is, they see this 1 millimeter, but just see this now. And so I cannot push it further. It's not making the band. So clearly, and I have been the big proponent of this technique, that in a long calcific lesion, don't think about going through all. Use 60-70%, you have cut the calcium, and maybe that will be good enough. Otherwise, we'll come back again. So we are done here, and we are coming out with the Dyna-Assist, right? Yeah. The Dyna-Assist working now? Okay, good.
Dr. Sharma, can you go over that again? I think it's an important, very important teaching point.
Yes, if they can show, these are the two buttons. Focus a little more on the top, please. 80 and 120. I would say the 120 they should put a cross mark. And now what happened is to advance the device further, the crown they call, forward or backward, it's a glide assist mode. So we can easily advance or so. So this is when blinking, when the continuous means it is ready. But when you blink, that means it's on the glide assist mode and it will come out without any problem. So you're ready to take it out? Yeah. Okay, keep the wire there. Yeah. So see, the same process, all these both devices, atherectomy or OA or RA, both are on a over the wire system. 1 second, slow.
What's happening?
Yeah, the key is to go slow.
We lost the wire position, but importantly I also noted
but that wire never went to the lumen anyway, distal lumen.
Yeah, I also noted that the distal wire position was not ever perfectly down into the distal vessel.
It was very tough, very tough.
Doesn't look good, doesn't look good.
Good. So this is what?
So what's
Get
next?
a 2.5 compliant balloon.
What have you got next?
So clearly, right now we have the two wires. One is the run through, one is the fielder. We're trying to go into both the branches and see whether we need to come back and complete the rotablation, I mean orbital, or we go with the rotablation, because I was a little concerned the way it did not make that turn. You saw that I was pushing.
Yes, sometimes this flex tip wire, there is some rare circumstances where it's not as supportive, but it's very good for wire bias.
I know.
So what happens is sometimes you have to switch to the advanced wire, and that actually allows you to take it in a straighter segment.
But Jesse, let me ask you, would you have used the advanced wire in this case? This is the kind I teach, that this angulated, you should go with the Viper Flex.
No, absolutely. I think Viper Flex is good. There was aneurysmal remodeling past your lesion, so you don't want your bias to, perforate and stuff. So I think you did good here. I really think that was good. I think you got through 3/4 of the lesion, so I think you modified it.
And I can tell you this concept of the incomplete atherectomy, whether it's orbital or rotational, it will probably decrease, in my opinion, complication of this procedure. Because you don't have many times with a long lesion when ready to come out, that's where the perforation occurs. So I think as long as the work is done, work is basically able to open the lesion. Now here, it was always a very angulated diagonal to begin with. If it does not go, I would not press at this time. I try to open the main vessel first and then retry again, because here we know that ostial of the diagonal was a pinhole they said on the OCT.
Which wire is that? Is it Whisper?
Yeah, they're actually right now, this is the fielder wire. But let me leave this one for the time being. Let's open a little bit of the LED with a 2.520 balloon right now.
15.
15? Is it 2.5, 15 or 20?
15.
Okay, 15 balloon, good. Ready? And we try to open those areas and see what we get. Because same.
Yeah, I was concerned.
So we have actually now shown the rotational atherectomy. We have shown the orbital, and soon they will be ready with the laser. Okay, go up here. 6, 8, 10, 12, negative. And more calcium, circular calcium was more proximally.
Yeah, it's more important,
go
I
up
think,
here.
for you to modify and try to hopefully open some railway into that diagonal. I don't want you to lose that
Right.
diagonal. And you were supposed
Yes,
to show us your
absolutely.
final result of your
Well.
previous case. So we still want to see that.
Yeah, that one, I thought you saw it on the side. We used one more OCT catheter. Bifurcation case, the case they told me was playing on the side.
I know, but we
Came
were
out good with a 4.5 and okay, we'll show it again. Yeah,
You'll show it
but
again.
I can just yes. The key is that maybe I need to learn a little more OCT because the second catheter, new catheter, also didn't go up, and I documented that. It did not make a turn through the maybe stent struts or so. We opened the new catheter earlier when you saw it.
Yeah.
Was not going. In the new catheter did not go, but we documented that. But then we have great angiographic results, and the fellow still wanted to do IVUS or some other technique. I said, good, put the IVUS catheter on the patient's chest now. I think 2 OCTs are good enough.
So is a patient having any chest pain? Because I'm seeing some EKG changes.
No, this one has the elevation. Yeah, definitely. The patient has EKG changes. Now, before we give dye, always try to see ST elevations there. I'm definitely concerned about the diagonal.
I'm seeing depressions that are concerning
Yeah,
me there.
yes.
I want you to open that diagonal.
Has to be. All right. Let's
Just
see to
saying,
believe
I
it.
have eyes behind my head here. Don't think I'm not in the lab.
Yeah.
I'm not seeing these things.
Yeah.
Well, the good thing you
pressure
did
is
lose
good.
the
I
diagonal.
would give some vasodilators now. It'll open it up. I think
we
it's
just
good
gave-
Here
flow.
it goes. Here it goes.
we
Look
gave
at
us-
that. So that's a great.
we
that's
gave-
a great example of plaque modification. A little balloon angioplasty, changing, and now we
Yeah.
see flow into the diagonal. So it's great to see
Look at that. Diagonal looks better than before without wiring.
No, but I think it's
I think you have a better retrograde flow to the diagonal.
I mean, I think one of the things was, I think that the takeaway here was we were struggling, right? You
Yeah,
saw
that
he
was
was struggling
whisper,
wiring.
whisper,
Instead
whisper.
of struggling and dissecting more and creating more havoc, he changed the plaque morphology into the main vessel, open, and hopefully now with I think you're going to need a whisper. He's going to get into that side branch.
We are getting the whisper ready, yes.
Yeah, Samin, you wanted to show us the orbital, but don't you think the rhoda would have been easier in retrospect?
If you ask me, yeah.
Yeah, don't ask
Yes,
him.
yes.
He's always going to
But-
say that about Rhoda.
No, but I think in this
comments?
particular case, no, I would say in this particular case, I think the 1.5 rota bar would have gone through and through, but the whole purpose here is to show actually, you know what, I'm a little happy that I did orbital, and we actually have another case of the long lesion where we'll do a 3/4 of the rota. We'll purposefully, in this case, by default, we could not go completely, but I have another case today where we'll do a 70% rotablation of the lesion, not complete, and show that that's good enough. But I think we need to go to whisper. Little die now.
Yeah, I think this is like a CTO pretty much. The calcium is stopping you from going, and you're hooking it. So you may need something. Yeah, there you go. You got it. You got it.
So this is what's called a Cardellino a maneuver, or sometimes called a suicide maneuver, where you modify a balloon over the side branch. The risk, of course, that you're going to lose it, but in actuality, you clear out a lot of the plaque that's inhibiting you from getting into it.
It's a great teaching point because many people are scared to do that. You know, in the middle of this, I mean, you feel like you're definitely going to lose. You're never going to see that side branch again. And here, it changed it to the better.
And actually, you know, let me make a point on that. And we published this almost 20 years ago. That you have a very tight lesion, and many times the branch comes off after the lesion, and you cannot get to the branch. So what you do is you put both the wires distally like we did in this case. So even when you are doing a balloon, you're creating the cracks. but your wire is in the main lumen. And that is why we were able to get the same, the fielder wire of course required a little manipulation, but I remain in that cracked plaque of the proximal mid LED. So this is the K. So I know that a lot of people call us suicide. We do this routinely, and I would say maybe if we had done those kind 100 times or 2 times we are penalized, but 98% of the time it works quite well. So this is the 2O15 balloon.
The same concept is
But
true
key
for
here,
pot.
both,
When you're doing,
both wires should be distally, yeah.
when you have bifurcation and you cannot recross, if you do good pot, it's much easier to cross or to recross. So it's a very similar concept that by dilating
So
the area.
and if you don't
better
put 2
channel.
wires down, you could always use a Suzuki, right?
Yeah.
Just
Yeah,
slide over
that's
the one
true.
that you've got
Yeah.
interluminal, and you put the wire out the side.
Yeah, but
So
you know, with balloons, Roxy, the balloon, this is as high risk to close with stenting. So balloon, okay. But with stenting, because of the angle, because it extends 10 millimeter past it, and it's calcium, that's your enemy in bifurcation. So I think with stenting, this will shut
The
down.
stent we are
So
going
you
to
really
what?
have to
Yeah.
figure out
Science,
what your stenting strategy is going to be.
in the
Yeah,
diagonal,
and I guess
they
that's
are,
a big question, Dr.
3O38.
Sharma.
38, 3O38 and 2.25.
Dr.
Yeah,
Sharma,
I'm sorry,
the-
okay, what is the
what's-
question now? Go up.
Yeah, the question is are you going to do provisional now here for this side branch?
No,
or
no,
Are
no.
you already
No, I think it's a very
committing
good
to
diagonal.
stenting?
No, I think it's a 2.25 diagonal. We'll do plan it to do a mini crush. This is the 7 French little die. 7 French VL 3O guide. Go. We
know,
do want to
though.
do a mini crush. Yeah.
So,
Why
so
do you
Dr.
want to
Sharma,
do a mini crush here? I don't know. I don't know that I agree with that. Ron?
let me ask you a provocative question. If
Yeah.
we had the available DCB, would
we
you
were
do
65.
DCB on the
That I can tell
diagonal?
you. No, I
and
made that
stenting
point.
on the
I
LED?
made this point. If we would have a DCB, this is a beautiful case for DCB, 2.25.
Exactly. Yeah.
Well, we don't have DCB.
I disagree. I think
Yeah.
DCB is not proven, especially with these high-risk features of a calcium angulation and extending that much past the distal
You're
vessel.
2.5.
It's a very high risk for closure. So, you know,
But look
DCB
at,
may work, but
look
you-
at the
technically
Roxana.
you'll-
This is a good size vessel, 2.5. I mean, let's say if the LED was okay, patient come back with the diagonal, we are going to put a stent in the diagonal. So I always say that your size, what is this now?
Yeah, and DCB was more for smaller vessels. This is a very large diagonal too.
No, the diagonal is pretty small in caliber, I think. Jackie?
No, I was just going to say.
We're
in
putting
this
a
case, I'm
2.5.
more worried about the structural benefit of the stent as opposed to the restenosis, because it's more about the calcium, and putting the stent in the main vessel is going to close off that, and a DCB is not going to change that risk.
Right.
Okay, so you're doing another mini
Good.
crush here. Should we go
Yep.
to, should we stay with you, or you want us to go? I really don't, I'm
No,
really anxious about,
You
I
need
want
to
to
see
see
this.
Dr. Kinney.
No, you need to. Yeah, no, but you will go there, but let's see this real stuff.
No,
Mini
the real
crush and then you
stuff
go.
is in the other room. The real stuff is in the other room, Dr. Sharma. Sorry to say.
We'll make it. But listen, a few technical points we made here. Half orbital atherectomy, then it's a good size vessel. Not dye yet. Why, don't give dye until necessary. We give it now. Now you show it. Little dye.
Don't give dye when it's not necessary. Remember that.
That's it.
I've taught
Yeah.
him. I've taught
Very
them
important
well.
point. Yeah, good.
Well, we should
Go
point
the
out that
diagonal.
it's June and a lot of the new interventional fellows are just starting.
Yeah. And
But is that really a mini crush? I don't know that you're in the LAD.
yeah. Oh yeah. You'll see it.
All right.
Or we call ultra crush. Okay, now let me tell you what we do. Little modified technique of the DK crush. So what is the difference in the DK crush and mini crush? That you are opening the ostium before you putting the stent in the main. So let's say the Sharma's modification. Now you go 20 atmosphere of the ostium. So you go extra mileage to open that
that's
ostium
the Sharma
negative.
way.
And then, yeah.
That
So
is not, Kinney
that's
did not do
all this
that.
not in the pot. Yeah,
Okay.
good. Little die, just see it, little die. We took the wire out.
You know, I'll give you another modification.
Dye.
That's the Sharma way, but you know, if you had just left that balloon in there and deploy the LED stand, you push the stand a little bit back and then reinflate that balloon that's trapped, reinflate, correct it, and then reinflate your LED, you have a DK crush with 5 steps less.
Oh, I see. That's an interesting.
Good one, another good one.
Okay,
lot of modification of the DK crush. One sec.
Is this a 3.0 stent you have? This, because I
Yeah,
hope you're going to
3.038.
go a little
Yep,
bit higher
this
than a 3.0. I'm sure this is a little
Yeah,
bit bigger than a 3.0.
Move your hand. Okay, what was the vessel size on the OCT?
Sure. The best size is...
On the OCT, I thought it was just 3.25 there. We are going to do a kissing balloon anyway.
Yes.
Ready?
Yeah.
Are you believing in pot, doing pot now?
Good. No, I would kiss. Remember in the non-left main, we actually have the paper also in endothelial shear stress and pro-pot. Remember the pro-pot was, majority was the main, the non-left main. And what was the pro-pot overall analysis? That's the first randomized trial, which showed that you have a percent of the mal-approach stent were not lower, rather p-value of 0.1 in many segments. And our shear stress paper also showed the same. Kissing balloon versus pot, and we can show that slide, published, I think CCI, the circulation cardiovascular intervention. That kissing balloon, I think nobody actually has real data to show that pro-pot will be better than kissing. One trial, pro-pot trial, showed no benefit. We have our data. So we will do the left main, definitely pot, but others if necessary. Because if I have trouble here, I will go with the balloon, our 2.0 balloon into the side branch, then maybe we can decide to do the pot. But otherwise,
well,
to me,
Sharma,
I personally think our teaching is,
In this last angiogram, I think you did a nano crush, not really a mini crush. I'm wondering.
But that's good.
I am still wondering if you actually made it into that ostium, because it looks a little bit hazy. Take a look.
Okay, 1 second. Yeah. First is, let's see here. You see the stent is fully covered. Magnify further.
I don't know. Play it.
I think more magnification.
Play it, Sam.
Yeah. Okay. No, I know, but we'll do it also. But look at the angio first. Yeah. That's one now.
You know, if
also,
there is a question, you can IVUS this or OCT this, and then you'll know for sure.
No,
you don't have to
no, Roxana, one more thing yet. What happens now with the kissing, the top part of the stent of the LAD will become 1.1.
Okay.
1.1, because once you do, it's going to cover that whatever 1 millimeter you are missing on the top, become 1.1 here.
Okay.
See this
because
now.
I think there's a little missing on the top. You see?
Yeah. So, but that one, but we do a kissing. Remember the top strut of the LAD now going to cover that ostium. Yeah.
Yeah, the thing about pot here is because they image with OCT and they size their stents. If you don't image, you have to do pot. I mean, you have to image anyway, but I think the imaging here was important, so they sized the stent well, and you can then recross. The thing about kissing here is, you should always, the data is that you should always have a very short overlap. You don't want long overlap because then you deform the stent proximally, then you have to report that proximal area.
Really good. And you see it's really a minimal overlap. Let's hear from Jason. Jason, any comments here on the overlap and all that?
At the main
Two
balloon,
things. One, I think
main vessel balloon.
when you do LED diag,
320 hyperstretch is good.
calcium like that, I think it's
320.
very key to be more
go up.
eleocranial
20
than the REO or
320
AP
hyperstretch.
that Dr. Sharma's in now, to see the true ostium of the diag, because you could see that, like you said, Roxana, it was off by about 1 millimeter.
OCT is ready?
Yeah. But the key also is to reduce the restenosis, because it's going to restenose in the ostium of the diag there.
Right.
Is the post-dilatation there.
Yeah, so we're going to see him do now that. Holger, and then we'll go back to Dr. Sharma. Holger, any comments?
Yeah, and we'll show you the IVUS here. I mean OCT actually. I don't know why I'm using word IVUS. Initially we were thinking that OCT whether make a turn or not. I think there may be a little wire bias. 1 second. Yeah, go up here in the side branch, so that we can get. Anytime you have trouble, there may be a mixture, intertwining of the wire. So just go low pressure, and then you'll be able to anchor whichever vessel you want, and it will go in. Yeah.
Very nice little trick there.
Yeah. So now 1 second, we are going to do proximal, and then we document On the OCT, that ostium is fully covered. Go, both of you.
Okay, that's good.
The other thing is important is when they have these important bifurcations, crossing through a distal stent strut is very important. So I would take time, image, do stent boost, and make sure you're crossing the distal stent strut, because if you cross proximal, you actually pull metal and you actually deform the stent. So distal is very important.
Okay, Holger?
Yeah, I'm looking forward to the IVAS because I'm also not 100% convinced that the ostium is really fully covered, but we will see it.
We'll see it, exactly. He's going to prove us wrong because, you know, he's always right.
All right. No, I can tell you, I may not be. So, but let me tell you first, on the angiogram. First thing first, I'm going to tell you based on the wire. Let's advance the wire a little bit.
But, you know. I called all these things. I said, be careful you don't close the diagonal. I would treat that first, and it went down. I think it's also the ostium is
No,
not
diagonal
fully
didn't
covered.
went down. No, diagonal did not go down. Diagonal got better flow, Roxana.
First it
After
went
the
down,
orbital
then you
atherectomy-
made it better. Then you made it better.
No, diagonal never went down.
Okay.
Diagonal never went down. Remember, after orbital, diagonal got actually, it was angulated, it was difficult in crossing, but it never went down here. It was basically, actually, we were surprised that after orbital, I want to teach everybody there that look at this case, we started after orbital atherectomy.
Well, where's
This
that
is the
diagonal?
diagonal.
Hold on.
Yeah.
Show us the
Come here.
diagonal after
This is the
orbital.
diagonal. This is the
No,
diagonal.
that's before.
This is the diagonal, right?
Yeah?
Yes. Right,
Now,
ready?
orbital. Show us orbital.
Yeah. Yep. Right.
Okay, now,
And,
now show us the diagonal.
Orbital. Yeah. Yeah.
Where's the diagonal, Dr. Sharma, there?
Yeah, right there. Coming. Bigger than before. See that? How bigger the diagonal is before that, no closure.
Okay.
It's a better, yeah. Yeah. No, that is for sure. The diagonal and same thing that once you do atherectomy of the main vessel, the side branch should not close. But let's see where the...
This is why we have fun in live cases. All right, let's keep going. Show us what's happening now with your mini, micro, nano crush.
Or no crush, let's see.
Actually, you can do
better, some ST
OCT
depression.
and you can reconstruct it and it'll tell you exactly where your stent is. So you only can go in the main limb, reconstruct it, and it'll tell you whether the stents are touching or no.
No, do you want to go in the main or the side branch?
I think side branch,
Main.
Dr. Sharma, because the main, you're going to,
All right.
of course you have a stent there, and it's going to be hard to tell.
Now, let's hope this OCT goes in because I'm not having good luck with the OCTs today.
I know, because you hardly use
already.
some.
OCT police is going to come after me. Oh, went in.
It went in. You have to just have, you know, there we go. It's not
No,
Sharma
it
speed.
did not go in.
OCT needs to get to
No, it-
Sharma speed. You have to use
No,
it
but
more,
are
and then
you
you
okay
tell
with
them
or
what
no?
to do.
No, the second marker is the camera, so it didn't cross.
No, it didn't cross.
No, but can it show us the ostium or no?
No.
It's
You are
still flowing.
in the LED.
No, we have to go, that
Yeah.
distal marker has to go now.
Yeah, but how do we do? This is
It is
again
not
same
budget.
story. So see
Yeah.
this wire is very good position. I go back in. We have done the kissing. Okay, good.
Now it goes.
There you go.
Are we okay now?
Little more.
Yeah.
Little more?
Yeah.
Yeah, a little more.
Yeah. You guys will dissect this
Yeah.
vessel.
But it's covered. Okay.
Are we ready?
Okay, just. So enabling. Yeah, please cine and inject.
Yeah, show us the longitudinal of the IVUS. Will be able
Yeah,
to
yeah,
tell.
yeah. Yeah, perfect image. You can take it out.
Okay, we are going to go to the LED in case it's needed.
Sure. Yeah,
Looks
looks
good,
covered.
though.
Okay, show it.
Yeah, I'll come back to the ostial dia.
Yeah, show the ostial diagonal to my colleagues there, all the expert. I'm not the expert
so
on
I
OCT,
start
but
from
show
the,
us.
just the proximal of the D1. The stent is well expanded, and then the lesion is covered. And sorry, I'm hiding this dot. It's better.
And make a longitudinal also, right?
Sure. Yeah. Exactly. We see.
Look
the
at that.
Yeah.
Look
Exactly.
at that, Roxanne.
You win, Dr. Sharma.
Yeah. All right, we are
Good
done.
work,
You can go to
Dr.
room
Sharma.
1 now.
Yeah, and I know the edge dissection well expanded. Yeah, perfect.
All right, excellent. Can we go to now Dr.
All
Kinney,
right.
because we want to see that other case.
No, she didn't.
Dr. Sharma, can we go to Dr. Kinney? Okay, Dr. Kinney, you're on. Can you tell us what you've done?
Okay, you guys missed the real case of the symposium.
I know, this is what I know. Believe me,
Yeah,
I've been trying to get to this room for a long time.
Men have to do their show, so let's see.
Okay, all right.
So I think when we left you, right?
Yeah, tell us where we were. When we left you, you basically were gonna use a guide extension.
We took Dr. Lasala's. He said that, remember, we could go, so I can tell you, now we have the Godzilla. I just wanted to tell you, Godzilla just would not go anywhere. So this is where we are. I had to take a 2O balloon and get the Godzilla. It's not even making a turn. You see that?
Yeah, yeah.
So this is that we got just at the mouth. Then went with the laser. So this is where we are. I did various way of gut. Laser somehow went, but did not cross the entire lesion. I think probably did half of it. So then I said, okay, let's probably go back to the rota. So finally we were able to do the rota again, but same, did not cross the lesion completely. But at least what happened is, if you see the wire, we were able to get the wire down.
At least the wire is
I'm just showing you, fluorosave. Just see how, this is on Dyna, how difficult was it to get the rota across. So every time you try to advance into the vessel, everything is coming out. So on Dyna, you gradually go forward. You see that? Yeah. And then, since we were able to do the wire, even then, probably not able to cross the lesion. See that? This is the max we could get. So right now, we are wired side by side with the, now since we have done laser and some kind of 1.25 bar, this is a 2O balloon, if it even makes any turn here. Now we have Godzilla there.
Because I wonder if you would even, if you could, I mean, it's a crazy idea, but maybe after, if you dilate it a little bit, then maybe you can bring in IVL.
Bring your 1.25 bar a little more.
Yeah, I mean, you could do microcatheter if it goes.
The 1.25 bar did go in.
It's going to be very tough to bring here IVL.
It's going to be not cross.
Yeah, it's going to be hard.
Yeah.
Now get the Godzilla again.
I would do microcatheter, and if it goes, then I could probably, you could put a wiggle wire in there, probably change the bias, and then try to take a balloon down there.
It's really guideline would be, or guideline extension would be the best way, if you can deliver it. And I believe you can.
She tried. I think it was hard. She couldn't get it
So
around the
Yeah,
you have this
Godzilla is
technique
not
with
even
the
making.
balloon.
You have to know one thing. When you have a stent, using guide extension is very hard. No matter what people say, it's very hard. If it is a native vessel, the same, this Godzilla would have gone all the way down, or whatever you want to use guide extension, it would have gone and we would have been able to go there. Once you have an ISR, it's very hard to go with the guide extension. But that's okay, we'll now try again with the guide extension, and that was 2O12, right? New, would not go. I still have 2 wires, hoping that 2 wires can help movement of the balloon. Go, take the wire. Rotor wire, pull the wire.
Yeah, I think you've tried a lot of different things. I think a wiggle wire may not be a bad idea here to change the bias.
Yeah. We don't even carry it here in Mount Sinai. Okay.
All right. So what's your plan now, AK?
No, I think I will go with the 2O12 balloon with the Godzilla.
Okay. Try to get
And
that
then
Godzilla now a little bit
balloon,
further.
yeah.
Maybe then you can bring the laser back and get through the whole thing. Maybe that's...
No, I think we have done the laser atherectomy as much as possible. If we can get a balloon there, dilate it.
I just think you're going to have a hard time dilating this without some...
Yeah, the goal has got to be to get a balloon down there and try to inchworm that extender around that first bend. So that you use the balloon to kind of smooth off the resistance as you're going into the stent, because that's where you're getting hung up. Very challenging, very difficult. Your guide positions are constantly popping out, but you're going to have to try to inchworm a balloon down there and get the guide extender over the first bend.
Yeah, it's hitting the
That is why I tried first with the 2O. So if you want to do this, structure, you have to have 1-to-1 balloon size. So the 2O balloon did not help me first, so we went with the 3O short balloon.
Yeah, you could just inflate it at the tip of the guide liner and then bring it up there so that it'll allow you to go, because there's a wire bias with the stent.
Right.
I wouldn't take it down too much.
This is like a mother and child technique, but it's hard. It's hard when you have instant restenosis. It's easy to say about it, but
it's very hard. No, there's a question. I mean, you're going to
one
have
other thing that we recently got approved in the US. It's still not available. It's called the Open NC balloon, which goes up to 50 atmosphere. It is available in Europe for ISR and for underexpanded calcified lesions. So it will be approved, probably. It will be available. It's approved by FDA.
Okay,
it will be available for marketing probably in the fall of this year. So it's something.
How deliverable is that balloon compared to the other equipment?
Ron, they asked how deliverable is that balloon compared to other equipment?
It is pretty deliverable. I mean, you should ask our European colleagues if they're using it, but
Reno, are you using that?
Okay, go now.
I know that it exists, but I never used it.
Uh-huh. Holger?
Same as Gerard. I have never done it.
Okay.
Yeah, Anu, is your GuideZilla over both wires?
Done.
Or over one wire?
Yeah.
Over both wires?
Both wires.
Yeah. Well,
Yeah.
if that is not allowing you to go, that's an issue.
Yeah, she's really, if this is running out of tricks here. So now what?
Give me 1.2
I would use a longer balloon, because I think the guide liner is getting caught on that edge right there. If you could put a balloon over it to cover it, sort of then slide it around.
I think it went further down. Okay, some die.
Did you hear Dr. O'Neill's recommendation, a longer balloon?
I don't know whether long balloon will make a turn. You see how I'm struggling with the 12 balloon. We can try that, but I don't think it's going to help. Go. You have?
But he thinks that the GuideZilla could then go over that longer balloon and turn around.
The equivalent of that would be to balloon that proximal segment before you get down to the mid portion.
How about taking a compliant balloon?
I tried that before. We can do that. Get us a 3-5 high pressure 8 short balloon.
This is compliant balloons, right? Anu, you're using?
Okay.
The 8 is not non-compliant.
The compliant balloon will go in better, no?
Compliant balloon length you have? Only 15, right? 12 you have? If you have 12.
Well,
don't you think a compliant balloon will go in further, and then you can pull your guide liner over?
so if you don't mind, we're going to leave you, if it's okay, Dr. Kinney, we're going to put you on the side here, and we're going to go to the talks, if that's okay, because we're so
I think there's
behind.
another case.
What do you want to do?
Okay, you can do the talks.
Is that sound okay with you?
Talks.
Are you okay with that? I mean,
we're
very, very excited about this case, but I also think we got to get to the talks, and we've got this great debate coming up on LV support, so we don't want the place is full.
Yes,
everybody
no problem.
wants to watch this. So, is it okay? We're going to keep you on the side, and we're going to go to. Thank you so much for the wonderful panel. Thank you, Dr. Kinney, Dr. Sharma. And I stand corrected that ostium was covered with a stent. Thank you, Dr. Sharma, for proving me wrong. And we'll start with the first controversy for today. LV support in complex PCI. Essential by Bill O'Neill, rarely needed by Holger Thiel. Let's start with Dr. O'Neill. Dr. O'Neill.
Thank you very much, Roxanne. If I could get my slide up. I don't really think I need to give this lecture. I think Dr. Sharma sort of proved the case for me. But, both he and I have been doing coronary intervention for probably 30 or 40 years. And you get a feel for when you need this. It's kind of like pornography, when you see it. And so high-risk cases really are very important to understand. The case that we saw this morning was high-risk, bad ventricle, severe left main lesion, need rotablator. And in the past, before support, you would dread these cases because you were walking on thin ice. Go through rapidly, do as little as possible, get the culprit artery fixed, and get the patient out of the cath lab. And it's doable. There's no question about that you can do these cases without support. But the complexity of these really require that you have more hemodynamic support. So what do you need if you're going to be in this game of doing hemodynamic support? You need to be able to do large bore access, 14 French femoral artery sheaths. You have to be able to know how to use dry closure techniques. You really have the repositioning sheath, etc. you need hemodynamic imaging, as we saw this morning. You can't really do these cases well without having optimal hemodynamic results. You need to be competent doing rotablator, orbital atherectomy, and laser, bifurcation, stenting, and then hemodynamic assessment and strategies to monitor these patients. And I think it's really crucial that you have all of those in your armamentarium if you're going to be able to get into this business. Well, you know, Holger is an absolute master at randomized trial, and he's done incredible work with this in cardiogenic shock. So I know that he's going to be getting some trial data. What is the trial data on patients with poor ventricular function, complex multivessel procedures? There's only one study. There was one in Europe that was done with a balloon pump, and there's only one in the United States that's been done, true prospective randomized trial, and this is the PROTECT 2. This is the data that we have. This is what we have to live with. The patients were treated with high risk. They had 3 vessel disease with EF less than 30, or left main disease with EF less than 35%, just like the patient we saw this morning. And the patients were randomized 1-to-1. The primary endpoint was a composite at 30 days. We wanted to go 90 days. The FDA said no, the surgical results should be 30-day endpoint. But again, we as the people that designed the trial wanted to go 90 days, and so we did follow the patients for 90 days, and so we were able to get a composite endpoint at 90 days. First, without a doubt, Impella provides better hemodynamic support than balloon pump. We looked every 15 minutes during these cases to see if the patients became hypotensive, and the degree of hypotension was significantly greater in patients that had balloon pump compared to Impella. And it makes a difference how many vessels you treated. On the left, you can see that the patients with balloon pumps have the 1 vessel disease, 2 vessel disease, and 3 vessel disease. The more vessels you treat, the more likely you are to get hypotensive during these coronary interventions. And that really does matter, because then the operators start to hurry, you're doing less complete revascularization, and the patients become impaired. With Impella, there was really no significant change whether 1, 2, or 3 vessels were treated. So this is the endpoint, and again, this is the data that we have. On the left, you can see the intention to treat 448 patients, and at 30 days, there really was no difference in event rates. And this is why the DSMB, when they took their first look, said that the study should be stopped on futility. But we knew that the results really were important. I want to point out to you that the original Hochman shock trial, the first New England Journal paper on cardiogenic shock, the results were negative. At 30 days, the results were the same. At 6 months and a year, then the mortality stayed, and that's why we have a 1B indication for use of a PTCA in cardiogenic shock. On the right side, the per protocol analysis, these are the patients that actually met the inclusion-exclusion criteria. It was significantly different. So this is the data. On per protocol, if you're using the devices correctly, you will have an improvement in events. The other thing about these event curves is that the things that happened to these patients after 30 days actually were very clinically significant. They either had to be rehospitalized for heart failure, they died, they had major adverse events. These were not just biochemical markers. So it's really important. It's not only an event curve, but meaningful data for the patients. And so when George Dangus looked at the analysis, again, when the original study was conducted, one of the adverse events was acute myocardial infarction. This was defined as a 3-fold increase in cardiac isoenzymes. When a more modern approach with an 8-fold increase, which is now what's being used, which is clinically significant, there was a 30% reduction in major adverse events with the Impella versus the intra-aortic balloon pump. This study was done in 2010 to 2012, so it's a decade old. There haven't been any other trials that have been done in this space. And the reason for that, it is very difficult to do these studies. The patients are extremely ill. Doctors don't want to randomize these patients, and it's been very difficult to sort of continue with this, but we are continuing. Again, the other important thing is if you're going to treat 1 vessel, it's really unlikely that you're going to have much of a benefit or much of a difference between balloon pump and Impella. However, if you treat 2 or more vessels, the results are significantly better with a significant reduction in adverse endpoints when the patients are treated with Impella. Now, again, if you look at this slide, this study was conducted between 2008 and 2010, and this is really just at the dawn of the use of hemodynamic support throughout the United States. But the use of Impella has started to increase, and now we have much more experience. So the procedure really was in the early infancy when the original PROTECT 2 study was done. We now have the PROTECT 3 study, which is a prospective FDA-mandated post-approval study with patients that have adjudicated endpoints. They have an independent clinical event committee, and we're looking at hard endpoints and comparing the PROTECT 3 versus the PROTECT 2, you can see that across the board, MACE is lower, rate of myocardial infarction is lower, repeat revascularization is lower. Very importantly, bleeding and vascular complications are significantly lower now, because when we did the original PROTECT 2 study, patients did not have ultrasound-guided access. There were no closure devices that were available, and we were largely using two puncture sites to use the Impella and do the coronary intervention. So with all of that, the procedures have gotten substantially better. Hemodynamic support with a 3.5 device is significantly better than with a 2.5 device, and the need for CPR and ventricular arrhythmias was also significantly reduced. So the American cardiologists have gotten better at using Impella in these high-risk procedures. It's safer, there's fewer bleeding events. And I think that the results really looked dramatic if we look over a long period of time with balloon pump on the left, the PROTECT 2 Impella with a 2.5, and now with the CP, the clinical events have gotten significantly better. And I think now that this whole procedure has gotten towards like a plateau in terms of efficacy, it is time to do a randomized trial. Greg Stone is the co-principal investigator with Stefan Windecker. This is now a large study, 1,200 patients that again meet the same kind of endpoint criteria that we talked about, are going to be treated with either Impella or control. Now, control can be nothing if you don't want it, or control can be intra-aortic balloon pump, or it could be ECMO. But it can't be Impella, and they're going to be randomized. The events are going to be looked at 1 month, 6 month, 12, 24, and 36. There'll be serial echoes, KCCQ, 6-minute walk, and the usual Dr. Stone multiple subgroup analysis. The hypothesis is that you'll be able to improve the patient's hemodynamic stability, you'll improve stent optimization, more complete revascularization, and this should result in an improvement in outcome. The primary endpoint is going to be all-cause death, MI, durable LVAD, or heart transplant within the first 3 years. So that's going to be the major endpoint, but the patients will be analyzed at these endpoints that I've talked about. And the last patient will be, the analysis will be done when the last patient has 1 year follow-up. There's going to be major sub-studies, right? Heart cath, renal function, and viability. So I think that the data really is very strong for the use of mechanical circulatory support. We only have one randomized trial in the United States, which is the PROTECT 2. This is now a decade old, and the results have gotten substantially better. So if I was a betting man, I would predict that this study is going to be markedly positive. Thanks very much for your attention.
Yeah, it would be great to get them. Because it's easier to do it with slides, and also to discuss in particular the PROTECT 2 trial. It was nice to see the Kaplan-Meier curves by Dr. O'Neill, but I will dissect the data into more detail. So this is my relevant or possible financial relationship, so I don't have one, but I believe in evidence, and I believe in randomized trials, and that's the reason why we do the randomized trials. And usually, at least for the intra-aortic balloon pump SHOCK 2 trial, this is what we did. We did a randomized trial, and we are not using the intra-aortic balloon pump in Germany anymore. And also, I know that many other countries in Europe are doing it because they believe and they follow evidence. So I try to give you some information on mechanical circulatory support in first high-risk elective complex PCI, as Dr. O'Neill has done, and I will also briefly discuss the possible benefits in cardiogenic shock. So There are some indications based on, so this is what we did, ERPCI, Aleit Kefo from Milano has done it. As you can see, I'm also one of the authors, and I always try to push the people to evidence, because it was not so easy, because there were so many believers in that we have to use it. At least we came up that the intra-aortic balloon pump in high-risk PCI should not be used based on BESIS-1 trial, but we said, okay, so in highly selected patients undergoing high-risk PCI, there may be an indication based on PROTECT2, but we will have to look into the evidence behind this. So this is intra-aortic balloon pump. This has already been mentioned. So we have the BESIS-1 trial. It's a randomized trial done in UK. As you can see it here, once again, severely reduced ejection fraction less than 30%, and patients were randomized to elective IRBP or no IRBP, and this were the main endpoints. So in hospital MACE, there was no difference. Procedural complications were significantly reduced. This was mainly hypotension, so there was less hypotension when intra-aortic balloon pump was used. Honestly, I'm a little bit surprised on this, because the intra-aortic balloon pump does not change the mean arterial blood pressure, because it's only shifting diastolic blood pressure to systolic blood pressure, or the other way around, but it has no effect at all on the mean arterial blood pressure. Now we have to look for the impeller. So we have just heard PROTECT2. You have seen this study design, but I just come back to the primary study endpoint. Have you ever seen such a ridiculous 11 composited endpoint for a randomized trial? This is what we're not doing anymore in clinical practice, or it's more a decade ago. But it's combining very soft endpoint together with hard endpoints. And this is also important, so Dr. O'Neill just mentioned it, it has been stopped for futility. This is important. So this is not a randomized trial which has been finalized. So this were the primary study endpoint, major adverse events, no effect at all. There was maybe, we can consider it, there's a trend towards better outcome at 90-day follow-up. Now, this is what always is shown by the believers in the impeller. So the per protocol analysis at 90 days, which was significantly better with a p-value of 0.048, so seems to be beneficial, but you have to look into more detail into the endpoints. Look for this. Death, heart endpoints, and myocardial infarction were numerically higher with the impeller in comparison to intra-aortic balloon pump. So the difference in the endpoint was mainly driven by hypotension and repeat revascularization. So this is what we have to keep in mind. Heart endpoints were not changed by the impeller in comparison to the intra-aortic balloon pump. And this is what evidence is. So heart endpoints are death and myocardial infarction. Nevertheless, it has been approved by the FDA, and this is what you are doing in the United States. We also have, I always see it, maybe I'm a little bit too old nowadays, so the younger people, they are not able to do easy PCI, even more complex PCI without an impeller, where I always ask, why you are using it. This is something I do in 5 minutes, and I don't need this device. So nevertheless, this is what you are doing in the United States. There's a huge difference in centers, as you can see it on the left-hand side. There are some centers which are using this device very, very often, and then there are centers which are not using it as often. On the right-hand side, you can see the indications. So triple vessel disease, left main disease, but only a few cases with ejection fraction of less than 30%. And this were the inclusion criteria for PROTECT2. So you have adopted it, although there's no evidence at all. You are doing it now nearly on more and more cases. Now looking for the data. When you are comparing it, impeller versus no impeller, on the left-hand side, you can see it. There's significantly more death because this is selection criteria. This is clear. So you only selected high-risk patients. There's significantly more cardiogenic shock, and there's significantly more new heart failure. And you have significantly more complications, more stroke, more tamponade, more major bleeding, 18% major bleeding if you're using active mechanical circulatory support, in this case the impeller for high-risk PCI. And vascular complications, 2.3%. I personally believe this is probably also underreported. At least what we have seen in prospective registries, this is much higher. Now we have to look for the adjusted comparisons. For MACE, significant reduction, but once again, keep MACE in, this is not death and MI. Safety, severely more complications with this device in comparison to intra-aortic balloon pump. If you look at or dissect it into further in unprotected left main, no benefit with respect to MACE. Left main lesions more than 50%, no significant benefit, but significantly more complications. Same, or maybe a benefit with triple vessel coronary artery disease. If you use orbital or maybe normal rotablation, no benefit, but more complications, at least 2 high-risk features. There's also no benefit with respect to MACE. So this is observational data, registry data, but once again, not really confirming to the use of this device. Now, just very brief look into what we are doing in cardiogenic shock. Randomized data, impeller or tandem heart. You can see it down here. So 30-day mortality, no difference if you're using active mechanical circulatory support in comparison to nothing. There's some benefit on the mean arterial blood pressure. There's some benefit on lactate. But on the other hand, you once again have more complications, you have more bleeding, and you also have a strong trend towards more limb ischemia. And I've learned, and I know the data, bleeding and limb ischemia is increasing mortality. So on the one hand, we have some hemodynamic benefits, and on the other hand, we induce more complications. And now what we know regarding cardiogenic shock is that early revascularization in acute myocardial infarction can reduce mortality. Culprit shock, our randomized trial in Europe has shown that if we restrict PCI to the infarct-related lesion only, then we can also reduce mortality. And guidelines formally said that you have to do everything. Clearly, we could show by randomized trials that is not beneficial. Norepinephrine is probably better than any other drug with respect to vasopressors. IVB clearly has no benefit, and that's the reason why, at least in Europe, we adopt the guidelines. It's a class 3 recommendation. That's the reason we are not using it anymore. And if you are using unselectively mechanical circulatory support, you are also not able to reduce mortality based on randomized data. Currently, less than 200 patients randomized. So in summary, there's no evidence that heart endpoints can be reduced, as I've shown to you from PROTECT 2. For me, it's surprising that it has been adopted and that it's currently so often used in clinical practice. Maybe it's a case we have seen by Dr. Sharma. This is a case where we probably would use it. Currently, we have no subgroups. These needs to be defined. This is wrong, so this is PROTECT 4. RECOVER 4 is for cardiogenic shock. We need this trial to really can say if there is a benefit if you're using it. For cardiogenic shock, it's exactly the same. No evidence that heart endpoints can be reduced. It's also for me surprising that we have adopted it in such a often way. And subgroups, I don't know. We have to wait for the randomized trials, DANGER, ECL shock. And you can see ECMO, there are currently 3 ongoing trials. I give you the numbers. So this is what we have currently included in our ECL shock trial, 365 patients as of today. We hope to finalize the trial, ECMO versus no ECMO in severe cardiogenic shock by the end of the year, and hopefully present the data next year. The EuroShock trial has been stopped because of slow enrollment, and also the DANGER trial is enrolling still extremely slow, and we will have to wait if really Impeller will be able to reduce mortality for patients with cardiogenic shock. So thank you.
That unbelievable that you're able to do these trials, these shock trials. We've also, I'm sorry to be so distracted about what's going on in room 3, so maybe we can go to room 3, bring Dr. Kinney back, because we saw that the suggestion from Bill O'Neill kind of worked with the balloon, and she was able to get the guide extension around. Can we get Dr. Kinney back, please? Dr. Kinney?
Okay, so
can we get her in the front?
Where we stopped.
Can we put her in the main?
Can you see us?
Yeah, we see you on the side, but we want you in the main as well. They're working on it. Go ahead.
Okay.
Go ahead. Explain.
So this is where we were. Yeah, after rota, remember we said we did 1 to 5 bar. It did not go all the way down. Earlier, I can tell you, even before trying this, I did try to get the guideliner down using a 3.5 high pressure balloon. Did not work, but this time, again, you see that we were able to get the high pressure balloon down and then get the guideliner all the way down. You see that? And then we used the shock. Yeah, after that we did the shock wave. Yeah, this is the shock. Before, we were able to get the IVL balloon all the way down. This is where it was pre, and this is post. So exactly what
so
we
every
have
device
seen,
was
that
used.
Is an eccentric chunk of calcium. Yeah.
Rotoblader,
Calcific nodule
laser,
or
and
nodular calcium.
shockwave. Amazing.
Yes. Yeah. And then we've done that. We ballooned, and we have some imaging. This is now we had a 3.5 high pressure at 24 atmospheres, and then we can show the imaging if you want. This is the imaging that we are doing with the Kanavi system, which is both IVUS and OCT in one catheter. So the MLA we have got now is very good. There is 7.5. So what our prediction was, underexpanded stent, big calcific nodule behind the stent before the first PCI. So now the question is, what do? We went with a 3.40 actually high pressure, trying to dilate it more. Other than that, I think we probably have to leave this alone rather than putting a second stent.
I have to tell you, you leave this
panelists.
alone with nothing treated. I think it's going to come right back. Dr. O'Neill, the mic is right in front of you. If you could press and give us some comments, and we've got everybody here, so we could at least do that. Get some comments in.
Show the simultaneous. So you see in the screen, you have the simultaneous IVUS and the OCT, and in the IVUS you did 360 calcium, and on the OCT from let's say 11 to 4. You see the effect of the IVL. So you see the fractures there. It's an advantage of doing simultaneous imaging, you know, in the same catheter. So we've been trying to expand that with every device we have. And we're still, avoiding the proper expansion because of the calcium nodule. Now the issue here will be if we keep dilating and get a better lumen, or we stop with the 7.5.
Can you get this?
The reason, Roxana, I said leave this alone because we will bring him back in a few months. We have to do. No. It's single layer stent. That calcific nodule. Remember the treatment for calcific nodule, nodular calcium. Actually, this will be a nodular calcium because a stable patient has to be some kind of atherectomy. Likely will be rotational atherectomy with a bigger bud, so that we will get a good stent expansion and then only place a second stent. Otherwise, that area will remain like that.
Mm-hmm. Okay.
Yeah, this is exactly
because if we keep dilating, actually when I was going high pressure balloon, I told Pablo, please get a covered stent ready. I was thinking that we could probably perforate that area because you see, it's an eccentric calcific nodule. These are very difficult to treat.
We already have used like 3 pressure balloons that rupture.
I totally agree with what you're doing.
Go ahead, Bill.
I totally agree with what you're doing here because I've had coronary ruptures with those like pebbles of calcium. When you push it hard enough, the thing will break, and then you really got an incredible mess because you have a hard time delivering a covered stent there. So I agree with you that it'd be better to cautious here. Two quick points. I don't like using 1.25 or I just don't find that it provides enough atherectomy. I think a 1.5 or going slowly is a little bit better. But for the audience, one life-saving thing is that if you do happen to push the bird through and you can't pull it back, that's a problem. And actually there's a technique where you cut the rotoblader cable and then put a guideliner over the rotoblader burr. And that's a way of pulling it out if it ever gets stuck.
Wow, yeah. Great.
Yeah, excellent point.
Yeah. We had a little stall. We actually did have a little stall with the 1.25. We felt the dramatic decrease in the RPL, and we removed it immediately, and we were able to go through. But the points are very well taken.
Anything down, that it's going to be a multi-modality extravaganza. You have to use everything in the toolkit, all the tricks, and you've nicely gone through them sequentially with an excellent result. You rise to stop where you are, and I'll just say that in about 20 minutes I'll give you a very, very similar case in my presentation.
Yeah, I would just add one thing. You really need to measure the MLA or the CSA post-procedure now, and if you do have more than 6, it's probably going to be enough. I don't think that you need to push more in terms of physiology, probably it's going to be enough. So all what you have to make sure that it's not interfered with tissue, and that's where the role of brachytherapy. You may have tissue there before. If you never had tissue before, you probably don't need to do brachytherapy. That's the beauty of doing imaging, and getting the classification. This is just mechanical or also biological risk analysis.
Is that?
Yeah, it's pretty unbelievable what you just did, but I'm thinking
What is
that
it?
this is
How
a
much?
great plan. We
Okay.
fully agree. Unbelievable case. You showed us all these 3 technologies, and it's perfect segue for our next talk, our next sort of...
1 second, MLA right now at the tightest where we did everything is 7.6. You can see it there. I think we take everybody's advice. It's time we stop here, and we'll bring this patient back electively in 4 months.
No. So we
You're
can't
showing
wait
it
to
there.
hear about this. It's very exciting, and we'll let everybody know. Thank you, Dr. Kinney. Masterful job. Unbelievable. All right. Well, now we move to, we saw 3 separate devices used. We've got two fabulous sort of controversies. Calcification. And Jazz Singh will say, IVL, final treatment, atherectomy, needed in most cases. John Lasala. Let's start with you, Jazz. Can we have Dr. Singh's? There we go.
Thank you, Roxana. So I've been given this opportunity to debate my mentor, my colleague, and we work in the same lab together at WashU, and we do the same kind of procedures and we help each other, so it's not very fair. So Dr. Sharma likes that though. Anyway, I'm going to talk about intravascular lithotripsy. These are my disclosures. And so these are 4 cases that I did in the last couple months, and if you look at it, they're all calcified, they're all messed up. And how do we treat those? And I'm going to make an argument that intravascular lithotripsy is the mainstay of treatment of all these scenarios. So I'll try to, if I have time, I'm going to go over these cases. I have little snippets at the end. So, okay, so intravascular lithotripsy, for those of you who are not familiar, it's actually a pretty simple to use device. So moderate to severe calcification is seen in a lot of patients that we do in the cath lab, and even more elderly patients that we tackle, right? You know how much atherectomy is used in these patients? Less than 5%, right? That's why calcium is your enemy. That's why the TLR rate, stent thrombosis, all those things are very, very poor. Because the learning curve, people are afraid. There are complications, all those kind of things. So now if we have a device that can actually take away all that fear and has good data, then why would you use atherectomy, Professor? Tell me. Okay, good. All right, so this is how it works. It actually is a balloon. It's filled with 50-50 contrast. It has electrical energy. Then when it interacts, it actually creates this sonic pressure wave, this acoustic wave, which is pretty close to about 50 atmospheres, and it actually breaks. Why is this not playing? Okay, there you go. So you can see there, it's hard on hard and soft on soft. If you put a hand, you get electrical thing, nothing really happens. But it's a bony material there, it just breaks it, and that's how it really works. So you can see in the OCT, it actually, you can pull back, you get multiple fractures. You not only get superficial fracture, but you get medial fracture. And what happens when you get medial fracture? You could change the compliance of the vessel, right? What do you want to get? You're going to get minimal stent expansion, right? It is not only dependent on superficial calcium, it's dependent on how compliant your vessel is. And so this is very important. That's why I think this is more attractive. Not the other atherectomy devices don't really do that. All right, there is data, disrupt studies 1, 2, 3, and 4. A lot of data has been published. You can see there's consistent results all throughout in terms of procedural success. You can see, as John said, and he'll show you that sometimes it doesn't cross, but there are things that we can do. The complications are much, much lower. The Disrupt 3 was recently published. It was based on the performance goal, primary safety endpoint, 30-day MACE, and effectiveness in 384 patients. And you can see here the in-hospital 30-day MACE was compared to all the other studies, and then it met the primary safety and effectiveness endpoint. So you can see here, ease of use. You don't want to be 5%. There was no evidence of learning caps. They're all in patients. Most of the doctors who really enrolled, that was one of their first cases, they didn't have to learn too much. It's just a balloon. So that is very, very important, right? No learning curve. And you can see it's one of the most safest, it's not really atherectomy, but calcium modification tool. And you can see compared to orbital, rotational, the Prepare Calc and Rotaxis trial, the complication rate of severe perforation, dissections, and all those things is much, much lower. So how about calcium nodule? Dr. Keeney showed calcium nodule. You can see in this cartoon here, you can see how it orbits, the orbital, how rotational has wire bias. What if your nodule is on the other side? It really depends on where your wire is. When you pull back, how much wire bias you change, you can do that. But it's very, very complicated, right? It's very, very complicated. But actually, if you looked at the calcium nodule subset here, most of them are in the right because it's tortuous, and that's how the nodule forms. The LAD was pretty much non-nodule calcium. You can see the stent expansion with IVL was uniform across the board. So you worked in both, like here, both in calcified nodule and in non-calcified nodule. Okay, so you can see the calcified nodules here, OCT, so you can see a deformed eruptive nodule, then you have a deformed nodular calcification and non-deformed complications with atherectomy devices, especially calcification, smaller vessels, and a lot of different factors involved, but they have complications. You can see here, the MACE, bleeding, all those things are much, much higher in females. So if you look at the pooled analysis from the Disrupt studies, females, men versus women, you can see pretty safe in women versus men. Comparative procedural success was very, very similar. And you can see serious complications, not too bad. So very, very similar in females. This is one of the ones that really shows you that females do as well as male in non-atherectomy calcium modification shockwave. Atherectomy is really not. So larger studies need to be done, obviously. Endpoints were very, very similar. So in real world situation, you can see here, I'm not gonna go over this algorithm too much, I don't have time, but if you see here, all these roads, never mind you're uncrossable, you won't expand, you come here, all the roads lead to lithotripsy. And here you can see, non-compliant balloon, people used to use mild calcium. Severe calcification doesn't work. IVL, dog boning, high-risk patients, thick, deep calcium, left mains, osteals, bifurcations, and now I added nodular and females on there. The only scenario, atherectomy, is uncrossable lesions and diffuse calcification, which I will show you. So this is my slide that I made up. This is the scenario. Left mains, there is data that minimal stent expansion with shockwave is much, much better than just atherectomy and a balloon inflation, okay? It has about 93.7% you actually achieve the minimal stent area in left main, which is very important. Bifurcations, obviously, you can have 2 wires down, you can do shockwave bolts, osteal lesions, pretty simple to use, deliver with the guide. ACS patients, they have a lot of calcium, a lot of LD. If you look at acuity and Horizons AMI, a lot of people actually presented with acute coronary syndrome with calcium. They have platelet clots, some of them have fibrin-rich red clot. What does atherectomy do? Embolizes stuff, right? Here, you put it in there, you don't embolize, and that's why it's very attractive in this scenario. Large lumen, wire bias, no problem with guttering and perforation, obviously atherectomy failure, and calcific underexpanded ISR like we showed here, and female sex that we talk about. As I said, long lesions and failure to cross are the only scenarios, all these scenarios. So I'm not 100%, but I'm 98% IVL. So Professor, it's going to be all yours. So I'm going to stop here. Ease of use, no learning curve. Excellent safety profile, excellent data, promising in both concentric and nodular calcification, promising in female subsets, ACS patients, more studies needed in ISR, and then limitations in long lesions and uncrossable lesions. So I'm going to show you a quick case here. This was one of the cases that I showed you. Patient presented with ACS. Okay, this was one of my cases. So you can see this is as bad as a calcium gets. So how do we do this? It's very hard to, very hard to wire, and it's very hard. We wired it, but we actually couldn't even cross a microcatheter to go down. So what do? We listened to John, and we just wired with a flex wire, the CSI flex wire, and then we did CSI. And you'll see here, it has a balloon pump already transferred from an outside hospital. So we did CSI, and then after CSI, look what happened. It is such bad calcium that your balloon actually is still dog boning. So this is atherectomy failure, okay? So what do? You do this. You do shock wave, you expand it, you IVUS it, mark the ostium on IVUS. Your IVUS will show you here, I'm not gonna go over it. And you can see we protected the circumflex, and that's your final picture. And that's what shock wave does. This is atherectomy failure, but you can use these cases really together. So very, very important. I'm not gonna show the next case here, but what I'm gonna do is, see this case, everything is occluded. What do? Atherectomy, probably problem. So you do shock wave here on the circumflex, open it up, no flow limiting dissection, good luminal gain, and then it gives you time to do whatever you want to do. So we did that, and I'm going to go over this thing. The thing I want to really show you is the last case that I showed you, this case here. So see here, right coronary artery is calcified, ostial, and you can see you are not coaxial. And these are the things that you have to be really careful in doing atherectomy. No other device will really work. So here, you are starting the atherectomy device in the cusp. You can dissect the cusp, cause AI, or you can do what you did there, perforation. And this is, I think, scenario where shockwave really works very, very well. You take it down, even if it doesn't go, take a balloon in there, get your guide coaxial, and do it, and your case is done. So I'll stop here. Thank you very much.
Okay, I've been told I got to hurry with lunch awaiting. This is no debate. I agree with everything that was just said. It's just a matter of perspective. I haven't been able to win a debate with Jazz since I tried to convince him that baseball is a legitimate sport. And it's not just rugby and soccer. These are my disclosures. I have obviously a long-time atherectomy user. This we know, calcium is prevalent. The population gets older, diabetes is rampant, more calcium. Calcium leads to worse outcomes. You've seen this data previously. All the p-values, this is from Mount Sinai, it's got to be true. Everything is worse. And when you go to the meta-analysis, including all the others, it's also worse with calcium. So no question that calcium is a problem and inhibits us from both delivery, expansion, and optimizing our stents. Complications due to calcium. I won't go through this. But we do know that once you see that there's over a 270-degree arc of calcium, stent expansion is almost always going to be incomplete or asymmetric. So it's an independent predictor of stent thrombosis particular. ROTA we know we can use and be safe and effective, providing good clinical outcomes. Not a lot of randomized data. The pre-calc trial gives you a combination of ROTA versus modified balloon like scoring and cutting. You can see that the p-values were significant for strategy success. There was a lot of crossover as a result of not being able to just do it with a balloon or crossing with a balloon, and a lot of other features. But the result of that is that ROTA gives us an advantage compared to those. This has been shown already. It's part of your algorithm as based on the SCNI presentation. including mechanical, laser, and intravascular lithotripsy. Before lithotripsy was even introduced into the US market, it had a role in the SCNI algorithm. So that tells you that people were very high on it, as I am. The Optimum trial as was presented last night, this is surgical turndowns, variety of operators. We were like the 4th leading enrollers for this particular trial, lots of surgical turndowns, 27% with hemodynamic support, atherectomy 32%. You have to be able to take on these kind of high-risk cases with lots of calcification and really optimize imaging on top of this for people whose average syntax scores were 32, total lesion lengths of 74, and CTOs over 50%. So a huge amount of difficult disease here. The predicted rates of mortality were met basically at 30 days. So we can get equivalent to what would have been predicted and do it by percutaneous means. We know that imaging helps us. Just seeing it on the angiogram may not be enough. You can tell severe when it's severe because it's up there. That means it's got to have over 180 degrees. Moderate and mild is more difficult. So this is required sometimes that imaging may help you with preparations and determination what to do. I would try to base our utilization more logically on what's an index score that helps us with this. The angle as determined by OCT or IVUS gives you a couple of points. Thickness greater than 0.5, lengths greater than 5 millimeters. And once you really get to a certain point, and we'll see the cut point, this is the IVUS equivalent of that, 270, 360s, nodules, vessel diameter less than 3.5. And once you get to the point of having at least 2 or more of these, you have to start considering atherectomy. If you look at a IVUS to predict underexpansion, the D group is no angiography calcium cohort, the atherectomy group is C, and then the validation and derivation is A and B. These numbers clearly show that atherectomy will basically kind of neutralize the inhibition of stent expansion, and that's what you take away from this. And that cut point, as we said, is somewhere around a calcium score of 2. Here's a case example. This lesion doesn't look that bad. It's IFR positive. On the IVUS pullback, you can see that there is calcium showing up right there. There it's over 180, maybe 270 degrees. The operator elects not to do with it and get away with it. And although the IFR was normalized, because of the incomplete expansion of the stent that you see on IVUS, you're going to be at higher risk for restenosis, if not a frank stent thrombosis. So I'll give you one case. This is going to seem like St. Louis's most famous philosopher is Yogi Berra. He said it's like deja vu all over again. You'll see what I mean in a second here. Previous CABG, CTO with a right coronary, having lots of angina. And here you have an issue where you can't even get the guide catheter coaxial on the right coronary. So trying to get this and advance a wire is very challenging. It's coming in as an angle, as you can see in the RAO. After a number of wires, we're able to get a Judo 6 to go through a serpentine advancement and get it distal. So it looks like we're in good shape. The wire is distal. We're home free, right? No problems. Straight shot, nothing to do. Okay, the microcatheter doesn't go. 1 millimeter balloons doesn't go. What do I do now? I can't do shockwave. I can't even do atherectomy, or can I? What's my only option here if I don't have any backup and support to drive any through there? Well, I have to use a laser, okay? That's the only thing that's going to track over an 014 wire. 70/70 fluence and pulse, 50/50 contrast, and that doesn't work. So I got no other choice. Go back to another laser. 38 laser trains. It's a new indoor record. Just to get enough fracturing. Now, laser does not ablate calcium, but it's going to fracture it enough to get things through. The Mamba, the microcatheter passes, but now a balloon will not. So I'm still stuck. Does this sound familiar? 125 rotablator burr. Bill, I know you don't like this, but nothing else was going to go through there safely. It looked like a mess when I took the angiogram. We got that through, and then after laser, rota, multiple balloons, and a shockwave, Guidezilla, IVUS, and DES, this is what we end up with a final result. This is 3 hours worth of work. It doesn't show it in a 2-minute presentation. But this is very similar to the case you saw, and the need for bringing in multiple modalities that are not antagonistic for the most part. They are synergistic. Believe me, if I could get a balloon down with a shockwave, I'll take that every time. But most of the time, I've got to couple it up with at least an NC balloon, if not, frank atherectomy followed by balloons, and then maybe a shock wave on top of that. OCT can do the same thing in terms of predicting just how many points you get, looking at deep, superficial, and nodular calcium. Again, we can go down this algorithm. Notice not all pathways lead to IVL. It actually has some other things that you can go through that determine whether it's crossable or not. This looks like a simple lesion. We do OCT on it. It looks like the calcium is superficial. The arc is 360 degrees, so we get points there. The calcium thickness is 1.3 points there, and a length that's almost 10 millimeters, so another point. 4 points total. This didn't look bad to you, but you'd really need to do some form of either IVL or atherectomy. The question is, will the balloon cross or not? And that's where it comes down to the important bifurcation in our strategy. Turns out the balloon did cross. Now we can take on the calcium. We'll size for success, 1:1, 3 millimeter by 15 millimeter IVL. Here I am debating IVL, and I'm doing it instead of atherectomy, only because I've got a rational way of looking at it in terms of imaging. The fracture was taking place. This is the lithotripsy. Many times you'll see the balloon inflate right in front of your eyes, even though it's only 4 atmospheres, as it begins to fracture. We can see that there are fracture planes here in the OCT. And now that we've done that and fractured it and changed the compliance, you go ahead and stent, and you end up with a good result. Final OCT shows a good expansion, optimization of your results. So conclusions, calcium is the most significant deterrent to a positive outcome in complex coronary disease. High calcium scores, meaning generally above 2, portend trouble, poor outcomes. You've got to take these into consideration. The algorithm is very helpful in choosing. Yeah, if you can cross primarily with these high calcium score type lesions with IVL, go ahead, do it. But for the most of the part, you're going to need some adjunct, at least a high pressure inflation, if not atherectomy, coupled with IVL, so-called rototripsy, other type things. This is what we do. We don't have atherectomy randomized studies to really bonify this, but believe me, try to do that case without it, there's no way it's going to happen. That's unfortunately mostly what's referred to me from the outside. Thank you very much.
Wow, thank you so much. What a morning we've had. No, can we give a round of applause to the incredible cases, fantastic presentations, amazing faculty. We're just so blessed. And Dr. Kinney and Dr. Sharma just showed us 4 most complex cases live. We are going to take only a New York lunch break. That's only 30 minutes instead of 1 full hour. Please be back here at 2. We're going to get right back. Get your lunch, enjoy, visit exhibits. Please spend time with our industry colleagues. Thank you.
with live case presentations 5, 6, and 7. I'm George Rengas, moderator of the session, and let me invite Doctors Barman, Duvuri, Fox, Godino, Huber, Kearney, Singh, Stone, and Waxman to join us here at the panel. And we're great to have to see already that the cath lab is getting prepared. I see there is this must be the dream team of room 2, in the cath lab room 2 dream team. And we're going to have some CTO action in this session. Well, while the cath lab gets prepared, I'm not sure they hear us, but perhaps AV team can give us a connection with the cath lab, and we can get started slowly. But in the meantime, let's just poll our great panelists. All of us join us quickly. Let's start from Kurt Huber and coming this way. What's going on with CTO, and what is the consensus of revascularizing CTO in your environment and area? Maybe the broader area of Austria, but also in your cath lab. You know, because there's a variable enthusiasm, I think, in the United States, very, very medium or also very low. I don't think high exists anymore, but there are other people who are disregarding out front.
We also have a lot of enthusiasm in this procedure. We do it since more than 15 years now, or even a bit longer, and we have an ongoing registry, single center. The interesting thing is that heart clinical endpoints are not different to patients who don't receive CTO, or where the CTO is not successful and the patient, the vessel cannot reopen. So I think it depends on a clear selection of patients, and we will find out in the future, or we have already a lot of data. And I think it's an important procedure. We are really working on it. We do every week CTOs. We have a special team that is very experienced. I think this also is important, that you should be very experienced to do that. I think for the future, I think it's a very positive thing.
No, Dr. Barman, Nitin, you're very experienced. You're doing as many CTOs as you like, or you think they're not referred anymore, or, you know, maybe when you're discussing with a clinical doctor, they're not that into it.
Yeah, no, I mean, I agree that the most important thing is obviously case selection, and really identifying where the value is, since the literature at large doesn't really support it across the board, but certainly with the advancement and progression of complex disease and what we know, at least in kind of pool data about the importance of full revascularization, I think it's a critically important skill set to have. It's also quite different, I would say. So, this is not the forum for this discussion, but who should be approaching them, and what format and what type of training is required for that, I think, are really important points as well.
Who should approach them? I wonder. Should anyone approach them? Dr. Kinney, what do you think? What's happening in the far west?
Yeah, so in our north left corner, we try to mostly to base it on indication and ignore the angiogram as much as possible when we're doing the patient selection, which sometimes you're in these cases and wondering, like, this is why other people say no, but I think there is, like, we saw some examples of that recently with John LaSalle's case, but I think we're never going to beat the surgeons potentially based on data, but if a patient is turned down for surgery and it's a vessel that would be grafted, we do our best to get complete revasc if they seem like a patient who could benefit that based off competing risks. So I think while that makes it trickier, we're really trying to ignore the angiogram as much as possible until you're to the procedural planning standpoint.
No, it makes sense. Let me go back to Ron Waxman all the way, who came a little late. Let's see, he wanted to avoid the question, I think. Ron, the question was that, and not avoid it, is what's your view and your personal view in your cath lab and the general environment in Washington, D.C. referral basis regarding CTOs? Is there interest not so interest, used to be higher? What's going on?
So it's easy. Definitely there is a lot of interest, but it's not in the hands of everybody. I think this is a specialty that requires special dedicated operator or team that is willing to commit to understand all the issues that related to CTO. And this is from patient selection to equipment selection to imaging selection to know where the limitations. So yes, we do have 2 operators that are dedicated to most of the cases. It doesn't mean that others are not doing simple CTOs. Some CTOs, not all CTOs are the same, but this has to be taken seriously. You cannot just take it, oh, I'm doing CTO like I'm doing bifurcation, etc., etc.
Yeah, well, it makes some sense. I don't know if Dr. Stone would like to join us up here and participate in the discussion as well. Mario, why don't you tell us? We see a little hesitation about the CTOs. They say, you know, clinical cardiologists say it's okay if we don't open the CTO, maybe you don't. Patients are doing fine. Meanwhile, the surgeon always bypasses the CTO. And then you say there's a benefit for complete devascularization, but at the same time, you say, oh, you know, maybe don't need to open the CTO. What's going on there? Why is CTO an advantage when you go for surgery, but seems to be maybe, I don't know, maybe not such an advantage for PCI?
Well, George, clearly we have a different approach to CTO. Technically, they do not really represent a problem for surgery. Sometime I must tell you that you follow the epicardial coronary artery that is totally occluded to the end and you simply do not find the lumen. And so I guess in that situation I don't see how PCI can work. But if there is a lumen, for us is an anastomosis like any other. We published something back in the day showing that revascularizing CTO may in fact improve at least regional function, and that was in the right coronary artery, even electric stability. So I believe that there is a benefit in revascularizing CTO, especially in surgery. With PCI, I guess the technical issue is much more relevant than in surgery.
Maybe Dr. Duvuri, what's happening in your neck of the woods regarding CTOs, and what's your attitude?
Yeah, I mean, as others mentioned, case selection is important. And once that is done, if it's a straightforward, short segment CTOs, you know, I tackle them. Anything beyond that, as Ron mentioned, you need a dedicated team, and you know, we have a good team with Dr. Kinney and Sharma, and they take care of the tough ones.
John?
I think, you know, everybody's kind of said where we're at. I think there was a lot of enthusiasm years ago, and this creation of even more volume for cath labs. I think that is kind of faded. I really restrict mine to the LAD and symptomatic patients. You know, I think that's the territory that matters the most. But anything short that you can get across easily. And then anything that's really important that is complex, as Dr. Duvuri does, have a tendency to give it a shot and then give it to a team that really does it dedicated.
Yeah, well, that's interesting because indeed the original studies that said, you know, there's some benefit, even mortality, is if in the LAD territory. So I'm glad this came up in the discussion because LAD territory CTO may I don't know, require special attention and all that. Let me come to Dr. Stone there, who obviously is going to, you know, modify a little bit the question. Greg, why is it that all the CTO trials, well, several of them, in many countries, one can say, even from many biased operators, they're doing CTOs themselves and doing trials, nothing has been overwhelmingly positive. Is it too difficult to do? Are they too greedy to do the CTOs clinically as opposed to randomize into doing nothing? Is that hurting the field, perhaps? You know, what is your field point of view? Why we haven't proven a tremendous benefit in any study?
You know, speaking frankly, the trials haven't been designed well.
And all clinical trials can be either positive or negative according to the types of patients that are put in, the endpoints, being realistic about the sample size and the power analysis and the effects that you see. So with CTO, whether you expect improved survival or reduction in myocardial infarction or reduction in cardiovascular hospitalizations, for clinical endpoints, you're talking about thousands of patients, and it's not going to happen by opening up obtuse marginal circumflex occlusions, okay, or distal right coronary, posterior descending or posterolateral. You would need big, principally LAD occlusions. Then you've got quality of life, which is another endpoint, which of course one trial, the European trial, was positive on, and that is more realistic for a trial of 600 to 1,000 patients, but it just wasn't convincing the way that it was done. So the bottom line is that CTO trials can definitely be positive with, again, the right kind of commitment, an international organization, the right kinds of patients, the patients that are really at high risk, and if there's really equipoise in designing the trial.
So what would be you say the deal breaker or an innovative trial that hasn't been done? And one can say if your trial did thousands and thousands of patients to show benefit, wouldn't this benefit be minuscule? And could that make sense to do that? So are we going to go for a MACE? Well, what do you think was, from your point of view, a trial to do?
Well, I think there's value in both types of trials. There's definitely value in proving improved quality of life with CTO PCI, as long as there's no downside in safety. The home run would be obviously to have a clinical outcome benefit. And when you're talking about procedures that are done in tens to hundreds of thousands of patients around the world, to do a 3,000 to 5,000 patient trial is not unreasonable. Yep. I mean, it took GISSI, right? The original GISSI trial and ISIS-2 trial in 20 to 30,000 patients to establish thrombolytic therapy for acute myocardial infarction.
Yep.
The question is that even if you have a negative trial, will people stop doing CTO? And what I hear they won't. They will continue to do it because they strongly believe that on individual patient that they know it's still going to work and the trial has some deficiencies. So that's maybe take some of the motivation to do a big study if you know that people will continue to do the course of based on their belief.
Great.
So that it may be downgraded on the guidelines or maybe upgraded on the guidelines, but the question if it's going to be, the only thing can be is doing more CTO.
Well, stay right there. We're talking about the guidelines, and I think we see the message here from the control to invite Kurt Huber to talk to us about revascularization guidelines 2021 in clinical practice, a perspective of PCI. Let's hear from Dr. Huber, and then we see if the cath lab is ready, we go to cath lab, otherwise we hear from Dr. Godino. Slides for Dr. Huber, please.
Okay. I told them that they were ready, so.
Will they start? Okay, will they start now? Or the slides first?
Oh, we got to go into the talk.
The communication is very bad, I can tell you.
Okay, so
we are ready here. Instead of going live, they started.
If they want to start late, I don't have a problem. Let's see, maybe. Control, please put us live to room 1. I'm going to discuss with Dr. Kinney. AV Chief, put us live to room 1, please.
Yeah, we see live. We are live here.
Yeah, but can you hear me, Dr. Kinney?
Yes, I can hear you very well. Can you hear me?
Okay, great. So we'll revise the plan as directly. Let's go straight with you with a live case. We're getting a message over here to delay, but there is no need to do that. No. Go ahead with your case.
Good. So case number 5, if you can see the presentation slide, is a 79-year-old male who had initially presented with the classical angina symptoms with risk factor of hypertension, hyperlipidemia, had a positive stress test, MPI, with multivessel ischemia. And cath, of course, showed a 3-vessel disease with the circumflex LPL, and there was a RCA disease. Since the syntax cure, though it was 3-vessel disease, and if you see that patient had a 3-vessel disease, had a bypass cabbage referral. However, he refused. Then he came here and we did the PCI of the right coronary artery as well as circumflex. Today, he's here for the PCI of totally occluded LAD. If we can start showing the angiogram. So medication-wise, he's on aspirin, clopidogrel, Lipitor, lisinopril, metoprolol. They have checked the PRU, and PRU is 192. So if you can see the angiogram, this is a dual injection. RCA stents are patent. Go minus. Yeah. You see the feeding vessel, the LAD, good distal target. And going to the JCTO score calculation wise, only thing you would say is you can see the cap, that is tubular or not a brunt. And then long segment, no calcium. We are not sure no true side branch at that area. So this is where we are with the LAD CTO. I know you were having discussion about CTO, which patient should be getting revascularization.
Yeah, and looks like we said, maybe LAD, symptomatic patients with LAD would be definite. So comes out as a definite. So this, I don't see the proximal cap really. It's very difficult to see. It's very much in proximally. There's a lot of branches overlap. It's going to be challenging to go to isolate it. But
let me just no, not too much. I need to see. Ready?
Well, we see
here
something.
You don't see it well at all. You see the origin of the LAD, and then there's that large diagonal. Yeah.
Yeah. Yeah, I think it's challenging. There's this. What do you think about your approach given this challenge? No.
I am going to start antigrade itself. We have Corsair, and I'll start with the Fielder. That would be the first wire of choice. You always want to try polymer jacketed wire, Fielder, whether you want regular Fielder, XT, any of that. Yeah. To see if there is, micro channels or something. So I'm going to start with the regular Fielder, and then we start wire escalation as we keep going.
Well, I know some
given heparin, and our ACT is about 290. Yeah.
I know some European operators are going to be very keen on starting retrograde here, and definitely some Japanese ones. So I don't know, Dr. Stone, what do you think the rationale is for that? Although, given the there's more and more calls to try antegrade all the time.
Well, first of all, I'd like to see it. It looks like on the AP cranio that there might be a cap. You didn't see it at all in that kind of shallow caudal, but I would wonder if in an LEO cranial or in an REO caudal we could see the cap. That'd be number one. Number two, you'd like to always try to go antegrade, but you need to see the cap for that. If I couldn't see the cap, then I would use ultrasound to try to identify the cap by ultrasound. But if there's absolutely no cap and you really can't see it, then I would have a low threshold to switch to retrograde.
So start on the grade by low threshold to switch. Dr. Barman, what do you think? Would you go retrograde?
I wouldn't. I think a broad point is obviously to do the things that you're good at. So if you're very facile with that strategy, it's not unreasonable for a case where the cap is not so clear. I would add that I think it's critically important, maybe for obvious reasons, to really, before we start engaging, take multiple views to really understand the anatomy. And I know that they've done that. I'd also, I think even before you get to the lab, and I'm sure the RCA didn't look overly complex, just I think another panelist had mentioned this in a previous session about maybe the order in which these interventions
You want to do
are
retrograde
done,
of the RCA so we can see,
starting with
right?
CTO first, so that you're not compromising a donor.
Antigrade also, okay.
Certainly if you fail and CTS is still on the table. And
Okay, go RCA.
lastly, someone may already
Go.
be committed to
Retrograde.
DAPT, having stents in the other vessels, so should there be a important bleeding complication, stopping DAPT can get complicated as well.
Dr. Huber, you seem to be agreeable, but I don't know to whom.
The cranial picture is better. We'll go more RO, I think.
Well, I have a
That
very
time
similar
will be
opinion than Greg has. So it's fine to have a try here, but
Okay, someday.
from the first picture where we really haven't seen where to go antegrade, we would eventually have started retrograde here.
Retrograde. Yeah, Dr. Kearney
That
and
is
now
the only
Dr.
one.
Waxman.
Yeah.
Any ideas
Other
for
thing is,
the
do
West
we
Coast?
go?
Yeah, I think these LCL LEDs are always challenging. I almost never use IVUS guidance here, but you could put a wire in the diag to try to see, because I think the guide is sort of favoring you away from the osteo LED potentially too. But this might be a case where you can actually see it. I don't use that technique
So
very
the
often, and
question
I'm not
is,
very
do
good
we
at
go
it
with
as a
the
result.
FCL,
But
right?
if there's
Yeah.
not a lot
Let's
of
see the
confidence,
picture,
you
yes.
might
Yeah,
get a
okay,
clue.
good.
But I think more than likely we're going to need retrograde to solve some of the problems, because especially the LED,
think
you have so
it's,
many branches
pointing
and other
towards
ways you
the-
can get lost.
it's,
I think now we're seeing a little bit of a
that's
beak
the
here,
major
though.
challenge.
So it's
coming
not
Get us a
uncommon
FCL.
that we need some retrograde to solve that, and the main issue is to trying to do reverse cart away from the left main, so we're sure we're okay there.
Oh, that's the only view that I start seeing it now. Can you
six
freeze
French,
it?
right?
Can you freeze it, please, at the
six is
spot that
also
we
fine.
can see?
Yeah.
And then you can try to aim there.
You know,
It's
this-
a short.
There you go.
So it's a short left main. You
Yeah.
see that?
Yeah.
So I think
Finally,
guide
we
is
can see,
selectively
yeah.
into the. Yeah.
So this is the view, or you just poked with the wire? Because
the
we
view.
didn't see it
That's-
before.
that's the
This
view.
is the view, right?
No, this is the view.
This is the view.
We saw it actually in the
It's
first
the
picture.
holy grail.
It's the
Where you
REO.
go.
That's what I'm about to say,
extreme
all about
REO
imaging.
cranium, which
Yeah.
always helps you in this
It's
area,
going
or the REO.
Don't open the
caudal.
guide yet.
Yeah,
we are.
let's
Don't
see,
do
are
that.
we in that pouch? And if we're in that pouch, then you can
We are
put
in
the
the pouch.
microcatheter. But are we in the pouch?
Don't open yet.
But
We
you
are
ha-
in the pouch.
Are we in the pouch?
Yes.
But just go back to the entry. If you have doubt, this is a very large vessel. If you do IVUS backward on the adjacent vessel, like the diagonal, you will see where the entry is. I mean, it's not going to be big.
Okay, some die.
You'll be
tell
able to,
you-
and that will save you all the dye and all the other contrast. We just already spent
You're
like
in the
30
pouch,
minutes.
but
You see
the,
at
but
least
the
a four.
corsair goes in the diagonal. Yeah.
A lot of this is starting cleanly, so as you're lining up your wire, if you take some cines and just one or two views to really tell where you are. I mean, you can do it with IVUS, but you can really do it angiographically by doing some orthogonal views, and it would be an extreme areocranial like you got into here, an extreme areocaudal.
Yeah, no, finally we find this view. I think it's critical to understand how the differential origin of LED diagonal is. I think this view is great. The difficulty, you already saw it, the wire went there, but the support catheter was just too straight and too non-flexible, one can say, to approach there over the soft part of the wire. Very tricky.
So a lot
Very
of
tricky.
times I won't use the catheter just
Field of
yet.
fine
Just
cross.
start with wiring first so that the wire is cleanly free and see how far you can get.
Yeah.
A lot of times this will just direct you the wrong way and then you can't track it in.
Yeah.
If the filter ready.
Get me the fine cross.
Fine cross and filter gives both the.
Yeah, I was thinking
I have
to do
Corsair. I'm going to change it. Yeah.
Yeah, we change the
This is
Corsair.
so
I think the Corsair is just too straight in the beginning. The other option might be you put a wire in the diagonal, just a BMW or whatever wire you like. So it always stabilizes your guide a little bit, and you can also see. So to avoid it, let's say. So this wire.
No, the one other thing is take a FCL guide that will be dedicated into the LED. Rather, the VL guide in the short left main is not a good guide. Let's see. We'll try once more with this fine cross. Otherwise, we have to change the guide.
Yeah, but
You have FCL ready. Okay.
I'd say put the wire in the diagonal so you can see where it is.
Now we are back. We changed to fine cross and fielder again. And let's see if this will help us.
Fine cross is not steerable as the Corsair, but is not, doesn't have this bulky edge. So it may be able to make that curve a little bit towards the LAD. I guess not really.
Okay, now, right?
Or you may, or you get a more dedicated.
So now you
wire.
see that you need a stiffer wire here.
Yeah, go with a stiffer
you need
wire.
Some stiffer wire to drill.
Yeah.
Or can
so with a stiffer wire, and as Dr. Fox suggested, if you're able to advance a wire beyond the radio pack portion, and it's a little bit stiffer, maybe the catheter, hopefully the catheter will
change to Miracle here.
Hopefully the catheter will follow.
Or can you put a wire and a balloon into the diag?
Yeah, exactly. I think we need to advance a little bit there.
Somebody said it. I think it's a good idea to have a wire in the diagonal. Number one, there's a lesion in the diagonal and you want to protect it. But number two, it'll also help stabilize the guide. And then by withdrawing the guide a little bit, that will actually angle it towards the LAD.
Some die?
And you can even do a low pressure inflation in the diagonal, right?
I have.
Yeah, I wouldn't start doing
am I there?
Yeah, we are there.
You got a long case.
I mean, technically, if you inflate it on the diagonal exactly at the bifurcation, the wire and the catheter will stop buckling into the diagonal. You can inflate it to a balloon in the diagonal and just block it, so the wires don't go.
All excellent points, but I have.
Meanwhile, you made
the proximal cap.
Yeah. Which wire are you using now? Gaia 3?
No, supposed to be Gaia 3, but since...
supposed to be Gaia 3 according to the app, you mean? Is that what you mean? According to the app, it's supposed to be Gaia 3?
No, not according to the app.
According to who then?
Look at the way the curve was.
Artificial intelligence.
Myself.
But I thought you made the app.
It does not. No, look how the LED's the takeoff is. Gaia comes with a pre-formed curve. And I was worried I may not be able to make the turn, but looks like this is not doing anything.
Yeah, so we revert back to Gaia 3 according to the app.
Otherwise, I will change to Gaia now. Yeah.
Is there a factoid that can show the wire escalation up, please? In one of the multiple screens
Andrew,
we have.
Can you put it on the side, the CTO wire escalation?
Yeah, what's happening? Yes, I see. Yeah, I guess we are, but it's in a screen that I can barely see from my location.
Only the first
so you can
wires.
look it up. The audience can look it up there.
Yet.
But the audience can look it up. But the panel and myself have a hard time seeing what's projected.
Okay, now die.
That's great.
That's a good shot.
Okay. I have some.
Get me the Gaia then. You know, the tip end on that wire looks somewhat extreme to negotiate through that straight.
So
LED
Miracle is a very old generation wire, okay, compared to the current newer generation, Gaia Next. Gaia Next has a special core. They call it as X-Trend. So 1-to-1 torque is a single core. 1-to-1 torque is excellent. Hydrophilic. Now the Miracle is a no hydrophilic coating. The current most wires are either polymer jacket along with hydrophilic coating. So they really help in anti-grade. So now I'm changing it to Gaia 3 Next.
So Gaia 3
so
Next.
This is Gaia 3 Next.
Get a Confianza Pro 12. Don't open it though.
So it's something to say that, you know, the wire bend in most cases really is just a loop. It doesn't really matter, but I still take a lot of time to make a good wire bend in your CTOs where you really try to get it almost a double curve where the curve is really at the end of the wire so you can really move that tip around.
Okay, it's going away, right?
As you're exploring to where the cap is.
I might add 2 points. One more generally
it's good.
about
Keep
the
going.
concept.
It goes somewhere.
The concept of anchoring, you know, while it's very valuable, I think it has to be done with caution as you lose a lot of tactile feedback.
You know, we don't really know where the trajectory is. This seems
pretty
very
good.
good, the trajectory.
See, the wire tip is
very good.
Very nicely done.
Let's do a...
so do a retrograde injection, see where you are.
We are in the septal. Okay, ready?
Yeah, ready.
Might not have just gone that far. But.
Yeah.
There you go.
I just have to get into the LED.
Seems like we're very good. We're in the septal. Let's see where we are though. Yeah, we have to be in the another branch to be sure, and we are sure now.
Okay, that's LED.
Okay. Beautiful, beautiful, beautiful. That was a great job. The Gaia 3 wire, successful
Okay, take
wire.
another picture and document that we are in the digital vessel.
And
you never know.
Yeah, I would say that this is.
Wow, where are we?
Well, somewhere, but I don't know. Let's see. Let's see.
One of the branch.
Let's see.
Wait.
Let's see.
Oh,
Yeah, try to get in the main
table is
LED.
stuck. Yeah, we'll get into the main somewhere. I want to go to low Mac. Okay, some die there, or in the LED, or somewhere outside.
That's why the second view is always helpful.
Yes.
Okay, now?
Yes, it is.
I don't know, it seems a little far off. I
It
think.
might have gone subintimal here itself, yeah.
I may come all the way back to the proximal cap, because even re-entering there, you're going to lose, proximal branches.
How about a different view?
No, I think the little core of this wire needs to point down as opposed to point up in a little bit further back. About, I think about a centimeter from the...
Yeah.
From the, right there, you're already going a little bit up. I think that might be the situation. You need to come back and go a little bit further
No
down.
die?
No.
Okay, right here, I need to enter into
A
the...
little bit further back, I'd say. A
Proximal
little bit
vessel,
further
yeah.
back.
This is why Gaia, as good as it is, the curve,
A little bit further back.
pre-made curve does not help most of the time.
A little bit further back. A little bit further
It
back.
does not matter, we need a little...
A little bit further back. How about trying an unmodified curve confianza? Just go straight, no curve.
I'm going to go to Confianza. Yeah. Get me Confianza 9.
9?
Pro.
Pro 12.
Same thing, regular 9 or 12, what do you want?
Pro 12.
Oh, he wants 12.
Pro 12,
Give him
Pro 12. So we have a fast track
So Pro
escalation.
is same, Pro means there is a hydrophilic coating, then there is a regular non-Pro,
Yeah.
non-hydrophilic coating.
We're going to need the
Okay.
coating a little bit.
No die. That's subtle, I guess.
Is it worth taking an antigrade? Do you see any dye going?
No.
At exactly 10 millimeters or so after the tip of the fine cross, I see a slight deflection upward, which I think might be the exit. So somehow...
So,
you got to
see, we
pull
took the
back.
fine cross, but the issue is the fine cross does not go any further. But let me get it at least into the proximal cap a little bit. Okay, get me the Confianza. So I'm going to take this out and go in with the Confianza Pro 12, as George mentioned. Wait, don't open, don't take it out. Do not remove the wire until you have your next wire ready. And I'm just going to make the curve myself.
I think if this doesn't look good, alternatively, we can downgrade pretty quickly to a jacketed wire.
John,
that
there
may
is a
knuckle and
microphone
tell you
right
more
here.
about where you are in the
Oh, yeah,
architecture.
go ahead.
I'm going to recommend that if I'm going to take a cranial LAO shot in the lateral view, that'll tell you how the medial or lateral to the
LAO cranial suggested by Dr. La Sala.
I agree that another view, you'd like to see if and where you're leaving the vessel. I mean, in that one view, it looks like you're in a septal, but that can also be deceiving. And because I don't know that a Confianza Pro, penetration power is not necessarily your issue here. Right.
I would say just keep pushing.
No, John, I think I am subintimal. That's why we have to re-enter.
But where are you? Where are you subintimal?
From the get-go.
Right here, proximal, right here. I am redirecting the wire.
Keep the redirected towards pointing down, that little curve point down.
Yeah. Retrograde die. Okay, right here, I think.
Yeah, why not different view?
No, it's going
Okay,
up.
what view? I don't think view is, they want eleocranial. I want to do anything. Good.
Different.
Now, if we have done, we have multiple channels. Somebody mentioned go back to polymer jacketed, downgrade, go to polymer jacketed wire. Not a bad idea either. But here, I don't think I've been in the lumen at all.
Well, I mean, that's why Dr. Huber and others suggested the retrograde, but you know, sometimes you can get be surprised. You just don't know. So antegrade always seems to be a trend these days. Even though if it's very difficult like this one, it's incredibly difficult.
I want to come back. Antigrade.
Yeah, the ambiguity is really difficult here. So I think the resistance that we saw initially was promising, and it's just hard to tell where the guy is exiting. So sometimes just using that through that initial puncture and then maybe de-escalating.
Fielder ready.
Fielder again. I'm going to go back to fielder and see. I think definitely Gaia, if you see here, the way I think we made the entry, Gaia took us to the upper surface of the LED, right?
So I guess another wire can
and
take
we could never re-enter. That's why our confiance I was hoping will allow me to re-enter, but it did not.
Yeah.
Now they were saying go eleocranial. How?
You can, once you enter, we'll take one.
Okay.
Well, now we're away, so I would just stay here because this is the view that shows you the entry point, and once you make some advance, you can see something else. So the hope here is that this wire now will somehow take the entry of Gaia and then find a different way inside.
I mean, ideally, you should re-enter the cap in a different location, but since...
Well, on the other hand, some wires tend to go high, parallel to the diagonal, for example, and I don't know, we dismiss that possibility, but sometimes the vessels make a loop, so it may go up and then go down towards the middle AD portion, not necessarily that is completely straight.
Gaia we make with the curve, right?
Yeah.
Get the Gaia 3 back again. I'm going to make the curve, extra curve on the Gaia, and see if that can...
So you're planning to
Want to take an
re-enter
integrated
from scratch, right? I mean,
yeah,
that's probably
re-enter proximally from the scratch. Yeah. Can you take
a good strategy.
Picture, right?
And another strategy is parallel wire. I know we don't do that
Good.
much, but it's still an option if you get the wire in the wrong direction.
No, but the channel is not the best
Along with re-entering, I think sometimes an angled catheter like a supercross will facilitate puncturing the cap.
That is another thing we
in a different spot.
should be. Now the question that, or do we even change to FCL guide before doing that? Do both. Okay, now.
Fielder.
Yeah, is there a, do you want us to go perhaps, I don't know, I see the
Changes too.
I see the, there is another line, there's another case going somewhere else. You think we should get started with that, let you work a little bit in peace and then come back? Is that,
Yeah.
I don't know if they're ready or not.
Yeah, saying that they're ready.
Yeah, when they're ready, they can request us from the other room, and then we'll join there.
This could be the same, could be different. Will die. Same.
So then maybe now do your other view.
No, we have re-entered into the same one, different. So what I want to do probably is, I think we will change to FCL guide, maybe the orientation could change, and then try the same wires again. Meanwhile, you should go to room, which room are there already? 3?
The room number ready, that room. Which is the room number ready? Let's go to that
room
one.
3.
All right, guys, move this camera a little bit away, slightly.
Okay, here's Dr.
Okay.
Sharma and
Welcome
Dr.
from
Sardar
room 3.
Farhan. Excellent.
All right, we have Farhan and Muthu and Gaurav. My team, Vicky and Ashley, right? All and everybody else, the same crew for, yep, move the monitor away so we can see things.
Excellent.
Yes. So this is the case number 11. We jumped a little bit, but still the sequence wise, very interesting. Wanted to show always something different. This is the patient, 67-year-old, had a PCI in the past, positive stress test, an anterior wall ischemia, good medical therapy, and here for the LAD intervention. And I'll show you with what LAD is. In this case, particularly because of the rota or plus minus cutting balloon. So rota ablation, yes, plus minus cutting balloon. This is our trial. Where is the slide? Advancer clicker. Can we buy the advancer clicker? Yeah, move it, then move, good. So this is what we are going to do, rota cut concept. We start, this is the FDA initiated trial. The issue is, we usually do rota and high pressure. Question is, can you do cutting balloon? Rota plus cutting balloon, use a smaller burst and yet get a good stent lumen. Next. And basically, there are some data to say. You do cutting balloon and with the rotational atherectomy, you have a better lumen gain. Next. So this is basically the rota cut trial with myself and Jeffrey Moses, 60 cases, pilot study next. And the trial is quite intense. Intense in the sense, multiple IVUS runs. So appropriate case which need to be for severe calcified, you do IVUS in the beginning, after rotablation, plus whatever you need to do, and then rotablation, then you do a adjunct technique, and then in the end. The end is blinded. So after we are all done, a particular investigator is not there for the final IVUS run. Idea is, it's the minimum stent area. It basically is the end point of the trial. So with that note, let's go back to the case. We are all set here. So this is the patient with appropriate, and look at this one. Already we did an intervention of which the RCA picture, always we say, patient comes back, even if it looks good, you have to take the picture of the previous picture of the PCI, with this is where we are. And more important is circumflex good, and look at this LED. And we'll ask the audience, I mean our panelists, aneurysmal, calcific. Everybody will be worried about that what will cause perforation. But look at the calcium. And I always say the calcium is that before you give the dye, you take a clear cine on those cases, and that will tell you a tram track point of view. See here. See, you see the whole tram track of the vessel. It's the severe calcium. Is it severe calcium? And then, of course, there is aneurysm. You'll have a discussion. What our goal is, this case is that we have a rota cut strategy. Rotational atherectomy and rota cut trial with the cutting balloon. And we'll do some IVUS runs while you have a discussion ready. So right now, I have the fielder fine cross, going to go through this lesion, change it to the rotawire, require a baseline IVUS, which I think we should be able to go through once we navigate through this aneurysmal segment. Always happens, the aneurysmal, that your wire is free flow, less mag, go to a low mag. You don't
Low
need
mag,
further.
okay.
Yeah. Okay, so wire has been advanced, and we'll try to do, if this goes in, yeah. So we'll do I was on the rotor wire. Let's get the rotor wire. Okay, George, you can have a discussion that in this tight lesion, will somebody think about doing this case with the IVL? But I can, lesion is a 90+%, approximately, whether IVL will even go, need to be seen.
Yes, we saw
See
that.
Yeah, yeah, see that.
Yeah, well, there's a combination of calcific lesion with aneurysm. Has any comments or reservations about this case? Maybe Dr. Waxman.
Yeah.
I think it's a very novel concept to go with this device combination, as long as the order is rota first and rota cut second. Because cutting balloon is not indicated for calcified lesions, but it can give you maybe better expansion. That's, I think, the premise of the study. I think that the concern about this case is that looks like an aneurysm there, that you want to make sure you're going to go safely there without any perforation, especially with rotational atherectomy, that you have control on that. Again, I prefer to do imaging if the IVUS or imaging cutter will go to better understand what is this entail.
I mean, I would not have, let's say, without the trial, I would have just done the rota and then maybe in the end, if needed, imaging. But this we wanted to show. But as you said, I'm sure you probably have a connection with the FDA. I'll tell you why. Took us 1 year to convince FDA that cutting balloon in the severely calcified lesion after rota is okay. Took 1 year because this is an investigator-initiated trial. And there was so much difficulty back and forth. We provided our data of the database that combining is okay. We say cutting balloon is not indicated for calcified lesions. And therefore, we have almost back and forth combination. It's the Roxana Maran's team really persisted with all the questions I answered, provided our data, and finally, we have approved. This is the investigator-initiated study with the FDA sponsored. But you are right. The biggest difficulty we had was to convince that it's okay. This is strategy we use in our clinical practice. Okay, so here, it doesn't go beyond. So that's okay. How are we doing for the...
Okay,
can we see
when they start with the pullback, like 70,000. So I'll start pullback from here.
Can you see that aneurysm or no?
Not this all of the aneurysm part. The 270,000. Here is a big chunk.
This is that aneurysm. See that?
This is the aneurysm, big vessel.
And that should be a very tight lesion after that.
Yeah. Yeah, it's also 270,000.
Full circular calcium.
Yeah, 360,000.
1.5 will be okay.
Yeah. 1.5.
All right, Ran and others to tell us what we do after this. Okay. It didn't go after that aneurysm, which is okay. But we saw that circular calcium before the aneurysm and a little bit had the distal part. The question is, I know that if IVUS did not go through, IVL alone will not work. So we are here with a 1.5 rota bar and ready to do a rotational atherectomy unless there is some objection.
175 is this?
So, I think the concern is obviously, atherectomy in the thin wall aneurysm you want to be really careful of. So the stenosis really seems to be before the aneurysm. So I would try to not do atherectomy in the aneurysm. But the other thing with IVL, I think it's an interesting IVL case. And even if you can't cross with the IVL, you can use a 2.0 balloon and then pass the IVL catheter. And that was done in about 20% of the cases in the approval trial.
Why is this not running?
Interesting. Mario, what do you think about robotic or non-robotic Lima to LAD? I see you anxious in your seat. Hybrid revascularization. RCA has some stents. There is a patient is on dual antiplatelet therapy. There you go. Lima to LAD, robotic or not. Doable? What do you think?
Well, George, as you know, that has been the future for the last 20 years. So there is a reason for that. And the reason is that I think the concept is attractive, but it's not for every patient, it's not for every surgeon.
Would it be for this one?
Well,
okay, we are testing.
You know, I understand you guys are focused on the angiogram. I would like to see the patient around the angiogram.
Okay. Yeah, test.
And that would give me a lot of information of how easy or difficult the case would be in patient with.
What is the BSA for this patient?
BSA. Chest and height.
Now this patient is actually the average height and weight, non-diabetic. Huh? And BSA is 1.95. So it's a good case for robotic and nothing against that because of aneurysmal. And we'll see if there's any trouble we do now. Before we continue, I think if you can go back to room 1, they say that Dr. Keeney crossed that lesion and they're ready to put a stent.
Let's go back to room 1.
Yeah.
Let's go back to room 1 then.
We complete there and then they go to...
And then we come back to you quickly. Dr. Kinney, hello there.
Yeah, we are good.
Oh, you see us? Okay, good. All you went away and we recrossed. So remember, we changed our strategy. We pulled back. And then with the same Gaia, same thing. You see that cap? If you can see in this view, it is actually beaking.
Yeah.
So you needed a wire. Short proximal, so it's very difficult to get a wire. That's why I took Miracle, exactly the reason for Miracle, so that I can get into the center of that proximal cap. But looks like Miracle would not go further. Then Gaia took us on the upper surface, came back, and when we entered the proximal cap, and then I think with the, this is where we were, after we re-entered with the Confianza.
Confianza Pro 12, successful work.
And yeah, with the Confianza 12. So if that, I think going back to the point was same. We were initially subintimal and we tried Confianza, would not. If not, what would have been the next choice? What I would have done next? Change the guide, go to just FCL, so that we know it is just for, facing the LED. And like Nitin Barman mentioned, could we have gone with the curved catheter like a supercross or something so that we know it faces the LED more. And what are the wire escalation? Let's go back to the wire escalation. So we already were with Confianza 12, which is 12 gram. So the next that is available for us would be either a Progress 200, which is about 13.8, or Hornet, which is also close to that 14. Yeah. But Gaia 4 goes up to 10 grams next series. Otherwise, we didn't need it, but if you truly have calcium and your re-entry, if I was not able to go with Confianza 12, then I would have gone with the Progress. It's very good. It's a polymer jacketed wire. The tip has a hydrophilic coating, that's not a spring coil. Tip is spring coil, which is with a hydrophilic coating and tapered. So many of these CTO wires, what's the great thing about this new generation wires, many of them are tapered. And I hope they're showing our app slides in the side, where we have a library of over 130 coronary guide wires, and we discuss every wire, the property of every wire. I think as intervention cardiologists, it's good to know which wire works in which situation. We also have over 20 cases, complex cases, showcase which wire to be used to where. So after that, the fine cross actually went all the way down. We exchanged with a 300 run through, pre-dilated with a 2.5 balloon, and now we have a 48 millimeter synergy because patient had synergy on the other vessels. So we're just going to place one stent. We are just focusing to make sure ostial LED is covered, and that's where we are. Any questions, George?
No, I think that was very well explained. Any comment from Dr. Huber?
My question refers to the diagonal branch. Isn't there a significant stenosis immediately at the site where the LED was occluded?
Is there a diagonal stenosis? Is that what you mean? Yeah, well, I guess we'll see after the stent. It's very difficult to distinguish right now with the equipment and all that. I think there is an intermediate lesion. Is there a diagonal?
I don't think there's a significant lesion. Here, there's no significant lesion in that diag. You see here?
No, I understand, but these are a significant lesion after the crossing. That's the question of course.
Okay.
We'll see.
No, I thought he was mentioning.
I agree here.
Okay, ready?
Yeah.
Greg thinks there's a lesion there. He said it from the beginning.
Yeah, in the AP cranial, it looked worse.
There's an intermediate lesion there. That doesn't show it, it doesn't show it at all because it's overlapped, so it's good. No lesion seen.
In the AP cranial, it looked worse. Your setup shot.
I did not think there was a lesion, but...
Okay. Well, you see it better than we do. It's the confidence monitor is a little far away from us.
Okay. Time for some vasodilation, and I think
it
we're
looks
done
quite
with this
severe. New to us, it looks quite severe in this view, the osteodiagonal. That doesn't look severe to you?
It's a great collateral to it.
No, now after stenting, there is side branch stenosis, but I think again, same thing. We probably would say 80% we can recross and kiss. Yeah.
Yeah, I think it's reasonable to do a little recross and kiss. It's probably maybe there was a 50% or something lesion, very borderline at all. And now after all this work and scratching it with wires and putting a stent and all that, it's jailed. It's get a little worse. All right, we don't have to stay here unless you want us to stay. We can go back to Dr. Sharma.
No, I think you can go back, finish that case because I'm about to start the second CTO in room 2. So here we will recross, kiss, we give vasodilators, and otherwise LED is done. We see all the branches patent, which means that everybody suggested, go proximally and re-enter proximal. That's what we did. And this is where we are.
Sounds good. Let's go to room 3. Great job. We'll see you in room 2 in a little bit. Let's go back, Dr. Sharma, Rota cut case.
All right. So we showed the IVUS, the circular, and I would say that I'm glad that a panelist agreed. I always wanted a little cutting balloon, the diagonal to be taken care because it's a good size diagonal. I mean, we need to really open that up. But there is now a little more pinch. Even originally was some blockage, but definitely now you have to have a good result of this. Okay, now we are ready with the 1.75 bar Rota Pro, as you can see here. And now question is, and then this is the kind of case we could have perforation. Pull the wire. So we have actually, some of these tough cases, you have a papyrus stent ready. Whether it's a Joe stent or papyrus ready in the room, not in the cabinet, which sometimes may take 30, 40 seconds. So this is the kind of case. We have it ready here. Good. So now, question is, the speed check outside 150, we have the Rota Pro setup, 150 speed, all of them. And then you have do what same, the technique point of view. First we have to pull back the wire. Wire is quite good. Yeah. So now, once we have proximal, 3 things: add advancer knob, add the Y connector, simple thing. An idea there is that will prevent and just a tap on the Dynaglide and will not jump. So with that note, we are ready to start. We have 1.75 bar ready, although it probably would have taken a 1.5, we'll see. If we feel some resistance, and same, packing, touch, come back. No, we did not cross yet, and it's the RPM, because of the angulation, went down to about 130, so we are going to upgrade our RPM to 150, 55. I know that one small randomized trial of 100 patients didn't show any difference, low or high speed, but we go with the low speed usually, 150 and so. Good, 150, yeah.
Somehow
we can't I'm not doing a daughter, but touch and come back, yes.
We can't hear the burring. I don't know why. I don't know. Is it stalling or is it we don't hear the burr? I don't know. Anyhow, but we do see the burr advancing and, the slow motions there.
You don't hear the noise of the burr?
No, we don't hear the noise of the burr, no. Is there I don't know if but we hear you. Is there there may be, let's recheck the voice, the volume connections from this room, please, AV team. Otherwise, this is a little bit of a silent movie.
So, George, when you do a case like that with the aneurysm, you have on the shelf or next to you a covered stand ready to open?
Yeah, papyrus. What is
yeah.
We have to show the factoid with papyrus, pericarditis, tray, and protamine. There is a factoid we have, but we rarely use it. I think this is very, very good, very, very good technique crossing. It went all the way. Pretty stable, I'd say. And for anybody who had doubts regarding whether this case required a rotablator, the difficulty with which the bird is advancing, I think this makes the point very clearly. This vessel is severely diffused disease all over.
Just for the crowd, it's an interesting point that you didn't hear the burr noises. Burr noises
with a brake release.
Is it different if it was a pseudo-aneurysm versus an aneurysm? Because I think also that that part you need to take into consideration.
Just to go over that again.
And there is a lot of calcium distally.
I mean, if it's a pseudo-aneurysm, you would never put an atherectomy catheter next to it.
Go ahead, John.
Even the pitch, you really need to be listening to the burr sound, because even the pitch will tell you when you're about to stall, when you're not going to stall. So it's the first thing that you react to. It's not the odometer, it's not the speed on the machine. It really is your ears.
Yeah, no question about it. But indeed, the aneurysm seemed to be a little eccentric, to say the least. I don't know if it's pseudo or a circular-like, but definitely an eccentric aneurysm.
Run through.
One can say in that location.
Well, it's
very curious to see how we are.
It's a real aneurysm. It's not a pseudo-aneurysm. Yeah. You can see the three-wall structure.
I was always in Greg's camp that I wouldn't necessarily want to burr into an aneurysm. Okay. May have tried a non-compliant balloon and then shockwave.
Well, let's see. First of all, the pressure is good, so there's no perforation, Dr. Waxman. We'll take down this factoid. Very good.
I will take this.
All right, so let's see.
You know, another question, how do you treat aneurysms like that? I mean, right now we don't have any good covered stent and nothing label on that, but do you leave those big aneurysms by themselves or you cover them if you had a good device?
No. In this particular case, as you saw, there is a lot of disease distally. Even after the aneurysm, look at the calcific. So we are going to cover it, and actually we have published that what you do is you go proximal to distal segment, long segment of stent, and basically what happened is we actually have a jack intervention case report. After when patient comes back, you have proximal to distal, you don't need the covered stent. So what will happen is the aneurysm, there will be no flow, and we have a follow-up CTA and angio on that RCA with one of the fellow we presented, published. So what happened, because of low flow, it closes up by itself. Flow becomes very little, so aneurysm actually becomes just half in size. Yeah. And you'll see here that in this particular case, that is what's going to happen now. This is the run-through wire. I have my rota wire there, and we are going with the 3.5 balloon now to open it, and you are getting ready?
The so-called end-to-end technique, normal to normal.
Yeah, normal to normal. And that's what we are going to use here. What stent supposed to use here?
It's a synergy because the RCA got the synergy.
Yeah, because synergy here, we'll use a 3.5 38 synergy in this case. Because it was a 3.5 vessel by our IVUS imaging. So go up here and leave that wire to a modified cutting balloon.
I have
10. But since this patient is not in the trial, we 6, 8, 10, 12, 14,
14, 16.
Now, lesion has to open before we go further, and if required, maybe we combine with the IVL. It's a 1.75 bar. This area bar did not complete. So we just stop at that level, and that is what I have been making a point, probably less traumatic,
14,
because
16.
now you have IVL. And I think that one of the advantages of the IVL with the synergy, it's not only just the synergy maybe for stent expansion. I think IVL will decrease our atherectomy complication, be it may rota or orbital. Why? Because we'll use a lower speed, we'll use a smaller bar, and that's what will happen.
Going up.
So this is at the level
14,
of aneurysm,
16.
and somehow patient is having hiccups. You see it, the diaphragm having a very aggressive movements, and I know that Dr. Keeney will be ready in few minutes. So this is here. So question comes in here that angiographically we are okay, or we have to go with the IVL now. Go up again.
I don't know. I don't think so.
So can you IVUS and show us how you've
14,
done?
16.
18, yeah. Yep, we'll do it now.
With
Good.
rotational,
Okay. We'll do the
one
IVUS
difference
again.
between rotational atherectomy and both orbital atherectomy and IVL is that you don't get as deep calcium fracture. So the rotacut concept makes a little sense because you can hopefully extend the depth of the calcium fracture. With OAS and IVL, you tend to get very deep calcium fractures, so you probably don't need a cutting or scoring balloon.
Right.
Okay.
So essentially,
All right,
you
so
crack
we
a
are
little
here
bit,
now.
and
I
then
was
you open
now
up the
again.
crack. Yeah, that would be interesting to see the IVUS assessment of this concept.
Also, everyone's always worried about stenting across those aneurysms because you're going to, almost by definition, have 3 millimeters of malapposition.
Almost, yeah.
But that's not a concern. That is absolute no risk of stent thrombosis as long as you've got really good expansion of the stent.
Right.
Stent. And then more importantly, by the time we'll be done with the stent, I can guarantee you this aneurysmal size will become half. As I mentioned, because of no flow, and that is what else happened now.
Yep.
Okay, we are here. Start the IVUS quick.
Okay, check the imaging. Yeah, good healthy part. Okay, start to work. But this part, it looks like vessel size is 2.5.
3.5.
But normal vessel.
We are very
is
distal
coming.
yet.
Yeah, now calcium plug start. Yeah. 1 quadrant calcium, some blanch. Yeah, lumen is getting bigger. Here is like 3.5. Or like aneurysm part. It's,
But at least there is a cut, right? There is no circular calcium. So Greg, your point that it's not a much deep calcium superficial or there, we have made some cuts.
I see the
And at this area, it's not a full 360 degree, only 180. Now we are getting to a little higher. This was the one, we got a good lumen of maybe 2 millimeters, it was 1.75. This is the aneurysm.
So this is the aneurysm part.
And now we are going to come a little proximal.
Oh, let's see.
Okay. Yeah.
This is the proximal lady. Still
Good.
coming.
Okay,
Still coming.
good. With that note, what we are going to do is we are going to put a stent. Then you'll go to the room 2 for Dr. Keeney, and she will do this another CTO case. And once she crosses, we can put that on the side.
38.
And then stent.
Stent, give us the...
So put it on the side and complete the case, and you will start your lectures and so. So far, so we are good.
416 synergy.
No, stent.
Interestingly, with
But
the...
I'm sorry.
Tell the stent what we need.
It's interesting to see that
35,
proximally
25,
you
20.
pretty you
360 degree
sanded the
calcium.
lumen, but you didn't make deep cuts into the lumen. So
Ideal
you
they
made the
have.
lumen larger proximally, but you didn't make the deep cuts. So it would be nice to get something that would cause deep fractures in that proximal lumen before you start
Well, I have a
trying to stent it.
question. Greg and
See, right here. See here, you were still almost 300 degrees of calcium.
But
But
hopefully
we have
with some
shaved
cracks.
it. Remember, we have shaved it because we went through the bar.
Well,
From that point of view,
Right. There's still
clearly that
360 degrees of calcium.
OCT may tell us exactly how much we shaved, but we know that we went through the lesion, so it has to do some shaving, and so here we are ready with it's a 3.5. Huh?
Well, Dr. Duvuri brings up the possibility, which obviously another approach,
38.
the rota shock approach, instead of the rota cut. With the rota, and then you do a shock wave. That's another approach, I suppose, for extending and do that. It's just not exactly this approach.
That's
but
actually what I would
somewhat.
favor personally, because I know that you're going to create deep cuts in the calcium with lithotripsy at this point.
To improve the compliance, right?
Absolutely.
Right. So, no, I think the question comes is you are absolutely correct. That at what point now you bring IVL in this particular case. So that's, I think, a very good point. So I would say 2 things. If I had not done the imaging, or imaging says that, yeah, lumen is looking good, we have made some cuts, interruption, it's okay. And it's not a deep calcium, which we have modified. Or secondly, I would say that if you you have done the rota, just you go to high pressure balloon or cutting balloon, little die. And if you, little further, 1 second. Yeah, go up here. So this is the 3.5 38 synergy, XD. And we can always, we can post dilate. Look at the stent. Nicely expanded at 14 atmosphere. Stent usually we do 14 or 16. And angiographically, of course, since this case we did IVUS, we are going to repeat it again. But I can tell you once angiogram, if looks good, it's rarely, because we had modified the plaque. And of course, sometimes you can just do our stent boost to see the results.
Whoa.
Okay, let's take a picture here. So we can let them go to other side. Good. Look at the aneurysm size. See that aneurysm has become half the size than before. This is exactly we published on one case report. That aneurysm actually was 8 millimeter, became 4 at the time of the stenting with a 4.0. So with that note, if everybody is okay, we are ready to move on to our room 2 for another CTO with Dr. Keeney.
Excellent. That was a great case and a great result, exactly as predicted with a normal to normal technique. Dr. Keeney, let's go to your home room, room 2. Let's see what's happening.
I think so too.
Yeah, I like the word home room. Room 2 is where the most of the live cases has been done and relayed to the relay that we do every month and the entire world, what we call the Taj Mahal of the cath lab here. So myself and I have Parasuram, he's our structural attending, but a young budding great interventionist. Then I have Isha, our fellow. She was also homegrown, all her fellowship, everything done in Mount Sinai, and she's going to stay as a faculty here. So you'll see her in many of the live cases with me, and of course the whole crew from the morning right here. Okay, so if you can show the slide, which is live case number 7, 68-year-old male with stable angina right now, but when he first presented, which was 2 weeks ago, he presented to his cardiologist, who is a Mount Sinai cardiologist, also had angina class 2, but more important is that look at his ischemia, extensive moderate anteroseptal apical ischemia. When you see something extensive, you know that you are going to find a totally occluded vessel. So he has multiple risk factors. Years ago, he had history of MI. At that time also, I took care of him. And this time when he presented, he had shown a lady that was total and a significant 90% lesion of the circumflex, which we took care. So this is his angiogram. The LPL stent looks good. RCA that was done, MI vessel years ago, that's also okay. And
Right.
EF is about 45%. So let me show you the cranial picture. So what is interesting here, yes, we have a mid-LAD, that's CTO, and heavy calcium. Before we give any kind of dye, there is a tram track calcium right there.
Right.
So you have a CTO, about close to 20 millimeter lesion, calcium, and a side branch. So it makes it JCTO score of 3 in this patient. So we thought, this kind of situation, again, the discussion could be, he's a good case, distal vessel is beautiful, that he could go for just a robotic lima, and we could have done the PC of the circumflex versus the earliest discussion that, try, what it has been shown. Anybody with a JCTO score greater than 3 should go to, the center of excellence to do the CTO. So that's one, or at least give a try, and if we fail, maybe at that time you can refer him for a single vessel, a robotic lima to LAD. So this is where we are. You can ask the panel what would be the plan, how we approach this vessel.
All right, Dr. Barman, what do you think?
I think that obviously the noticeable differences are, well, first of all, I agree that lima consideration is always not unreasonable. But from a technical standpoint, obviously the calcium seems to be the most challenging. The length is not substantial. There's a good runway into the cap and a pretty clearly defined cap. There does seem to be some disease in the just beyond the distal cap that can sometimes pose some challenge in terms of reentry, but I think a standard antegrade wire escalation strategy is reasonable, and depending on how you cross and pending some imaging determination as to how to modify.
Great. Dr. Kearney, any ideas? Any other ideas, perhaps?
Yeah, this is a great antegrade case, and at least we don't have all the ambiguity issues, including because of the track from the calcium, but I agree she's likely to need a penetrative wire because it's fairly blunt and because we know that calcium's there. But it does look like we have a good reentry zone before that next diagonal and some room to work there for ADR as well.
Okay, so I'm going to start the strategy the same. I have a fine cross and fielder, so I can get where we are. We already are there. And once we are there, we'll try.
You're already there. Ready
No,
to
means we were all not there, means we are not, the fielder, we are in, with the fine cross and fielder, but fielder would not go further. Resistance
very tough.
there.
It's
So I
a
think we have to change.
It's
Yeah.
a calcific one, so it's very difficult for filter to work. But it's may make some channels, and then other wires can pick up those channels, and That's how it works.
Question now, can you ask the panelists what would be the wire escalation that they would use or something? I know I mentioned the wire escalation that I use here in Sinai.
What is the app indicates as wire escalation is a question. And then
so the wire escalation question, I think one other wire I did not mention earlier, many people use it, is a pilot wire made by Abbott. So pilot comes 50, 150 and 200, and that wire was extensively used actually in expert CTO trial. We were the Center for Expert CTO trial. And then I did mention the progress wire. The progress wire family comes with, again, multiple with the tip load, but the one we use here in Mount Sinai would be Progress 200, which is again close to 14 grams. Now you can ask other people any other wires that they would use.
Ron Waxman.
I would say this is a very powerful wire, but you have to be wary of dissections here because it tends to dissect subintimal and you have already an angle. So
other ideas, Dr. Huber. What wire would you use here?
Well, I really would use the wire that is used at the moment here, despite the potential fear for a dissection, but I think it's a good wire.
Dr. Stone?
Which wire?
Everybody agrees with you so far.
Yeah, I think the Pilot 150 is a good choice. You could also, go up with the Gaia series. The key is tip control. You want to be able to really feel this lesion. Because if you're up against a little calcific nodule, it'll deflect and it'll become subintimal.
Yeah, the deflection in the distal part, particularly because there's a high-grade stenosis with the calcium, is a really concern here.
Okay, antigrade only you see, right? Some antigrade dye.
Let's take a picture, see where you are. Retrograde picture, please.
No, antigrade actually you're seeing more than retrograde, I think. Okay, go both antigrade and retrograde. Okay, first retrograde.
I think it's a great result.
Oh, yeah, a guide came out.
Retrograde.
Okay. Yeah. This other thing about this retrograde is, okay, I have to make sure. Antigrade you can see. Wait.
Antigrade, we're not going to see that much. We need to verify the distal wire position, but now you're in an unusual projection to engage the guy. There you are. Okay.
Okay. Give me. Go antigrade. Okay. I think we are in the lumen there. Yeah.
Looks pretty good.
Yeah.
Well,
so this was
let's see
Miracle 6.
Let's see if we advance it over the distal. Yeah, Miracle 6?
Yes. I don't know, I may be the only one that uses Miracle 6.
Yeah, I guess so. I would have gone with Confianza Pro 12.
Okay, I know you like Confianza Pro 12.
Is still a good wire.
I know that was your next one. That's good. Great.
Okay,
no,
now,
it's a great
I'm going to change
example.
to Rota.
Yeah,
I'm going to change to Rota. Now, other wires that we did not mention, but probably in the calcific vessel. Actually, we have laser ready in this room because many times in a calcific lesion, we'll be able to cross, but here fine cross, or the wire catheter usually do not cross. In that situation, remove it out, and then we know, like we crossed here, we know that we didn't create any dissection. Laser is not a bad idea that you go and lumen, and then you can either dilate with a balloon, or if you really have a lot of issues, then go rotational atherectomy exactly the way we did in the other room. The other wires that which should be used cautiously is the Astato group. The Astato actually comes with the 20 and 40. The tip load is 20 and tip load of 40 in the coronary. Could be used in the calcific vessels to make sure that you can puncture the proximal cap. So I'm going to change to Rota wire, and since the fine cross crossed, we'll probably use a 1.5 bar, then balloon, and do a stent.
Yeah, very good. Why don't we, this was expected. There was a great demonstration of the crossing. Let's go to the We're going to put this on the side. We're going to keep watching you work. And we're going to silence, though, the room 2, so we can proceed with our 2 lectures on the guidelines. Thank you and congratulations to Dr. Kinney and Dr. Sharma for 3 great cases, 2 CTOs and 1 rota cut. And I'd like to thank the panel for joining us up here. You may stay if you want, or you may go to the more convenient tables over here for the faculty. And let's go with the 2 PCI first, Revascularization Guidelines 2020, PCI perspective, Dr. Huber from Austria, and surgical perspective, Dr. Godino from Cornell Medical Center. Kurt. Slides for Dr. Huber, please, AV control.
Where are the slides?
AV control. Slides for Dr. Huber on, please.
Yeah, ladies and gentlemen, it's difficult to talk in 10 minutes about all these great revascularization guidelines 2021 with respect to PCI. I did a very subjective selection of what I think is extremely important, and just to tell you, the European guidelines, the last update was 2018. They are very similar to what I will tell you in a minute. So, extremely important that there are some inequalities in access to care, cardiovascular treatment, and outcomes in women, African Americans, Hispanics, South Asians, and patients with low socioeconomic status. And the decision to offer revascularization should be made on the basis of a patient's clinical characteristics, preferences, and should be the same for all patients, regardless of sex, race, or ethnicity. So you have seen this slide already in the morning. So in the middle, there is the patient. There might be the heart team. I come to this in a minute. And then there are clear phases of patient-centric care in the treatment of coronary artery disease. That's pre-intervention, that's peri-procedural, and post-intervention. Don't go into detail here in the sake of time. The shared decision-making and informed consent is also extremely important, as you know. And I also don't want to go into detail here, but this is a process that has to be taken on an individual basis with all our patients. I would say as soon as a heart team is necessary, also the cardiac surgeon should talk to the patient. It's relatively easy to influence the mind of a patient, so we really, especially we try in Europe, to keep on the guidelines. Now, the heart team is important if optimal treatment is unclear. For the unprotected left main disease, 3 vessels disease, 2 vessels with LAD and 1 vessel with LAD and diabetics. And I think this is something that is not done on a routine basis in all interventional cardiology departments, even not in my department, but we try to be very fair and discuss especially complex cases with our surgeons. The syntax score has lost a bit on importance compared to the years before, but it may still be useful in multi-vessel coronary artery disease. So what are the general benefits of revascularization, no matter whether it's CABG or PCI? First, we are able to lower the risk of spontaneous MI, unplanned urgent revascularization, also cardiac death. And most important for the patient is that we improve symptoms with these revascularization techniques. So revascularization versus medical therapy, we had quite interesting studies, ischemia trial or the 10-year follow-up STITCH trial, that showed us that an intervention not really is important in every patient where it can be done. It's really important in left main, and there is, with respect to the improvement of survival, still a benefit for CABG compared to PCI, although PCI is done in majority of patients. Meanwhile, with respect to multi-vessel disease, if you have a 3-vessel disease, a normal left ventricular function, a low syntax rate, then there's a 2B advantage of revascularization versus medical therapy. For multi-vessel disease, left ventricular ejection fraction moderately reduced or severely reduced, it's quite clear that if it's severely reduced, that CABG has to be preferred. There are still data lacking from prospective randomized trials with respect to PCI. Now, just show you a case. Here you have the LED and the diagonal branch with significant stenosis. Also in the circumflex, you can see proximal stenosis. Here the circumflex with a proximal stenosis, and here the right coronary artery. Relatively short lesions that seem to be treated quite easily with the intervention. What we have done finally, I didn't show you more about this specific patient, but here you see the outcome: LED, first diagonal branch, circumflex, and right coronary artery. Why not surgery in these patients? The syntax score was low, the left ventricular ejection fraction more than 60. So this patient received 6 drug-eluting stents with almost 8 centimeters of total stent length. Now, CABG is important with respect to where it is really to be preferred to PCI, and we will hear about this, I think, in a few minutes, especially in complex coronary artery disease and diabetes. So these are patients we usually send to cardiac surgeons in Europe, especially in Austria, in my country. And as can be seen, there's a clear preference for CABG. With respect to multi-vessel disease, I have shown you already the data. And so this is more a plus minus. In the majority of patients, we meanwhile decide here for PCI if it is doable. There are some other interesting procedural considerations, important considerations. First, FFR or IFR in patients with angina and anginal equivalent, undocumented ischemia, and angiographically intermediate stenosis to guide the decision to PCI. What we heard this morning is that it's not always PCI. That is the best options, could also be CABG in certain circumstances. Then it's clear that radial access should be done compared to the femoral access. In both situations, acute coronary syndrome and chronic ischemic heart disease. We have a reduction of vascular complications or bleeding. We have also a reduction in death with respect to ACS. And we should use drug-eluting stents. It should be a clear preference to bare metal stents because restenosis rate is lower. MI and acute stent thrombosis rate, meanwhile, is very acceptable and also very low. We have seen some embolic protection device in the cases. There is a recommendation to use it for this venous vein graft. And with respect to CTOs, we had a lot of interesting cases just now, but we discussed that we can do it in uncertain improvement of symptoms in case of refractory angina despite optimal medical therapy. And after PCI non-CTO lesions, we don't have clear positive outcome data with respect to hard clinical endpoints. But I guess this data will be shown within the next 2 or 3 years. There are some studies ongoing, and I hope everything goes in the direction we believe that CTO is an important procedure. Just one example with respect to FFR or instantaneous wave-free ratio. So these are recommended to guide the decision to proceed with an intervention. It has been tested for PCI. We have seen the data this morning that also CABG could be an important way to revascularize patients. And here we have this intermediate stenosis, patients with angiographic intermediate stenosis, and an FFR of more than 0.8 or an IFR of more than 0.89. In this situation, we should definitely not perform a revascularization. And I show you just one example. So these are patients just eyeballing. On the left-hand side, a patient with stable angina. Right-hand side was a patient coming in with an acute coronary syndrome. In both situations, it doesn't look very severe. So the stenosis don't look very severe. But if you do an FFR in this situation, on the right-hand side, there was a clear indication for an intervention. On the left-hand side, this patient could be treated with optimal medical therapy. There are some procedural considerations with respect to the non-culprit lesion in patients showing up with an acute ST elevation MI. So at time of primary PCI, if low complexity and normal renal function, we should do all stenosed vessels in the first approach. If there is significant stenosis, then in a non-infarct-related artery, sometimes it's better to do a staged PCI, but also here studies are ongoing. This is what the guidelines tell us at the moment, and also a staged CABG, if complex multi-vessel disease is existent, is a good option. With respect to the non-culprit cardiogenic shock, guidelines tell us routine revascularization. This would be in Europe, based on recent trials, that we should only treat the infarct-related artery and do the other potentially stenosed arteries in a stepwise approach. The recommendation for timing of invasive strategy in patients with non-ST ACS is given here. In patients in cardiogenic shock with refractory angina, hemodynamic or electrical instability, these patients should be treated like a STEMI within very few hours, maybe 2 hours would be an optimal situation. If you have a patient at high risk with an increased Gray score for clinical events within 24 hours, if you have a patient that is initially stabilized and who are at intermediate or low risk for clinical events, here you can wait a bit longer, but definitely you should do the intervention during the hospital stay, which usually is also very short. For example, in our hands, it's maximum 2 to 3 days, and within this time, patients are optimally treated. Antiplatelet therapy, there is a lot of change in the past. So what you see here is what the guidelines tell us since many years. In stable ischemic heart disease, usually used now a drug-eluting stent. In this case, you use aspirin and clopidogrel up to 6 months. In theory, you could stop dual platelet therapy a bit earlier, but this has only a 2B recommendation. I come to the light orange part a bit later. Bare metal stents almost not used in clinical routine. Aspirin and clopidogrel for 4 to 6 weeks, and in acute coronary syndrome, it's usually aspirin with one of the stronger P2Y12 inhibitors, prasugrel or ticagrelor, but also clopidogrel would be possible to use. And here you would do a dual antiplatelet strategy up to 12 months, and in specific cases with a high ischemic risk and a low bleeding risk, you can go on with a prolonged dual antiplatelet therapy. So interesting new thing, which is now the first times in this way in guidelines. It's not in the European guidelines at the moment in the same matter, is that you can shorten dual antiplatelet therapy between 1 and 3 months. 3 months usually is what is done in the majority of cases, and then go on with a P2Y12 inhibitor monotherapy. This is true for stable disease, but also for acute coronary syndromes. And based on an extremely important trial, which a lot of sub-trials, a Twilight trial, and you can see on the left-hand side that the primary endpoint of bleeding complications is significantly reduced if you reduce dual antiplatelet therapy to 3 months. But the key secondary endpoints like death, MI, or stroke, heart clinical endpoints are about the same over time. And the most interesting thing here is that we have a lot of pre-specified post-hoc analysis. We have high-risk patients, patients with complex anatomy, diabetics, no difference in gender, also patients with prior MI, very similar data as this main trial. The significant reduction of bleeding events and similar MACE rates. What about patients who need a PCI and need also an oral anticoagulation because they suffer from atrial fibrillation? So in this case, we should do a dual antiplatelet strategy only for 1 up to 4 weeks, again in patients with a high ischemic risk and a low bleeding risk. Majority now receives dual antiplatelet therapy only during the first days until the patient is released from the hospital, followed by a dual antithrombotic strategy. In the ideal situation, a new oral anticoagulant in combination with clopidogrel. There are few data, especially in patients who show up with an ACS, that you could use ticagrelor instead of clopidogrel, but these data are not very well bound on clinical expertise from prospective trials. It's only about 10-12% of patients that were treated in this way. And non-vitamin K oral anticoagulants are better than warfarin to reduce the risk of bleeding. This is why these substances should be used. This is my last slide. There is additional evidence needed, and we heard this today in many instances. With respect to PCI, this is the blue lines here. So the underrepresented racial and ethnic groups need to be better evaluated. The role of PCI in patients with left ventricular dysfunction to improve survival or cardiovascular outcomes, a complete revascularization in stable ischemic heart disease, and PCI in patients undergoing TAVI. Very important new options, indications, but we need more data with this respect. I thank you very much for your time and interest.
All right, let's continue with Dr. Godino's slides. AV control. Dr. Godino's slides up, please. Thank you.
Thank you, George, Roxana, for the invitation. So I'm asked to give a surgical perspective. I do not have a relevant financial relationship to disclose, but I need to disclose, first of all, that I am a surgeon, this is obvious, but also I was part of the writing committee of the 2021 ACC AHA SKY guideline. And I will focus mostly on the controversy between CABG versus medical therapy, because this is really what has been at the center of the debate. And this is the reason why the Surgical Society, in the end, decided not to endorse the guidelines. So it will not be CABG versus PCI this time, but it will be CABG versus medical therapy. And the Surgical Society are basically saying that we got it wrong. And so I will briefly look at the data that are the foundation of the current recommendation and see if the Surgical Society were right or wrong. I think we need to acknowledge that most trials comparing CABG versus medical therapy are old. They do not represent current practice, and probably more so in the medical therapy arm. There are few more recent trials that were generally small and underpowered to detect even moderate treatment effect in the surgical strata. In general, they show no difference in survival between CABG and medical therapy, but a statistically significant reduction in cardiovascular events. Ischemia, that is always used for this debate, should not be used for this reason, because it was not designed to individually compare the two revascularization strategy with medical therapy. So this is the classic meta-analysis that is generally used by those who believe that there is a benefit for surgery versus medical therapy. It was a meta-analysis published in 1994 in The Lancet by a group of investigators that pulled individual patient data from 7 trials of CABG versus medical therapy. Those are the 7 trials, and the first thing you need to note is that they were all the trials even in the 90s. Those trials enrolled patients almost 50 years ago, and actually in the text of the Lancet IPDMA, the investigator very clearly acknowledged that those trials may not have reflected the practice as it was in 1994. And if we look at the procedural detail of those trials, I think we have confirmation of that. The ITA was using 10% of the patient in the surgical group, aspirin around 20% of the patient in both groups, beta blocker diuretics all largely underutilized, and interesting, a sizable proportion of patients receiving digitalis. And I always remind, when I give this talk, the audience that in the 70s, when those trials were performed, the standard of care for gastritis and gastric ulcer was partial gastrectomy with vagotomy. Now, I have gastritis, and probably after the publication of the guideline, I may have an ulcer, and I hope that my treatment decisions are not based on what was the standard of care in the 70s. If we go back to the Lancet IPDMA, individually, only the European study showed a statistically significant reduction of mortality with surgery. For the other, there was a reduction of mortality around 5 years with surgery, but at the end of the follow-up, the curve started converging, and there was no statistically significant difference. In the pooled IPDMA, the difference between medical therapy and surgery did reach statistical significance, but you can see how the treatment effect was large at 5 years follow-up and then was smaller towards the end of the follow-up. And another important thing to notice is that the absolute difference was really small. Surgery was associated with a 4 months survival advantage over a course of 10 years. So even though statistical significance was reached, the absolute difference was really small. So I don't think the Yusuf meta-analysis should be used at all for this debate. Regarding modern trial, there are 4 modern trials comparing CABG with medical therapy, and my personal definition of modern trial would be a trial where at least aspirin, beta blocker, and statin are used in the medical therapy arm, and the ITA is used in the majority of a patient in the surgical group. One of the problems with those trials that they were all including a specific subset of patients with low ejection fraction diabetics or isolated LAD disease. Only MAS2, that was a small trial, was enrolling in general patients with multivessel disease. So if we look at those trials relatively quickly, in the STITCH trial, we know at 5 years, surgery was associated with a reduction in mortality that did not reach statistical significance. Statistical significance was reached for cardiovascular mortality, and when readmission were included in the composite outcome. However, at 10-year follow-up, there was a statistically significant reduction of all-cause mortality in the surgical arm, keeping in mind that those were patients with low ejection fraction. In BARI 2D, in the surgical strata, there was no difference in survival, again, between the 2 treatment groups. There was a statistically significant reduction of cardiac events with surgery. And into 2 smaller trials, MAS1 and MAS2, where the results were consistent, no difference in survival, a statistically significant reduction in cardiac events with surgery. There have been a number of meta-analyses comparing in general revascularization versus medical therapy. The problem with those meta-analyses, those aggregate data meta-analyses, has generally been that the surgical and the PCI arm have been analyzed together. In this one, for example, data are extracted separately for the PCI and CABG arm, as you can see, but then there is a single pooled estimate. Same author gives separate estimate for MI, for myocardial infarction, and they found a statistically significant reduction of MI with surgery, not with PCI, compared to medical therapy. So overall, I do not think we got it wrong. The current guideline provide strong support to CABG versus medical therapy for reduction of cardiovascular events with a 2-way indication, and a less strong support to CABG for a difference in survival, because in recent trials there is actually no difference in survival. There is new data, however, that are being published, in online last week, and that they may potentially add something to the debate. We have performed, we have repeated basically the Lancet IPD-AMA, only looking at those 4 modern trials that I have described at the beginning. It is still problematic because, again, the individual trial were focused on specific patient population. So there is a lot of clustering by trial, but we use individual patient data and we try to adjust as much as we could. What we found is that over the course of a 10 years follow-up, there was in fact a statistically significant reduction in mortality with surgery compared to medical therapy. However, the curves were crossing clearly, and at around 2.5 to 3 years, there was a switch in the treatment effect. In fact, when you look at the time segmented analysis, surgery was associated with a significant excess in risk in the first 6 months. There was no statistical difference in mortality between year 1 and 3, and then starting at postoperative year 4, the difference, the survival benefit for surgery becomes statistically significant. At subgroup analysis, younger patients and patients of non-white race benefited the most from surgery, and the treatment effect was, for the rest, consistent across key subgroups. So I think that the existing evidence seems to suggest that there may be a survival advantage, but there is for sure a reduction in cardiovascular events over the long-term follow-up with surgery compared to medical therapy. And I would respectfully note that this is exactly what the guidelines say. The evidence, however, is weak, especially for survival, does not reflect contemporary practice. I believe that the contemporary randomized trial is needed. However, I anticipate that equipoise will be an issue. And with this one, I thank you for your attention.
Thank you, Mario, and we're going to move on straight into a great session of interventional controversies, and we have Professor Greg Stone from Mount Sinai talking to us in the most heated controversy of left main revascularization, PCI, and right after we're going to have an expert from Toronto, surgeon Professor Stephen Frames. I don't see him somewhere, but he must be right here, right after. Stephen, why don't you take your seat over here so you can listen more clearly and offer your rebuttal right after. Greg, go ahead. Thanks for great.
Thanks, George. I think we've done an awful lot in the last year to really settle this controversy, as I'm going to show you now from the totality of the evidence. And I will argue that the data supports PCI in most cases, and that that's what patients want. These are my relevant disclosures. So we've had a lot of discussion about the heart team, and the heart team has a goal, and its goal is not what I want as an interventionalist or what Dr. Frames wants as a cardiac surgeon. It's what the patient wants. And we're supposed to be able to inform the patient with the best evidence, taking into account his or her individual circumstances to help to propel them to their goals. So what do patients want? Well, most patients do prefer PCI compared to CABG for left main disease or any coronary disease if it's a reasonable thing for them to do. And the reasons are very obvious. I mean, I think surgery is a fantastic procedure, but it's a lot to go through. And there's substantial recovery time that's required, and there's a setback for the patient to get over the trauma of surgery, if you will. As you see from these pictures, a left main patient 24 hours after surgery versus 3 hours after PCI. And this is actually sometimes more obvious to our patients than it is perhaps to us when we're focusing on data and long-term outcomes. So the principle of autonomy dictates that patient's choice must be respected. Patients would like to undergo a lesser invasive procedure of any type, if possible. So the fundamental question then is, whom are the advantages of CABG so profound that we should strongly recommend that patients go through the considerable discomfort and prolonged recovery that surgery entails? And I think in this regard, you have to put yourself in the patient's place or your family members. So what do patients want? Well, in addition to obviously having as simple and safe and easy to recover from procedure as possible, when you look at what patients want compared to what physicians want, it's often different. Physicians think that mortality trumps all and other endpoints are much less important. Patients, on the other hand, think that stroke and large myocardial infarctions are at least as important as survival. And then they think that other types of recurrent angina and repeat revascularization are much less important. So for patients, those three endpoints are very important. Everyone would agree that mortality is probably at the top of the pecking list. So now we can ask, is mortality different between left main PCI and CABG? And I would say without any doubt the definitive database is the individual patient data pooled analysis from the 4 contemporary randomized trials of DES versus CABG with 5-year follow-up. And all the principal investigators said we have to solve this issue. And so we gave our databases to Eugene Brunwald and Mark Sabatine at the TIMI study group and let them do their own analysis. So 4,400 randomized patients, including Excel and Noble and Syntax and pre-combat, and there was absolutely no significant difference at 5 years in mortality between surgery and PCI. A 1% difference, not statistic P of 0.33. By Bayesian analysis, if there was any difference at all, it's likely less than 0.2% per year, less than 1 in 500 patients per year. That's what this slide shows. We have 2 of those trials went out to 10 years, and at 10 years, actually the curves converge, kind of what Dr. Guardino just showed you with medical therapy versus CABG. The longer you follow them up, the curves are more converging. So absolutely no long-term difference in mortality. And if you look at all the predefined subgroups, there was no difference according to preserved or depressed left ventricular ejection fraction. Diabetes is not a discriminator of mortality in left main PCI patients. And in fact, even the Syntax score had a negative interaction p-value of 0.48. But this was explored in great detail in spline analysis, looking particularly at cardiovascular mortality, which is where you would expect to see any difference if there was going to be a difference. And up to a Syntax score of 33, there clearly was no difference in mortality, or if anything, the point estimate slightly favored PCI. But after a Syntax score of 33, then mortality starts to favor CABG. And by the time you get really high, up to 45, that's when it became significant. So in the really anatomically complex patients, there may be a survival benefit for surgery. Now you have to offset that with the second most important endpoint, which is stroke. And stroke rates are different. And in this analysis, there's about a 1% absolute difference in stroke in the early peri-procedural period, and that extends out to 1 year. And then there's accrual of events in both groups, which somewhat narrow the curves. But about 1 out of 100 patients more will have a stroke after surgery compared to PCI. That will be more important to some patients than others, and especially patients that are at higher risk for stroke. What about myocardial infarction rates, the third endpoint? Well, here we've got offsetting benefits and risks. Large procedural myocardial infarctions are less with PCI than CABG, but spontaneous MIs during follow-up are less with CABG than with PCI. Overall MI rates not a whole lot different. Well, what about all the other outcomes that matter so much to patients? Recurrent angina, chest pain, musculoskeletal disorders, other procedural complications, infections, bleeding. What about atrial fibrillation requiring chronic oral anticoagulation, vascular complications, repeat hospitalizations, repeat revasc? And what about the more subtle things, cognitive decline, depression, time to recovery? Well, again, what patients really want is to live longer and live better. And I talked to you about living longer, that's mortality, and living better. All of that can be encapsulated in quality of life outcomes. And when you look at the formal quality of life studies that have been done, you actually see that early on there is a difference in quality of life. And it's substantially better with PCI than CABG. And this reflects the difficulties of going through the peri-operative CABG period. So if you look, for example, at the SF-12 in the randomized Excel trial, early on after PCI, patients are substantially feeling better at 30 days, and they feel slightly worse after CABG. And it takes up to about 6 months for the patients to recover. That is a lot to ask patients to go through, so you really have to have a lot of benefit before I would want to go through it, let alone a patient. There's also faster recovery of mental functioning after PCI compared to CABG, and then there's a catch-up by 6 months, and then it's equivalent again, just like physical status over time. Depression is substantially greater after CABG compared to after PCI for at least 12 months after the procedures. And both procedures are excellent at relieving angina, okay? Maybe a small, tiny difference in this analysis that favored PCI at 30 days, but marked improvements in angina relief, so patients are having minimal angina after both PCI and CABG, and that's sustained out to 3 years and beyond. So Dr. Guardino, a leading cardiac surgeon, Michael Farku, who ran the FREEDOM trial, and I put together and recently published in the European Heart Journal a unified perspective of how we interpret the totality of the evidence to inform patients. And we decided that, first of all, PCI and CABG are very different procedures with different risks and different benefits. For many patients with left main disease, the choice between PCI and CABG will be agreed upon by all subspecialists. CABG will be strongly preferred by the heart team for many patients, particularly those with extensive non-left main related coronary disease. In contrast, PCI is going to be preferred very clearly by all members of the heart team for patients such as those with frailty, severe COPD, prior stroke with residual defects, etc. For other patients in whom revascularization can be safely completed with both procedures, that is, when equipoise is present, there'll be substantial and comparable long-term improvements in survival and quality of life after both PCI and CABG, although the journey is different. Early on, it's easier after PCI, and then there'll be fewer later events after bypass surgery. So in these cases, the patient needs to be informed, and patient preferences regarding the early versus late trade-offs of the procedures should inform clinical decision-making. Thanks very much.
Let's hear from our surgery debate. New slides head on, please.
Give the talk using my slides.
Yeah, I'm going to be showing a lot of the same slides. It's just a different interpretation, so that would work. Do I have to do something to bring up the next slides? Well, to get started, the surgeons aren't the enemies in the room. The Tampa Bay Lightning are the enemies for both Toronto and New York. Right. At least that's how I feel. Okay, thank you. So I'm Stephen Freems from the University of Toronto. I'm thrilled to be here. Thankful for the invitation. I'll be talking about the case for CABG for left main revascularization. These are my disclosures. These are my other disclosures. And also, I am a cardiac surgeon like Mario. I'm now going to present the American Revascularization Guidelines as they pertain to left main revascularization. So for CABG, it received a Class 1 recommendation, and this was for survival against medical therapy, and PCI a 2A recommendation. That's my glasses, sorry. 2A recommendation for revascularization, again, to improve survival. Now, these recommendations are based on very old studies, and Dr. Guardino showed the information quite well. In terms of PCI versus survival, there are no trials, PCI versus medical therapy. There is a network meta-analysis that provides indirect evidence that there is a survival advantage for PCI. In terms of patients with complex disease, with CABG, it received a Class 1 recommendation rather than PCI, or in preference to PCI for survival. In patients with diabetes, it received a 2B recommendation in patients with low to intermediate complexity to reduce MACE, not to reduce survival. Now, as was said earlier, the syntax score was downgraded. In part, this is because many institutions do not use the syntax score, and when it is used, often the peripheral or local readings are different than the core lab readings. However, we all know that features of coronary complexity are extremely important in terms of individual patient decision-making, and so that is included, and it's shown here. This data has been presented quite a bit. To reiterate, there was no statistical difference in terms of mortality seen in the panels on the left. There were reductions in spontaneous MI and repeat revascularization, and there was an early difference in terms of stroke, although no difference in stroke overall over 5 years. This is the information presented somewhat differently, PCI versus CABG for each of the same endpoints, and the absolute 5-year risk per 100 patients. And with PCI, there would be approximately 1 more death at 5 years, 3 more spontaneous MIs, no difference in stroke, and 7 patients who undergo repeat revascularization. Again, there were no significant treatment effect modifiers except for acute coronary syndrome, in which CABG was preferred in patients with stable ischemic heart disease. I would think this should be considered hypothesis generating, as there was no overall benefit in terms of mortality between the 2 groups. There is controversy in terms of perioperative MI. There have been 2 large cohort studies in cardiac surgical patients that do look at the effects of biomarkers and early and late outcomes. This is from the European Heart Journal. In the panel on the left is peak troponin after coronary surgery, and the median peak troponin is 70 times the upper limit of normal. On the right side is the association of MI determined either by the universal definition, by the ARC definition, or by ECG criteria. And for each of those, there was increased hazard in terms of MACE, as well as mortality, but not according to the SKY definition. Dr. Stone talked about the early physical recovery, and it's certainly much better in patients who undergo PCI than CABG. And again, he pointed out to the similar, substantial, and durable improvement in symptoms achieved by both modes of revascularization. I'm now going to show some population data from the province of Ontario. This has been presented, it's under review, but the reason I'm showing it is to see whether patients who do undergo PCI are well represented in the randomized trials. So the total cohort of patients is 31,000, approximately 25,000 patients who had CABG, 6,000 had PCI. I want you to focus on the first exiting box, and these are the patients who were excluded. There were large numbers of patients excluded with STEMI, prior cardiac surgery, recent PCI, and dementia or cognitive dysfunction. So in other words, most of the patients who have PCI in real-world practice are not represented in the RCTs. Now these are the PCI patients after exclusions, but before matching. And still, they're quite different than the patients seen in the randomized trials. They're older, the mean age is older than 70, and the degree or extent of coronary disease is much greater than the patients who are represented in the randomized trials. I'm going to briefly present some slides about FAME3. Left main patients were not included in FAME3, but it is the most recent comparative study, and I want to show it to show what modern results in CABG are like, and that the benefits or the safety of PCI and CABG have improved lately. So at 1 year, MACE was higher in PCI than CABG, and death, MI, and repeat revascularization were higher. In other words, that delayed effect that you see with CABG patients having to wait 1 to 2 years before there's a benefit was not seen here. Early recovery was probably worse, but the cardiac events were less at 1 year. Now lastly, heart team. Heart team is extremely important in terms of determining individual patient decisions. And for many patients, stenting is absolutely the right decision. So to conclude, I would say that CABG remains the dominant modality of revascularization for left main patients with stable ischemic heart disease. And on average, CABG is the preferred revascularization modality for candidates who are both, but not based on mortality. In the real world, PCI is used more often in situations not captured by the RCTs than for patients enrolled in the RCTs. There are clinical and anatomical considerations that affect clinical decision-making for individual patients, and the heart team approach is strongly recommended to optimize individual treatment decisions. Thank you.
Great. Do you have any questions regarding this latest debate before we go to the next one? No, really. Well, any questions about it? Or should we go to the CTO debate? Why don't we go there? Because we kind of started it in the panel, and let's see if questions come up later. The CTO debate reads as, the guidelines got it wrong. We have Dr. Kearney coming all the way here from the Pacific coast to make sure we understand very well the guidelines are. She's very motivated, came all the way here to tell us that. And then we have Bill Nicholson, with a very defensive title, says CTO in selected patients. Let's hear about that. Okay, thank you.
Yeah, I think they gave me such a juicy title, so the flight was worth it. But I think my most important disclosure while these show is actually that I did a year dedicated for high-risk PCI and CTO training, so clearly my perspective is also skewed that way. And while I'm supposed to spend the next 8 minutes going over some issues that we review in the guidelines with respect to CTO specifically, you've already seen this image, but I think there are a few things that are really important takeaways in terms of shared decision-making. I think this comes up all the time, and some of the work they've done around LAAO, occlusion, and some of the patient shared decision-making factors in there, I think we could do a better job of applying to CTO PCI specifically, but certainly this is important. And actually the guidelines pointed out that while we really emphasize mortality and durability and all these other important things from trials when we're making our heart team discussion recommendations, patients may have different priorities. And actually in this one survey from 2013 at least, even when death was presented as higher with PCI, patients still preferred that over CABG. So I think there's a lot to unpack there on an individual level, but we need to get down to that to help make the best decision for the patient. Now, what's the deal specifically with CTOs? Altogether, while we've already reviewed that there was a class 1 indication for treating symptoms with PCI when patients have refractory angina on medical therapy, we in the guidelines actually noted that despite suitable anatomy with refractory angina on medical therapy after treatment of non-CTO lesions, the benefit of CTO to improve symptoms, CTO intervention to improve symptoms is uncertain. And I think what that really comes down to is that guidelines are based on randomized trial data. And we have, an embarrassment of riches in cardiology. A lot of our recommendations are based on this. But if we're thinking about high-risk patients in particular who are receiving an intervention, I think running good trials like this is hard. And we see that in the trials we have. So if we drill it down to a very simple example, if you offer my dog the ability to enroll in a trial where he gets the kibble that he gets every day and is already taking versus that, plus this really gross-looking bone that's available on Amazon, he's not going to enroll in that trial. He would just order that gross bone on Amazon. Unfortunately, he's very dumb and he can't do that. But I think with our patients, by the time they get referred to a specialty center, they've already maximized their medical therapy. Most of them have voted with their feet and are highly motivated. So I think generalizing that to the broader population we actually see in clinic is difficult and is also limited by variable success rates and other things. So I think overall, part of the issue is that guidelines really emphasize randomized trials, but real-world data is really relevant in this patient population. So if we look at the two main trials that they quoted, Decision CTO had a really difficult time enrolling and went over 7 years, and they still had slow enrollment, but did manage to get over 800 patients in. But there are a number of factors there. So actually 14% of the patients did not have any anginal symptoms. They were randomized before they underwent non-CTO PCI, so a number of patients actually had improvement in symptoms related to treatment of other lesions. And the crossover was 18%, but actually that happened almost right away within 3 days. And so obviously a lot of the patients were actually just dissatisfied with their randomization, not that they came back months later with a small STEMI or something else that led to intervention. So because of all these reasons, from a post hoc analysis, that was deemed to be underpowered. But the guidelines really emphasize this because it is the largest randomized trial to date that we have for CTO patients undergoing a randomization for intervention. If we look at EuroCTO, that also dealt with slow enrollment, and they only got to about a third of the patients they had planned. They underwent 2-to-1 randomization, which probably did help with crossover, which was about 7%. And so if we look at the results that we get from there, I think there's some things that are not too surprising. One, in decision CTO in that selected population, we didn't see a change in MACE rates or symptoms that was statistically significant, but both groups showed improvement in quality of life scores. Remember, they also had other lesions treated before they were selected for this. If we look at EuroCTO, what we do find is that the patients who were in the PCI arm, a much smaller proportion of them end up with class 3 or very low rates of class 4 angina in follow-up after intervention compared to the control arm. And I think that's why when we're counseling patients, this is what we're really focusing on. Interestingly, in that group, they did see a lower rate of MACE with the p-value of 0.02 when they're looking at 3 years. And so I think when we look at all of this data across the board, the trials are great to give us some ideas, but they're highly selected patients. And so one really helpful registry was the Open CTO registry, because this was 1,000 consecutive patients. These were at high volume centers with a high skill set. They were complicated. Procedural success rate was actually a little bit lower because this was core lab adjudicated, but despite that, patients did show an improvement in symptoms that was quite significant. I think that also gave us some really important data to help us counsel patients about clinical perforation rate and things like that, because it was core lab adjudicated and really well done that way. And not surprisingly, the patients who had the highest burden of angina are the ones that we saw the highest benefit from in terms of their Seattle Angina Questionnaire. And importantly, these patients were, nearly all of them were appropriate or maybe appropriate by appropriate use criteria. And these patients were on good medical therapy and all the important things coming in. I think the other challenge that we deal with is that we're defining what's generally a physiologic problem in terms of ischemia by anatomy alone and drilling it down to something as simple as CTOs. When we're often having these heart team discussions of multivessel CAD patients, oftentimes part of that factor is because they have a chronic occlusion. And so we're trying to factor that into a more complex thing. In addition, I think Dr. Wexman mentioned this earlier, not all CTOs are created equal. So this gentleman, unfortunately, his lima went down a month or two after surgery, had recurrent symptoms. They have a patent being grafted to a diag here, so the anatomy was pretty complicated on the diagnostic, but we can see with the dual angiogram that actually connects better than we would have thought. They crossed that with a workhorse wire. This is a case from Tuesday. And in general, now this gentleman's LAD is taken care of, and hopefully his symptoms will get better too. So I think altogether, we're making these anatomical distinctions, but is that in part because of our risk tolerance for the procedures? They are higher risk than general PCI, technical limitations, or both. And I think if we look at some comparators like vein graft PCI, which is also high risk for acute and downstream complications, that in general we're recommending the native artery if that's feasible, and CTOs are a big part of this patient population presenting for intervention, as well as redo CABG with a patent lima is higher risk. And so I think a lot of the patients we're seeing actually fit these descriptions better, and so I don't know that there's as little certainty in those groups. Altogether, I think in part there is a high rate, a big part of this is our skill set, and so trying to continue to get better at our skills and our center experience really does seem to matter. If we look at the Michigan data, using insurance data, the high volume centers treated patients with higher baseline risk. They actually had the same rate of MACE events after the procedures with a higher success rate. And so I think taken a different way, low volume centers still had an increased rate of complications, but without that achievable success rate. So I think altogether, using different techniques and having the skill set to work on that can hopefully make these cases safer. So I think where do we go from here? Well, certainly emphasizing shared decision-making is really important because there's lots of areas of uncertainty about, there's no right answer in many of these cases. I think once we make the decision to do PCI, whether it's CTO or not, we want to perform that in a way that is more consistent with Syntax 2 than Syntax 1. So the guidelines mention that the stents have improved, but there's a number of other things they did there. One of those was increase their CTO success rate, but the patients were on high rates of goal-directed medical therapy, and they used much higher rates of imaging and invasive physiology. So altogether, I think as long as we continue to get better, then we can probably study this better in terms of the data. So just to end on that, I think there's a number of courses, these two sponsored by CRF, including CTO Summit, have really been helpful for me in terms of my pattern in addition to this course. Epic Live, which my counterpart is a part of, was also great for kind of learning different things, getting out of our own lab and learning new tools. And just a plug for the Women as One Climb program has a CTO dedicated group, which is a really fantastic way to build your skill set. Thank you.
All right, and this is a surprise for the counter team of a last-minute substitution to deliver an even better rebuttal to all the slides have been rearranged for following the great talk of Dr. Keating. We have Dr. Pratik Sandasara coming up for CTO PCI only in selected patients. There he is. Thank you for coming.
Thank you, Dr. Dangus. I am not Bill Nicholson, but he did train me, so these are his views and opinions. No disclosures. So we'll start off with the case that we typically see as a referral. So I have a 68-year-old male. He presented with class 3 angina, had a cardiac PET which showed 15% lateral ischemia. Subsequently had a coronary angiogram that's shown here. You could see a mid-circumflex CTO that's filled with left-to-left apical epicardial collateral from the apical LAD, as well as an epicardial collateral off the right coronary artery. He was started on optimal medical therapy, including 2 anti-anginal medications. On follow-up, he continued to have lifestyle-limiting angina, and so was referred for CTO PCI. You know, typical kind of referral pattern for us for these patients. And so the question is, you know, how do you select patients for CTO intervention? I think it really comes down to four things: clinical indication, the anatomic characteristics of the CTO, operator experience, and assessment of complication risk of the procedure. So looking at each of these in a little bit more detail, when we look at clinical indication, this is seminal work from Gerald Werner and colleagues from Europe, and they looked at, despite adequate and well-collateralized CTOs, they put an FFR wire down after crossing, and they found that they were all, the myocardium subtended by these CTOs were ischemic. And the IMPACTOR CTO trial showed us that PCI, a successful CTO PCI, viable myocardium, led to a reduction in myocardial ischemia burden. And this was measured by stress CMR. And so what this leads to, you know, the EuroCTO trial, as Kate already alluded to, mentioned, randomized trial of 396 patients, CTO PCI success rate of 86% in the trial. There was a significant improvement in angina frequency, quality of life, as well as physical limitation in patients that had CTO PCI in addition to optimal medical therapy. And so, you know, we can safely say that there is ample data to support CTO PCI for symptom relief. We mentioned OpenCTO. This was a 1,000-patient registry across the U.S., 12 high-volume centers, using the contemporary hybrid algorithm approach with a technical success rate of 86% and a fairly low MACE event rate. Again, we see the same findings here. There's improvement in the Seattle Angina questionnaires, Rose dyspnea score, as well as physician health questionnaire depression scores following successful CTO PCI. So what about complete revascularization? You know, that's a topic that came up earlier. You can see in the Syntax trial, patients with residual or incomplete revascularization and a high residual Syntax score had adverse outcomes. Well, patients with multivessel disease often have CTOs, and in fact, presence of a CTO is one of the main reasons for referral to coronary bypass surgery. You can see in some of these trials of multivessel disease, the rates of CTO were upwards of 20%. And in the CTO, in the Syntax CTO sub-study, actually, the patients were referred for, they were randomized to bypass. A third of them ended up not getting bypassed for a multitude of reasons that are listed here, including diseased vessel or inadequate conduit, or the vessel was too small to bypass. And so, you know, you can look here at the outcomes of these patients with a total occlusion that underwent revascularization, and those that didn't have a complete revascularization had a worse outcome compared to those that were able to get complete revascularization. And so, you know, what about patients that do get a bypass on a CTO collateralized vessel? Well, there's some data to show that in a non-LAD vessel that gets a saphenous vein graft, at 1 year, the patency rates are 20 to 24% with bypass surgery. And so I think, you know, for complete revascularization, I think CTO PCI is a reasonable reason to have patients undergo CTO PCI. What about improvements in ejection fraction? Well, there was a study, the EXPLORE trial looked at changes in LV function 4 months after CTO-PCI of a non-culprit vessel for patients presenting with a STEMI. The overall conclusion of the trial was there was no change in ejection fraction. However, if you look at a subgroup of patients with LAD CTO with low EF, there was a statistically significant improvement in LV ejection fraction in these patients. And so I think patients with low EF, viable myocardium, particularly in the LAD territory, may benefit from CTO-PCI. And so the next important criteria to look at is, I think, the anatomic characteristic of the CTO. And one of the tools that we have, is to assess the anatomic complexity are the JCTO score, the Progress CTO, CL, ORA. Multiple scoring systems are available to help determine the complexity. But in the end, it kind of boils down to the common predictors of complexity, which are post-CABG patients, proximal cap ambiguity, calcification within CTO segment. Circumflex CTOs in particular are challenging, and as well as presence of tortuosity. And so the reason it's important to look at complexity is, as you can see here, as the JCTO score increases, indicating higher complexity procedures, the need for dissection reentry and retrograde approaches also increase, and which translates into a higher risk of procedural complications that's seen here, especially with retrograde CTO-PCI. And so it's important to keep in mind, the anatomic complexities of the case, especially when you look at operator experience. And we know from real-world registry data, such as NCDR, that CTO volume directly correlates with procedural success and MACE rates. So in Progress and Open CTO, which are high-volume centers, the procedure success rates were around 90% and the mortality rate less than 1%, compared to the general standard success rates around 50–60% for non-high-volume operators. So this is really important as operators to self-reflect on the anatomic complexity before taking on CTO-PCI cases. The last thing we should look at is the complication risk of the procedure. And we have a Progress complication score that can help assess risk of peri-procedural complications based on patient age, CTO length, and use of retrograde approach. You can classify patients according to low, intermediate, or high risk of complications. And this also helps have a discussion with the patient about whether to proceed with CTO-PCI or not, based on the risk of complications. So in conclusion, when we're selecting patients to undergo CTO-PCI, I think it's important to look at the indications, symptom relief, to achieve complete revascularization, and possibly to improve LV-EF, especially in the setting of an LAD CTO. The anatomic characteristics and assessment of complexity of CTOs is important as an operator to self-reflect and maybe not take on the highly complex cases, especially if you don't have the necessary skill sets to use the advanced techniques such as retrograde PCI. And finally, it's important to assess the risk of complications, as it's important to know how to manage them, but also discuss with the patients about the risk benefits of the procedure. So I'll quickly finish with our case here, going back. Patient has a JCTO score of 3. He has a blunt ambiguous proximal cap. There's calcification. The lesion length is more than 20 millimeters. But more importantly to me, if you look at this angiogram, you don't have many retrograde options that are not high risk. So both the epicardial collateral off the RCA and the apical LAD are the only retrograde options here in the presence of a ambiguous proximal cap. So we started antegrade, and we tried to solve the ambiguity with IVUS guided cap puncture base. But you can see on the right-hand side our wire has exited and is not moving with the vessel. As a result, we decided to turn our attention to the retrograde approach. We tried the epicardial collateral off the RCA, but we're not able to wire this. At this point, we turned our attention to the epicardial collateral off the apical LAD. Here you can see we take a very soft wire, SU03, on the right-hand side, which is able to walk up the epicardial collateral and get to the distal cap here on the left. Then we take we were able to wire the antegrade guide here on the right-hand side with a Gaia 3, convert to an antegrade case, and able to stent and get the vessel stented. patient did well, no adverse outcomes, but this is all with an understanding of operator limitations and skill sets before proceeding, following a discussion with the patient after reviewing the anatomy. And that's all I have. Thank you.
Everybody gave such a great talk. I invite everybody to stay up for the panel. We have Dr. Moreno joining the moderation, Dr. Waxman joining us, Dr. Barman joining as well. We're ready to go directly to the cardiac cath lab for the next session, the final 3 cases.
Okay, Anu, I see you. We need the rest of the panelists. I see John Fox, Dr. Mehta. Okay, tell us, Ginny, what do you have for us?
Deja vu. Deja vu. The same room, same thing.
Oh my God.
Yeah, live case number 8. So this patient, actually, in this session, we wanted to teach engagement of the coronaries after TAVR valve. So this patient, 68-year-old, multiple risk factors, dialysis, and once you know dialysis means calcium, who also had aortic stenosis and had TAVR a few months back with the SAPIEN 3. And that's what we are going to show. At that time, EF was okay. He did have, known CAD, and I can show you the left-sided pictures there. Here. The stents are okay, and the engagement of the coronaries here, which I think they can show you our publication as well as the app we have, how to engage the coronaries, re-access of the coronaries through these valves. So here, looks like it did not go through the valve itself. It's beyond because the sinuses are large. If you see, this patient also has an aneurysm with 4.6 centimeter ascending. So that is his medication that he has had. So after TAVR, he continued to have symptoms, and that is why he's here. And this is the artery we are looking at right now. So that looks like it's a calcified pericardium and then heavily calcified vessel. So Rob is going to show you the angiogram. If you can show on the, yeah, can you see it? No, too close.
Okay, we barely see it actually. But
no, it's too much light. Decrease the light of the room. Decrease the light of the room.
We see it. So it's a selective injection in the LAO projection. Play it again.
No, the vessel was open with a 95% eccentric lesion of the mid RCA, and there was another calcific 95% lesion in the distal RCA. But from our decision that, okay, we'll bring him back to do PCI to now, this is where we are. The vessel is subtotal now, calcified. You see that?
100%.
Yeah. And when I meant deja vu, is this vessel was behaving like the vessel we had earlier.
Absolutely. Now, do you
so
have
again, guide engagement was easy. We just took a Lima guide. So you see that we didn't have to go through the valve. We are behind. So that's one way of engaging. But when you go to self-expanding valve, since self-expanding valve actually extends into the aorta more, then you have to go through the valve. You have to make sure you are in the center of the valve, and then you got to exit through a particular diamond to get access into the coronaries. I hope they're showing the animation side by side so you can start watching how to re-access these coronaries, because it's become very challenging for interventionalists since we are doing this in even low-risk patients who are 65 and above. They're likely to come back with coronary disease in the future. So let's go back to this patient here. So we went with Fielder, fine cross, thinking that maybe we'll be able to cross this easily since it was subtotal, but we started having our usual issues. So we went Miracle Bro, did not work. My favorite wire did not help me. And then I tried the Pilot 200. Same, like I said, it is a polymer jacketed wire with hydrophilic coating with the tip load anywhere could be 3 grams to 200 could be more than that. That also did not help. Now, other antigrade wires that newer wires that are out there is another wire called Mongo. That's also same polymer jacketed hydrophilic with a very, the tip load is very little, like 0.3, 0.8. So I thought maybe that we may be able to go through that. Only wire I did not try was a Whisper. And then we moved on to Gaia 3 with a special curve. And this is where we are. Gaia 3 there, again trying, you see that? Your eccentric lesion, you have to make sure that you have a hairline lumen and our wires have to get into that hairline lumen with the calcium around it. So this is a Gaia. Finally, we were able to advance the Gaia. Yeah. There's a lesion further down. Can you see a calcium down there in the distal? Yeah. So we're right there right now. Then we went ahead with the Godzilla and I have a laser. Remember earlier with the other two CTOs, we tried to do rotational. One we did just with the balloon, since was okay. The one we did in this room. The other one, heavy calcium, we did rotational atherectomy, balloon and stent. Now here, there's no way. The fine cross was not going further down, so I am not taking the effort. I mean, even thinking of doing a primary rotor wire here. So we left the Gaia wire there and we are ready with the laser. And Godzilla behaved okay, and this is where we are. I didn't need a balloon support to get the Godzilla all the way down.
So you're planning to do laser for the mid lesion, and then...
Yeah, and if that goes well, then I'll have to try to advance, yeah.
You need support for the distal, yeah. Any comments from the panelists?
Means we have to cross.
This is a tough of the toughest, huh? So, this is the 0.9?
Yeah, 0.9, and we are starting. You ready? Okay, I'm going.
Very good. It's interesting that we didn't see collaterals from the left. I was trying
exactly,
for this CTO a double injection, maybe something.
Yeah, he did have some disease, but then it has progressed very badly. The angiogram which Rob tried to show, but I think you can't see it well.
I might add one point when there's a clear, nasty, tortuous calcified vessel to preload the mother-daughter guide liner into the catheter before you even engage it. It'll facilitate things when you know you're going to need it, rather than fail to cross your microcatheter and then have to exchange out.
Are you able to engage the lesion, Anu, or not yet?
No, not yet. But the usual, remember our, that's why I meant deja vu. You can see the angio?
Yeah, we see.
Can you?
The angio we don't see. We just, we see the angio now, yeah. This is how long ago, this angiogram?
But
at the time of the tower.
Which was?
I think we made some progress with the... Oh.
It's a big right.
Massive right.
Anu, we're looking at kind of the low arterial pressure. Do you think that's mostly because you're damped with the guide catheter? Because the pulse pressure is pretty narrow.
One because Godzilla is all the way down. I pulled back. You see about 80. I'm going to try again. And I think it did make some progress.
But still pretty low. You might want to give some fluids or something. It's still pretty low.
The arm pressure is 109. We're doing the cuff now. I see it.
Okay.
Yep. Thanks, Scott, for that
calcified
pericardium.
That's a lot better.
That calcified pericardium will not handle much blood.
Yeah.
Okay. Dr. Mehta has a comment. Go ahead, Dr. Mehta.
Pedro, 2 comments. First of all, I think just a beautiful teaching case would be fantastic to see how it is. The traditional, and this is the question for the panelists, I don't know how everybody feels, including Ron.
212.
The traditional feeling with the laser used to be you avoid it with tortuosity. And again, you know, with putting in a guide extension catheter, I think you somewhat reduce that. Plus, of course, undersizing the laser catheter in almost 4.0, I think stepping down to a 0.9 does that. But I have always, in the previous experience when I used to do tons of laser, that always was a concern dealing with tortuosity.
1.2 balloon.
Very good comment. Yeah, this is if we anchor,
1.2 balloon.
if you anchor that balloon, you may be able
I think I've got no, I'm not. Now I have to go 3.5 and like we did before, maybe get the Godzilla further down. Get me a 3.5, 12, high pressure. 15 you have?
Yeah, the tortuosity in the proximal segment is actually not that bad. It's just the calcification. So hopefully the Godzilla may navigate that through.
You know, plus you're going to activate the laser.
Give me 3.5,
3.5,
15 you have? Okay.
Any comments, Dr. Stone?
No, I think laser is an interesting choice here. I think there are several things you could do. You could do a small balloon and then a lithotripsy. You know, I don't know that you know, you had a trouble with the 014 wire. You could have probably wired it with you know, the new Viper Flex wire. You could have considered OAS, although that tight lesion, it may not have been the best choice. So you may have needed to balloon that even at the beginning.
Go.
But I don't think you shouldn't consider it a loss if you have to use a small balloon, either a 1.5 or 2.0, to make access for some of these technologies.
Yeah. The other issue with any type of atherectomy is the angulation of this lesion. And
no, first you need the wire across.
Yeah, absolutely.
Right?
Yeah.
Whether it's Viperplex, Rota wire, I'm having trouble with the regular wire here. Okay, advance. And any movement, everything comes out. Good?
Ready?
Yeah.
This is a 3.5 or a 3.0, the balloon?
3.5.
3.5, so 1 to 1. This is what
give me a
helping.
1.2 balloon. Good, go down, hold on. 1.2, Sprinter Legend.
One of the problems is the Lima guide is not going to give you guide support. And you can have a guide extension, but you really still need to know the fundamentals of having a guide. And it's, I guess, a problem with the valve and the way they thought you had to engage it. But Lima has no back support.
I mean, I try to get the guide catheter extension down as far as you can.
1.2 Trek is okay? You want the Sprinter?
1.2 Trek?
Give us a 1.2 Trek.
No, Sprinter Legend you don't have?
You have it.
Yeah, give me Sprinter Legend.
We always used to say if the guide...
So we are going to the small balloon 1.2.
You haven't...
The smallest we carry. So actually we have a 1.0, right? Get us a 1.0 Sapphire. Not yet, not yet.
Yeah, Sapphire has a
try
1.0
balloon. Otherwise.
You haven't tried the Corsair, Anu?
I did not try the Corsair. We could get that. Actually, Corsair will go through the Godzilla.
I think the Takura balloon is very good low-profile balloon. We use in CTOs to cross these really tight lesions. That may be an option as well. And then I agree, like a microcatheter with more push, like Corsair, or even like a turnpike spiral. You could try and see if you can push that through the lesion there.
Correct.
That push balloon is a nice balloon, the 1.2.
It's getting there.
Okay, go up here. This is a 1.2.
Go.
Sprinter Legend.
We lost the image.
You have the turnpike spiral, right?
Yeah, we lost the image. It's in still right now.
We lost the image?
Yeah. We hear you well, but the image is still. Now it's coming.
There we go.
Okay.
Okay, wait. Give Corsair actually.
Yeah.
You have Corsair? We can try Corsair to go further down.
Should it go?
I don't have good guide support.
Oh, wow.
Amplats would be a better guide for this.
Yeah.
Go up here.
Yeah, this is a case where we might use a trap liner. It's a little tricky because it's not the world's best guide extension and that upper curve is challenging, but at least Then once we get kind of our purchase down, you might be able to get that right close to the lesion and then use that to get the microcatheter across and move on. But that initial tortuosity is certainly
No extra small.
Yeah. And as you mentioned, it's a big aorta, and you got no guide catheter purchase here. So, I mean, ultimately, if nothing else works, you'll go up to an Amplatz and maybe even an AL2.
Okay, give us that. So we're changing to Corsair. Let's see.
So as I was saying that before, just for the people who are graduating and starting out, your guide support is really, really important. The equipment's gotten so much better. You can do all these elaborate things, but if you start to wire and you notice your guide is getting kicked out, it's usually too small of a guide, and you should adjust in the beginning. And then these other tertiary devices are much easier to deliver because you at least have some backup in the aorta and the cusp.
Got it.
Hold it.
Okay.
Always about guides.
ARTs, I think, are really nice guides, which is kind of a reverse Amplatz.
Yeah.
What could be in that?
The AL system.
If you want what, get us, you think AL guide may go?
Anu, any reason why you didn't
With
start
this?
with the AL1?
This is so large.
No, only because of this one, we did not know that it's going to be a CTO like this. We can try AL because of, with the valve,
Right, yeah, no,
AL
clearly.
guides are not the best,
Absolutely.
That was the main reason,
0.75.
because you're doing it.
0.75.
And maybe even AL1 here because of the dilated aorta. Now, since the wire has come out anyway, I can change the guide and see if that helps. Yeah.
Do you have do you have any conal branch or anything to trap the guide? Thinking in a larger.
Then you have to go 7 French. Yeah. Then you have
that's
to
what
go
I'm
7
saying.
French, which we don't have. Yeah.
Thinking in a larger bore. Sometimes.
No, all that could be done, but you have to take into account the tower valve that's sitting next there. Yeah.
AL1.
AL1 coming.
J-wire.
AL1.
So you're going to try an
AL1.
AL1. We'll see if it's large enough.
Yeah.
And then,
They want an AL2.
yeah, let's go with the Corsair fielder again. Pull back.
Hold on.
Okay, wire back.
It is my impression that when you have these super calcific vessels, large vessels, the compliance is zero, and independent of the guide you have,
Pull back.
it's going to
Okay.
pull back.
This sidos or no sidos? Other thing was the Medtronic.
Yeah, we were talking
Oh,
about that
pulse
with
and
Ron
fire.
Waxman.
No, because we tend to use a lot of mark guides who are actually soft. Good. Pull back. Okay. Okay, let's see.
No.
Looks better already.
No, I don't know. Okay, good. Good. Too big, I think. No, 0.75 is okay, I guess.
Let's see, let's work
Yeah.
a little.
No, can't be too big.
So little
Yeah,
bit.
this is AL1 is too big.
No,
Okay,
you're
there.
there, you're there.
No, just push it a little more.
I'm there.
You're good, you're good.
There.
If anything, it's too small.
I think 0.75 may be a better.
No, but you're there. You're
guide.
no?
It's not going to give you more support.
Sometimes it's nice to take the stiff part of the wire,
There you
go.
just
Yeah,
straighten out your guide a little bit and get closer, and then pull it back.
That actually could change the shape of your guide.
That's kind of what you
I
want.
think you can
We
wire
actually
it.
teach fellows other way around, that don't keep the wire at the tip of your guide,
No,
because
but
it definitely changes the
that's kind
shape.
of what you,
Yeah.
That's what you want to do. You want to just change it until you engage it and then pull the wire back and it kind of conforms.
Try to wire there and see.
Yeah, I would wire it
Yeah.
once you got some flow, and then once you have the wiring to add stability, then you'll be able
No,
to
no, no.
manipulate the
Guys,
guide more.
this guide is worse than the other one. It's barely sitting there in the ostium.
That's the other thing. Yeah, you need a
Okay.
good.
Yeah, see? Okay, now?
It's not in the ostium.
It's easy to say, but you have to get to a
0.75.
position that you can intubate the guide.
Vitals.
But I agree. I mean, I would try
Yeah.
maybe 0.75.
No, we are changing it to 0.75.
Yeah. You know, I don't know what about you guys, but our threshold to treat this lesion when
Where's
a
the
patient post-TAVR is going to
Hmm.
be very high. I mean, we're not going to go after those, especially when they come for TAVR and you need to deal with this. Probably would not. The only thing in his favor that he had an open artery just before the TAVR, but you really have to be very symptomatic to push us to do that lesion.
Okay, this is AL 0.75. Earlier was a Mach guide. This is a Medtronic, right? Or maybe. Aye, probably it's worse than the Mach. We have a 0.75 Mach.
You know, it highlights the issue of revascularization before or after TAVR. Huh? On that end, Ron, what are you guys doing in Washington? Are you revascularizing all severe lesions before TAVR, or?
Only if it's a large proximal LAD. You know, again, most of the studies has not shown that there is much utility into that, and you attribute most of the symptoms to the aortic stenosis, not to the coronary artery disease.
Let's wire.
So sometimes it helps us to
Yeah.
select which valve. We prefer to use the Edwards because of coronary access. But many times we just put the TAVR
Pull
and
back.
patients are relieved with these symptoms, so we
pull
leave
back.
it alone.
Pull the wire back.
Correct.
The complete trial is ongoing, you know, which uses SAPIEN valve, where you have the randomization after TAVR, PCI versus medical therapy. That is a trial that's going to tell us.
That is correct. And there was a small study
Yeah.
that was never completed by Simon Redwood that didn't show much difference. But it was a small study, so. But now you can maybe reposition or align the guiding more coaxial.
It's not. No, see earlier, other thing with this Corsair was not.
This is your Gaia 3?
No, this is a Fielder.
Fielder? Okay.
Yeah. I don't know. I'm not happy the way the guide is.
You're still behind the frame, right?
Yeah, I'm behind the frame. Yeah.
But the Fielder is not going to go. Do you think? Oh, yeah, it went. Beautiful. Okay.
I think the laser did something. No.
Yeah.
But this guiding sitting much better. You can see it gives you support. It doesn't push
You
back.
see?
Yeah, it's not moving in and out.
It's not moving. Yeah.
I'll tell you what we need, and we
You
don't
see
have
how,
it.
see how easy that was? It's all guide support. It's all guide support.
Well, what we need is a front drive. This is like when you're driving your four-wheel drive and you
Yeah.
get into an issue. You're pushing all the stuff from the back, right? You have to go through all the tortuosity. It's very, very hard.
Yeah.
Imagine you have a system, and there is one like that, but not on a commercial market,
Get
that
the,
you actually give the push from the
rotor-wire.
tip of the guide. So then you have much more force. This is like a front drive capability.
Now, this aggressive guide, I take everybody's point. Yes, all guide support, but you have to be very cautious with this aggressive guide. We have seen so many cases of guide dissection, the proximal normal vessel. So that is why I think we have to be very, very cautious and know which cases, what kind of guide to be used. When you're using an aggressive guide like this, you have to have enough experience to use them.
Oh, you're absolutely right. In fact, there's even there have been debates going on in Twitter in the last week about it. Somebody showed a case of a severe coronary dissection from an Amplatz guide, and Half the people are saying you should never use Amplatz
But
guides
can-
and coronaries, and the other half are saying you can't do complex cases without an Amplatz. And you have to know to get it out, you actually push it forward to get it out. People need to have the experience and know how to use an Amplatz if they're going to use it safely.
The guide itself,
You want to go ahead?
whatever company is making it, they're much different. There are really sharp guides and they're really soft guides. These mock guides from Boston Scientific that I think you guys use up here as we do are very soft tip guides, and they make this work a little bit easier or gentle.
So you're changing the wire now.
What wire is this? Okay, no, I'm changing because there's a distal lesion. Now, my thing is if I can get rota wire down, then I think maybe we'll be able to get through. Otherwise, we'll have to do the rota of the proximal vessel.
Just mat that down.
Look at this. The wires are just not moving. I will have to use torquer.
Yeah.
Are you going to use the Corsair here or Fine Cross?
That's the Corsair.
This is
That's the
this is Corsair.
Corsair already.
Yeah.
Okay.
Why don't you approach this from a CTO? This is the rota wire?
No. This is the Gaia now.
Which the Gaia? Okay, I'm sorry.
No, you want to.
Okay, yeah.
Okay, so
Okay, they want to go to 6 because they have another case with the core valve, engagement of a case of a core valve, okay? So we can come back here later, yeah.
I don't know if she did.
okay, I see
All
room
right.
6. Dr. Sharma, we see you. Tell us a little bit the case.
good.
Go ahead.
All right, well, first, welcome from room 6. Today, this is the first live case, although all the structural cases are done from this room. And that is why this patient who has tower with my associates here, Parusram, and we have 2 of our fellows here, Mayank and Shiv, and of course our cath lab nurses and the rest of the staff. So key is, this afternoon we had 2 cases lined to show engagement of the coronary arteries, patient post-tower. One was the Sapien, which is the real mama case, real one. What I'm going to show is, although this case which I'm showing is the evolute, but looks like maybe a baby case compared to what Dr. Keeney is dealing with. This is the case number 9, 80-year-old. A patient actually has presented with both angina and dyspnea. And the echo, stress echo was done pre-procedure, and it was interval ischemia, was stress echo. And then, of course, severe aortic stenosis. We did the angiogram, and I'll show you that. There was a diagonal disease, 90%. Moderate LAD disease, there was anterior ischemia, and we said, you know what, same concept of the complete tower and the CAD examination trials and all, showing that leave the CAD alone and just do the valve. And we did the valve on this patient. Patient did not get any improvement. Continued to have chest pain, and they came to the office again, came with a 1 month, which we do 30-day follow-up, and then came back again just last week having chest pain. We were looking for ideal case. We said, well, let's see this case. But this is more of an engagement point of view. So JR catheter actually rapidly went in, and this is the engagement of the right coronary. So just wanted to give the point. We have a JACC paper 2.5 years ago, the engagement of the coronaries post-tower. So one is the JR catheter. If there is any trouble, then you go with a NOTO. And this is where the catheter sees a nice selective injection. There's some osteal disease, just mild. And look at the leaflet, how does the anterior leaflet is stuck behind, looks like a multiple shadows. These are all the dye going into the crevices of the old valve. See that? And then the left system was the one question. So this is basically the left. So question is, you go with a smaller catheter, whether you the JL30 or FCL30 or EBU 2.5 or even smaller. So key is that you go a smaller catheter. This is just like a Bantal, and this is where we are. We use a FCL 3.5. So we have choice between FCL 3.5 or FL30. Based on that frame, we thought that we probably FCL 3.5 will be okay. And you can see here, it's set very nicely. This is at the osteometer, at the frame, just frame of the core valve, and the valve itself is just below. You see that any time my catheter is there, it's caused moderate central regurgitation because it is preventing the leaflet motion. But it is there. So angiogram wise to that diagonal, you see that very angulated diagonal, proximal LAD was about 50-60%, which looks less now. And this is where we are. So just to say, engagement point of view, the engaging the catheter, angulated vessel diagonal was there. So whole purpose was that we try to see the LAD because patient has anterior ischemia and look at the long segment of the myocardial bridge. Clearly systolic squeeze. So we felt that the most important is because of symptoms. You're right. Usually our threshold doing a PCI post-hour is to the sky. Really patient has to be acute coronary syndrome kind of. And although it's a big, it's like 2.5 millimeter diagonal, 90-95%, despite the valve working good, the valve area with the head clearly 1.8, we saw it, there's no paravalvular leak, clearly central, created by the catheter. So we said, let's check from the LAD point of view that where is the trouble. Now, can we see the picture of the IFR? We said we'll decide based on the IFR. Yeah. You see that IFR, the distal to the proximal, pull back. So it is, all the gradient is in the myocardial bridge. At the level of the diagonal, you have becomes 0.95. So there is just, we have shown that actually in our JAC paper. It's not uncommon, it's more IFR actually than FFR. That IFR you can see, there is a clear-cut gradient, it's because of that myocardial bridge. We pull back, and this is where we are at this time, just to show, this is once you bring back the wire, that whole gradient disappeared. Proximally became 0.99. So the key is that this case does have the diagonal disease and ostial diagonal disease. We were able to just use the right guide catheter, is smaller, 3.5 or sometimes actually FL30. Now, can you do it from the radial? We did make a point in our paper that yes, of course, those who are radial expert, and I see a lot of experts there with Nitin Barman, John Fox, which are 90+% radial, probably can do it through the radial also. But we felt that in order to engage, sometimes it's difficult. And I actually have couple of cases where we could not do with the radial and we had to resort to the femoral. But that is just the personal experience and so. But key is that yes, try to use a smaller catheter, long sheath, and that is what we did. Always these cases, you use a long sheath, give you additional support. And this is where we are. And now the rest of the case will be just simple, more interesting. I'm sure everybody wants to go back to Dr. Keeney compared to here. But just point-wise, we wanted to show, we have done the IFR, we are going to do a cutting balloon of the ostial diagonal using a 2.25 and put a 2.5 12 stent. So that is the plan here. If any other questions, any yes, no, and again, just want to make sure that everybody understands this point, that this was done because of patients' very symptoms. Now, we try to advance this cutting balloon, which is not going. See this now? The question is, we do a soft balloon, maybe a 2.0. It is interacting with the, see here. This is the run to the, it's a fielder wire in the diagonal. And is it the, give a little die, why? It's a trouble. Yeah. It should go.
Is that stuck on the strut?
Maybe just like, yeah.
On the frame.
It probably at the strut.
On
yeah.
the frame.
Let's get a compliant balloon. So we actually had a choice that we are going to go with the 2.12 compliant or 2.25 our Wolverine. And I was like, kind of little tempted the way everything happened. Wire went into this angulated diagonal very easily. We felt that, it's reasonable.
Do you want to put
go with the 2.25? Yeah.
What about rewiring this?
You wonder.
One is the rewiring. Yeah.
You wonder if the bridge is giving the symptoms also. So.
The other thing is you may need support. A Godzilla there or a guideliner SS.
Yeah. No. My only biggest problem is that you have something at the ostium, and this is what the challenges you see. We looks like the guide is, we are very happy, guide is there, but no. But again, that could be the effect of our cutting balloon, and if we'll see this, if there is not the issue, if this is still give a trouble, then we'll rewire clearly. Try to go to the maybe different strut or so. Nope, it's
I
went
like the
very,
idea
this
of
is a 2.0.
I like the idea of a 2.0 compliant balloon.
Yeah, yeah. So even but 2.0 compliant may not go because of that angulated. And maybe now we know that this is the case, it could be good for Godzilla or guideliner.
Yeah.
Yeah, because of that angulation, this
you
is a
need
floppy
support.
wire.
It's,
No,
it's
and
the angle and it's a
Go on.
short guide, so
Yeah.
it doesn't give you a lot of support.
It's about coaxiality of the guiding catheter.
Yeah, exactly.
Like a regular PCI technique.
Yep.
Looks like you're in the tip of
see
it.
that?
Yeah, you're in the tip of it.
Yeah. So we are going to go up now.
Yeah.
Yeah.
There you go. Nice. Nice job.
Because this, I can tell you every other month, I will have a case which is coming to us from other places. They just cannot engage the coronary. And majority of those cases are from Evolute. Some cases, rare cases of the Sapien also does happen. But with the Evolute, not uncommon that I get at least 1 or 2 cases per month because the significant lesion is there and they could not engage it. Good. So now I think we'll definitely
Look
try.
how much bigger the vessel's
There was a little
getting.
trouble. Yeah, big vessel. Yeah. So now it explains patient symptom actually. Now what I'm going to do is that maybe the leaflet is obstructing or some way. So at the ostium, where the cutting balloon had a trouble here, I just want to go low pressure here. Will not cause any damage to the left main, but just to align, as Ram said, that maybe we want to be a little more coaxial. Good. Good. Negative now. Going to try that because it's still there is a very significant lesion remain at the ostium. See that now? Still there is a very tight lesion, but big vessel. So all explains symptoms and the persistence. You know, most of the time, patient after tower, they feel good. They continue to a little short of breath, a little bit. We always say, this takes some time and will go away. But this patient has a normal ejection fraction. And we knew about this CAD and positive stress test before. I know there are a few of the trials going on at present because very difficult to really determine whether it will be a trouble or not. Complete tower is one of them. But more importantly, you have significant lesion. Should you decide based on the physiological testing? And that's maybe somebody can comment on how they feel about it. To me, I think the physiological testing to make a decision in this tower patient is always a troublesome. Although post-tower maybe not, definitely pre-tower. What we can give and not give. So this does not go. Okay, which is fine. So let's get the Godzilla.
So just to give you follow-up on the radial, we use your same concept of using a smaller guide, even maybe a JR35, but the no torque catheter also works well. But the JL3 is usually...
But the only problem is that with the JR is still okay, but with the JL, angulated circumflex and LED, it gives very much trouble.
Yeah, no
just
support.
Catheter, no support.
No support with a JL.
For the straightforward LED, still may be okay, but others give a trouble there.
Sometimes if you get a balloon, you can just kind of bring your guide up and into it, but you have to have something to track over it.
Yep. Okay. So let's say now we are starting. Let's
the balloon now.
You think it will go without the balloon or it will need a balloon? What do you think? Let's predict.
I think you will need the balloon.
No, you need a balloon. Yeah. Yeah. I mean, same thing. You don't push the guide. As Dr. Keeney mentioned also that the pushing the guide is one technique, but that really can create a dissections. And so we use all the cases 45 long sheath, either 25 or 45, and 2 actually gives nice support. And just concentrate on that aspect. And so let's see now. I'm putting the same balloon back, the same balloon which we had earlier. Yeah. I think it may need a little push here.
It's going.
You go up. So now, once it inflates, we'll telescope the guide. Let's see, it comes now.
Yep. Beauty.
Good. Negative.
Case done.
Yeah. Negative. Yeah. So now we're just going to put a stent, and if you want to go back, let's find out from Dr. Keeney, because I'm sure there will be more excitement and more teaching points in those cases, that particular case. Was a very tough case.
We're back with you, Anu. Tell us what happened. Do you hear us?
Let me go show you side by side.
Oh, you rota? Oh, you cross. Very, very nice.
No, so I think we left you here.
Yep.
Right? Yeah, we finished all that. So now, then remember we went with I think what I did was use you were there when I went with the fielder wire all the way down. And you also were there with me till I got this Corsair. So then I was able to, I did try a Gaia again because he was behaving like a CTO distally. None of them helped me. Fielder again helped me go through that. You see that?
Yep.
And then was very difficult, but we were able to get the Corsair across the distal calcific lesion. Like we normally do, only the tip crossed it. Then I removed the fielder, put a rota floppy wire. This is the rota floppy wire sitting there. We created a little bit of channel. Always confirm that you are in the lumen before you do any kind of atherectomy. So this is, I just want to show. Look at this behavior of the rota.
Is it 1.25?
You see how it jumped? Jump means the weight, 1 to 5. Yeah, same. When we have so much trouble, go back to 1 to 5. Scary. And then we were able to go through that. Again, was not easy. Multiple passes, see that?
Yep.
Gentle. Yeah. And then we were able to get through the distal. I had to do Dynaglide to get the length because this is only 9 centimeter, 90 millimeters of the rota. I had to do Dyna to get all the way down. So now this is where we are after, this is the final picture we have. Of course, taking out was also not easy. We have, we are going to side-by-side wire with a run-through wire, pre-dilate.
Very nice.
You see that? We may need a help of the Godzilla again to deliver the stents. Yeah.
Just again for the younger attendees, that was great wire position to roto something that distal. You have to have enough wire position. That's what you obtained, and that was great.
Are you going to image to help guide whether you need more lesion preparation?
I don't think a catheter will make a turn here.
Yes.
Let's, okay, give me the fine cross again. I was thinking side-by-side wiring, but nothing is moving.
Yeah. Sometimes exchanging, if you could have that rota wire back exchange with for a mailman or a,
I think if you took a non-compliant balloon,
slam.
went up, and then if it didn't go, think of shockwave.
Yeah, that's a good idea.
Yeah, the tip of that wire might be kind of beat up too.
No, this is the new run-through wire we have.
Oh, is that a new wire?
I'm going to go fine cross, right? No, that was side by side. I was going with the run-through wire because we created a lumen. But I think what I'll do is I'll take the fine cross. You want Corsair again? Give me Corsair because
again,
Corsair made the
then
turn.
exchange your rota.
Go through that rota and then probably do a run-through. Get some more support. And once upon a time, before the guideliner and the Godzilla came, we always used to use a mailman.
The Grand Slam
for these kind of cases. But we are Grand Slam, mailman, and then the double wire with the fielder wire. That's how we used to do these cases. But now, with the help of Godzilla, we can do it with just run-through. Run-through is a great wire also. Let's see if the run-through wire, we are able to get a run-through wire, and maybe we can get IVUS if people want to see. I know, I want to make sure I get the run-through wire down.
Yeah, the mailman, the Corsair is behaving beautifully, huh?
I think at this stage, maybe I can change.
Exchange.
Right?
Yeah, this wire is not going to go.
No, 300, right?
You
Yeah,
have
we need a 300.
Yeah.
You have a lumen.
300 run-through. Because this is a, yeah. What, Pedro?
Yeah, you have a lumen. You already opened that distal. Play us the picture while we...
Open the IVUS quickly. Yeah. Is Kiski around? If IVUS goes. But I think before that, we may want to dilate, no, first?
I think I would.
Yeah, I don't think the IVUS will fly
No?
without dilation.
I mean, ideally, I would not IVUS this or anything. Like John Fox mentioned, we dilate balloon. If balloon looks good, we stent. If it does not look good, then we have to consider
That's what I would do. Just
shockwave.
keep it simple.
Yeah, we can always IVUS at
simple.
the end.
And I think that that's something for everybody. When you have a non-compliant balloon and it gives,
Yeah, beauty,
that's
beauty.
telling you a lot.
Yeah, perfect. Now we're talking.
Okay, good. Come out. Pedro, deja vu, right? Our earlier
Perfect.
case.
Beautiful. This is going
You can see
very
how,
nice.
how much the guide made the difference now. It's,
Yeah, the
sitting
guide play a
stable.
major role here.
This is a Medtronic guide. They're sitting like a rock.
0.75.
Usually we don't like this. Yeah,
like a
0.75.
spectator
not,
looking on
not
what you're
AL1,
doing.
0.75.
Let's try a balloon.
Balloon first, right?
Yeah.
Or you want to try? Now since we opened IVUS and
Put the Godzilla, huh?
Greg is requesting, then we will we'll go there.
Yeah, you may go. but I will put the.
No, give me the Godzilla anyway.
Yeah, I'll put the.
Let's
Godzilla.
have everything ready.
Yeah, let's go safe. It's too late.
Let's have all our. Give me. Where's the Godzilla? You cleared?
You know, if you can image it, I think it would be great. I think, you know, a lot of us on
Yeah,
the
yeah,
panel
no, we'll
would,
try, but,
would do image guidance to.
We were just.
Yeah, and
It's a tough vessel. It's a hard vessel, and I think you want to make sure these stents will expand.
Yeah, the lithotripsy will probably be good here.
And I don't know what that distal lesion looks like. I don't have any feeling
what
of it
balloon do you
yet.
have?
Okay, IVUS is ready.
I may add one point. Looks like you're able to tackle these
We
two
need a balloon,
complex
okay.
sequential lesions, but
A balloon?
sometimes
Yeah.
it may be favorable to kind of tackle the first, potentially even stenting, sometimes stenting a buddy wire to anchor your system to facilitate device delivery may be absolutely necessary, but obviously it looks like.
What you say, Nitin?
No, I
Yeah,
just said when you have-
that's a great point what Nitin is saying, that if we have two lesions, like here you have proximal RCA and we can't do anything for the distal RCA, take care of the proximal RCA, so much so that you stabilize rota, means do rota, balloon, stent the proximal, you can actually trap a wire and then you go and take care of the distal.
I would add that beyond even efficacy, trying to navigate tortuosity without sufficient support would just increase the probability of dissecting and making the distal lesion a lot more challenging. So if there is, and there seem to be enough runway or wire purchase, let's say, in between, or oftentimes we'll take a marginal branch and treat a proximal right, and then redirect our equipment to the second lesion after ballooning and or potentially stenting.
Just a question for the panel. Suppose we did put a stent there and it was not expanded. Has anybody done shockwave within a newly placed stent that you guys know about? I know you're not supposed to because it disrupts.
Well, it's off-label use, but sometimes.
We have done here in Sinai,
Yep.
both shockwave as well as rotational atherectomy, both.
Gotcha.
Means acutely placed.
I mean, the reason that it's off-label because it can reduce the coating from the stent and be associated with restenosis.
Yeah, it's definitely better to avoid that situation.
Yeah, but if you do imaging up front, you're not going to have.
I mean, that's why you're doing the imaging to avoid it.
Yeah, that's what I thought.
It'll never happen if you
see
image.
how the
Nothing, right?
IVUS
Okay, start.
is in the
I don't
angulated
want to,
vessels.
IVUS is separating there. I don't
Yeah.
want to push anymore.
Actually,
I
a lot
hate
of
that.
calcium
Well, there you
balloon
go.
is deep,
It's
but
360
before,
degrees calcium.
It's unbelievable.
Yeah.
Wow.
sorry, the darkness.
Okay, good.
So you've come to the guide.
Okay, give me the balloon, 3.5.
Yeah, we saw the just the
Yeah.
proximal part.
Yeah. I know. I took it out. I took it out.
It's out.
Don't talk. Yeah, we're done. We're out. Yeah, he's going on analyzing. I'm in the guide already.
And I think that
Correct.
And I think that's great for the audience. You don't have to IVUS the whole thing. If you just get the IVUS down there enough, you usually get enough information.
That's like a fly, right? IVUS, flying IVUS it's called. As you're flying procedure, just get a quick. What size you have? 3.5?
Yeah. 3.5.
Dr. Moreno, how about needles in this
I don't think you need mirrors here.
There is no lipid here.
You want to go down?
Yeah, go down. Yep.
Lipid used to be there, not anymore.
Low pressure.
Yeah. No, but
So
it's
then I
not
guess
very
another
fine.
shock
You know,
wave.
so Anu, given that the IVUS wouldn't cross, I think
Yeah.
you got to be a little careful with the
Good.
balloon, and if it doesn't come up at
Down.
moderate pressure, then I think you may need more lesion preparation.
Yeah, I think
Go
you need
here.
a larger bear.
No,
or,
also you have
or-
to remember that the
or
tortuosity, and it is a short monorail, and that's why I showed is that
Right.
it is separating because it's short monorail. So I think the tortuosity, go.
What size is this balloon, Alu?
3.5.
3.5.
3.5, okay.
Let's see if it comes up fully and at what pressure.
Okay, good.
All right.
This is where we were, right? Okay, good.
Give us the atmosphere.
Oh,
there.
20? 20, here.
Yeah, atmosphere.
It looks
Sini,
nice.
20. I think we are good, right?
Looks good.
It's expanded. Yeah.
You're good all
So
the
we
way
will
to
put
the
two,
mid vessel for
stents.
sure.
Huh?
Well,
don't
with
think we need any vessel
360,
preparation.
360 calcium.
Go with the 4.0,
Yeah.
5 balloon, and put a 5.0 stent up.
Okay, now take a picture. Ready?
Go.
Okay. Beautiful.
Frozen,
Yeah, go ahead.
frozen again. Your image froze again.
Professor La Sala, go ahead.
There we go. Let's see.
That's great.
Okay.
3.5,
Now we're getting some flow.
Yeah.
4.5, right? 24? 4.5? No, 4.0.
Right. Right. I know how to deal with restenosis. Yeah.
Rob. What do you want? 3.5 or
I think
20?
3.5, 33.
Agreed.
Oh,
I guess
more. Max?
another question I had about shockwave is,
Go.
have you used it more than the 8 cycles? Do you pull a second balloon when you can't break something? Yes. You do? Yeah. I guess my last question.
Okay, good. Okay, get us a stent.
Bring it up and then bring it down.
I didn't know that.
No.
Suck it down.
So let's get
Thank
a sense. How many will favor the shock wave for the proximal lesion?
Right there.
No.
Everybody?
I did on the
point?
bend.
Yeah, I
yeah.
would.
What size you want? 3.5?
No, the distal expanded pretty nicely
Absolutely.
with this
33?
balloon. Did you? Yeah.
I think the proximal also expanded, but what everybody wants shockwave?
Well,
Yes, I
people
think for the
wants
mid
shock
segment.
wave.
Shockwave, what's the size you have?
So the lumen follow
A
the
4.0.
vessel size is 5, but
4.0 in the mid segment.
4 is not the
Get us into the future of
Everybody wants
interventional
it?
cardiology.
Okay, we
Let's
go.
do
We
shockwave.
has to be quick because I have the guideliner all the way down with the damping pressure. 4.0, no, 4.0. 4.0, right?
yeah.
This is a 4.0
Yeah,
vessel.
shockwave.
so-
No.
Okay, so we're going 4.0 shockwave as requested by panel.
Megatron stents. They're got more cells designed for.
Anything else, Pedro?
Well, it will, if you can advance that Godzilla beyond the angulated segment and go into the mid RCA, then we could have a nice imaging just to finish the course with a nice imaging of all
No,
that
no, no.
vessel. You think it's too much?
Well, if the shockwave will go,
Well,
then you don't need it. But
Yeah.
if the shockwave will
Usually-
not go, you're forced to do it. So
No, the
Also,
shockwave,
now
I
that
think
you-
the shockwave is going to go.
Now that you've opened the mid-right coronary lesion, I think the IVUS catheter probably will go.
This is why what I was thinking that, but I will advance the Godzilla through the lesion, so we have no risk.
See, this is that mid,
Yeah.
you're saying this balloon 3.5 is a small balloon for the vessel, that's why it looked expanded?
Yeah, we believe you may have incomplete expansion. Yeah.
That was
Yeah,
pretty. That was pretty tight. You know, that looks like a pretty good expanded balloon.
The minimal luminal area will be.
I mean,
will not reach
I would
90%.
just stent without doing IVL at this time, but if everybody requests, we'll go with it. Okay, before doing that, you're saying I should IVUS?
No, let's.
Again?
you know,
I can try. Yeah, of course.
the panel supports the lithotripsy now.
Right.
And
Okay.
Dr.
No-
Dang
no
has
need
wanted
another imaging.
both proximal and distal.
Okay.
4-0. You know.
I think let's
Whenever
keep
the
it to
shockwave
proximal,
goes, right?
I think that.
Yeah. It's a 4-0 vessel, and distal, we are not sure how big the vessel is.
Yeah.
Yeah, it's not 4-0,
I
the
want to
distal
go.
one. It's probably
Yeah.
3-5.
So I don't want to go 4-0
Yeah, you can't.
IVL distally.
I wouldn't use the same balloon.
It's a little
One thing is for sure, with IVL, I would prefer, I mean, I'm not that much of imaging. I think John Fox was mentioning, we do a lot of cases just based on fluoroscopy, on our experience. But I think with IVL, we definitely have to make sure there is more than 3/4 of calcium before
Correct.
we go in with this device. Okay, so 4-0.
I got one.
We may lose the pressure with the tight fit. You have it, right? Connection? Let's see. Deliver. Deliver. Go.
Yeah. It's already ballooned to a 3.5 millimeter, yeah.
Take a deep breath.
That's perfect, huh? Just a little dive?
Okay, go. No, come down.
Yeah, we
Okay,
got it, we got
good.
it.
I think that's there.
Yeah, we got it with the
Yeah.
nose.
Okay, go. Start.
Now, tell us how many atmospheres right now. See, it's under
Is that
expanded.
4 atmospheres?
Four atmosphere.
Four,
We are
yeah.
4, and then we have to go to 6. So
You
we're
can see
done
the
with the one
waist on the
cycle.
distal
Go to
part of the
6.
balloon.
Yeah, that's why the
It's
shock wave
capture
was
only part of
important
the
here.
lesion, not the entirely.
But ideally, you should have the shock wave in the middle.
Go.
That's where you get your
I
best
know, but
penetration.
everything
yeah.
is coming out again.
So just
You can
for
advance it a little bit more. As well.
operators who haven't used shockwave a lot and use heparin, just make sure your ACTs are good because you're doing a lot of repetitive long
Yeah.
This is
inflations.
Angiomax case or heparin?
No, heparin.
You usually like your ACT
I think it's
up
done.
above 250, close to
Yeah,
300.
but you too
It opened
proximal.
Why don't you advance your Godzilla now?
No, everything is stuck
No,
now.
I think Wendy's not hearing you.
Okay? I think we did that. Down.
Are we happy with the expansion? Good enough?
I think so.
I think one of the issues is when they made it more deliverable, the emitters are generally in the more proximal segment of the balloon too. So on some of these, I've been fooled where I ended up having to go back and redo some segments when it wasn't expanding.
Yeah. I think
Nothing
that
is going, my friend.
the
I
distance-
think at this time,
Yeah, pull it all
the
the way back
artery
in.
is telling me, you've done enough, just put a stent on me.
I'll still favor going through that lesion with the Corsair, with the Godzilla. Put it in the mid.
I will have to go back now.
Yeah,
We
with
need
the
a
balloon.
to
Just
get
the
the
balloon.
Godzilla down. Yeah.
So you don't have surprises with your stents. It would be
Let's say,
nice to stent the
3.5
distal
balloon.
first.
A lot of times it rewraps well if you
3.5/15,
pull it
that's
back
fine.
in.
Yeah,
and then try it
stenting the distal first is a good idea.
Do you have a 3.5/15?
Other thing also, you have to see that delivering this device was not that easy.
So what's the plan?
Nothing, we are going to get the Godzilla way further down and place 2 stents.
Exactly. That's what we have to do. Yeah, people may think let's stent the mid lesion, but with this angulation and calcium, advancing to the distal will be troublesome. Still doable because it's a big vessel. You're using a new balloon?
Yeah, old balloon, that's maybe a trouble. Go. I'm going to see if I can get the Godzilla way further down. Okay, come round.
Right?
Yeah.
Moving nicely.
Yeah, give us a new 3.5. 3.5/15.
Tell you, 4-5s, sometimes they get a little stiffer on you and they're harder
What
to
is
recover.
it? Foro.
Yeah.
12, 3-5, 2, 3-5. Okay. High pressure. And what's the strength we are taking?
We said 3.5, 33.
Okay,
Let's
give
see.
me balloon.
Let's see
Yeah,
if the
yeah. So I
if
can
the
get it down.
Godzilla goes down, then we can choose a long stent with no problem.
Yeah, yeah. Oh,
Can they show our face also? Didn't I tell you? Show the face.
You know.
5.
Yeah.
Maybe our nurse can check our ACT?
We did.
Okay, thank you.
It's 318 last check.
Yeah, that's a beauty.
Go.
Now we're talking.
No, I'm not saying 3, put 5. So you show everything on the top. We were in such a great position before. Go, right?
Maybe it's too much to ask.
Exactly.
Maybe it's too
We were
much
in a
to
great
ask.
position earlier.
Yeah, and that's sometimes
you're
the reason to
moving
just go
along.
ahead and, balloon stent.
Now watch the guide.
Looks like you're around the turn, though.
Also, in these tough cases, we have to know that once you think you're ahead of the curve, try to finish the case rather than going for perfection.
OCT would probably go.
Please. We are here to see whether we can stand and come out.
Oh my God.
So take it down. Yeah.
Maybe a little inflation at the tip of the, yeah,
Go up
over
here.
there, yeah. See if you can do that curve.
Keep going again.
Ready?
Yeah. I think this guideliner is done for the day. Okay, hopefully the stent will go. Good?
Yep.
Try a little
Let's
more.
get the stunt.
Okay.
Nothing is moving.
3.5.
Okay, so size for the distal stent.
Yeah, 3.5.
3.5.
3.5, 33.
Yeah.
33.
Play the picture, Joe.
I would rather use shorter stents, not a very
Yeah,
long one,
that's what I
giving all
thought.
day.
Why don't you play the
torture.
picture?
Okay.
I think the distal lesion was not that long. Probably like a 23.
Okay, wait, don't open.
See?
No, see that?
You want to go?
We have created so much disruption. Let's try. If it goes, we take it. Otherwise, we go to a smaller one. I think we need that length.
But Pedro, you
And
see
then
the
after
mid
that, let
segment
us,
is the segment that's going to reach the nose next time, and it's going to come back. I mean, this is the area that was not completely dilated by the shockwave because the shockwave didn't reach through the entire lesion.
Are you talking about the 3.5-33 distally?
Yeah.
Yeah, I agree. There's a lot of long diffuse disease there. I would agree with covering all that.
Okay, let's try.
And 4.0,
Yeah.
4.028 proximal.
Might even go 38.
420.
I may just try to get that curve fixed and then try to bring my Godzilla down through the stent and then take a longer stent.
Yeah, you may need that.
Let's go slow.
I mean, that mid lesion is probably a 5.0.
Nice.
Nicely
Beauty.
done.
Beautiful.
As I was saying.
All right.
Don't ask me to do any more, guys.
Dr. Kinney
Let's
will
finish
have...
here. Okay, some die? Yeah.
Yeah.
Good. Okay, go.
Going up.
That's good.
You think of 4.0.
12 atmospheres.
Okay, now.
See if your guideliner goes. Actually,
Please, Pedro.
it may not need it.
Nothing
huh?
is moving.
Yeah,
Okay, go.
Okay, stay there.
You may use
Okay.
again the
Yeah, it's okay.
balloon
Go
to
up here.
get the guideliner even further down.
That
now.
guideliner is it's still
Okay.
larger than the lumen you've got in the mid right corner.
Yeah, yeah.
Good.
Yeah, yeah.
No, I think the.
It will
okay,
go. I
good.
mean, it went
Proximal.
already. The 3.5 and the 4.0 is the same stand. Huh?
If you can let the guideliner behave like the stand, that would be awesome.
4020?
No, no. 28,
Longer,
right?
longer, yeah.
28?
At least.
Okay.
4028 proximal.
How about 4.528?
Megatron will not make a turn, I think. I'm not trying that.
Yeah, and the
I think you need a lot of
Yeah,
support. with that
4024
lesion.
also would make it.
Remember the way I hope you saw how the stent was getting in from the guide to the guideliner. We got to be very careful. There's a in this kind of tortuous way that this is making movements. There's a risk of stripping the stent off. So now we are 4.0. If you want, we can post-dilate that one.
Probably it would be good to post-dilate.
Event, we can image.
When you're done.
Yeah, post-dilate and then image, yeah. You see that?
beauty. I thought he was
Okay.
short. This is a short. Right?
I think you're short.
Why don't you go with a longer stand?
No, okay.
This is too short.
Next, some die. Oh, wait. Okay, now?
No, it's not good. It's short.
Okay, now? Yeah, okay, good. Go.
Going up.
Yeah. We're just covering everything.
All
Okay.
that.
Get us a 4-5 high pressure. You have a 12? Short.
Still a little
There are
waste on
questions
that
here
balloon
about the
approximately.
talks that we still have
It'll be interesting
pending.
if that expands. I think it will, but
Yeah.
it'll need a high pressure.
Let's suppose
NC.
I
Will
lay-
expand now.
You'll notice there's still some waste on that balloon proximally.
Yeah.
So
That's
you'll
what-
need an NC at high pressure.
That's what high pressure ballooning.
Yeah, that's the area where the shockwave was not doing the job.
Yeah.
Yeah.
It was with the nose cone of the shock wave that was not
But
expanded.
it's relatively
No,
short.
no,
though,
that
so
area,
it'll probably
that area
expand.
shockwave did
That area.
expand, was there.
It'll
Shockwave was
probably
there in that
expand.
area.
It's a short focal
It
stenosis.
expanded. Let me go back with the shockwave.
It did. It dog bone there.
Question, Anu, do you
Yeah.
think we should move on
Yeah,
with
okay,
the
see, look
with
here.
the talks?
This was that shockwave. Yeah.
Yeah.
It
Yeah,
did
that-
take care of that
yeah,
area.
that's the
And
area
then-
that it was not doing all the job.
Yes, yes. But then it would not go any further. What's the next question we had?
No, we just post dilate and we probably will have to move on because we still have a lot to do here. We have 5 cases.
Okay.
At the end of the day, it matters what
I
is
don't
the
know. I
lumen
think
that you
everybody
have.
wants to see the imaging at the end.
Yeah, okay.
You have the IVAS ready?
I was first. Ready?
This is a large vessel. If you
Oh.
have a CSA of 7 and above, that's good, even though it's
Okay,
not.
good.
This is
Good. Yeah.
And you probably will have, because I think that normally
Go.
that would have been
Go.
like 10 and above. 'Cause it's-
Good.
It's
20
looking-
atmospheres.
Looking much
4, 5,
better.
20. I think as much as we could. Yeah.
Beautiful.
Okay, IVAS, right? Ready? Oh, good. Okay. We're doing IVAS, final IVAS.
You want to post dilate a little bit more distally or not?
No, she hit exactly the spot. It's, I don't think.
Oh,
we
I
need
think
more
it
than
came
that.
out. Everything.
Can we come back?
Balloon got stuck. I'll have to take everything out.
What do you mean?
Explain.
Yeah.
You think the balloon rupture or what?
Yeah, I think the balloon got ruptured. Yeah.
Well, it's
Yeah.
neutral.
It's not coming out.
So you
That's okay.
you have resistance to pull it back?
Yeah. Anyway, I think I have to take everything out and then
Yeah.
you carry on with your things. Yeah. Okay.
Yeah,
Good.
I'm glad I didn't tell you to go to 25 atmosphere.
Let's do the final shot.
It shows you there's still calcium in that lesion.
Well, remove the guide. Yeah. Okay.
Yeah, the balloon.
So the balloon got stuck.
Trapped everything.
Remember, I was worried the stent will strip off.
Yeah, they'll rewire it.
Yeah. So the balloon got detached. It's actually okay. Yeah.
Yeah, it was just
right here.
Can you give us a little puff? See how things look?
Yes, yes, yes. Right now they're okay. They're okay.
Hold on.
Very nice.
Vessel looks beautiful.
Good
Okay, wait.
Good cine.
Except for IVUS, I think we were able to get everything done.
Looks very good. Yeah.
All right.
Okay, thank you, Anu. As always, you are a
Thank you.
master. Let's move on. We have Ron Waxman here. He's an expert.
No.
Oh.
Tell them we are live case.
Not so fast, said Dr. Sharma. Not so fast.
Okay.
Okay, Dr.
I know.
Sharma. Show us
I
what
know.
happened.
Okay, very quickly, I know you all got great, maybe a remote, we call Zoom radiation toxicity. But let's make it very simple and quick. You can hear it, right? This is the case number 10, came for LA RCA intervention.
This is a tough one.
Okay, but patient has PCI before, and of course our same crew working since morning relentlessly, all ready to show the last part. Although it's a grand finale, but of course the last case of the day, and then we'll start the lectures. We have done the stent of the circumflex, the stent of the LAD, all have been checked. They're all good, and now patient came still symptomatic and a good LV, and you can see there is a distal RCA bifurcation, not a large vessels, but there are subtotal. You see that there. So we are just going to take you through. We were able to put 2 wires. They use the score flex 2O. 10, and then we did a balloon in the AV continuation, the good size. So we would have mini crush, same way, which we talked about that we favor mini crush. We had a little trouble in advancing the balloon in the side branch, so we did an anchor technique, basically balloon distally, and then able to get a 1O balloon, and then kissing balloon, and this is where we are. And we are done.
Wow.
Keep it simple, you start your lectures.
Yeah, beautiful case. Beautiful case is this. Thank you so much. Nice demonstration
All
of
right.
the anchor.
Fantastic.
Okay, so we're going to start here with Ron. He's a pioneer and an expert in this subject of the lipid content plaque. And he has a case with ACS, non-obstructive plaque.
Again, this is a great meeting, and I'm humbled, honored to be here. I'll try to make it short because we are going to do like rapid fire cases and discussion. And I'm going to share with you, see if this is moving. These are my disclosures. And this is just a snapshot of 5 cases that presented to the cath lab post-CPR. You can see the cardiac arrest that they had from ventricular arrhythmia, VF. You can see the lesion in the angiogram. What is common to all those cases that were done by Ryan Meder was that they underwent NIRS chemogram. And all of them had a high LCBI at 4 millimeter max. So you can see here that the range of the LCBI was from 400 to 883. Now, you can argue, well, this is the context of the acute coronary syndrome. The hole definitely had a lesion, but what do we do with this kind of patients? So this is a 33-year-old patient who presented to the lab with non-STEMI. The culprit lesion was at the distal RCA. It's a straightforward lesion. It was treated with PCI and a stent in the distal right. But part of the angiogram was the left system. And you can see here that there is some moderate disease in the LAD. Now, with a show of hands, how many of you will pursue here with any physiological study? Raise your hand. Nobody? 1, 2, 3, 4, 5. I know some of the girls will do Hirminoka also, but there is no need because we had already a lesion. Okay, how many of you will do imaging of this vessel? We have few. All right, this 33 years old, it's a very unusual to have someone at this age. There are definitely irregularities. So he had chemogram. This is NIRS, and what you're seeing here, there's a lot of yellow here. And this is question, going to bring an event or not going to bring an event? We do know now results of 2 studies, the LRP and Prospect 2, that were using NIRS in a very large cohort of registry. There are also small registries that show that if you have more than 400 LCBI, you're also going to have a future event. This patient also underwent physiology, which I'll share with you in a second, but the key question was, look at the chemogram, will this lesion cause a site-specific event, not just overall event? Obviously, he does have an event on the right coronary. We don't have the LCBI there, but that was the non-STEMI. So what else do we look on the IVUS? So we look in plaque burden because we do know that patients with plaque burden and TICFA and LCBI are good correlates for a subsequent event. The MLA was 3.9 centimeters square. And again, the plaque burden is very suspicious. Now, obviously, we're not treating any of those. But my question to you, now that you know the LRP study results, you know the Prospect 2 results, they all show that if you have high LCBI plaque burden, you have a likelihood to have overall event and even site-specific event. How many of you would treat this patient differently with medical therapy? So those patients will get already statins, but would you give something more than the statins?
I think so. I think this is an unusual age to see this much disease. So I think there's something unusual going on. So I wouldn't jump into usual therapy just yet. I would have treated the right, then get your data, and then try to figure out what exactly is this problem, and is this, you know, an injectable cholesterol-lowering agent kind of situation.
I agree.
So no FFR here or IFR?
Well, it's coming. It's coming.
It's coming. Okay.
I'm going to show you the pathology that you would expect to see when you have LR lipid-rich plaque, and you know that approximately 85% of those plaques causing sudden death and have a lipid core or lipid pool. So we had the LRP study. You know about that study. I'm not going to go through much, but just show you the event rate. So the event rate on the patient level, if you have more than 400, 13% versus 6%. And in the plaque site level, it was 3.2% versus 0.8%. And the events were pretty serious. There was cardiac death, cardiac arrest, ACS, non-fatal MI, also PCI and CABG. So going back to this patient, I showed you all the information. He came with new onset angina 15 months later. 15
months.
Yeah, his physiology, I don't have it on those slides, was normal. So there was no physiology abnormality. The FFR was more than 0.90. But you can see here, new onset of angina. This is 15 months later at the same vessel. Yeah. So this is the baseline, and this is 15 months later. And I think this case speaks for himself. Again, another study, Prospect 2, shows overall event. Look at the non-culprit lesion-related MACE, 8%. That's pretty significant within 4 years. And then when you put head-to-head the two studies, the LRP and Prospect 2, you see that the event rate miraculously almost the same, 13% in LRP, 12.1% in Prospect 2, and on the site level or lesion level, it was 5.4% at 4 years in Prospect 2 and 3.2% in LRP. And another sub-analysis that was done by Akiko was the higher the LCBI, the more event you will have. So my take on this, and I'm not going to show you more cases because I think we are short of time, is that we have to pay attention to the non-culprit lesion because these are the lesions that may cause you the mortality and the spontaneous MI, while we heard all day long that all the lesions that are being treated which are culprit, at the most will reduce some angina, and they're not reduce mortality. So again, we do need a very large study, but something has to be addressed here. And the question would be, how do you treat those patients? What do you do for them? So there is a study that was done by Lawrence Raber that shows that PCSK9 at 2 years reduced the LRP, and I think at least we know that as a surrogate, this will reduce it. As a relate to this patient, you have to measure the Lp(a), and you have to be cautious on the opening lecture that was today, a fantastic lecture by Dr. Fusser, as usual. Would you treat that with a bioresorbable scaffold? I'm not sure. Here's a case from Prospect 2 that was actually looking on FFR that was 0.90, plaque burden 81%, and you can see here that if you treat the BVS, you had a much larger scaffold area compared to if you treat that alone. And bottom line, again, we do need some study to show that you're going to have less events if you're going to put a BVS like in this case versus other cases that you're just going to go with medical therapy, because all those patients in Prospect and LRP were treated optimally medically. So we can identify the vulnerable plaque. We have different modalities, imaging modalities. It can be done by OCT, NIRS, and also even with IRF-IVUS. And I think we have to pay attention to these non-culprit lesions and then to start to embark on studies which would tell us how to treat those findings. Right now we have many medical therapy, but if you look at the next generation DES, their event rate at 2 years is less than 3.2%. So you ask yourself, if I stent, if there is a single lesion only in one spot, is stenting going to be reasonable? It may be, rather than to leave it to the medical therapy. And I'll stop here. Thank you.
Yeah, thank you. That was beautiful, Ron. Let's move on with Gennaro Sardella, who's going to talk about bioabsorbable scaffold, emerging data.
Thank you. Thank you, ladies and gentlemen. Thank you to Teodor for my invitation, and I'm very excited to stay after 2 years in New York in person. This is my disclosure. This is the evolution after the first balloon angioplasty of the PCI. And in 2010, like a dream, appeared the bioresorbable scaffold. And as Dr. Wassman showed us several minutes ago, according with the luminal area modification, the attracting concept behind the BRS was to restore vessel integrity, to restore vasomotor reactivity and endothelial function, and the complete reabsorption that it was the real dream. But several studies arose some concern. The registry, GHOST European registry, showed these very bad results at 6 months, 2% of target vessel MI, but more than this, 4% of TVR, 2.5 of TLR, and the stent thrombosis 2.1. And after this, in the same year, 2017, there was a meta-analysis about the Absorb 3,261 patients in Absorb versus everolimus eluting stent, and it showed us that it was a terrible result in terms of death, myocardial infarction, or revascularization. The authors tried to explain and stated that as these devices are less forgiving compared to DES, optimization of the final result and appropriate antithrombotic therapy maybe could be essential when scaffolds are implanted in complex lesions. And for this reason, they hypothesized some device-related mechanism of this failure, the thicker struts, the under-expansion, and the dismantling. And for this reason, they hypothesized a particular technique that it was so-called PSP in terms of pre-dilatation, optimal sizing, and the post-dilatation of the stent. But the question is, bioresorbable stents, is the game over? First of all, we have to know that except the 3 Phantom Magmaris and this stent IBS, all the bioresorbable scaffolds are made with a PLLA technical features. This is very interesting, the summary of the polymeric BRS under investigation. You can see that between the most used stent, BRS, Absorb, Mirage, and Phantom, all they discontinued or stopped the trial. Just 2 of those stents, the Dissolve and Magmaris, continued the trial and are again under investigation. Nevertheless, there is some reemergence. I think that this was the nail in the coffin of the Absorb. The AIDA trial compared the Absorb BVS with X-Science, and you can see, even in this case, very bad results of the Absorbs in terms of TLR, 10.1% at 5 years, and the device thrombosis related 4.1%. But this trial gave us some interesting lessons. The first one, you can see the landmark analysis from clinical outcomes between 3 and 5 years. You can see that between 3 and 4 years, the device thrombosis related was not significantly different, but it was different just the TVR and TLR. And between 4 and 5 years, every of these result, it was not different between BVS and X-Science. And you can see the incidence of device thrombosis up to 5 years of follow-up. You can see that it's much more between the 24 hours and 30 days, up to 1 year, between 1 and 2 years. It starts to decrease between 2 and 3 years, and between 4 and 5 years, it was similar. The same effect of DAPT on events and scaffold thrombosis. You can see that overall, between 0 and 5 years, patient on DAPT and patient off DAPT, it was the difference in favor of patient of DAPT. But this difference, if you make the landmark analysis between 0 and 1 years, you can see the patients on DAPT had the scaffold thrombosis of 70% versus 29%. But if you take after 1 year, up to 5 years, you can see it's just 4.8 on DAPT as events compared with 81% of patients off DAPT. And the same thing for the scaffold thrombosis and non-scaffold thrombosis. You can see that overall 13 were on DAPT, scaffold thrombosis and non-scaffold thrombosis, but you can see that between 1 and 5 years, just 1, it was on DAPT between the patient with scaffold thrombosis. Thus, this analysis was very interesting because, in my opinion, hypothesizes the reduction of this excessive risk may be by prolonging DAPT after BVS implantation. This is another very utilized stent, the Phantom stent, that it was not in PLLA, but its properties was the Thyrocore, that has some benefit respect to PLLA. And you can see this was presented last year at TCT by Matthias Lutz, the Phantom 2 trial, with not bad result at 60 months, just 5.4% of TLF. But even in this case, you can see that there were no new events between 36 and 48 months. You can see 0, 0.4, 0, and 0.8. And we moved to Biosol for registry, another very used, the Magmaris scaffold that it was made by magnesium. You can see the backbone, it was reabsorbed at 12 months, and the biolutin coating, it was reabsorbed at 24 months. This was presented by Stefan Veraille last year, and it was published on CCI. You can see the stent thrombosis, it was quite good. And this was the sub-study of the Magmaris, the MAG-STEMI. You can see the overall, the all patient with ST elevation myocardial infarction. It was the comparison between Magmaris and sirolimus eluting stent. You can see that at 3-year follow-up, the device-oriented composite endpoint, it was more was increasing in BRS. The target lesion revascularization, it was more, and of course, the DAPT prescription, it was more. But If you make a landmark analysis, even in this study, from 0 to 1 year, you have a more event according with device-oriented composite endpoint and TLR, but if you make the landmark analysis between 1 and 3 years, you don't have any difference between the two stents. Thus, the author stated that maybe the BRS was associated with a higher rate of a TLR clustered within the first year of follow-up. The Italian Society of Cardiology stated that some recommendation that it was like similar to the PSP technique, the 4P strategy that focused the attention on the patient selection, the proper sizing, the pre-dilatation, and the post-dilatation. And in this study, they stated that extension of DAPT for 36 months as per the guidelines does not seem necessary for patients undergoing Magmaris implantation. This is just for Magmaris. Since the resorption process is already complete after 12 months, as opposite, that is very important to say the difference in the future, to PLLA scaffold like Absorb, which require more than 36 and 48 months of resorption.
I think, Dr. Sardella, we have to summarize now.
Yes,
okay?
This is the last study, the aptitude scaffold that is the second generation that showed very good result in terms of late lumen loss. This is my conclusion. The BRS in a short time have become the great revolution in this field, but with the same speed they fell down in the expectations of interventional cardiologists. Even though some companies who invested in this technology went bankrupt, but others are still investing in this field. Some lessons: an appropriate patient selection. The new generation BRS may be improved mechanical properties of this device. Has been shown that the difference in outcome with BRS as compared to a everolimus elutis stent does no longer exist 3-4 years after BRS implantation. And finally, maybe an appropriate and BRS patients fit duration of the DAPT is a crucial point to improve outcomes. Thank you for your attention.
Thank you so much. That's an interesting and hopeful presentation. We have Dr. Arthur Reitman. He's going to talk about calcific lesion in a large vessel rota shock. I wish you could do this in 5 minutes, my friend.
I can do it in less.
You're wonderful.
I can do it in less. Thank you to SS and to Dr. Kinney for inviting me. I was part of the fourth program over 20 years ago, so it always feels like I'm coming home. I'll show you the cases that I think we've all had plenty of opportunity to review today, but basically a combined strategy of rotational atherectomy and shockwave lithotripsy, in my experience, has yielded the best results in some of the most complex lesions. Again, just going back, stent-related events after a year, regardless, just very quickly, regardless of the stent type that we implant, bare metal, first or second generation drug-eluting stents, events continue to accrue out to 5 years at a rate of approximately 2% per year. We know that severely calcified lesions pose the greatest threat, and eccentric calcific nodules tend to be one of the places where we have the largest problems. The impact of calcium is incredibly detrimental, as we all have information that we've accrued over not only just the past day, but it's something that most of us know on a day-to-day basis. The opportunities for lithotripsy are really remarkable. The two emitters transmit forces in 4 different ways. I couldn't help but notice yesterday there was a little bit of science behind what the Fed did on the right-hand side. On the left, we show how the emitters initially demonstrate a burst of acoustic energy, Seemingly, I think the Fed thought there was going to be some science behind what they did yesterday as well. The algorithm on the left of a high calcium content via coronary angiography, critically important, and we've gone over this multiple times today. As opposed to plaque rupture on the right, the densely calcific lesion tends to be deep and have properties that are vastly different. So Dean Kariakis and Ziad Ali did an amazing job outlining these principles last year in JAK intervention, the pathway, the 10 most important pieces of shockwave lithotripsy we'll go over at a different time, but suffice it to say, the MLAs of these stented segments are dramatically larger in the Disrupt Coronary Disease 3 trial than they were with either atherectomy or balloon angioplasty alone. The secondary endpoints continue to demonstrate parity with this technique over a long period of time. The procedural characteristics really demonstrate that if it's 270 degrees in arc, then we achieve the greatest results. So this is a case of a 73-year-old. This was a couple of weeks ago, transferred to us from an outlying hospital. You saw the right coronary artery. We were able to do rotational atherectomy, followed by shockwave angioplasty in the proximal portion of the vessel, yielding a yielding a result that looks like this, almost impossible to get with atherectomy alone. OCT helps us to characterize why we're able to achieve success like that. Mostly it has to do with the multiple different directions that lithotripsy can fracture that deep calcific calcium. We see it on OCT. I thought we were going to see it today, but we didn't have the opportunity. Finally, this is just another example. Multi-vessel disease, relatively asymptomatic until she was transferred to us from an outside hospital, a 70-year-old female, markedly depressed ejection fraction, heart failure, coronary disease, identified by diagnostic catheterization outside institution, and by MRI, there does not appear to be delayed hyperenhancement, and as a consequence of that, no surgical plan for revascularization was the note that was left in the chart by the surgeons. This right coronary artery looks small. We did use an impella to assist us. You can see trifurcation disease, small vessels, again, rotational atherectomy, followed by shockwave lithotripsy, yielding this result in the right coronary artery. Again, diffuse distal disease had been relatively asymptomatic, and this result in the sort of trifurcation of the distal left main, ramus, and circumflex. So I know I'm one of the few things holding us back from the boat trip, so that's why I made it quick.
That's fantastic. Beautiful demonstration of the lithotripsy, and we are inviting Dr. Samir Mehta. Dr. Dangas has gave the opportunity to Samir to illustrate about a multi-vessel STEMI, culprit only or complete revascularization.
Pedro, thank you so much. My first observation is how common this is. So, as I searched for an appropriate case here, so certainly in a week there were 3. And so I've selected which I thought probably has the better teaching point here.
Mm-hmm.
So 77-year-old male with 1 hour of severe crushing chest pain, bought at 10:30 in the night via ER, pretty good response. And clearly by EKG, I remember driving there and I'm telling them, look, pull out a JL4 guiding catheter and a choice PT extra support. I mean, it's evident what the culprit is going to be. And here is the culprit. The question is that thrombus in the little problem here going to the previous view. Was there thrombus in the mid portion of the LAD, or it's some calcification? And the other point which I, over years of doing it again and again, often you're rushing to do a STEMI, looks straightforward, it's going to be LAD and let's put in a guide and get over with it. Yet again, I look at this case and I tell myself, look, there is always so many benefits of knowing the entire anatomy. Takes you just a moment, take a picture of the right, and once you take a look, now I'm already thinking, as I'm doing the LAD, that look, is this something also I need to address today? And which is, I think, the entire purpose of this conversation. I think data, and including the complete trial, has demonstrated that you need to do the non-culprit. The question is, when? That to me is the real issue here. So we have a culprit in the LAD and of course significant disease in the right, and let's see what the approach should be. So far as the data, not much doubt, a couple of papers, but this one is really leaves no doubt, recommendations all becoming much clearer after that, that in the presence of additional disease beyond the culprit, the question is more of timing, which is specifically outlined in their summary slide I'll show you in the next one. But once you're looking at the data, whether it is a primary endpoint or the secondary, clear benefit of doing a complete revascularization for patients presenting with STEMI. And here it is, and if you look at it, performed either during the index hospitalization or soon after discharge. And once you piece it through and take a look at a couple of editorials, the optimal time actually was defined by the editors at 2 weeks. So back to our case, straightforward, two options. Option one is bring the patient back for stage PCI of the RCA in a few days, but during the same admission, which is what was done in the majority of the cases. Or, why you give him some time to recover from his MI, why give more dye, although this patient's renal function was fine, bring him back in a few weeks and take care of the problem with the right. And the option two here was, look, the LAD didn't look difficult at all, straightforward, and why not take care of the RCA at the same index sitting. And that's where I think there are a couple of lessons to learn. And so I'm running this in my mind, and sometimes in Miami, the decision becomes straightforward. So this is amongst my 22 years of doing STEMI in Miami, 41% of patients have no insurance, and this patient makes it much easier. So, would you want to wait the next day? Probably, but I'm pretty sure in the meantime I'll get another call from the administrator, and there are all sorts of reasons. So I think in this particular case, with both options being clear, with the real message here being that in the desire and pursuit of chasing the second lesion, don't mess up. So if it's looking something much more complicated, I think you're clearly better off bringing the patient back subsequently. And so with that, here is his index lesion. Again, the mid portion of the proximal and the mid portion prior to the diagonal there. I'm not certain if that's calcification or thrombus, but I often use a lot of aspiration, maybe more than what I should. But in this case, so this is the right coronary artery taken. And here it is, the wire kept going into a small diagonal. I think I reposition it, put in a 2.5 balloon, and it's restored flow. And At this point, I'm not sure if I can get both the lesions. I move into more of a areocranial view. There is also a little distal left main there, and have a much better sense of the sizing. And this is, I think, a 3.0 or 3 or 3.538, and good enough result. And so this is fixed. And at this point, I decided to take a little better picture for the circ. Looks everything okay. But you see a nice Timmy flow, good blush, and you also start seeing a filling of the distal part of the right coronary artery. So at this point, over the years, I have given myself a couple of straightforward rules that, look, if I'm going to be trying a second vessel, I'm going to do my best to use the wire which I had used before and use the balloons. So it kind of tells me that, look, the lesion probably isn't that rough. So here is back with the right coronary artery, view with the AP cranial to open out the PDA there. And, but this was a little more challenging what I thought. Almost felt as if it's a subtotal occlusion, as even suggested by the collaterals, and getting the wire was more harder than what I thought, but the little more persistence, the wire is there. That's the same 2.5 balloon which I had used for the LAD, and a few more dilatations with that, and it's a pretty impressive, very large right coronary artery, I'm sure, contributing significantly to the ischemia. And from there onward, it really is a straightforward case, a long stent here and another one there, and that's the final result. I think I gave some more nitroprusside to augment the distal microvasculature flow. Now you can, again, cross it, put in an export catheter, but I think that's where the chasing of perfection in this second lesion, I think there is no purpose to it. You've already opened the culprit in the LAD. The patient's primary purpose of primary PCI has been achieved. Here is another picture just to demonstrate the excellent blush. And the patient was transferred overnight to the intensive care and went home the next day. I don't have a follow-up. This was just done 2 weeks ago, but I have no doubt the patient is doing fine. So in summary, here are the conclusions. I do believe that as we are confronting these patients more and more, it's going to be really your judgment. Should you, first of all, stage it, give it a couple of weeks, a few days, or maybe do it at the same time? I think we'll be doing a lot more of these procedures at the same setting. The equipment has become so much better. Thrombectomy devices have become better, and yet I think it's all a matter of good clinical judgment. You can have early discharge cost savings, but I don't think every patient should be done at the same sitting, and therein lies, I think, the final message of complete, which I don't think is kind of talked as much, that not only do you need to just have an angiographic follow-up, I think using clinical judgment to do the second lesion is important. Thank you.
Fantastic, fantastic. Dr. Mehta, thank you so much for the beautiful example. And we're going to have our dear friend, Dr. Dangas, who's going to knock out the high bleeding risk patient. Bleeding, bleeding, bleeding. Case of PCI in a high-risk bleeding patient.
All right, great. Great discussions and great cases. Let's see what we can do here about HBR, high bleeding risk, while I think Dr. Sharma and Dr. Kinney make their way towards here. So we'll have a lot to discuss until then. Oh, Dr. Sharma just arrived, so we've got to go fast now, change pace. So this is an 80-year-old person with hypertension, anemia, CAD, PCI middle AD, RCA, with a taxus, recurrent angina, and you can see 3-vessel CAD, offer cabbage, refuse cabbage, and you can see the angiograms here in a very complex left main and triple vessel disease, and ultimately a very good result at all these counts. And the intervention summary, you can say the aspect is the schedule of the PDA, but clearly the main job was done, as you can see here. So what's the antithrombotic strategy at follow-up is determined by ischemic and bleeding risks and many complex criteria. And in this environment, we know very much about the complex criteria of the lesions, the vessels, and all that. I think the European Society did a very, very important document regarding the ARC-HBR and the ARC group, really, with many, many factors that are there. Many patients have it, but I think because they weren't grouped, maybe we're going to kind of put in together the fact that, they're more prevalent than we ever thought or ever imagined. So the balancing, perhaps, is by de-escalating or reducing dual antiplatelet therapy or its intensity to a single agent or not, and you can see the twilight, by reducing the aspirin, cutting down the aspirin, the bleeding was almost halved. And this had a lot of questions, or could that be happening and be applied with a complex PCI? And the answer was yes, when we did the complex analysis of our patients in this study that included, as you see on the left-hand side, very, very important complex subgroups of patients. And then further analysis indicated that the high bleeding risk patients, according to the previous criteria that I showed you from the ARC European group, they had a lot of savings in bleeding particularly. And this has been further analyzed in a very large meta-analysis of over 24,000 patients, and the monotherapy indicated a lot of bleeding savings, tremendous bleeding savings without any penalties in the MACE. In the mass adapt also, the abbreviated adapt was a winner. In fact, that it was essentially the same. By the way anybody can see any of these graphs, they're the same except for bleeding that was again nearly halved. Regarding the de-escalation, that's another way to cut down. If you don't cut an agent, you can also reduce the intensity of DAP by using a less potent agent, such as clopidogrel, for example, or a low dose of prasugrel, or something like that. Essentially, you reduce the intensity of antiplatelet treatments, then you save the bleeding, and indeed, you may actually save some MACE as well. Through a different mechanism. So the key point to remember is that you re-stratify very clearly the thrombotic risks as well as the bleeding risk. See where your patient comes and how those can be applied safely and longer term. Thank you for your attention, and welcome Dr. Sharma to the Convention Center.
Dr. Moran, want to say some words?
Not yet then. Welcome. Dr. Meran to
All right, well, we have a little surprise for you.
Okay.
Let's go live to Dr. Kinney. Dr. Kinney, where are you?
Can you hear it?
Reno.
Looks like they're all enjoying. Where are we? Where is our champagne?
There you go, coming up now apparently. Dr. Kinney, we can see you, but we don't hear you.
Can't hear you, Dr. Kinney. Can't hear you at all. Whoa. Now?
AV Master.
Good luck.
AV Master. Voice to Dr. Kinney,
here
please.
We completed our symposium today, and we are here for the final say bye-bye from the cath lab. We just wanted to say who are the people involved in the cath lab who behind myself, Dr. Sharma, able to do these complex cases so swiftly. We have the entire staff, which now myself you saw working with Joe Sweeney, Parasuram, Amit Huda, and we have our another structural attending here also who has helped us emotionally. And then what you can see is cath lab staff. Everybody wave, fellows.
Let me just say, it is humbling.
And then,
let me just say.
One other thing we wanted
to
say
go
is 25 years
Kitty.
is the 25th year of the CCC Life. We started in 1998, and the journey has been very long, but more important, I think, was what Dr. Sharma always dreamt about, trying to teach people. And I can tell you one thing, every person that is here has been trained by him. So what has been imbibed in us and myself and all these attendings, why we are able to do this kind of complex cases, not just in Mount Sinai, but all around the globe now. So people all over USA and many people in Europe, Australia, and India, trained by him, taken his tips and tricks and able to help patients globally. That has been what was his dream, and continues to do that. He's the one who wanted to start the web teaching, or rather than the Symposium 1998, web teaching started way back in 2006, so that we are able to do live cases everywhere. So the thing about live cases came into him is one thing in what he has is that if I know that I can do a case, I want to teach other people, and so that they can also do the cases. And he always believed in teaching people. And I think that is something that he always tells us, that even when he was in medical school, he was the topper, always reading books, and we always make fun of his top 10. Always read, have slides ready, and keep teaching people about the subject as well as technical tips. He was never shy of teaching the technical tips to anybody else. Why? Because he wants everybody else also to grow and go to the next level. And here we are, ready to celebrate the 25 years with you.
Yes, of course I want to say something. Let's say something. Thank you.
All right.
So
And
I take the champagne. I take the champagne from you. Go ahead.
Award.
Go ahead.
Special award that we wanted to give you. I'm giving it to you virtually from here, and Roxana, who is your other student, going to present to you there.
Thank you. Thank you, Dr. Kinney. Let me just say what a humbling moment it is to be in the presence here on this occasion, on the 25th anniversary of this incredible course with our mentor. Especially knowing that you trained all those people, but you trained my husband and I as well. Myself and George Dengis, both trained by you. And exactly 25 years ago, we got married. So there you go. This is an incredible year. And, and you brought us together, Dr. Sharma. Thank you for that as well. But most importantly, what you've done in the last 25 years with this course is expose the world and share your skills with the world in the most open, your gifted, incredible technique that you've now given to all of the people who are working there. And of course, Anu is a gifted woman herself with incredible work. And by the way, I thought it went very well that the two of you were separated in two separate labs. It went very well today. And we really enjoyed watching both of you and watching how amazing you both are. But what a day we've had. What a great 25th year anniversary. And let's make sure we thank our sponsors. Let's make sure we thank Trisha Gaffney and Gaffney for doing all of this incredible work. All of our sponsors, and most importantly, all of you who've tuned in. And then, of course, our faculty who have traveled from around the world to be here and making this incredible. It started as a clinical case, but it is now a complete, very amazing one-day symposium that brings academia, clinical work, clinical science, experience. I mean, it's just all that. It's one of the best meetings, and it's because of you and Dr. Kinney for leading this, and congratulations on this 25th year anniversary. Congratulations.
Very simple. One, the foundation of the symposium, of course, it starts with Roxana for last 10 plus years, and it's been tremendous getting all the stellar faculty. And of course, my co-partner, which, say that you pass on the torch. I carried the torch, and now the torch bearer, Dr. Annapurna Kini, you say Annu or AK, what she showed today, the type of cases, amazing. And that actually good. What Roxana said, we were separate, that's good. So that we continue to go. One keep struggling, somehow happened to be, my case was a little simpler, so at least we took the time. But anyway, thank you, everyone. And we are ready for the toast.
Yes,
Drink to all.
raise your glass.
Beautiful.
Thank you all for being here. Congratulations, Dr. Shah. Let's get a picture. Can we get a picture with all of this wonderful faculty? We got to do the faculty. Oh, hold on, we have a raffles.
Raffle.
We always do a raffle.
The winner has to be present to win.
Okay, yeah.
Empty glass.
Okay, let's say
go to the.
Okay, yeah, sorry. So we have three. These are maximum visit to the booths. There is the punching card. I mean, I know this is something new started. I may not agree, but looks like it's a good. It's a $200 gift certificate. One is Athesam 10 scene.
Ihtisam Tahsin.
Yeah.
All right.
Good. So please pick up the gift at the
up your
registration
gift at
desk.
the registration
Okay.
desk.
Then we have a Melaku Demede, Arch Cardiology Associate.
Arch.
Huh?
Malaku.
No.
No.
ARH.
ARH. Malaku
Demede.
Demede. Malaku Demede.
Demede is there. All right.
You there?
Yes. Okay. Then the Christian Adapt. Christian Adapt.
You guys can hear, right?
Good. Okay. So those are the three done. Now we have
two more raffles. One for me, one for you. No.
So those are extra. That was just because you went visit to the booth. Now these two are raffles which are decided by our symposium, our organizers, and particularly to say those
One
who
fell
stay.
down. One fell down already.
That's okay. He's
Out.
going to choose another.
Good. We need him.
The question is, the person, other does not matter, but for these are the two, and what gifts we have? Okay, iPad mini and then iPad probably Pro. iPhone, whoa, we are getting better. All right. Okay, so this one is iPad mini. A person has to be here. Last four digits, 4098. Please look at yours. 4098.
Okay.
Going once. Going twice.
Okay. Last four digits, sorry. Okay, these are, on the ticket.
You need a raffle.
4049.
If you don't have
you need
a
a raffle ticket.
don't look for a ticket. If you don't have a red raffle, don't look for a ticket.
Okay.
Okay, another one. 4112.
4112.
Yay!
Yes, you just got an iPad mini.
4112.
Come on over. We have to see your raffle ticket.
You have to verify.
All right, let's choose the next one
Verify your raffle.
because we all want to go on the boat.
All good, but don't worry. Boat won't leave you without you. Boat won't leave. Okay, last one. 4143.
4143. Let's have you.
Over there, Sunny Gold is our attending. Let's find someone else. A disqualified.
Sunny.
Who? Sunny Gold?
Yeah. But they said this one. Wow.
You got disqualified?
Yeah.
Sunny.
No, why?
Come here, get another one.
Marks are right fault. Now you can answer for a little more. All right. Okay.
Wow.
With that note, of course, Dr. Keeney from that side and myself and
All these people are here. We want to go get a picture.
and we'll take a picture with everyone. And just to say, there's been a tremendous day, educational, and all these will be available. I already got few requests for the lectures. which have been
Everybody wants
given,
the lectures,
But they
yeah.
all will be available within maybe 48 hours maximum?
Yeah. By the way, let's keep the cath lab there. We're going to go right in front with all of the faculty present to get a picture with Dr. Sharma.
And
Please
everybody,
come up
let's come.
right
And
here.
cath
No,
lab
no,
will be in the
let's go here.
background. Yeah, come. Wow.
All right.
I just want to say, guys, don't delay. Look at our fellows, the staff. They are all ready for the boat. They want to have the real stuff, not the empty bottle. I mean, the glaciers. move the camera a little bit like this.